Hello, good morning, everyone. Good morning. Let's start with today's marathon on INICET, and I will be covering the topics of medicine, GIT, CVS, and general medicine. And this session is just to give you idea about the high-yielding topics or repeatedly asked topics from INICET. So INICET is one of the exam where you will get a repeated topics. In depth, you should be studying those topics. So from the GIT, so let's start with the GIT first. Important topic is celiac sprue. So topic celiac sprue. And what are the points about the celiac sprue? They will ask. They will ask about the most sensitive antibody, most specific antibody. They will ask you about the most sensitive and specific antibody. Then antibody to be done if patient is IgA deficient. Then they will ask you the biopsy criteria. So let's see the answers to these questions, and these are usually one-liner questions of the celiac sprue, and we will also be discussing the potential question PQs on that topic. So that is potential question expected. Any new drug which have come, any new criteria which have come will be asked. Now, the sensitive antibody is anti-TTG antibody, and that is of IgA type. Specific antibody is anti-endomysial antibody. Now, most sensitive and specific, both the things are combined. Then it is anti-TTG. IgA deficient anti-gliadin antibody. That is of IgG type, and biopsy criteria are the Marsh criteria. Now, the potential question. Vaccine which is recommended in celiac sprue, because of the autosplenectomy, the vaccine which is to be given in this patient is autosplenectomy occur. So we will give here a pneumococcal vaccine. Capsulated organism vaccine will be given here in cases of celiac sprue. Now, the second important topic is the IBD topic, inflammatory bowel disease topic. So here the main questions are on the pathological basis, like which is the most common site which is involved, the characteristic findings of that IBD. So in the ulcerative colitis, Crohn's disease, the most common site is rectum, and in celiac disease it is the ileum. And the main important finding here is continuous lesions, and here it is a skip lesions, while the presence of fistula goes in favor of Crohn's disease, while creeping fat, it goes in favor of Crohn's disease again. Transmural involvement, yes, transmural is Crohn's disease. While toxic megacolon is a feature of both, but more common in ulcerative colitis, plus minus in Crohn's disease. So these are the some of the important points about the manifestation they will ask, and the extraintestinal. So extraintestinal manifestations they are more in CD, except pyoderma gangrenosum and primary sclerosing cholangitis. These two are more in UC, more in ulcerative colitis. And as such, treatment based questions, they ask you about the newer treatment of the new drugs for IBD, like JAK1 and JAK3 inhibitors. They will ask you those agents, while they will ask you anti-integrin antibodies like vedolizumab. So IBD potential question will be on the newer drugs. Now, the third topic from the GIT that they frequently ask is the hepatitis B serology. And if anything new which have come in the hepatitis B, they will definitely ask. So hepatitis B serology, it is the different types of the phases. They will ask you the diagnosis and their typical pickup. So HBs antigen positivity, if anti-HBC antibody is of IgM type, so you should mark acute infection. While it is IgG type, then you will mark chronic infection. The next step here is supportive. And here it is the HBV DNA that will be done. And HBV DNA less than 2000, observation. And if HBV DNA is more than 2000, then we will go for the antiviral treatment. So now biopsy is not mandatory. To start with the treatment of these patients of chronic hepatitis B, and usually it is a tenofovir or monotherapy of entecavir. Usually for 1 year they recommend. While if a patient has HBs antigen negativity, so we will look for the anti-HBC antibody type. So if this antibody is IgM in nature, then it is a case of a window period. This is one of the favorite question of these examiner, window period serology. While if IgG is present, then it is a case of past infection. While post vaccination, to post vaccine, there is only one marker, and that marker is anti-HBs marker only. No other marker will be present here. And hepatitis B related serology, they ask the D infection. So about the D infection, so if it is a co-infection, Hep D co-infection, so the antibody which will be common will be IgM anti-HDV. That is common in co-infection and superinfection. So superinfection is again IgM anti-HDV. So it is a common antibody in both the conditions, but if there is IgM anti-HBC, that will make it co-infection. While if it is IgG anti-HBC, that will make it superinfection. So the differentiating feature here is IgG and IgM. So these are the two important viruses which they ask about the serological aspects. Now, the fourth topic in the GIT is the topic of the complication of cirrhosis, and most important complication they ask is the ascites. Very important. So ascites, they give you the features, parameter will be given, and you will be asked what is the cause of that ascites. So SAAG, if more than 1.1, or less than 1.1. This is a very, very important criteria. So we will look for ascites. Now many students confuse, that is total proteins. So remember, that is a protein in the ascites fluid that they will ask. So if that ascites fluid protein is less than 2.5 grams per deciliter, then it is a case of cirrhosis. Not only the cirrhosis, it is a late bud cherry syndrome. Late bud cherry syndrome. Late word should be mentioned here. Late means it is a cirrhosis which has happened here, and SBP. Do not forget spontaneous bacterial peritonitis. SAG more than 1.1 and total protein will be less than 2.5. Less than 2.5. While if the ascites total proteins are more than equal to 2.5, then it is a case of post sinusoidal obstruction. Post sinusoidal obstruction. That means it will be early bud cherry. Now, what will you mark for bud cherry? More than 2.5, less than 2.5, if only bud cherry syndrome is written. So in that condition, assume it to be early. Bud cherry is usually acute in nature, so it is early when nothing is mentioned. When nothing is mentioned, then it will be CHF, IVC obstruction, post sinusoidal obstructions. While if SAAG is less than 1.1, then the cause can be either serum albumin is very low, for example nephrotic, or ascites albumin is increased, which is a case of exudative peritonitis. Exudative peritonitis like cancer, TB, acute pancreatitis. So this is a simple flow chart for your last moment revision topic. And the fifth topic from the GIT they ask is a very sad disease. Indeed, in the differential diagnosis, they will ask you like patient has neuro, psychiatry, abnormality, wing beating tremors. There is KF ring. So what is the gold standard investigation for the diagnosis? Answer is, this is a case of Wilson disease, and gold standard for the diagnosis is liver biopsy. Liver copper will be assessed. Liver copper more than 200 will be assessed. While the drug of choice is these days combination of zinc plus penicillamine. Zinc plus penicillamine. So Wilson disease they ask very, very frequently. They give the clinical feature, and in the MRI they will ask you the panda sign in the MRI of brain. Now, so this 250 is in pathology, while in medicine in Harrison book it is more than 200. So these are some of the high yielding points of the GIT. Now high yielding points of the cardiovascular system. So in the cardiovascular system, the first topic is their examination of the cardiovascular. And which examination? All of you know, which we have discussed so many times. The first topic is JVP. They ask the physiology of waves and the timings of the wave. That is the 2 points. These are the favorites of the examiners. So physiology of the waves they will ask you, and which wave is coming at which time they will ask you. So this is A wave, this is V, X, V and Y, while this is S1 and this is S2. This is S2, and they will ask the superimposed ECG diagram on that. So ECG is electrical event first, P wave will be first, followed by the atrial contraction, and just before the S1 QRS complex will be coming, just before the S1, and then when the T wave finish, then S2 will start. So this is the superimposition of the JVP waves. So maximum question you will get from here only. While the number two is the murmur. They will ask you the murmur theory based or the diagram based, and from the diagram you have to assess ki which murmur is this murmur present. So suppose this is systole. They will give you the diagram like this. Then S1, S2, the diagram will be like this. Then S2, S1, S2, S1. So this is the murmur they will give you. This is the murmur they will give you. All right. So there is ejection systolic murmur. Ejection systolic. AS and PS. Valvular disease. Pansystolic. So this is pansystolic murmur. So this will be seen in MR and TR. This is early diastolic murmur. Early diastolic. So this will be seen in AR and PR. While mid diastolic murmur with pre-systolic accentuation. So this is MS and TS. And also know that they will ask you with that wave correspond to which part of the ECG, that wave is corresponding. So you should be knowing the ECG waves at which time they are coming in relation to S1 and S2, which we have just done in the JVP diagram. So new questions will come to you, but conceptual question which you can solve easily. Now the number third topic besides the murmurs and valvular disease they ask is this topic of heart failure. This is their favorite heart failure topic. So the heart failure topic they ask you the clinical features they will ask you, and in the clinical feature just remember that JVP elevation is pulsatile. It is not non-pulsatile. That is repeatedly asked question. JVP elevation is pulsatile. While the management of heart failure with reduced EF, management of heart failure with preserved EF. So here 4 drugs, ARNIs, they are much better than the RAS inhibitors, beta blockers, MRAs, and SGLT2 inhibitor. So these are the 4 drugs that is approved for heart failure with reduced ejection fraction. For preserved ejection fraction, it is SGLT2 inhibitors and finerenone. That will be given here, finerenone. While further treatment, they will ask you the ICD indication in heart failure and CRT indication in heart failure. So ICD indication is if the ejection fraction is less than 35%, very important, that is after 3 months of medical treatment. Then implantable cardioverter defibrillator device should be put in the patient. While CRT is a cardiac resynchronization therapy, so this is done when there is a left bundle branch block like pattern, and of course wide QRS will be there, wide QRS. So in that condition, cardiac resynchronization therapy is done. Resynchronization therapy is done. So this is the topic of the important topic of the hypertension, and number 4 topic from where they ask the questions of CVS is hypertension. And I have received so many messages from the students ki which guidelines should we follow. So basically AIMS examiner follow the AHA guidelines. So AHA guidelines, they have made the questions like if the grade 1 hypertension is there and comorbid conditions are absent, then we will go for just lifestyle modification, and comorbid conditions positive, so we will do lifestyle with drugs. While grade 2, all patients should start with LSM with drugs. Grade 2 is more than 160 by 100. Indeed, they have put that option कि antihypertensive will be started when the BP is more than 160 by 100. 160 by 100. Antihypertensive drugs. And here additional topic from the pharmac that you will be adding pharmacology. That is the drug interactions, contraindication of antihypertensive, particular drug antihypertensive like ACE inhibitor should not be given in pregnancy, bilateral renal stenosis. So these should be your additional topic from the pharmacology. They give integration with the medicine. So the range is grade 1 is 140 to 159, and diastolic BP 90 to 99, and here it is grade 2 more than 160 100. Now the fifth topic of importance is the myocardial infarction, and maximum question you will get in NSTEMI. Very simple questions. So the treatment of NSTEMI is dual antiplatelet therapy, low molecular weight heparin, nitrate, and beta blocker. While contraindicated is thrombolytic agents, thrombolytics, and PCI. Usually they will ask you immediate PCI indications. Immediate means within 2 hours PCI should be done. So that is most important. Unstable patient, refractory pain, then ventricular arrhythmias, heart failure. So this is their favorite. Immediate indication of the PCI in non-escalation MI. That is more important because the prevalence of non-escalation MI is increasing. Now the sixth important topic is the topic of arrhythmia. Very important topic of the arrhythmia. So the QRS should be assessed. If QRS is wide, then it is a ventricle origin of tachyarrhythmia. So if it is monomorphic, stable patient, amidron will be given. While monomorphic unstable patient, then synchronized DC shock will be given. So same morphology of the QRS is there. While ventricle origin is ventricle flutter, ventricle fibrillation, or polymorphic. So these are all unstable. So we give a synchronized DC shock. That is defibrillation. Defibrillation will be done. So simple flowchart. Wide QRS complex, if you see in the question, so just look at whether they are of same morphology or different morphology. While QRS is normal and their pick is mainly favorite pick is P wave is absent. So there will be two possibility here. So one is QRS complex is coming. In between there is a T wave only. This is a T wave. Other is this one, QRS complex T wave. So these are the T waves. Only one wave seen between the QRS is T wave. So if the rhythm is regular, this is PSVT. If the rhythm is irregular, this is atrial fibrillation. So Next step, drug of choice, control heart rate. Controlling the heart rate. So controlling the heart rate, drug of choice here will be the adenosine, and here it is beta blocker. Beta blocker will be given, and if patient is unstable in both the condition, unstable patient, so DC shock, synchronized DC shock will be given here. And this simple flow chart will cover almost your 99% questions which are coming on the arrhythmia. So they have a very limited questions on the arrhythmia. One is PSVT, other is atrial fibrillation, then polymorphic or ventricle origin of tachyarrhythmias. Now coming to the topic of general medicine. So in the topic of the general medicine, the questions which are guaranteed are on ABG. I will not discuss this whole calculation. You should be doing the ABG. Second topic is the topic of shock, that they will ask you the drugs which are given in particular shock. Third topic is very, very important topic of anemia. Fourth topic is the topic of in general medicine, vitamin deficiencies. Vitamin deficiencies. So in ABG, they ask calculations. So calculations should be there. In shock, they ask you the diagnosis. How the diagnosis is made? So very simple. JVP or CVP will make the diagnosis. If JVP or CVP is low and extremities are warm, so it is septic shock or anaphylactic shock. If cold, it is hypovolemic shock. Very, very simple. If JVP or CVP is high, then pulmonary capillary wedge pressure will determine whether it is obstructive shock. Obstructive shock means cardiac tamponade or pneumothorax. So here the pulmonary capillary wedge pressure will be low or normal, while cardiogenic shock, pulmonary capillary wedge pressure or lungs will have crepitation, so it will be increased. So creps in the lungs will be positive. So this is the first thing that they will ask you in the shock, the JVP or CVP. And in the anemia, they ask you about the diagnosis of the anemia. So diagnosis of the anemia, their pick is microcytic, and second they ask about the macrocytic, where patient is totally vegetarian, taking totally vegetarian diet. So in the microcytic, the most important test is the TIBC. If it is low, it is chronic inflammation. If it is high, then it is iron deficiency. And if it is normal, then sideroblastic or thalassemia will be the answer. Macrocytic, neurological manifestations, abnormality, B12 deficiency, and normal neurological, folic acid deficiency. Folic acid deficiency. So various state questions they will be asking. Now vitamin deficiency. So this you will be doing from your biochemistry section. So this is a important section here. Yes, number 5. Someone has pointed out dengue. Yes, they will ask you about the dengue. So in the dengue, most important is the fluid management. So that is done in cases of if patient has dengue shock syndrome or dengue hemorrhage. So fluid of choice is crystalloids. So this is the protocol, a simple protocol that you will remember. Crystalloid fluid will be started, and after starting the crystalloid fluid, improvement. Yes, then we will stop fluids. And if there is no improvement, the most important test is hematocrit. Very, very important test, hematocrit. So hematocrit is showing increasing trend. So what does this mean? This means plasma leak. Hematocrit is increasing, plasma leak. Add colloids. If decreasing trend, that means whole blood loss, RBC loss, whole blood loss. So blood transfusion will be indicated. Blood transfusion will be indicated. So this is a simplified flow chart, and platelet transfusion when it should be given. So platelet transfusion when it is less than 10,000 or when there is a major hemorrhage. Do not fall into the trap of mucosal hemorrhage, petechial hemorrhage. They are not major hemorrhage. Major hemorrhage is GI hemorrhage. GI hemorrhage. Then we will be giving the platelet transfusion. And final question. So final question is discharge criteria of discharge criteria. Afebrile for more than 24 hours without paracetamol. Adequate urine output. Urine output. Then accepting orally. Accepting orally. And very important investigation. Absolute platelet count does not matter. Just platelet showing increasing trend. Like yesterday 20,000, now it is 50,000. You can discharge the patient. So absolute value not important. And stable hematocrit. Hematocrit is stable. These are the investigation criteria. So these are the discharge criteria for a patient for dengue hemorrhagic fever or dengue shock syndrome. So this I have covered the topics of important GIT, CVS and general medicine in this time period of half an hour. So wishing you all the very best for your upcoming AIMS exam. Just go through this. All of you have done your notes. Notes are your base, and in the last day before the exam, scroll through these pages and most likely you will get the questions from these PYTs. So wishing you again all the very best.
Okay, so good morning all of you. I hope I'm audible and visible. Can you all give me a quick thumbs up if you can hear my audio and video? I just need a quick thumbs up from all of you. Okay, just a second. I'll just check if I am visible or not. Yes, so good morning all of you, and very welcome to everyone. So without taking much time, let us start with the session because it's just half an hour which is given to us. So in this INICET of dermatology, what I have done is I've put a lot of images. I'll start with infectious disorder topic because we do see a lot of questions from infectious disorder. I'll keep showing the images and I'll show or tell you the important points which is required for that particular topic. Okay. So coming to the first one, bacho, that is lupus vulgaris or cutaneous tuberculosis. Remember, bacho, in cutaneous tuberculosis, they ask you a lot of questions, especially related to, okay. In cutaneous tuberculosis, they will ask you mainly the questions which is the investigation of choice. So can you tell me, bacho, what is the investigation of choice for cutaneous tuberculosis? Please remember, for us to call a skin lesion as cutaneous tuberculosis, we have to demonstrate MTB in it. And that is why the investigation of choice becomes skin biopsy. Or if skin biopsy is not given, then PCR become the investigation of choice. Now there are multiple types of cutaneous tuberculosis. If you see an annular plaque with central scarring, so annular plaque with central scarring, that's a very characteristic feature of lupus vulgaris. If you see a verrucous growth, that is tuberculosis verruca cutis. If you see a nodulo-ulcerative lesion on the neck, that is scrofuloderma. So usually they ask you three types of cutaneous tuberculosis: lupus vulgaris, which is annular plaque central, scarring, scrophaloderma on the neck, nodular ulcerative lesion, and number 3, tuberculosis verrucocutis, which is the rough verrucous plaque. Now, bacho, they also ask you a question on tuberculate. Can anybody tell me what is tuberculate? It is a hypersensitivity reaction where you do not see any MTB in skin. It is just hypersensitivity reaction on skin. It is hypersensitivity reaction on skin. We do not have MTB. No MTB in skin. And what are the 3 cutaneous tuberculosis which you should know, bacho? The 3 cutaneous tuberculosis is number 1, erythema induratum. Erythema induratum, lichen scrophalosorum, and papulonecrotic TB. Papulonecrotic TB. In all 3, we do not see MTB in the skin. Papulonecrotic TB. So please remember, in cutaneous tuberculosis, the investigation of choice, the different type of skin TB, and the tuberculate is what they will ask you. I hope it is clear to all of you. Okay. Now, how to treat cutaneous tuberculosis? We treat it similarly how we treat pulmonary tuberculosis. We give intensive therapy of 2 months and continuation therapy of 4 months. Coming to the next, that is tuberculosis verrucocutis. I told you the verrucous plaque, which is very characteristically seen on the exposed areas, and there is the lupus, the scrophaloderma. We don't have image here, but remember, on the neck, if you see nodular ulcerative lesion, that is scrophaloderma. Now coming to the next, herpes virus. But your herpes virus is also important for your exam. First of all, if it is herpes virus, what investigation of choice you will do? Anyone, can you tell me what investigation of choice you will do if it is herpes virus? We will do zinc smear from the vesicle, because in herpes we get vesiculobullous lesions, and zinc smear will show a very characteristic multinucleated giant cell. Multinucleated giant cell. So what is the zinc smear finding? We get multinucleated giant cell when we do the zinc smear. Now, bacho, HSV1 is herpes labialis, which is also human herpes virus 1. HSV2 is human herpes virus 2, which causes herpes genitalis. And HHV3 is actually varicella zoster virus. The first episode causes varicella or chickenpox, and the virus get dormant in the dorsal nerve root ganglia. When it reactivates, it causes herpes zoster, which is also known as shingles. Now, bacho, herpes labialis mein you have grouped vesicles on mucocutaneous junction near the oral cavity, and in herpes genitalis you have grouped vesicle on the mucocutaneous junction around the genital area. In varicella or chickenpox you get polymorphic and pleomorphic rash. Polymorphic means you see multiple morphology lesion all together, and polymorphic is multiple lesions all together. Pleomorphic means the single lesion has a tendency to go from one stage to another stage. It starts as a macule, it goes as a papule, then vesicles, then pustules, and then crust. In herpes zoster, we get grouped vesicles on a single dermatome. So dermatomal distribution is very important. Where is the virus got dormant? In the dorsal nerve root ganglia, and when it reactivates, it presents like this, grouped lesions on a single dermatome. It is very painful, and that is actually only complaint, that is the pain which is associated with it. So please remember, this is very classical herpes zoster image. It is multiple vesicles on a segmental distribution, and I told you herpes simplex, which is 1 and 2, herpes genitalis, which is HSV2, they present as grouped vesicles around the mucocutaneous junction. Herpes simplex 2 is actually around the genitals, while herpes simplex 1 is around the oral cavity. Sometimes they ask you treatment, बच्चों, what is the treatment of herpes genitalis? We give kit number 5, but what is the content? Acyclovir 400 mg 3 times a day, TDS for 7 days. For herpes zoster, we give acyclovir 800 mg 5 times a day, 7 days. Here we are giving acyclovir 400 mg 3 times a day for 7 days. So please remember, these are important points which you should remember. And remember, in herpes genitalis, you will get a history of recurrence before it starts, and you also get presence of vesicles. Okay, vesicles and recurrence history. What is this? This is a human papilloma viral infection, HPV, which causes what? Bacho, this is again a very important topic for your exam. Cutaneous lesions of HPV infection is what? Now we have divided the warts into non-genital and genital. Let us first discuss non-genital warts. Non-genital warts are, number 1, verruca vulgaris, which is due to HPV. Can you tell me which HPV causes verruca vulgaris? 2 and 5. Verruca plana HPV 3 and 10. Then number 3 is filiform wart HPV 2, and we have plantar wart, which is on the undersurface of the foot. It is HPV1. If you have to treat the non-genital warts, just give cautery. You have to give the cautery, you have to remove it from that area by electrocautery, or you can use the radio frequency cautery. So non-genital wart should be removed by doing a cautery. There are 4 types of non-genital we have discussed: verruca vulgaris, verruca plana, filiform wart, and plantar wart. Now coming to genital wart, bacho. Genital wart, also known as condyloma acuminata. It occurs because of HPV 6 and 11. Now, one question which they always ask is, HPV 6 and 11, is it a low risk virus or a high risk virus? Anyone? Does it cause cancer? Answer is no. It is a low risk virus. It do not cause cancer. And how do you treat? Please remember, the treatment of choice for genital wart, you cannot do cautery for this. You give podophyllin. It is a plant resin which causes metaphase arrest, and it inhibits the viral proliferation and cell proliferation. But bacho, this is contraindicated in pregnancy. Then how to treat a pregnant female with genital wart? So during pregnancy, the treatment of choice is cryotherapy. We have to give, or we have to apply liquid nitrogen of minus 192 to 196 degrees centigrade to treat the genital wart in a pregnant female. So cryotherapy becomes the answer. Now sometimes they ask you, what happens if you do not treat the patient of the genital wart? Does it go into cancer? The answer is no. But long-standing genital wart can give rise to Buschke-Lowenstein tumor, which is per se not a cancer, but if you do not treat the Buschke-Lowenstein tumor over a period of time, it can convert into cancer. So genital wart will never convert, but when the genital wart goes into Buschke-Lowenstein stage, which is a chronic deforming type of lesion of the genitalia, then it can go into the cancerous stage. So that is about HPV. Please remember, image based, non-image based questions, multiple times they have been asked in your exams. Coming to next, molluscum contagiosum. But molluscum contagiosum is due to molluscum contagiosum virus 1 to 4. This is a pox virus, which is a DNA virus. Now, what is the characteristic feature? You have pearly white dome-shaped papule, and very characteristic, there is umbilication in the center. When you press the lesion, on pressing, a cheesy material comes out. A cheesy material comes out. And bacho, if I do the microscopy from that, what will I see? If I do microscopy of that cheesy material, I will see infected keratinocyte with intracytoplasmic bodies. And what are those intracytoplasmic inclusion bodies known as? What do you call those intracytoplasmic inclusion bodies? We call them Henderson-Peterson bodies. Henderson-Peterson bodies. But so when you take a biopsy, the cut section of the biopsy looks like what? A tomato smashed appearance. A tomato smashed appearance. The cut of the biopsy looks like a tomato smashed. That was also asked in one of your exam. Tomato smashed appearance. When you take a biopsy, it appears like tomato smashed. You see a round structure, the papule is round and there are septae in between, and between the septum you see round infected keratinocyte. Next, the dermatophyte infection. Bacho, it is the superficial fungal infection. And bacho, remember, superficial fungal infection spread through direct contact. But if they write the deep fungal infections like mycetoma, sporotrichosis, chromoblastomycosis, all the deep fungal infection or subcutaneous fungal infection, they spread through thorn prick. Dermatophyte do not spread through thorn prick, it spread through direct contact. But so there are three species of dermatophyte. One is trichophyton. It affects all three: skin, hair and nail. So try all three. Then we have epidermophyton. It affects skin and nail, not hair. And the third is microsporum. It affects skin and hair, not nail. Whenever you have dermatophyte infection, we call it tinea. And what is the characteristic feature of any tinea? We get annular plaque with central atrophy. Central clearing. Central atrophy is a feature of cutaneous tuberculosis, not tinea. Okay, so annular plaque with central clearing is a feature. For diagnosis, we do KOH mount and we will see dermatophyte hyphae. We will see dermatophyte hyphae. How to treat any form of tinea, bacho? The drug of choice for dermatophyte is terbinafine. But if it is tinea unguum, the nail fungus, we give the nail lacquer formulation. And what are the nail lacquer formulations that asked in your exam? Anyone? There are three types. One is amorolfin. Second is cyclopyrox. Third, tavaborole. So at least remember these three names of nail lacquer formulation which is used for tinea unguum. Other than tinea unguum, for the other teneas we give terbinafine. There is one exception which is tinea capitis, where we give griseofulvin as the drug of choice because it is the fungal infection of the scalp and most common species is microsporum, and that is how the griseofulvin becomes the treatment of choice. So as I told you, the tinea capitis, griseofulvin is treatment of choice. We have divided tinea capitis into inflammatory and non-inflammatory. Inflammatory is chirion, where you see painful bogey swelling, discharging sinuses on the scalp. Causative agent is trichophyton verrucosum and trichophyton mentagrophyte. And if you remember in our classes we have discussed the mnemonic is KVM, Kendra Vidya Mandir School. Second inflammatory tinea is your favus, which is yellow color cup shaped scales, scutulas with atrophy. The causative agent is trichophyton, Sean, Laney. But so there are two non-inflammatory tenias also. What are the non-inflammatory tinea capitis? We have grey patch and grey patch tinea, which is because of microsporum canis, and we have black dot tinea. Black dot is actually endothrix and grey patch is ectothrix. Black dot is trichophyton tonsurens and trichophyton violaceum. So mnemonic is black and white TV. Black and white TV. So please remember this much about the tinea capitis, two inflammatory and two non-inflammatory tinea capitis. Coming to subcutaneous fungus, mycetoma. Bachcho, mycetoma, very characteristic triad. What is the triad? Number one, swelling of the affected area or tumor of the affected area. Number two, there is, so this is number one. Number two, there is discharging sinuses. And number three, if you keep a cloth overnight, you will see grains, some crystals coming out of it. If the color of grain black, it is fungal, eumycetoma. It is fungal. Madurella mycetoma is the cause. And if you see the color of grain yellow, it is actinomycetoma, which is bacterial. If you do KOH mount, bacho, what do you see in eumycetoma? Doing KOH in eumycetoma will show septate hyphae. But doing KOH in actinomycetoma, nothing will be seen. It is negative. Bacho, can you tell me what is botryoomycosis? It is due to staph. If you see the features similar to mycetoma, secondary to Staph aureus infection, that becomes the botryoomycosis. Bacho, next is sporotrichosis, also known as Rose Gardner's disease. Very characteristic distribution of nodules. They are distributed linearly because there is lymphatic spread. The similar type of lymphatic or sporotrichoid spread seen with, can you tell me, sporotrichoid spread seen with sporothrix infection, Mycobacterium marinum infection, nocardia infection. So other than sporothrix, even marinum and nocardia can have similar findings. What do you see when you do biopsy in the patient of sporotrichosis? You see asteroid bodies. You see asteroid bodies when you do biopsy in these patients. Chromoblastomycosis, the causative agent is a fungus, Phyllophora verrucosa. Patient develops rough lesion, warty lesion. When we do biopsy, we see brown color bodies. We see brown color bodies. And what are these brown color bodies known as? Copper penny bodies, medullary bodies, sclerotic bodies. Okay, so please remember, they can ask you what you see on the biopsy of chromoblastomycosis. Coming to scabies, what is the characteristic feature of scabies? Bacho, patient presents with nocturnal itching. It is very classical in patient with poor local hygiene. Patient develops burrow. The classical site, the web spaces, wrist, elbow, axilla, chest, periumbilical. We call it circle of Hebra. But your treatment is something which is very important and very frequently asked from scabies. The topical treatment is 5% permethrin, which is drug of choice given in all adult and children. It works by acting on sodium channels, which causes influx of sodium. Second is GBHC, gamma benzyl hexachloride, contraindicated in children, pregnant, lactating females. Precipitate sulfur, which work by causing keratolysis, very effective in children as well as adult. 10% crotameton, again effective, the mechanism is not clear. And benzyl benzoate. But benzyl benzoate comes in different formulation. 6.5% is given for infant, 12% for children, and 25% for adult. And number 5, ivermectin, which is a oral drug. But this oral drug is contraindicated in children, pregnant, lactating female. Pregnant, lactating female. Please remember this point that this is contraindicated. You had a question recently in your INICET, which drug is contraindicated in children. So GBHC is contraindicated, ivermectin is contraindicated, and benzyl benzoate, if the percentage is high, it is contraindicated. What is the full form of GBHC? Gamma benzyl hexachloride, which is also known as lindane. Coming to psoriasis, bacho, again it's a very important topic. What is the classical clinical feature? Well demarcated red color plaques with silvery white scale, mainly extensor distribution. That is very characteristic. They are present on the elbows, on the knee, on the scalp, on the palm sole, as well as lower back. Please remember, there are different types of psoriasis. The commonest is chronic plaque psoriasis, which present on the extensors. This is the most common type. What are the other types, bacho? Guttate psoriasis, which is seen in children, and it is associated with infection due to group A beta hemolytic streptococcus. Number 3 is erythrodermic psoriasis, which is usually triggered by steroid withdrawal, and that is why systemic steroids are completely contraindicated in the patient of psoriasis. Pustular psoriasis, again due to steroid withdrawal. What is inverse psoriasis, bacho? Sometimes psoriasis occurs on the flexures instead of extensors. And bacho, there is one more type number 6, which is known as rheumatic psoriasis. In INICET, there was a question, in which condition you get limpet-like scales, thick tent-like scale. It is rheumatic psoriasis. Bacho, I told you systemic steroids are contraindicated in psoriasis patient, but can you tell me only one indication of giving systemic steroids? Systemic steroids are given in only one type of psoriasis, and that is impetigo herpetiformis. What is impetigo herpetiformis? It is the severe psoriasis in a pregnant female. Other than this, we do not give systemic steroids in any form of psoriasis. But in psoriasis patient, you get nail changes. The most commonest is irregular or non-uniform pitting. But can you tell me, where do you get uniform pitting? Alopecia areata, geometric or uniform pitting. The most specific finding is oil drop sign. But in psoriasis, we also get arthritis, where the distal interphalangeal joint is the most frequently involved joint, and patient develops asymmetrical oligoarthritis. Psoriatic arthritis is mainly seen in patients with HLA B27 positivity. HLA B27 positivity. So, bachcho, please remember these are some of the important points which you should know about psoriasis, clinical feature, the findings on the nail and the joint. Coming to lichen planus, 5 P's is how you describe. They are plain topped, polygonal, plain topped, polygonal, purple, pruritic papule. When you see the lesion on the surface, you see white lacy line and we call it Wickham stripe. You can also see the similar lesion in the oral cavity also. And one of the common trigger for this is dental amalgam. Mercury containing dental amalgam is the reason for this white reticulate lesion of oral lichen planus. What do you see on the nail of lichen planus patient? What do you see on the nail? The most common finding is thinning of the nail. The most specific finding is dorsal pterygium. Dorsal pterygium. The most common is thinning, the most specific is dorsal pterygium. You can see this picture. What is visible here? There is extension of the proximal nail fold on the nail plate and the fusion of this. So please remember the proximal nail fold extend onto the nail plate. Coming to the next, pityriasis rosea, bachcho. It is also a papillosquamous disorder which is due to HSV7. Whenever there is HSV7 infection, patient first develop a oval shaped plaque known as Herald patch. The Herald patch contains the scales on the margin. After development of this, patient develops multiple daughter patches which are distributed in Christmas tree or fir tree pattern. Please remember the Herald patch is also known as mother patch and the Christmas tree pattern is usually due to daughter patches. They are obliquely arranged on the trunk. Remember this condition has spontaneous resolution, spontaneous recovery. You don't have to give any antiviral drug for pityriasis rosea. Coming to pemphigus, bachcho, please remember in pemphigus vulgaris antibodies are against, IgG is against desmoglein 3, while in pemphigus foliaceus the antibody is against desmoglein 1. In vulgaris, along with the lesions on the skin, you see mucosa involved, but in foliaceus mucosa is spared. The level of split in the patients of foliaceus is subcorneal split, while in pemphigus vulgaris you get suprabasal split. In the patient of pemphigus vulgaris, when you do a biopsy histopathology, you get suprabasal split and a very characteristic row of tombstone appearance. What is the reason of row of tombstone? Intact hemidesmosome. The hemidesmosomes are not affected, they are intact. That is one of the assertion reason type of question you got in your exam. Intact hemidesmosome is the reason for row of tombstone appearance. Okay. Pemphigus foliaceus, as I told you, bachcho, the desmoglein 1 is affected and we get subcorneal cleft, mucosa is spared. We rarely see intact bulla, no intact bulla because only stratum corneum is forming the roof, so it is very fragile. Mainly you see crust and erosions. And these crust and erosions, they are present on the seborrheic areas. They are present on seborrheic areas like scalp, the face, the neck, the chest. Pemphigus vegetans, it is the rarest variety of pemphigus, rarest type. There is no bulla. Instead, you see vegetative plaques which are mainly present on flexures like axilla, groin. Okay, and it extend centrifugally. It goes from the extremities to the trunk. Bullous pemphigoid, the target is BP antigen 2, which is the part of basement membrane. Patient develops IgG against it. It is mainly seen in elderly patients, and the feature is itchy tens bulla. The characteristic site is the lower body, like peri-umbilical skin and the thigh. So itching and the surrounding skin also contain redness and edema. The pemphigoid gestationalis, it is nothing but bullous pemphigoid of pregnancy. Here also IgG against the BP antigen 2. IgG against BP antigen 2. Clinical feature is similar to bullous pemphigoid. The only difference is that the patient is pregnant here, and that is why you sometimes by mistakenly call it herpes gestationalis. But it is a wrong term. It has nothing to do with herpes. It's a misnomer, herpes gestationalis. Chronic bullous disease of childhood, also known as linear IgA disease. Linear IgA disease. Patient develops IgA against BP antigen 2. There is very characteristic distribution. There is annular arrangement of lesions, annular arrangement of the vesicles, and that gives string of pearl appearance. Now Dinesh is asking, or one of the patients is asking, BP antigen 2 location. But so BP antigen 2 is BP 180 and the location is basement membrane, lamina lucida. Dermatitis herpetiformis associated with gluten sensitive enteropathy. Gluten sensitive enteropathy. Patient have vesicles mainly on the elbow, knee, buttock and shoulder. They are very itchy. The treatment of choice is avoid bro. Bacho, what is bro? Barley. R is rye. O is wheat and O is oat and W is wheat. Drug of choice for dermatitis herpetiformis is Depson. What do you get on direct immunofluorescence? We get picket fence appearance. IgG on the tip of dermal papilla. Picket fence appearance. Coming to the STD, syphilis. It is due to treponema pallidum bachon. Primary stage has a hard, painless ulcer. We call it hard canker. In secondary stage, we have lesions like condyloma lata, which is the flat moist lesion. Then we have, this is macular syphilis. You can have oral ulcers. After secondary stage, we have a latent stage where there is no clinical feature. And after latent stage, we have tertiary stage where you have cutaneous features, gamma, CVS features, aortic aneurysm, and CNS, meningitis or parenchymal involvement. Yes, you are right. You also get, in secondary stage of syphilis, you also get moth-eaten alopecia, which is a non-scarring type of alopecia. Chancroid is painful, soft ulcer. We call it soft canker. It is also associated with painful lymph nodes. This is your donovanosis. Very characteristic red exuberant ulcer with granulation tissue. And this is your LGV, transient, less than 24 hours. The ulcer are painless. Painless ulcers which are transient. The presenting feature is painful lymph nodes. Sometimes the lymph nodes above and below the inguinal ligament is enlarged, and we call it groove sign. But so the causative agent of LGV is chlamydia. The causative agent of donovanosis is Klebsiella granulomatis or Calimactobacteria granulomatis, and chancroid is Haemophilus ducreyi. Alopecia areata. But in STD, please remember STD kit. We get a lot of questions out of STD kit. Alopecia areata is a patchy hair loss. The underneath skin is normal. There is no scaling, itching, redness. And the hair shows tapering at the lower margin. This type of hair is known as exclamatory hair. The treatment is intralesional steroid for these patients. Trichotillomania, when the patient pulls the hair, patient gets a patch with lot of broken hair of variable length. When you do a biopsy, you see intrafollicular and interfollicular hemorrhages, and we call it hamburger sign. If you see the marginal hair are spared, this is known as Freyer-Tuck sign. For treatment, you have to ask the patient not to pull the hair, and you have to give some psychiatric medicines. Coming to pattern hair loss or androgenic alopecia, बच्चों, that is because of androgen. In male pattern, there is recession of frontal and temporal hairline, while in female pattern, you have thinning of the crown with maintenance of the frontal hairline. Male pattern was classified by Hamilton, female pattern was classified by Ludwig. For treatment, we give minoxidil 2% for female and 5% topical for male. You can give 5-alpha reductase inhibitors like finasteride. बच्चों, leprosy we have 5 types according to Ridley-Joplin: TT, BT, BB, BL and LL. बच्चों, when we go from TT to LL, the CMI reduces, the bacterial count increases, the clinical feature increases. But so if I ask you, where do you get maximum nerve damage? Which pole? TT pole has maximum loss of sensation. And where do you see maximum nerve thickening? It is maximum towards the LL pole. Okay, so please remember it is maximum towards the LL pole. In lepromatous leprosy, you see multiple lesions. You get what is known as leonine facies. But so where do you get satellite lesions? Which type of leprosy? Answer is BT. Where do you get inverted saucer shape appearance? Also known as Swiss cheese, BB. And where do you get leonine facies? It is LL leprosy. There are lepra reaction to type 1 and type 2. Type 1 occurs in borderline patients. Type 2 occur in lepromatous patient. Type 1 is type 4 hypersensitivity and type 2 is type 3 hypersensitivity. For both type of lepra reaction, the treatment of choice is continue MDT, give oral steroids. Please remember, do not give anything other than oral steroids for lepra reaction. Thalidomide is not given anymore because of side effects like teratogenicity, peripheral neuropathy. But so what are the side effects of clofazimine? That is also asked in your exam. Clofazimine causes, number 1, dryness of skin. Number 2, it causes skin pigmentation. Number 3, intestinal obstruction. Okay, so with this, bacho, we are done with the today's class. This was the last slide which we had. So we have discussed quickly almost everything, bacho. But please remember, in STD kit, you have to read all the STD kit, the color, as well as what is the indication. STD and infectious disorder becomes the important topic. Other than the things which we have discussed, also read about the cutaneous malignancy. For example, the malignant melanoma, the basal cell carcinoma, because you sometimes get questions on these things also. Okay, so with this we are done, and I'm sure the next teacher will be waiting. So thank you all of you. Bye bye.
Okay, sir. I will. Yes, sir. Good morning, everyone. Good morning. Yes. So let's start. So I'm Dr. Srinath Chandramani. I'll be taking your two topics of medicine. So we are doing two topics, renal and rheumatology for the INICET exam. At the onset, let me tell you that in INICET, we are expecting more integrated questions, the questions related to any update in the guidelines and any new treatment options related to the disease, right? So in the patient with nephro and rheumatology, I have tried to compile all the high yield topics that are expected in the present exam. Okay, so let's get started. In this session, you don't have to write anything. Everything is in a PowerPoint manner and there will be a PDF, right? So you don't have to write. You just have to participate, answer the questions. So you feel confident in the exam. Chal. So first about acute kidney disease or the acute renal failure. The first step is how to confirm diagnosis of AKI. Using the KD-IGO criteria, the diagnosis of AKI can be confirmed when the rise in creatinine is more than 0.3 milligram per DL in 48 hours, or when there is increase in creatinine by more than 1.5 times the baseline in 7 days, or when the urine output is less than 0.5 ml per kg per hour for more than 6 consecutive hours. And that is why we say that minimum time to confirm diagnosis of AKI is going to be 6 hours. After confirming diagnosis of AKI, after excluding post-renal AKI on the ultrasound, we are going to look for the pre-renal versus the renal or the intrinsic AKI. To differentiate between the two, the most sensitive parameter is the FENA, fractional excretion of sodium. But how does it help differentiate pre-renal and renal? In the pre-renal cause, the FENA is going to be less than 1%. In the renal cause, it is going to be more than 2%, except in cases of glomerulonephritis, where FENA can be less than 1% also. But FENA more than 4% is characteristic of acute tubular necrosis, while 2 to 4% can be seen in acute interstitial nephritis. The most specific feature is the urinary NGAL level because neutrophil gelatinase associated lipocalin is secreted by the tubule into the urine in response to tubular injury. That is why, if present in the urine sample, it is specific for renal AKI. On the other side, what are the causes of ATM? The most common cause of ATM is going to be delayed treatment in the management of shock, followed by sepsis. There is contrast-induced nephropathy. The drugs, especially aminoglycoside, heavy metal poisoning, especially cadmium, and myotoxic snakebite can lead to tubular necrosis. But the moment contrast-induced nephropathy, where the FENA is going to remain less than 1%, even though it is a tubulo-interstitial disease, it is an exception to the rule and it is going to be less than 1%. Muddy brown cast, which is typical of tubular necrosis, is usually absent. The injury, in contrast, peaks at 48 to 72 hours, but recovery occurs within 7 to 10 days. So, typical MCQ, after giving the contrast, when should we do the serum creatinine test? Answer is after 48 to 72 hours. That is the peak. And within 7 to 10 days, there is an optimal recovery. And if you want to prevent contrast induced, first one, ensure hydration. Second, use water soluble contrast. You can give an acetylcysteine to reduce the risk of nephropathy. Acute interstitial nephritis. You can look when the patient has fever, rash, eosinophilia. And as discussed, the most common cause is going to be drug induced. The most common drug is the NSAID, ibuprofen, diclofenac, and your aceclofenac. The most common autoimmune disease is going to be Sjogren's syndrome. And there is atheroembolism can be there, right? So, this is the recent thing that I'm noting in every student's profile that you want to look at the PDF. है ना आम तो दिख रहा है ना तेरे को उदित तो let us at least look at the screen. This is exactly what it is. So if you have everything printed in front of you, you're not going to be able to revise it actively. Right now you do an active revision, उसके बाद passively read करना notes. इतना कौन सा जल्दी है ना? पीडीएफ सबको मिलेगा. ऐसा लगता है कि पीडीएफ मिले बिना जिंदगी अधूरी रह जाएगी. चलो, so coming to the rhabdomyolysis. Rhabdomyolysis is suspected when patient has come with a tubular necrosis with a CPK level more than 5000, hyperkalemia, hypocalcemia, because we know that there is a intracellular ion, hyperkalemia, phosphate also intracellular ion. When it comes into the blood, binds to the calcium and becomes hypocalcemia with cola colored urine is present. Chal, okay, great. So coming to the second one, glomerulonephritis is there. In glomerulonephritis, we have nephritic syndrome and nephrotic syndrome. Chalo, first wala padho. When do you say diagnosis is nephritic syndrome? When patient is having hematuria, patient is having RBC cast, hypertension with mild proteinuria. What is the nature of proteinuria in nephritic syndrome? It is typically less than 3.5 gram per day and non-selective in nature. The most common cause of nephritic syndrome in the world and most common cause in the adult is going to be IgA nephropathy, and it is also called as synpharyngitic nephropathy, presenting with the recurrent gross hematuria with normal complement levels. Right? The PSGN is going to be the most common. Yeah, thank you, damsdelhi, Dr. Mahindra. Anna, so Mahindra is more important to students कि वो आपका IT team will upload the PDF. चलो, so they have responded. It will be available on the app in the revision section. Yeah. So most common cause of nephritic syndrome in our country and the one that is in India is the post-streptococcal gene. In post-streptococcal gene, antibody present is the anti-DNase antibody or ASO titer. Complement levels are normal, which responds to penicillin therapy, returns to normal. And typically, you get the starry sky appearance, and immunofluorescence shows granular pattern, subepithelial humps. So, as I told you, that the idea is that there is an integration between pathology and medicine, lot in the especially topic of nephrology. The directed complication of nephritic syndrome is the RPG. The most common, on the other side, most common autoimmune disease causing nephritic syndrome is the lupus nephritis. In lupus nephritis, the antibody present is double-stranded DNA. Complement level is persistently low. Immunofluorescence shows immune complex deposits on the GPM. That's why we said type 3 hypersensitivity reaction and full house pattern on immunofluorescence study. There is deposition of IgA, IgG and complement. And the most worst type of the lupus nephritis pathology correlation is the type 4. Type 4 is the diffuse proliferative type of lupus nephritis with maximum risk of developing RPG. The drug of choice is to give IV methylprednisolone therapy followed by cyclophosphamide also can be used. So yes, Dr. Udit, PSGN में initially complement level low होता है. After giving penicillin therapy, it can return to normal. ये correct answer होता है. Vasculitis syndrome is a rare cause of nephritic syndrome and majority are ANCA positive. Good pasture syndrome में everybody चलो type करो what is the good pastures antigen इतना ही type करो. Good pastures is also the classical pulmonary renal syndrome where patient comes with the two organ involvement hematuria and hemoptysis. So which is the good pastures antigen we say? Good pastures antigen is the alpha 3 subunit of the type 4 collagen. Alpha 3 subunit of type 4 collagen is going to be good pastures antigen. Hence, it is also known as the anti-basement membrane disease. हम इसी को कहते हैं. चलिए, coming to nephrotic syndrome. Anti-GBM काफी नहीं है ना? So it is alpha 3 subunit of type 4 collagen. Great. So coming to next topic, that is nephrotic presentation. When do you say GN has come with nephrotic syndrome? When patient is presented with edema, there is anasarca, there is hypercoagulable state. Chalo, bachcho, everybody type. Why hypercoagulable state presents in nephrotic syndrome? बस जितना पूछा उतना टाइप करो, नहीं तो ऐसे घूमते रहोगे. hypercoagulable state because of antithrombin 3 proteinase, protein C deficiency is there. But what is the type of proteinuria that you see? More than 3.5 gram per day and selective proteinuria, because more than 98% of protein in the urine is going to be albuminuria. The most common cause of nephrotic syndrome in the world or in the children is going to be minimal change disease, where there is loss of fusion of podocyte alone, and it is a steroid responsive cause of nephrotic syndrome with good prognosis. Correct? So antithrombin 3 proteinase, protein C, excellent. That's the correct answer. But the most common cause of nephrotic syndrome in the adult is the FSGS, focal segmental glomerulosclerosis, where most common cause is diabetic nephropathy. Most common type is diffuse type. But the rare but the severe cause and the collapsing type of nephropathy is seen with the HIV infection. HIV associated nephropathy is the worst type, collapsing type of FSGS. Moving on to the other side, membranous GM is the most common cause of nephrotic syndrome in the elderly. It is also the most common type associated with malignancy. It has got the worst hypercoagulable state with the maximum risk of renal vein thrombosis. In this patient, 85% of the cases are positive for anti-PLA2R antibody, that is phospholipase A2 receptor antibody. Okay, everybody is going to type. What is the biopsy finding in membranous nephropathy? The biopsy finding in the membranous nephropathy is going to be spike and dome pattern. That is typical of the membranous nephropathy. Okay? So what is the dreaded complication? Dreaded complication here is the thrombosis. Okay? So granular immunofluorescence, Dr. Ayushi, that is seen in the mesengoproliferative. मतलब that is seen in IgA and PSG. यहाँ पर उसका कोई भी वैल्यू नहीं है. यहाँ पर आपको मिलता है स्पाइक एंडोम पैटर्न ऑन दी बायोप्सी. ग्रेट. ओके, सो हमने पढ़ लिया acute kidney disease and glomerulonephritis. Chalo, let us come to the tubular disease. In the tubular disorders, we want to study the two topics. One is RTA, other is channelopathy. So step by step, renal tubular acidosis. एक एक करके पढ़िए. Renal tubular acidosis is a group of disease where there is a common defect in acidification function of the tubule. There are total 4 types of RTA. हर टाइप के नीचे कैरेक्टरिस्टिक फीचर सिर्फ एंटर करना है मुझे, आप भी बताते जाएंगे. So type 1 RTA is the defect of H plus K plus ATPase pump, which is the most severe type of acidification defect. What are the salient feature to remember? Hypokalemia, nephrocalcinosis due to hypercalciuria, and urine pH is always more than 5.5 is diagnostic of type 1 RTA. The type 2, also called as the proximal RTA, is the inherited defect of bicarbonate reabsorption in the PCT. What is the classical hallmark? Fanconi's triad. Fanconi's triad is the triad of glycosuria, amino acid urea, and the phosphate urea is going to be there. In the type 3 RTA, also called as the marble bone disease, which is the least common type of RTA, where is the defect? The defect is inherited CA2, carbonic anhydrase gene defect, leading to cerebral calcification and osteopetrosis is there. The type 4 RTA, also called hyperkalemic RTA, is due to defect of aldosterone. Most common defect of aldosterone can be due to drugs inhibiting aldosterone, like ACE inhibitor, ARB. But second one, it can also occur in the early diabetic nephropathy or early CKD, where there is tubular resistance to the aldosterone. So very easy, quick revision, but you will not forget. You must identify correct answer for the type of RT. Moving on to the second, inherited channelopathy. Again, same we will do. We will start written down the diagnosis. You will tell me the feature. The most severe type of channelopathy is the Bartter syndrome. Barter is autosomal recessive, inhibitory defect of sodium, potassium 2-chloride, ATPase pump. This defect leads to diuresis, which causes dehydration, hypotension, but the hallmark feature associated with deafness, because the same channel also controls endolymph concentration in the cochlea. Along with that, patient has secondary hyperaldosteronism, hypokalemic metabolic alkalosis present on the ABG. Everybody, you are right. It is going to be mimicking loop diuretic use. The second one, Gentleman syndrome, on the other hand, is autosomal recessive inhibitory defect of sodium chloride cotransporter. Here also diuresis is there, but the characteristic feature is hypomagnesemia and hypocalciuria. There is no kidney stone here. Hypocalciuria is there. Here also secondary hyperaldosteronism can occur. So ABG findings are the same. But Liddle syndrome, autosomal dominant stimulatory defect of the epithelial sodium channel, leading to no hypertension and hypokalemia. But the hallmark is unmeasurable aldosterone level. Hence, it is called pseudo hyperaldosteronism. We are going to call. That's correct. Barter syndrome can be mimicked by loop diuretic use. Gentleman's can be mimicked by use of thiazides, and Liddle syndrome can be mimicked by use of steroid, because steroids are predominantly glucocorticoid, but when given in excess dose can act on mineralocorticoid receptor, that is ENaC, and lead to the feature similar to Liddle syndrome can be there, right? So moving on further to the topic of CKD. CKD are the high yield points. We want to know about chronic kidney disease. CKD staging is going to be done by using two parameters into 5 stages. That is eGFR, same as creatinine clearance, plus albumin urea. So in this, most common cause of CKD in the world is diabetes, both India and worldwide. Most common symptom of CKD are the uremic feature. Among the uremic feature, the common ones are neuropathy, gastritis, or uremic frost. Most common type of anemia is the normocytic anemia, because the mechanism is erythropoietin deficiency. But when we come to metabolic bone disease, the most common osteitis cystica fibrosa. But why does it occur? Due to both hyperphosphatemia with hypocalcemia, which causes secondary hyperparathyroidism, leading to cystic lesion in the bone. So most common anemia, normocytic. Most common bone disease, osteitis cystica fibrosa is there. What about acid-base balance? Metabolic acidosis is the most common defect in CKD. Yes, but in the early stages of CKD, you get normal anion gap metabolic acidosis only when the disease becomes severe, where the GFR drops below 25 ml per minute. Will the patient get high anion gap metabolic acidosis can be there, right? So coming to the indications for dialysis, you remember the acronym, the vowels A, E, I, O, U. You want to remember A for acidosis. There is E for the electrolyte imbalance, especially potassium more than 6.5. I for intoxication of the dialysable toxin. O for fluid overload, that is pulmonary edema. U for both serious uremic manifestation or severe azotemia, where urea levels are more than 100. So, irrespective of the cause, these are indications for dialysis in a patient with the chronic kidney disease. Clear everybody? So every topic nahi kar rahe na hum. Here's a revision which is likely to come and help you revise entire topic of nephrology. हमने कर लिया 10 मिनट में. चलो rheumatology try करते. Rheumatology, the most famous, most common rheumatology disease in practice is SLE. Also, it is also the commonest disease in our MCQ also. So, examiners of INICET are very partial to SLE, inflammatory arthritis, vasculitis syndrome. हम भी उसी पे फोकस करते हैं. चलो, आप मेरे साथ पढ़ते जाएंगे, एक एक करके उसको फिल करेंगे. ठीक है? Most common clinical feature of SLE is the synovitis. Most specific feature, malar rash or discoid rash. Which is the entry or essential antibody for diagnosis of SLE? ANA has to be present, at least more than low titer 1:80. Most specific antibody is going to be anti-Smith antibody, but the most preferred is the dsDNA because it is both diagnostic and prognostic in nature. That is why best preferred antibody for diagnosis of SLE. But when you come to the prognostic antibody, very commonly asked, when a patient of SLE presents with pregnancy and she is inquiring about risk to the fetus, which is antibody you will do to suggest or predict congenital SLE? The one, only one, is the anti-Rho or the SSA, which is the only antibody which can cross the placenta. To predict risk of neuropsychiatric feature, which one antibody will you do? You will go for the anti-ribosomal P. Go for anti-ribosomal P. For predicting thrombosis, patient is presented with recurrent abortion, venous thrombosis. You will check for the lupus anticoagulant, that is APLA. For hemolysis, patient of SLE presents with anemia and the patient is having hemolysis. You will think of the direct Coombs test. You want to do anti-erythrocyte antibody. In the treatment of SLE, what is the backbone of SLE treatment? Is the hydroxychloroquine, which must be given to all. Steroids can be given as per the severity. As we discussed one of them in lupus nephritis, when the disease is in crisis, you give IV methylprednisolone or you can start with oral prednisolone. But all patients of SLE must receive hydroxychloroquine therapy for maintenance of the immunosuppression. Done? चलो next वाला देखते हैं. Inflammatory polyarthritis. In the inflammatory polyarthritis का मतलब है there has to be involvement of more than equal to 5 joints should be affected. As I told you, inflammatory means one of the two should be given. Arthritis, which is associated with severe morning stiffness, or those which are relieved by exercise. More than 5 joint involvement is the polyarthritis. The most common cause of inflammatory polyarthritis is rheumatoid arthritis. Most specific antibody in RA is the anti-CCP, cyclic citrullinated peptide. The differential diagnosis for RA are the spondyloarthropathy, where the genetic association with HLA-B27. And what does spondyloarthropathy contain? The psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease associated, and the reactive arthritis. So please remember, indirect answer. Whenever a patient has inflammatory arthritis, has family history positive, it is not RA. When it is actually B27, it is not RA. It is one of the SPA. That is the psoriatic, ankylosing spond, IBD associated, or the reactive arthritis can be there. In the inflammatory polyarthritis further, what is most common feature of rheumatoid arthritis? What is the pattern? Articular pattern. They present as a symmetrical polyarthritis. Most commonly, typically you do the MCP squeeze test. Proximal interphalangeal joint and wrist involvement is there. Most common ocular feature of RA is the keratoconjunctivitis sicca. Remember, it does not cause uveitis. RA does not cause uveitis. The most common type of interstitial lung disease in all autoimmune disease is the NSIP. But in the patient with RA, it is the UIP, usual interstitial pneumonia. The most potent DMARD is going to be methotrexate, but the safest DMARD is always hydroxychloroquine should be given, right? So step by step we want to follow. That patient is having the multiple points are there. So I hope we are doing clear. So SLE, important lupus disease. Update we have written. New drug anifrolumab we have studied. Inflammatory arthritis done. Bringing us to the last page of our revision today, that is vasculitis syndrome. Vasculitis syndrome, important one. Start with the large vessel disease, giant cell arteritis. We have discussed 100 times giant cell arteritis. What is the thing? Post-menopausal female having the headache, jaw claudication, risk of blindness, and treated with high dose of steroid. That is our GCA. Also, we mentioned polymyalgia rheumatica is most commonly associated with giant cell arteritis. PAN is another important topic. Commonly asked, polyarteritis nodosa can mimic scleroderma and can mimic microscopic polyangiitis also. But what is unique? Medium vessel involvement, hepatitis B association, it causes hematuria, but never causes glomerulonephritis. That is the keyword here. In the GPA, also called as granulomatous polyangiitis or the Wegener's disease. What is the important keyword? C ANCA positive. Most common site affected sinusitis. There can be lung abscess and risk of RPGN can be present. The eGPA, eosinophilia with granulomatous polyangiitis or the Church-Strauss syndrome is typically adult onset asthma, peripheral eosinophilia, mononeuritis multiplex, generalized rash, and the anti-MPO antibody, myeloperoxidase antibody can be present. And in MPA, you get the P ANCA, that is the MPO, no granuloma, no eosinophilia, helps to differentiate between the two. So typical questions are all clinical based questions. You must look at pathology, medicine, and dermatology correlation. Some bit of pharmac also important in case of our two topics that we discussed. Right? So keep it simple. End of the day, answer is going to be in front of you. In the MCQ, one of the option is right. So don't be in a hurry to mark the answer. Think logically. How much ever you can think, analyze, look at the keywords that are given in the question and don't panic. Okay. All the very best to you. So see you on the other side as colleagues and not as students. Chalo, all the best.
Good morning, all of you. Good morning. Good morning, all of you. So we are live now, and we will be talking about the important topic which should definitely come in your exam. Okay. So let us talk about. What I'll do is I will be taking two important topics. Okay. So first, what I want all of you to know is about genomic imprinting. Okay, now remember, this is a very important topic and it comes in every exam of yours, and in fact the last INICET also this came. Okay, so let us talk about genomic imprinting. Okay, so first of all of you who are going for INICET should be aware about this micro deletion 15q 11 to 13. So remember 15q 11 to 13. So these three exons 11, 12, 13 are missing. Okay. Now remember guys, if you get this deletion from your deletion from the child gets Prader-Willi syndrome. Deletion from the child gets Prader-Willi syndrome. And if you get the same deletion from your child gets Angelman syndrome. Can you see this? Deletion from child gets a different disease. Deletion from the child gets a different disease called Angelman syndrome. So guys, you should know what is genomic imprinting. It is defined as differential expression of the genetic defect. Differential expression of the genetic defect based on the parent. It is based on the parent of origin of defect. It's based on the parent of origin of defect. So you got this defect from whom? From father or mother. So expression depends on the parent. Okay. So guys, just remember two more important points. And if I write here, let me first write about Prader-Willi syndrome. Maybe I'll go on a new page and I will write about Prader-Willi syndrome first. Prader-Willi syndrome 70% of the times is genomic imprinting. Okay. So remember, Prader-Willi syndrome 70% of the times is genomic imprinting, by which I mean deletion from the PA. Angelman syndrome 70% of the times is deletion from the MA. Okay. Now all of you need to know about uniparental disomy, that both of these disorders can also be transmitted by another inheritance called uniparental disomy. So 30%, remember, 30% of Prader-Willi is unimaternal disomy. So remember, whenever I say disomy, I will speak the opposite. So Prader-Willi is unimaternal disomy. Angelman 5% of the times it's unipaternal disomy. So Angelman 5% of the times it's unipaternal disomy. So remember, when we talk about disomy, we speak opposite. Okay? When we talk about disomy, we speak opposite. Okay? So all of you, can you hear me? So all of you, can you hear me? Okay, cool. So let's go further and so all of you, can you hear me? Any problems in the audio? Okay, so just rejoin. Okay, I think you will be able to listen to me once you rejoin. Okay, I can. Thank you everybody. Thank you. I think most of you can hear. Good. So what you need to know is that what are the clinical features of Prader-Willi syndrome and what are the clinical features of Angelman syndrome. So this is Prader-Willi on your left. It is the most common genetic obesity hypogonadism syndrome. Most common genetic obesity hypogonadism syndrome. So remember, children who have morbid obesity, child or adult, they also have hypogonadism. So this child has severe neonatal hypotonia. So he is hypotonic right from the beginning. Neonatal hypotonia, obesity, small hands and feet, and mental retardation. Okay, so severe neonatal hypotonia, obesity, small hands and feet, and mental retardation. So remember, they have hyperphagia. So because of the increased renin hormone, they have hyperphagia. Okay, hyperphagia. So remember, the treatment of Prader-Willi syndrome is giving them recombinant growth hormone and the anti-renin therapy. So remember, anti-renin therapies are successful for. So there is their experimental drug. Renin is the appetite hormone which is used in Prader-Willi syndrome. Okay, all of you. Now Angelman is happy puppet syndrome. They are known for their laughter. So Angelman is happy puppet syndrome. They are known for their inappropriate laughter. So they laugh a lot. Okay, they are known for their inappropriate laughter. So you should know Angelman is normal at birth, not like Prader-Willi, which has neonatal hypotonia. Angelman is normal at birth, but subsequently develops seizures, mental retardation, and ataxia. Okay, remember that. So all of you should know the most important examples of genomic imprinting. Remember, for the INICET exam, the examples of genomic imprinting are very important. So we have already discussed two examples today. We told you 70% of Prader-Willi and 70% of Angelman syndrome. But remember, you should also know about transient neonatal diabetes mellitus. It's a transient diabetes in a newborn. It's different from other diabetes. It's a transient neonatal diabetes mellitus. Number one. Number two, even Beckwith-Wiedemann syndrome can also have the same inheritance. Temple syndrome, Wang syndrome, W-A-N-G, Wang syndrome, Russell-Silver syndrome, okay, and pseudo-hypoparathyroid 1B, pseudo-hypoparathyroid 1B, okay. So all of these exhibit genomic imprinting, okay. Cool. So let us go further and let us show you a very important inheritance for your INICET exam. So anybody in the class, I know this is a slightly difficult pedigree. So we are showing you 6 generations. I'm not showing you their partners because they're not important. Can you find a trend here? Can you find a trend here, everybody? What is the trend here? So if father is affected, child gets the disease. If father is affected, children get the disease. But when mother is affected, whether she is affected or she is a carrier, children only become carriers. When mother is affected, or even if she is carrier, when she gives the disease, children don't get affected. Who gets affected? When father is affected. So this is genomic imprinting. Expression depends on the Pa. For example, this is a pedigree of, you can say, Prader-Willi syndrome. So for example, you can say this is a pedigree of Prader-Willi syndrome. Okay. Yes, this was a difficult pedigree, but remember, one question will definitely come in your INICET from this topic. Okay. Expression depends on the Pa. If Pa gets the disease, children are affected. If Ma gets the disease, children only become carriers. See, mother got the disease, she was a carrier, children became carriers. She got, even if here, if mother gets the disease, children don't get the disease. Children only get the disease when they get it from their Pa, like it happens in Prader-Willi syndrome. Okay. So guys, this is a classic case of Prader-Willi, and they will explain to you in your exam about obese, hypogonadism. See, his penis is buried in the scrotum. Hypogonadism. Small hands and feet. Small hands and feet. Almond eyes. Okay. Almond like eyes, like, badam like eyes. Almond eyes is classically Prader-Willi syndrome. Okay. So this question came in INICET, last INICET. Anybody in the class? A boy with developmental delay, progressive obesity, hypotonia, hypogonadism. What will you think of? And there is a deletion in the chromosome number 15, long arm, 11 to 13. 3 exons are missing, 11, 12, 13. Of course, you are right, Dr. Harshita and Dr. XYZ. The answer of this question is Prader-Willi syndrome. Cool. So now let's switch gears and let us talk about a very important topic from the latest guidelines and from the latest issue of the OPGY textbook. Okay, from the latest issue of the OPGY textbook on dengue. Okay, dengue is a very important topic, and sometimes you even don't know about the basics of dengue management in children. So next few minutes I will switch gears and I'll take you to dengue virus and the management in children. So let us talk about dengue. It is a arbovirus, flaviviridae. It's a flaviviridae. Remember, it's a flaviviridae dengue virus. Remember, it is a single-stranded RNA virus. There are 4 serotypes which you should know. 1, 2, 3, 4. Okay? Okay? 1, 2, 3, 4. Fine? So, which serotype of dengue causes severe disease? Remember, 2 and 3 has severe disease. Okay? Okay? 2 and 3 actually have, remember, severe disease. Okay? Now, what is the vector? Before I go into the details of the clinical presentation, the vector of dengue is the female Aedes aegypti. Female Aedes aegypti. Okay? Albopictus is less commonly. Domestic day-biting mosquito is Aedes aegypti, remember, which breeds in stored water, all of us know, which has a short flight range and it bites in the daytime. Okay. So what I need you to know is some basics which is asked in the INICET exam. What are the risk factors for dengue hemorrhagic fever and dengue shock syndrome? Who gets dengue hemorrhagic fever or shock syndrome? So remember, the virus strain we have told you the most important is 2, followed by 3, 4 and 1. 2 followed by 3, 4 and 1. Okay. Then of course, recurrences. If there is a pre-existing dengue antibody, young children, secondary infection which all of us are aware of, genetic predisposition and hyperendemicity. So like, you are living in a hyperendemic area. There are 2 or more serotypes circulating simultaneously. Hyperendemicity. So guys, you need to know about risk factors. Now, why are we talking about this today? Because somehow, most of you don't know about the classification of dengue. Okay. So let us talk about the classification of dengue. Okay. So look at this algorithm. Dengue. Now the classification is not 1, 2, 3, 4. We say dengue with warning signs or severe dengue. Dengue with warning signs or severe dengue. Okay. So warning signs. Let us talk about dengue, probable dengue and warning signs. Probable dengue. Probable dengue means a child is living in an endemic area and he got fever and 2 of the following. A child is living in an endemic area, he got fever and 2 of the following like nausea, vomiting, rash, aches and pains. Okay. Tourniquet test is positive. Leukopenia, any warning sign. So that's a probable dengue. Okay. Then there is a lab confirmed dengue, of course, when you are able to confirm it by NS1 or antibody. Now this is what I want you to know. Guys, warning signs. This came last year in your INICET exam also. Warning signs. And I'll again repeat today. Abdominal pain, persistent vomiting, abdominal pain, persistent vomiting, fluid accumulation, mucosal bleeding, lethargy, hepatomegaly, a rapid increase in hematocrit, or rapid decrease in platelet count. So rapid increase in the hematocrit, rapid decrease in the platelet count. Okay, so all of you should know that warning signs, and this came in INICET. Now all of us, when we are in the ICUs, we call it as severe dengue. Okay, we don't go into the term of DSS4 nowadays. We say severe dengue. Now what do I mean by severe dengue? It means there is evidence of severe plasma leakage which has gone into shock syndrome or fluid accumulation. This child has respiratory distress. So severe plasma leakage, number one. Severe bleeding. If it's MODS, multi-organ dysfunction, liver, OTPTs are more than 1000, kidney involvement, heart involvement, CNS examination shows altered sensorium. So remember, multisystemic dengue is severe dengue. Bleeding, severe plasma leakage. Okay. So I'll again repeat. Now I'll show you a snapshot from OPGY textbook, which again says that dengue with warning signs should be admitted, should get IV fluids, and the IV fluids of choice are crystalloid. IV fluids of choice are crystalloid. So I'll again repeat. Pain abdomen, vomiting, clinical fluid accumulation, mucosal bleeding, hepatomegaly, lethargy, rapid increase in hematocrit, or reduction in the platelet count. So why am I talking about this? Is because you need to know at least the basic of this. You start with mostly a ringer lactate. I would say ringer lactate followed by normal saline, 7 ml per kg per hour. This is the crux. 7 ml per kg per hour. Any dengue with warning signs whom you admit, he has these risk factors or warning signs, hospitalize, and start with at least 7 ml per kg per hour, and then over the next hour, look at the hematocrit, look at the clinical examination. If hematocrit is improving, you go to 5, then next are 3. But remember, you at least give him fluids for 24 hours. Okay, so at least give IV fluids. Since he had warning signs, you give him IV fluids for 24 hours. If he is improving, you give it for 24 hours and discharge after 24 to 48 hours. But if he is not improving, then you increase to 10, assess at 2 hours, again give a bolus, and then lastly, yes, even in dengue, you may lastly give colloids. Okay, you may give colloids if they are not improving after 5 hours. See, so 6 hours, we have given a bolus here, another bolus here. Okay, assess at 2 hours. So if you have given him multiple boluses, he is not improving, lastly you may go to colloids. Okay, so what I will do is, okay, I will just talk about severe dengue and I'll ask you 2 questions and then I'll stop. So even according to the OPGY textbook, I showed you the WHO protocol just now. Even the OPGY textbook says severe dengue has severe plasma leakage, severe bleeding, or multi-organ involvement, heart, kidney, brain, okay, or liver. OTPT is more than 1000. So if you have a patient with severe dengue fever, I just gave you the definition. So in your exam, they will give you a case and they will ask you what to do next. So if they give you a multisystemic disorder of dengue with shock, of course, if it's shock, you will give a bolus of normal saline or ringer lactate 20 ml per kg. So if it's unrecordable BP or hypotension, you have to give a bolus 20 ml per kg up to maximum of 3 boluses. Okay, so remember, in shock you will give boluses, and after that you will assess whether he needs inotropes or de-resuscitation. So nowadays, the era is we resuscitate patients by giving a lot of fluid, and after that, they get pulmonary edema. We have to then de-resuscitate them. So gradually, if the patient is improving in dengue shock, we reduce the ringer lactate. Now, I'll just lastly talk about three things. When do we give blood? We give blood in dengue shock if a patient is not improving and hematocrit is in fact falling. If a patient is not improving and hematocrit is in fact falling. Okay. So let me start with two questions which came in INICET recently, and this is the first question. A febrile child with positive dengue NS1, day 5 of fever, he has got no hypotension, no bleeding, platelets are 20,000. Yes, RL or normal saline can be given. Now, platelets are 20,000. What do we do? See, we will just give supportive care. Just give supportive care. I gave you the indication for blood. Dengue shock with falling hematocrit. Okay. Steroids, there is no evidence for steroids. Okay. The WHO protocol, even in India, we have a Ministry of Health and Family Welfare protocol. So the evidence is less for giving hydrocortisone. Now let us look at the OPGY textbook, what it says about platelets. So let's talk about platelets first. So OPGY textbook says there is little evidence to support platelets or FFP for severe bleeding. There is little evidence for giving platelets or FFP for severe bleeding. Only for massive bleeding you may give blood, and if you are thinking of DIC. Okay, so platelets, little evidence. Now blood transfusion is only given in refractory shock with declining PCV. Okay, refractory shock with declining PCV. Okay. Okay, and then I'll ask you the last question. See, the last INICET had two questions on dengue. Okay. So anybody? Dengue with warning signs. Remember the warning signs, and a rapidly rising hematocrit, falling platelet count is, of course, you'll start with RL or normal saline 7 ml per kg. Okay, so remember, at least remember. So today, what we did in this marathon session, we talked about a very important topic of genomic imprinting and uniparental disomy, which is often asked in your exams. Okay, and secondly, we also discussed that the tropical illness like dengue, chikungunya, they may also be asked in your exams. If you have doubts, feel free to tag me on any social media platform, and I wish you all the best for this marathon of INICET, and I'll see you on the other side when you are a doctor in one of the hospitals where I work, and we'll see you there as a different role in our life. Okay, so thank you, all the best guys, and I'll give my mic to the next faculty. Thank you.
So let me welcome you all to the radiology section of the INICET predictors. So are you enjoying the marathon revision on the YouTube channel? Give me a thumbs up in the comments if you're able to hear me and see me. Just give me a quick thumbs up in the comment box and make us know that you are there and make us know that you are ready to attack the exam. Can you just quickly let me know in the comment box? And I'm very excited to meet you all online live on the YouTube. So and I can already see your comments and fires, लेकिन ना मजा नहीं आ रहा, थोड़ा सा और फायर चाहिए मुझे चैट के अंदर. लग जाते हैं बेटा, लगते हैं एक बार, ठीक है कि नहीं? And I'll show you today how do we predict the exam and how do we go about the real exam. Let's make a plan today. मैं सबसे पहले ना, I'll, instead of revising things for you, I will do a quick analysis of what has been asked in the past in a few slides, and I will try to show you some prediction on the basis of what has been asked. And I'm sure many of you have attended my boot camp of AIMS, my previous sessions, and I'll try to do some things for you. और आग लगा के आनी एग्जाम में बेटा, मेरा हर बच्चा जीत के वापस आएगा बेटा, ठीक है कि नहीं? वी आर हेयर टू विन द मैक्सिमम, ठीक है? मैं चाहता हूं हर बच्चा जाएगा एग्जाम के अंदर, डू योर बेस्ट. ये ना बात मेरे पास कोई लेके नहीं आएगा कि एग्जाम से डर रहे हैं, डर नहीं रहे, जीतने के लिए जा रहे हैं. यू आर हेयर टू डू योर बेस्ट. मैं चाहता हूं मेरा बच्चा पेपर के बाद आके बोले मेरा पेपर बेस्ट हुआ सर, रिजल्ट उसके हाथ में जो हम सबसे बड़ा है. बट आई वॉन्ट यू टू डू योर बेस्ट. अपना बेस्ट दे के आओगे, प्रॉमिस कि नहीं? प्रॉमिस? ओके, सो लेट्स स्टार्ट विद द फर्स्ट क्वेश्चन. द फर्स्ट क्वेश्चन दैट आई वांटेड टू ब्रिंग टू यू इज दिस. दिस इज वन ऑफ माय प्रेडिक्टर्स. This is a very favorite topic, only asked in INICET. Only asked in INICET, बेटा, और किसी एग्जाम में नहीं पूछते. You now need to tell me what is the MRI technique shown to you and why it is used and in which conditions it is used. What is the MRI technique shown to you and why it is used and in which conditions it is used? Quickly answer in the chat box. बता दो दुनिया को कि तुम हो वहां पे. Okay, so that is, tell me. Anyone? Name the MRI technique. This is not NCC beta. No, no, no. This is SWI. Only in the history of PG entrance, this image has been asked only in INICET paper. और कहीं नहीं पूछी गई. This is SWI. What is SWI? Susceptibility weighted MRI. Susceptibility weighted MRI. Can you now tell me on SWI what are these dark dots? ये जो डार्क डॉट दिख रहे हैं ये क्या है? These dots indicate presence of hemosiderin. Now tell me, why would you see hemosiderin anywhere in the brain? This is not toxoplasma beta. Hemosiderin क्यों दिखेगा कहीं पे भी? Hemosiderin tells me that these are the locations of chronic bleed. And this is what we look for if a patient is persistently comatose. Again, a favorite INI question. A patient is persistently comatose after high-speed motor vehicle accident. What do you call the condition? Diffuse axonal injury. And similar petechial hemorrhages can also be seen in patients with cerebral amyloid angiopathy. Cerebral amyloid angiopathy. So remember now, patient is persistently comatose after a high-speed motor vehicle accident. Which investigation will you do? MRI. Which MRI sequence? SWI. Why? Because it can show me hemosiderin. What does hemosiderin mean? It means presence of chronic bleed. Chronic bleed. And I can already see you are rocking the show, beta. जो लोग यहां नहीं है उनको पता रहना चाहिए कि टॉपर इसी YouTube चैनल के कमेंट में बैठे हैं. ओके. Second predictor always asked, anyone identify the brain hemorrhage? Okay, identify the brain hemorrhage and the source. You know this is EDH, source, middle meningeal artery. Trick question for INICET. Can this be venous? Can a EDH be venous rarely? Yes or no? क्या EDH आप सब जानते हैं आर्टीरियल है. आईना में बोले वीनस होता है कि नहीं होता? A+B करेक्ट कि नहीं? बोल. So can it be venous? Yes. Less common, but it can be venous. Which location? anterior temporal location. Yes, very good. I can see those. Yes, very good. I said middle meningeal artery, not your mama beta. Okay, I see some chats with typos. Okay, anyone? How will you manage it? Previous INI question. The correct answer is craniotomy with evacuation of hematoma. This is the last year's INI question. If you have a EDH, you need to do a craniotomy with evacuation of hematoma. This is the image, this is the management, this is the artery. Middle meningeal artery enters the skull through. Middle meningeal artery enters the skull through foramen spinosum. बहुत बढ़िया. Okay, let's see and answer another question, beta. Anyone try? This is the next predictor I was talking about. वो तो पिछली बार आ गया, ये है अगली बार EDH में अगर रिपीट करना है जो अभी तक नहीं आया. This is the question. This is another example of EDH. In this EDH, you can see some dark areas of blood and some white areas of clot. What does this sign mean? ये साइन का क्या मतलब है और ये क्यों दिखता है EDH के अंदर? Can you tell me in the comment box? The hemorrhage, a blood clot, should be white. But in this image, the blood clot is white, but the unclotted blood is appearing dark. Why you see such an appearance? And I can already see the activity in the chat is telling me it is swirl sign. There is presence of unclotted blood within, which tells me there is active bleeding within a EDH, which tells me that the patient is still bleeding during the CT scan. It is an expanding hematoma. We need to urgently treat surgically. I will ask you another question, beta. It is not chronic bleed. जो chronic सोच रहे हैं chronic नहीं है बेटा, ये active bleeding हो रही है EDH के अंदर. Okay, so this is called a swirl sign. Predictor. EDH is a sure shot INI question. They love asking head injuries. ये नहीं आया अभी तक. To mark it. And I am the only person saying अभी इसको और चैनल में शेयर मत कर, अपने फ्रेंड्स को मत बता. वो बाकी बोलेंगे फ्रेंड को बता. अरे भाई मैं कह रहा हूं कि जो हम बता रहे हैं, वी आर वर्किंग वेरी हार्ड इन दिस मैराथन. वी हैव हैड अ ह्यूज हार्ड वर्क डूइंग. लास्ट नाइट 2 o'clock I finished these slides for you. मैं कह रहा हूं कि वी हैव वर्कड वेरी हार्ड. ओके, कीप इट टू योरसेल्फ. ओके, एनीवन? लेट्स सी. Swirl sign on CT, active bleeding in EDH. Very good, beta. Now question to you is, let's see, any one of you can answer this, beta. An alcoholic has poor liver function, deranged clotting, comes to you with reduced consciousness following minor head injury. Anyone? Now मेरे साथ देखना बेटा, सभी बच्चे एक बार देखेंगे and try and answer this. This blood clot is appearing white. This is dark white in a subdural hemorrhage. Why is this patient having a mixed appearance? Why is this blood clot having mixed appearance? SDH तो है, आपने बताया SDH है, but why it is mixed? Some part is clotted, some part is not clotted. This is something that we discussed in EDH also. This is clotted, unclotted blood together. This means this is a hyperacute SDH. Further, he is an alcoholic. He has deranged clotting. They will not write deranged clotting. वो बोलेंगे alcoholic है, liver function problem है, reduced consciousness है, minor head injury है. EDH होता तो it would be major head injury. SDH minor head injury, reduced consciousness, and this is a hyperacute SDH. Now this is not chronic. मैं वही बच्चे आपको बताना चाह रहा था जो बिस्ट, आप जो ऑनलाइन बैठे PR बिस्ट. This is not chronic. Chronic के लिए मैं दूसरी स्लाइड लाया हूं बेटा, देखो. This is how SDH progresses. These are NEET PG last 2 years questions you might appreciate. Acute SDH appears hyperintense, concavo-convex due to rupture of bridging veins. But after a month or so, it becomes isodense. I may call it subacute. It becomes isodense to the brain parenchyma. You cannot appreciate it. After 2 months or so, it becomes hypodense and it becomes a chronic subdural. This is a chronic subdural. This is a acute subdural. This is a subacute subdural. Are you able to understand this? In between, it becomes isodense to the brain parenchyma. You can see it becomes just like the gray matter of the brain and you can no longer appreciate it. The density of brain hemorrhage reduces with time. So my question to you is this. Let us see if you can answer this question. And I wanted you to answer this question now. Many of you had this idea before. This patient had a minor trauma history. Recently, his drowsiness has increased. This is one of my predictors for subdural. Extradural तो आ ही रहा है ना. EDH का सब वो मैंने बोला स्वर साइन है. SDH में इमेज ये होगी बेटा. Now look at this image and tell me. You can now see the brain hemorrhage is appearing dark because this is a chronic subdural unilateral bilateral. Yes, लेकिन फिर white area बीच में layer की तरह क्यों इकट्ठा हो गया? And why has his drowsiness recently increased? Anyone? This is the predictor that they have not asked so far. This tells me this patient has a rebleeding happening in a chronic subdural, acute on chronic bleed, which is now all of you topper are telling. ये खाली chronic नहीं है ना, chronic होता तो dark था ना, फिर ये blood की layering क्यों आ गई इसमें? Why do you see this hyperdense layering in it? Because this is an acute on chronic bleed, इसलिए उसकी recently drowsiness और बढ़ गई. This has not been asked in the thread so far. They love brain hemorrhages. And these are my predictors from extradural and subdural hemorrhages for your exam. But they love cute signs. Let us see any one of you in the comment box. जो पहले बोलेगा वही best pooky बच्चा होगा. Let's see if you can tell me here or not. What is the sign shown on the patient in the MRI brain? He has some neurological symptoms, some brain problem, some liver problem, some lens problem. The sign is, anyone, is panda sign. Panda sign. Yes, yes. Face of giant panda seen in Wilson's disease. Wilson's disease. Face of giant panda. Wilson's disease. बिल्कुल बढ़िया. इससे बढ़िया मैंने आज तक बच्चे नहीं देखे. Okay, anyone. Now I want you to look at the next image. अब जो पांडा बता रहे थे ना पांडा, अब वो बताएंगे टाइगर. एनीवन? Eye of the tiger sign on MRI brain seen in PKAN. PKAN, also called as Helleverdon-Spas disease. सर ये तो पहले आया हुआ बताया ना आपने. बिल्कुल ठीक है. So the same question, the next predictor is, what will the patient present with? ये patient डॉक्टर के पास क्यों आता है? Anyone? Why does a patient of pantothenate kinase associated neurodegeneration come to the doctor? What is the symptom? The symptom is dystonia. Dystonia. ठीक है? So I have personally diagnosed 2-3 patients where I have made the diagnosis of a patient, young patient who came with dystonia. Can you keep this in mind? Dystonia will be the presenting complaint. Second question, what is happening and where it is happening? Why do you see eye of the tiger appearance? हो क्या रहा है? हो क्या रहा है? Anyone? There is iron deposit in the globus pallidus. Iron याद रखना बेटा. Iron deposit in the globus pallidus leads to the eye of the tiger appearance seen in PKAN. PKAN. Very good. Iron in the globus pallidus. अभी ना पांडा हो गया, टाइगर हो गया. एक बर्ड बता दो बेटा. Because they love asking one-liners. INICET, they love asking one-liners on neuroimaging. They love asking one-liners of radiological science directly in the block. Anyone? Look at the bird. Hummingbird appearance. Can you tell me now in which condition do we see hummingbird appearance of your midbrain? Can you name the condition? Progressive supranuclear palsy. Which part of the brain is atrophied in progressive supranuclear palsy? Midbrain atrophy. What is the appearance called as? Hummingbird sign. Hummingbird sign. Can you mark it now, everyone? Yes, yes, yes. Abhi ENT. The next my predictor is, in the INI paper, they are finding hidden topics from ENT and asking in an image-based question. Can you tell a man with a pulsatile neck mass, carotid angiogram shown to you? Pulsatile neck mass, carotid angiogram is shown to you. What is the sign? What is the sign and why it is seen? Anyone? This is called as liar sign. Seen in. Bolo beta. carotid body tumor. Carotid body tumor, paraganglioma, and chemodectoma is this called a liar sign. Very good. I can super see all of you. Okay, anyone? Name the sign seen in a young male with epistaxis in the image. Epistaxis हो रहा है उसको. Anyone? We know this is the Hallman-Miller sign of juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma. This is the maxillary sinus displaced anteriorly by the tumor. What you should not do? Do not do biopsy. Do not do biopsy. But what you need to do? You need to do pre-op angioembolization to reduce the bleeding during the surgery. You will do a pre-op angioembolization to reduce the bleeding during surgery. This is the role of interventional radiology in this kind of tumors. Okay. Now I will show you another new question based on the logic that they are going into the ENT aspect of radiology. Let us try to see. In this patient, this is an X-ray of the sinus. Can you now look at this radio-dense structure? Can you see this dense white lesion in the frontal sinus? What is it? And why? Can you tell me the diagnosis on this? Anyone? This is Waters view. Definitely, I am so proud of all of you, beta. Waters view. ठीक है बेटा. INI पेपर चल रहा है. बीमारी भी बता भाई. खाली वाटर व्यू काफी नहीं है. अब ये बता क्या दिख रहा है? There is a dense white lesion in the frontal sinus. This is called as frontal sinus osteoma. This is called as frontal sinus osteoma. कर लोगे? Okay. Can you tell me, any one of you can tell me quickly. देखो ये जो पॉट्स पफी ट्यूमर कह रहे हो ना वो अलग है. वो तो एक सब पेरियोस्टल एब्सेस है ना इस एरिया की. ये तो ट्यूमर है जो बोन बना रहा है. ओस्टियोमा है जो बोन बना रहा है. So I don't know, you are only looking at the location, you are not seeing. This is sinus osteoma. Frontal sinus is a classic location of a osteoma. Can you now tell me any condition in which you read about skull osteomas and colonic polyps? Connect the dots. कोई ऐसी बीमारी बताओ जिस स्कल में साइनस में ओस्टियोमा होते हैं, कोलन में पॉलिप होते हैं. ऐसी कोई? Any connect the dot? Can you do it? Then the answer will be Gardner's syndrome. Then the answer will be Gardner's syndrome. Are you able to do it now? Gardner's syndrome. ठीक है. टर्कॉट में ब्रेन ट्यूमर होता है बेटा. अगेन यू नो आई सी रोशन, यू नो आप कह रहे हो टर्कॉट में तो ब्रेन ट्यूमर होता है. डॉक्टर फॉर हेल्थ ऐश बेटा भी एक हफ्ते में पेपर है. Do you remember? Do you agree or not? Turcot syndrome, you have a brain tumor, not a skull tumor. Do you agree or not in the chat, anyone? So we are looking at Gardner syndrome. Yes, everyone? Okay. Anyone? Now I am increasing the difficulty to, okay. So brain tumor like glioblastoma, medulloblastoma, those are, so they don't want to ask you radiology. They want to see the connect that अभी आया नहीं पेपर में, नया आया, एक्सरे दिखा दिया, तुम बोलोगे रेडियोलॉजी में नहीं बताया. रेडियोलॉजी में क्या, पैथो से तो कनेक्ट करना है ना. ओके, आर यू नाउ क्लियर? अभी एक हफ्ते में पेपर है, कंफ्यूज कैसे हो रहे हो बेटा? अभी तो टाइम आया जीतने का बेटा. आई वॉन्ट ऑल माई चिल्ड्रन टू हैव दैट थिंग इन योर माइंड. जब मैंने डैम्स का लोगो बना, मतलब अल्फा बनना है, जीत के आना है यार. हम हारने के लिए नहीं जा रहे हैं, हम मजाक नहीं कर रहे. वी आर हियर टू विन द गेम बेटा. मेरा हर बच्चा ये पेपर जीत के आएगा बेटा. I am again telling you, look at this X-ray. This question, new question I have created for you. This question I made at 1 a.m. in the night. A patient has hoarseness of voice, laryngeal tumor, laryngoscopy shows supraglottic mass. Which imaging modality is superior for pre-epiglottic space and cartilage invasion? क्या करोगे? Cartilage देखने के लिए, and this is again a previous INI type of question, MRI किया जाता है. To see the cartilage in laryngeal cancer invasion, MRI is better than a CT. MRI, PET वेट जो करते हैं ना, ज्यादातर बच्चे PET मार्क करके आएंगे. PET करते हैं डिस्टेंट मेटास्टेसिस के लिए. MRI सुपीरियर टू सी द कार्टिलेज इन्वेजन. ठीक है जी, कर लोगे? ओके बेटा. सेकंड क्वेश्चन, दे लव एब्सेसिस. So can you tell me, do you see a cavity like lesion in this chest X-ray with air fluid level? क्या आपको एक कैविटी की जैसी बीमारी दिख रही है? इसमें एयर फ्लूइड लेवल है, यस और नो? देख पा रहे हो कि नहीं? यस बोल दो कौन है? इसका नाम है लंग एब्सिस। इसका नाम है लंग एब्सिस। लंग एब्सिस इज ऑलवेज अ प्रिडिक्टर फॉर बोथ नीट पीजी एंड INICET पेपर। लंग एब्सिस मतलब कैविटी में एयर फ्लूइड लेवल दिखा, एब्सिस मार्क करना है। सो वंस यू आर एबल टू डू इट, दे लाइक रेस्पिरेटरी ऑल्सो नाउडेज। पहले समय में ना दे यूज्ड टू आस्क मोर कार्डियोवैस्कुलर, more of neuro. Nowadays they are asking more respiratory. So in respiratory I thought what test you should do for characterizing interstitial lung disease. What test you will do for characterizing interstitial lung disease? The test you will do will be HRCT. वो टेस्ट होगा HRCT। HRCT, इस HRCT में फाइंडिंग क्या है और पैटर्न का नाम क्या है? अब बोलो बेटा, anyone? I want all of you to tell me what is this finding marked by the arrows. ये जो मैं एरो लगा रहा हूं ये क्या है? Touching the pleura, subpleural lung base shows honeycombing. I saw some of you saying crazy paving. नहीं है बेटा ये crazy paving. This is honeycombing. Honeycombing touching the pleura. Basal subpleural honeycombing. Honeycombing means irreversible fibrosis. जहां पे fibrosis है ना, that area will pull. That area will pull. And it is pulling the bronchi. This is traction bronchiectasis. Traction bronchiectasis. Connect the dots. Connect the dots, beta. UIP will be the answer. Usual interstitial pneumonia pattern. Prognosis poor. Prognosis poor. This is UIP pattern. If idiopathic, if there is no cause, we will call it idiopathic pulmonary fibrosis. Crazy pavement नहीं है, वो alveolar proteinosis में होगा, उसमें ground glass opacity and septal thickening होगा. Okay, beta. Another of my predictor. Let's see how many of you can tell. A patient was undergoing in ICU central line insertion. This is something you don't get to know, but when you put a central line, there is a possible complication. You might puncture the apical pleura and you develop deep sulcus sign. What are you thinking? Anyone? Central line insertion is the first clue in the question. Supine X-ray shows deep sulcus sign. What has happened? What has happened? Pneumothorax. So this takes into consideration all the style of INI question. Reason for pneumothorax, sign but in a supine film. On a erect X-ray, they have asked the tension pneumothorax in the past. They have shown you the pleural line sign, barcode sign in the past. This is my prediction. This is my prediction for the pneumothorax now. This is the topic that they are not touching, that it might be a complication in ICU of central line insertion. Can you mark it now? Okay. A gadolinium based contrast should be avoided if estimated GFR is below. Anyone? Contrast material you are ignoring. INI paper, they love contrast material. Anyone? Gadolinium based contrast should be avoided if the estimated GFR is. Anyone? Is less than 30, less than 30. If it is less than 30 and you give gadolinium, what is the risk? Nephrogenic systemic fibrosis. If you give gadolinium, you will cause NSF in these patients. Gadolinium, can you give in pregnancy or cannot give in pregnancy? Contraindicated in pregnancy. MRI is safe in pregnancy. Mark my word, possible question for your next exam. प्रेगनेंसी में MRI कर सकते हैं. जो बच्चे कॉन्ट्रास्ट नेफ्रोपैथी कह रहे हैं ना, सब गलत है बेटा. कॉन्ट्रास्ट नेफ्रोपैथी आयोडीनेटेड कॉन्ट्रास्ट से होती है, गैडोलिनियम से नहीं होती. गैडोलिनियम कॉजेस NSF. समझ पा रहा है कि नहीं? रजनी एंड ऑल दोस पीपल बेटा जो लिख रहे हो चैट में. अभिनव बेटा मैं देख रहा हूं गलत जा रहे हो तुम. कॉन्ट्रास्ट नेफ्रोपैथी इज ड्यू टू आयोडीनेटेड कॉन्ट्रास्ट. Gadolinium based contrast are not given if your eGFR is less than 30, otherwise you develop NSF. आया नहीं है अभी तक. अब बाकी लोगों को आने के बाद पता चलेगा गलत मार्क कर दिया. ये आंसर है इसका बेटा, NSF हो जाएगा. एंड सेकेंड, gadolinium based contrast should be avoided in pregnancy. याद कर लो, whenever you do MRI, it is safe in pregnancy, but contrast material is not safe in pregnancy. अभी तक नहीं आया, यही आएगा. So these are our predictors based on the pattern. They like to go into the safety of the radiological tests and contrast material. I'll tell you a few previous question. ultrasound based contrast are made up of microbubbles and they are safe in renal failure. True or false? True. Ultrasound contrast are made up of microbubbles and they are safe in renal failure. Correct. Previous INI question, you do the PYQs, you will find it. But ye nahi aayega na. The problem that most students are thinking is they will ask the same questions again. They tend to go into the same topic again. That is the key. Now I can see you getting on to it. My predictor now. In which condition do we see late gadolinium enhancement? This is my predictor on cardiac MRI. Never asked in the history of our country so far, but very trending in the world of radiology. Let's see if you can answer. Anyone? And there is a reason for my telling you this is. My reason is, if you've attended my recent DVT, I told you the reason why we give contrast media. We give contrast media to see inflammatory tissue or a neoplasm. These are the tissues which have more vascularity and they enhance. Okay. So when you look at this question, it may be say tissue enhance kar raha hai, it might be a neoplasm, might be inflamed. But in heart, in myocardium, it is the dead tissue which shows late gadolinium enhancement. It is a paradox. So it is a myocardial scar which shows late enhancement. It is a paradox. बाकी बॉडी में एनहांसमेंट मिल रही है, इसका मतलब वेस्कुलरिटी बढ़ गई है. हार्ट में अगर लेट गैडोलिनियम एनहांसमेंट एमआरआई पे मिलता है मायोकार्डियम के अंदर, इट टेल्स यू आई एम डीलिंग विद अ डेड टिश्यू. एंड पैराडॉक्स आर लव्ड बाय कॉम्पिटिटिव एग्जाम. उनको नहीं जानना कि तेरे को थ्योरी कितनी आती है नहीं आती, उनको जानना है कि अगर तू ऐसा सोचेगा तो वो गुगली पड़ जाए और गलत हो जाए. मतलब तुझे लगे ट्यूमर है क्योंकि एनहांस हो रहा है, तुझे लगे इन्फ्लामेशन है, पेरिकार्डाइटिस है, नहीं, इट इज अ स्कार टिश्यू. Subendocardial tissue of the myocardium will show late gadolinium enhancement on cardiac MRI if it is a scar. Mark my words. Anytime it is asked, even if you are a DM entrance candidate, please keep this in mind. It is a possible NEET SS question also, because most residents would think like this. A contrast should be given for hypervascular lesions like inflamed tissue or neoplasms. But scar is very important. Contrast MRI in myocardial scar shows late gadolinium enhancement. And I can see some of you are answering correctly also. Now I come to the most important set of ENT predictors now. And I want all of you to see this area, this area, this area, beta. This patient has pain in the neck and the skull, painful sensation in his throat, painful sensation in his throat, CT scan shown to you. Painful sensation in the throat, CT scan shown to you. What do you think is this structure marked for you? Phelps sign nahi hai Heyman beta. This is not Phelps sign. Phelps sign hota hai beta in glomus tumor. Phelps sign is in glomus tumor. This is not Phelps sign. Neurofibromatosis 2 nahi hai beta ye. Random ja rahe ho beta. Ab socho, if I now tell you that this is your styloid processes which are elongated, causing painful sensation in the throat. Can you now think ऐसी कौन सा condition है इसमें styloid process, stylohyaloid ligament? Can you tell me causing that painful sensation? Eagle syndrome. And I can see some eagles flying in the comment. Well done all of you. These are the styloid processes. सोचना नहीं बंद करना. ये नहीं सोचो कि याद करके आयो कि नहीं आयो. नहीं बनेगी बात बेटा. We need that common sense on the mark in the paper बेटा. ठीक है कि नहीं? The eagle syndrome, the elongated styloid processes, one of my predictors. Had never been asked so far, but my predictor. Another one of my predictors is this. In this patient, this is your posterior circulation. This is your vertebrobasilar artery. I am doing an angiogram through the vertebrobasilar artery and I can see a lot of collateral forming. These collaterals look like puff of smoke. These collaterals look like puff of smoke. And my nahi beta, I want you to say it right. Then it is your moya disease, puff of smoke appearance. Smoke in Japanese is called as moya. So say moya moya, dhua dhua. So these are collaterals which are forming because both the internal carotid arteries have progressive stenosis. Both the internal carotid arteries have progressive stenosis. This is puff of smoke appearance on angiogram, moya moya disease. Okay, I am showing you a history given to you. My predictor of a question. Let's see if any one of you can tell me here or not. A patient comes to you with reduced level of consciousness following open reduction and internal fixation of a femoral fracture 5 days ago. History is fracture of long bone, reduced consciousness, open reduction, internal fixation done, and diffusion weighted MRI is shown to you. What do you think has happened to his brain? ये ब्रेन में छोटे छोटे बहुत सारे इन्फार्क्ट क्यों हो गए? What has happened? What has happened? And this sign is called as star field sign. This happens because of fat embolism. Again, one of my predictors, because it is a upcoming thing in the radiology circles. Every time we go to a radiology event, we talk about these things. So fat embolism is a very important thing, especially if a patient has a long bone fracture and internal fixation has been done, further increasing these chances. He has reduced level of consciousness and his diffusion MRI shows a star field pattern. This is a sign seen in fat embolism. Very good. I can already see many of you are answering correctly, beta. Ek aur. A patient who is a known case of ulcerative colitis. Ulcerative colitis is a chronic inflammatory bowel disease, should go to the OPD. Now comes to the emergency. A patient who is a known case of ulcerative colitis comes to the emergency and a X-ray shows you a dilated transverse colon which is ahaustral. A dilated transverse colon which is ahaustral. Can you tell me what is the complication which has happened in the emergency? What is the complication that has happened in the emergency? This is called as toxic megacolon. Toxic megacolon. Can you keep it in mind? Complications, emergency conditions, they love asking. This is called as toxic megacolon. Now, I also want you to know what is happening globally. Recently, in the USMLE exam, they have given more focus on nutrition as a topic in the exams. Okay? And nutrition is now increasingly important for doctors to know. We cannot let influencers tell us about nutrition all the time. We doctors need to tell about nutrition. So I thought I'll put one new question based on nutrition for you. A strict vegetarian has ataxia, loss of vibration, tingling in both feet. MRI shown. What MRI finding do you expect and why is my question? We are thinking of vitamin B12 deficiency. And you will see a inverted V sign, hyper intensity in the posterior column. अभी वर्निक्स आ गया पहले. वर्निक्स एंसेफेलोपैथी सबको पता है. कंफ्यूजन ऑफ थर्मोप्लीजिया, अटैक्सिया रट ले, नहीं जीत पाएंगे. To win the game, I need to go beyond others. B1 हो गया, B12 कौन करेगा? वो करके जाएंगे बेटा. Okay. Now I want you to see the sagittal MRI. On the sagittal MRI, can you see the dorsal column of the spine is bright? On the axial section, a V-shaped hyperintensity is seen in the dorsal column. This is the inverted V sign of subacute combined degeneration of the cord that you see in B12 deficiency, and the symptomatology was also helping loss of vibration, and the classic symptoms of B12 deficiency are mentioned in the question. But the touch and the tadka to the question is I put a MRI in the picture. So that is how we build a new question, still remaining in the radiology domain, but going into the topics which are far more important, like nutrition for your INI paper, which most people are missing out on. Another of my prediction is, like we did one question on ulcerative colitis, let us do one question on Crohn's disease. Patients with Crohn's disease can develop perianal fistulas. Patient with Crohn's disease can develop perianal fistulas. Remember, mesenteric hyperemia leading to increased vasa rectae in the mesentery leading to comb sign, creeping fat, string sign of Cantor, transmural inflammation, skip lesions are typical of Crohn's disease, perianal fistula. But what will you do to evaluate a perianal fistula? The answer is not D, beta. Answer is not X-ray difficogram. वो पुराना क्वेश्चन है जो तू देख के आ गया, गलती हो गई. Answer is not CT, beta. नहीं बेटा, नहीं. SK बेटा नहीं, गलत हो गया. Answer is MRI. Perianal fistulas, today we prefer to do a MR fistulogram to see the relationship of the fistula to the sphincter. भूल गए क्या? Most common variety of the sphincter is intersphincteric, seen on MRI. Every day MR fistulogram is done in your hospitals for perianal fistulas. Again, one of the possible questions in the exam. Perianal fistula, सब सोचेंगे CT ये ट्रांस करना है, एक सबसे लंबी चॉइस देखे कुछ बच्चे तो इसको मार्क करके आ जाएंगे. वो नहीं है आंसर. आंसर है MRI pelvis. Can you do it? Yes. Okay. Final predictor. I have two more predictors in this image. Last time, I don't know if you saw this or not, they have asked this question. ठीक है बेटा, कर लोगे? Identify the structure marked in the image. आधे बच्चे बताओ ये body part कौन सा है भाई? This is HRCT of the temporal bone. कर लोगे कि नहीं? HRCT of the temporal bone. Yes or no? Yes, HRCT temporal bone. And the arrow is at the internal auditory canal or internal acostometers or internal auditory canal. This is the area through which your 7th, 8th nerve are passing. This is your internal auditory canal. Can you mark it in the exam? Okay. Then what is this on the side visible? ये तो सब ने देख लिया, पिछली बार के क्वेश्चन सब याद करके आ जाएंगे. साथ पे तो देख ले अगली बार के लिए. Okay. This is your middle ear. Now my prediction to you is, can you see a ice cream cone appearance in the middle ear? In the epitympanum, in the attic of your tympanic cavity, can you see a ice cream cone like appearance? What is this? Incudomalleolar joint. कई सारे बच्चे ना वेस्टिबुलर शोनोमा मार्क करेंगे, वो सीपी एंगल पे होता है, मिडल ईयर के अंदर नहीं. If you see a ice cream cone appearance in the middle ear, in the epitympanum, this is your incudomalleolar joint. And my question to you is, before I hand over to Dr. Deepthi, is this is the area of your mastoid, this is the entry to the middle ear. Can you see how your mastoid is connecting to the middle ear? Do you see that? Editus ed antrum that you read in your anatomy class. This is the area where you see this. Okay. But I wanted to just to show you why this is also important. Most people in your medical school are not doing it with the clinical relevance in mind. याद तो कर लिया आइसक्रीम कौन दिखेगा, लेकिन फायदा क्या उस बात का? अभी इसके दूसरे कान में देखते हैं. Are you able to see this is the soft tissue lateral to that area that I showed you. जहां आइसक्रीम कौन दिख रहा था ना, उसके laterally soft tissue दिख रहा है. Eroding the bone, eroding the ossicles, soft tissue dikh raha hai. What is this space called as? And if you see soft tissue in this space, and I'm sure you have seen it in your ENT class also, can you now tell me, anyone, can you understand this or not? कोई यहाँ soft tissue दिख रहा हो, इसे कहते हैं cholesteatoma, eroding the bone. What is that space? I just want one final answer from you. What is that space called as that you read in ENT? That is just an add-on thing. So this is how CT helps you. In unsafe C, this is space of Prusak space. Very good. I can already see the brilliant bachas here. Rank number तुम्हें define नहीं करते, तुम उससे बेहतर हो. I can already tell you, I can see great doctors in the chat today. बहुत बढ़िया कर रहे हो तुम लोग. अब मैं ये जानना चाहता हूं, why do you do a CT temporal bone? To see the ossicles, to see the unsafe CSOM, to see the, tell me, fractures, and any other indication for doing a CT scan? Bony labyrinth. Membranous labyrinth will be seen on MRI. Nerves will be seen on MRI. Bony labyrinth CT scan. That is why in hospital we do HRCT temporal bone. पहली बार INI के पेपर में पूछा गया इंटरनल ऑडिटरी कैनाल HRCT temporal bone लास्ट ईयर में. उससे पहले कभी नहीं आया. लोग देख ही नहीं रहे, वो याद कर रहे हैं. मैं कह रहा हूं ये देख ले, साथ में आइसक्रीम कौन पड़ा है, कांच तक नहीं आया. दिस इज द प्रेडिक्टर फॉर नेक्स्ट ईयर पेपर. So let's hope for the best. We have given you our best and we are with you with the final marathon. छोड़ के मत जाना, सारा अटेंड करना, आग लगा के आना, give a good paper, come back. We are very proud of you. And don't forget, as teachers, we love all of you irrespective of the results. We love all of you irrespective of the results. Do your best, but don't let the result define your self-worth. We love you all. God bless you. Let us do a final question and I'll ask Dr. Deepti, she's already in. Okay, final question. A patient has Ewing sarcoma. What imaging modality? Ewing sarcoma last year था कि नहीं था? था ना बेटा, तो मैंने नया क्वेश्चन बना दिया. Which imaging modality can show you bone marrow involvement, skip lesions in Ewing sarcoma? What will you do? लास्ट ईयर पूछा था ना, ईविंग्स का शक है कि ईविंग्स है कि ओस्टियोमाइलाइटिस है, क्या करोगे? वैसे ही मैंने डाल दिया ईविंग्स है तो क्या करोगे? एमआरआई इज द आंसर. एमआरआई इज द आंसर. ज्यादातर बच्चे सोचेंगे बोन ट्यूमर है, सीटी करना है. दैट इज नॉट करेक्ट. द बोन मैरो इन्वॉल्वमेंट, सॉफ्ट टिश्यू इन्वॉल्वमेंट will help me to see if it is a sarcoma or an infection. I need to do a MRI, not biopsy. MRI, MRI, MRI. Well done. Super proud of all of you. Keep reminding yourself, अपना टाइम आएगा नहीं, अपन खुद लाएगा. Handing over to Dr. Deepti. Thank you so much.
Hanji everyone, good afternoon to all the dear students. So how is the revision going? Power packed? Okay, so now yes, we are going to do the most high yielding points from obstetrics and gynecology, and these are going to be from INICET PYTs. So these are like your last minute revision things which you should know, and primarily I've based them on volatile things which are very important and you tend to forget as well. So are we ready? Okay, so this will also cover some of the updates that you are worried about, and it will also cover some of the confusers that you are worried about. I am going to show you something, but you need to stay active because I'm going to ask you something as well. Are we ready? Okay. Perfect. So let's look at this. So this is the first confuser. Multiple times you students have asked me, what are we going to mark when we talk about active phase of labor? So please remember, we are now following the WHO guidelines, and that is going to be from 5 centimeters. Okay, is that clear? Yes? Alright. Next, very important thing. When we talk about postpartum hemorrhage, remember the overall most common cause is uterine atony. So if nothing is mentioned, you have to take it as uterine atony. Can you now tell me the question? What is secondary PPH and what is the most common cause? So what we are talking about here is primary PPH, yes, which happens within 24 hours. So what about secondary? So yes, secondary PPH is going to be beyond 24 hours up to 12 weeks. And what is going to be the cause? So there you are going to answer it as retained placental tissue. Okay, so retained placental tissue. Are you aware of the new updated guideline as well? So definitely yes, blood loss more than 500 ml is to be taken as postpartum hemorrhage. Yes, but do you know the newer definition, everyone? Yes, so as per the newer definition, even if it is 300 ml or more, but there should be hemodynamic instability. So what all are you going to look for? You are going to look for either the shock index, which is more than 1, or the heart rate, which is more than 100, diastolic blood pressure less than 60, and systolic blood pressure less than 100. So these will tell you that there is hemodynamic instability and you will still take it as postpartum hemorrhage. Okay. Now tell me, when we talk about placenta accreta, who is going to tell me the most important risk factors? When will you consider it? So very, very important. Whenever you see this combination, previous cesarean and placenta previa, you think of placenta accreta. The question for you is, when we say placenta accreta, what will you answer as investigation of choice? What is the answer? So remember, the answer will remain as ultrasound. But yes, if required, we can definitely add a Doppler and we can definitely add MRI when the diagnosis is uncertain. So if it is a multiple completion MCQ, you will include Doppler and MRI as well. Okay, when will you consider vasa previa? So what would be the keywords? Very, very important. The first important keyword would be there will be sudden onset of bleeding, and second is fetal distress linked to membrane rupture. So if you see these three things together, you have to think of vasa previa. My two MCQs for you. Are you ready? The first one. What is the investigation of choice for vasa previa? Now you cannot answer ultrasound alone. It has to be ultrasound Doppler, right? So the investigation of choice is ultrasound Doppler. Remember, the management is always going to be a cesarean section. Okay, it is always going to be a cesarean section. INICET is fond of asking. So please remember, in vasa previa, will you tell me it is fetal blood or maternal blood? It is fetal blood. So now tell me, what test will help you differentiate fetal blood from maternal blood? Yes, perfect. The answer is going to be APT test. I want you to tell me, APT is a alkali test or a acid test. What is the answer? So answer here is, it is a alkali test. We use 1% NaOH. It is a bedside test, and remember, it is only a qualitative test. But compare this now to KB test. Okay, so compare it to KB test, and now tell me, where will you use KB test? So remember, KB test is typically used in Rh negative pregnancy. Yes, so now tell me, alkali or acid? So when we say KB, KB is the acid test. Okay, it is the acid test. We use citric acid. It is a quantitative test and it is a lab test. Okay, are we ready? Okay. Whenever we talk about previous cesarean, one of the complications you have to know is uterine rupture. So the most important keywords will be patient of previous cesarean in labor. But you all make mistakes in when we ask you most sensitive sign, when we ask you, the first finding, right? Or we ask you the most common sign in rupture uterus. The answer is not loss of station. Please remember, the answer has to be fetal bradycardia. What about loss of station? Loss of station is the most specific finding. But when we ask you first or most common or most sensitive, the answer is bradycardia. The AIMS people can write it as non-reassuring fetal heart rate. Okay, very, very important. How will you identify shoulder dystocia? Remember, AIMS is asking questions on definitions. So either they will give you the sign is called as turtle sign, or they will give you the time. So this is more than 1 minute delay. Okay, what is the first thing that you will mark when we talk about shoulder dystocia? The first maneuver everyone knows is McRoberts. The second maneuver is suprapubic pressure. Do you all know that it is also called as Rubin 1 maneuver? Yes, but what is the update? If the suprapubic pressure fails, now the ACOG recommends that we should do the next step as delivery of posterior arm and then go to internal maneuvers, which are rotational maneuvers like Wood's corkscrew and Rubin's. Quickly tell me, how will you identify? I have taught you as well whether it is Wood's corkscrew or Rubin's. So please remember, in Rubin it is actually Rubin 2, and we will be rotating the baby's shoulder in a clockwise manner. So clockwise manner is Rubin's and anti-clockwise is Wood's corkscrew. Okay, also tell me, in which maneuver do you do adduction of the shoulders? Adduction of the shoulder will be done in Rubin's maneuver. So it has to be clockwise and adduction. Who will tell me what is the last maneuver? So please remember, when we say shoulder dystocia, the last maneuver is to be answered as Zavanelli. So in the sequence, always look at the first maneuver and the last maneuver and then decide which is the correct sequence. Okay. Very, very important. You all know about most common type of twins. The most common type of twins is diamniotic and dichorionic. But the INICET will confuse you by asking the most common presentation in labor, and many students answer it as vertex and breech. It is incorrect. The most common presentation in labor is going to be vertex. Okay. Now tell me, when you are saying it is a dichorionic pregnancy, what sign will you see on ultrasound? Again, name signs are very important. So what is the sign called as? It is called as twin peak, also called as lambda sign. So this is sign of dichorionicity. I want you to tell me what would be the sign of monochorionicity. So then it is called as T sign or inverted C sign. Remember, the ideal time to look for lambda sign is going to be 10 to 14. If you have to mark one answer, go with 10 weeks. Please remember, there is nothing like DCMA. If it is dichorionic, it has to be diamniotic. It cannot be DCMA. Now be very careful. INICET people introduce some words and confuse you. Overall, most common is DCDA, but if we ask you most common type of monochorionic or monozygotic twin, the answer will change to MC and DA. Then the answer will change to MCDA. Named stagings and classifications are very important for INICET. So remember, the named classification for twin-twin transfusion syndrome is Quintero staging. And who is going to tell me what stage is hydrops fetalis? Because if you remember this, you can remember the others as well. So hydrops fetalis is going to be stage 4. What is stage 5? Stage 5 is death of the baby. What is stage 3? Abnormal Doppler. Okay, abnormal Doppler. Stage 1, bladder is visible. Stage 2, bladder of oligo twin is not visible. Okay, please remember, twin reversed arterial perfusion called as TRAP. Is it a complication of MC twins or DC twins? It is a complication only in monochorionic. What else do you call it? So apart from TRAP sequence, you should know it is called as a cardiac twin or monster twin. There is reversal of blood flow and it is an artery to artery type of anastomosis. Okay, is that clear to everyone? Perfect. What is the most common complication of MA twins? Kaun batayega? Remember, if it is MA twins, the complication is cord entanglement. And remember, they are always delivered by cesarean. When we are talking about delivery of twins, remember, if the first twin is cephalic, we will do a vaginal delivery. If it's non-cephalic, then we will do a cesarean. Emergencies are almost always asked in INICET exam. So remember this, cord prolapse. What is the first thing you will do? So again, the hint will be ARM with fetal distress, but what will not be present? No bleeding. So cord prolapse ka hint hoga ARM with fetal distress, but there is going to be no history of bleeding. The first and the most important thing is relieving the cord pressure. Okay, so how do you do it? So the best answer is manually lift up the presenting part. You can also do a retrograde filling of the bladder, or you can put the woman in Treadlenberg or knee chest position. Is that clear? The other position can also be knee chest position. Yes, we can put the cord gently in the vagina, but never put it in the uterus. The management is going to be emergency cesarean. Okay, so it's going to be an emergency cesarean most of the times. Very well done. Chalo, some important things that INICET is very fond of asking from ectopic. So these are important. One-liners have been coming a lot in recent INICET exams, so you be very careful. The most common site, if we ask you, it is ampulla. But if we ask you most common risk factor, it is PID. Who is going to tell me what carries the highest risk? Highest risk, batao. Highest may you will answer it as history of tubal surgery. That's the best answer. Or history of previous ectopic. That is the second best answer. Right? So highest risk ke liye, please remember history of tubal surgery. Alright? Okay. Perfect. Very good. Now, investigation of choice is not to be answered as HCG. For ectopic, it is a transvaginal ultrasound. And very, very important. Remember, HCG and serum progesterone are never diagnostic. They are only suggestive of ectopic. So, any term which says they are diagnostic is incorrect. Yes? Critical value of HCG for an intrauterine pregnancy on transvaginal ultrasound for most labs is taken as 2000 international units. Remember, the serum progesterone level less than 5, is it diagnostic of ectopic? No. It is basically suggestive of a non-viable pregnancy. This non-viable pregnancy could be an ectopic and could be an abortion, so it is never diagnostic. Then please remember, for medical management, the value of HCG that we require is less than 5000 international units. I have a question for you. Can you tell me, if cardiac activity is present, what treatment are you going to do if it is ectopic? So in case we write cardiac activity present, the answer has to be surgery. If we write ruptured ectopic, and how will you diagnose ruptured ectopic? Yes, any evidence of peritonitis, any evidence of hemodynamic instability have to be taken as ruptured, and the answer is always going to be surgery. With completed family also, the answer is going to be surgery. The difference is, in ruptured we will do a salpingectomy. But if cardiac activity is present, we can manage with a salpingostomy. Alright? Okay. Moving on to the next very important thing, and yes, I will be covering the updates as well. So preeclampsia, we all know, is blood pressure more than 140/90, but along with that, we should have proteinuria and we should have end organ damage. Now please remember, different guidelines consider different proteinuриas. For example, the ACOG and FIGO consider it as +2, okay, but the FOXY has given it as +1. So for you, you should take it as any evidence of proteinuria, we will take it as preeclampsia. When will you call it severe preeclampsia? So for severe, either the BP has to be very high, or there should be evidence of end organ damage. Remember, any condition like pulmonary edema, neurological symptoms, okay, raised liver enzymes, low platelet count, raised creatinine are all evidence of end organ damage. But please remember, oliguria is not taken as end organ damage. We have to measure creatinine values. IUGR is not taken as end organ damage. Okay, next out. Does Magsulf prevent eclampsia? True or false? Yes, it even prevents and it even treats eclampsia. That is why you will give Magsulf to patients of impending eclampsia and pre-eclampsia with severe features. And it should be the first step when you see impending eclampsia. Yes, most commonly regime followed is Pritchard regime. Remember, the loading dose is not 4 grams and it is not 10 grams, it is 14 grams. I want to ask you, what will you monitor when you are giving the loading dose? Don't answer it as patellar reflex or urine output. When you are giving the IV loading dose, you have to monitor the heart rate, okay? Remember, we will ask you the first sign of toxicity, and that is loss of patellar reflex, which will happen anywhere between 7 to 10 milliequivalents. Okay, so anywhere between 7 to 10 milliequivalents, there will be loss of patellar reflex. Please remember, any evidence of oliguria, you will not give the maintenance dose. Okay, please remember, oliguria is less than 30 ml of urine per hour or less than 100 ml of urine in last 4 hours. So very, very important. Okay, therapeutic blood levels, everyone should know, is 4 to 7 milliequivalents. Antidote you should know is calcium gluconate given IV. I want to ask you, when will you use Magsalve for neuroprotection? Yes, it is used, but when will you use it for neuroprotection? Only if the POG is less than 32 weeks. Only then answer it as neuroprotection. Okay, something that again INICET is fond of asking, maybe the other exams don't ask that much. When we talk about IUGR or growth restriction, what is the earliest finding you look for? So now the most sensitive marker is umbilical artery PI, pulsatility index. The cutoff we use is more than 95th percentile will be uteroplacental insufficiency. Very good. I can see you're answering the extra questions that I am asking as well. So now you have to tell me absent and reversal of end diastolic flow. Which is more ominous? Is it absent or is it reversal? So yes, reversal is most ominous. When will you do termination of pregnancy if it is reversal of end diastolic flow? What will be the answer? So for reversal, yes, the cutoff is 32 weeks, and for absent, the cutoff is 34 weeks. Below that, you will admit, you will monitor, you will give steroids, you may also give Magsalve. I want to ask you, if you see, extra question, if you see REDF with late decelerations, will you wait or will you do immediate termination? Tell me the answer. So if you see REDF with late decelerations, then we will not wait. Then the answer will change to, yes, then the answer will change to immediate cesarean section. Okay, remember the named criteria for HELP syndrome are Tennessee or Tennessee criteria. We don't need high blood pressure, but we need hemolysis, elevated liver enzymes, and low platelet count. Can you tell me how will you look for hemolysis? So for hemolysis, we can either do LDH or we can do serum bilirubin or we can do a peripheral smear. Can you tell me what will be the findings in the peripheral smear? Yes, it is going to be schistocytes or helminth cells. Perfect. Coming on to decelerations. So you all remember the causes. Remember, early is head, variable is cord, and late is uteroplacental insufficiency, or we will write it as hypoxia. Remember, sinusoidal is what you see with fetal anemia. Okay, please remember wheel chop. That's how we ask you to remember. And for most importantly, to identify late decelerations, please focus on when is it ending. If it is a late deceleration, the most important criteria in the image is it has to persist after the contraction. So if it is persisting after the contraction, it is the most important criteria and it will be a late deceleration. Everyone should know how to calculate the Bishop score. I have done a special video. It's there in the YouTube shorts as well. You should know how to do the Bishop scoring. If it is favorable, which means it is more than 6, what are you going to do? Then you will start oxytocin. If it is less than 6, you have to do cervical ripening. My question to you is, which is the most commonly used drug for cervical ripening? What will be the answer? So for most commonly used drug, you should answer it as PGE2. Remember, PGE1 is misoprostol. It can be used, but it should never be used in a patient of previous cesarean. It will cause rupture uterus. Very good. Chalo. Now, some extra things that INICET is fond of asking. So if you are doing a VBAC or if you are doing a TOLAC, it means the same thing. Remember, the most important criteria for successful VBAC is history of previous vaginal delivery. But the exams are going to confuse you. Is absent history of vaginal delivery an indication to do repeat cesarean? Yes or no? The answer is no. If there is no history of vaginal delivery, it's not an indication for repeat cesarean. But if history of vaginal delivery is present, it means it is a good prognosis for successful VBAC. Okay, the most important uterotonic we all know is oxytocin 10 international units, even as per the latest guidelines. Remember, we can give it IM or IV. Remember, in IV, it has to be an infusion. Remember, IV has to be preferred over IM. Okay, very, very important. Next, can you tell me when do you give this oxytocin? It has to be given within 1 minute of delivery. Now tell me the update. In AMTSL, which are the only 3 drugs allowed? So now we can use only these 3. Oxytocin, carbetocin and misoprost. Oxytocin needs cold chain, carbetocin is heat stable, misoprost is for low resource settings. Remember, carbetocin is 100 micrograms, slow IV over 1 minute. We can give it IM also. Perfect, very good. Now, super important, some drug things that your exams are fond of asking. Carboprost is also called as dinoprost, not prostone. Prostone is PGE2. It has an E in the end. This is PGF2 alpha. Remember, it is contraindicated in asthma. Do we use it in AMTSL? Never, never, never. We do not use it in AMTSL. We do not use it for induction of labor. Remember, methogen is contraindicated in hypertension and in women with heart disease. Now, can we give tranexamic acid in AMTSL? No. So, as per the new guidelines, tranexamic acid is not a component of AMTSL. But is it to be given in PPH? Yes. It has to be given in all patients of PPH within 3 hours. The earlier you give, the better it is. Who is going to tell me an extra question? What is golden hour? Golden hour is the first 1 hour of PPH when resuscitation must begin. Now I have okay, one more question. B. Lynch, remember, it is a compression suture, but it is only used for atonic PPH. It is not used for any other type of PPH. So please remember, if you have given uterotonics and the woman is still bleeding, who is going to tell me what is the next step? So if you have given uterotonics, she is still bleeding, the next step should be answered as balloon tamponade. Okay, balloon tamponade. Alright, very, very important MCQs for INICET, timelines, because they ask it to arrange. So now let's look at this. Gestational sac is the first finding. Can you tell me the name of the sign? It is called as intradecidual sign. The timeline is 4.5 to 5 weeks. The single best answer is 5 weeks. For yolk sac, it is 5 weeks. Fetal cardiac activity, 5.5 to 6, but the single best answer is 6 weeks. Question for you. Are you ready? Who is going to tell me what is double bleb? What are the 2 blebs? So yes, one is amniotic sac and the other is yolk sac. Okay, the best parameter overall for dating of pregnancy is crown rump length. The ideal time for crown rump length is 7 to 10 weeks, but it can be used up till 13 weeks. Okay, when should be the first visit, which is also called as what? Booking visit. The booking visit should be in the first 12 weeks. What are the minimum number of visits as per Government of India? So as per Government of India, what is the answer? Yes, it is going to be 4 or 8. 4. As per WHO, the answer will change to 8, and yes, INICET will mention it. Okay. Please remember, EDD corresponds to 40 weeks, and you always calculate it from the first day of LMP. Alright. NT scan, multiple times asked. The ideal time is 11 to 13 weeks. Dual marker, again 11 to 13. Can you tell me what are the combination called as? The combination of NT scan and dual marker is called as a combined test, and this is overall the most commonly used test in the Down syndrome screening in the first trimester. Chorionic villus sampling is a confirmatory test, never screening, can be done beyond 10 weeks up till 13. Okay. Quad test, the timing is going to be 15 to 22. And who is going to tell me which inhibin do we use in quad test? Jaldi batao. It is going to be inhibin A. Can you tell me which two parameters are increased? So inhibin A and HCG. Which two are decreased? Alpha fetoprotein and UE3. Alright, perfect. Amniocentesis has to be done in the second trimester, 15 to 20. But if INICET asks you about early amnio, it is 11 to 14 weeks. What is the best time for anomaly scan? Very good. You all are answering very well. Is it good going? Are you all able to revise and recall? Perfect. Okay, so anomaly scan is 18 to 20 weeks. This is also called as TIFA, also called as level 2 ultrasound, and please remember it is mandatory for all pregnant women. Okay, what about fetal echocardiography? So fetal echocardiography is again done in 18 to 22 weeks, but it is not done for everyone. It is only done in high-risk pregnancies like pre-gestational diabetes. Very, very important. As per the Indian guidelines, when should we do screening for GDM? So it has to be ideally done first at the first antenatal visit. We do not use HbA1c or fasting levels. The method we use is 2-hour OGTT, where we will use 75 grams of oral glucose. Okay, and it has to be repeated at 24 to 28 weeks. Who is going to tell me the cutoff to call it as gestational diabetes? What is the answer? For gestational diabetes, the value has to be more than or equal to 140. What will you answer if it is more than or equal to 200? Overt diabetes. Okay. What is the best time to give anti-D prophylaxis? It is 28 weeks. When do we do the growth scan? The growth scan is done between 28 to 32. You can mark the single best answer as 32 weeks. If your patient has placenta previa in a level 2 ultrasound, it is very important to repeat the scan at 32 weeks. We have to review the location of the placenta. Okay. Then some other early pregnancy findings INICET is fond of asking. They will ask you, when will you hear fetal heart? But the key word will be on Doppler. Do not answer it as 6 weeks. Do not answer it as 20 weeks. If it is Doppler, we are talking about handheld Doppler. The answer is 10 weeks. Quickening. Who is going to tell me a presumptive sign or probable sign? So quickening is a presumptive sign, bache, not a probable sign. Okay. And in primi gravidas, the timeline is 18 to 20 weeks, and in multi, it is 16 to 18 weeks. Okay. Corresponding levels. So fundus reaching umbilicus, you will answer it as 20 weeks. Fundus reaching xiphisternum, you have to answer it as A general answer is 36. Okay. Now, please remember the probable signs are repeatedly coming in the exams. So, Hagar and Goodles are earliest identified at 6 weeks. They are all probable signs. All other probable signs like Shadwick's, Osiander's, okay, Pisca, Sex and Palmer's, all these at 8 weeks. Remember 2 extra things. Ballotment. If INICET asks about ballotment, whether internal or external, they are felt in the second trimester around 20 weeks. If we talk about lightening, then this is usually at term, really 2 weeks before labor, so 37 to 38 weeks. So if you have to arrange in order, you should know the timelines, okay? Biophysical score, who is going to tell me what else is it called? Jaldi batao. It is also called as Manning score, right? 8 to 10 is normal, but anything less than 4 will indicate fetal acidosis and will need immediate termination, okay, as there will be fetal acidosis. Very, very important. What is modified biophysical profile? So BPP is all 5 things. Modified has only 2, NST and amniotic fluid index. Okay. If you have to start monitoring with NST, you should monitor after 32 weeks. Please remember to call it non-reactive. Who is going to tell me the criteria? Yes, non-reactive ke liye, we have to have less than 2 accelerations in 40 minutes. Now I have to ask you, non-reactive NST is a positive NST or a negative NST? It is considered as a positive NST, and NST has high false positive rate. Okay. Chalo. Super important again, definitions. When I say INICET is fond of asking definitions of arrest. So for second stage, the primi gravida, we have to wait for 4 hours if there is epidural. So INICET fond of asking this. Without epidural, we will wait for 3 hours. Can you tell me the cutoffs for multigravidas? So for multigravidas with epidural, it is 3, and without epidural, it is 2 hours. Okay. All right. Active phase arrest. Remember, the woman has to be beyond 5 centimeters. You have to wait for at least 4 hours. And there has to be adequate contractions. Please remember, the membranes have to be ruptured to make this diagnosis. MCQ for you. Are you ready? Can you tell me overall what is the most common cause of active phase arrest? The answer will be CPD, and therefore the management of choice is usually always a cesarean. Okay, this we have covered. So primary hemorrhage is within 24 hours. Remember, secondary is up to 12 weeks. What is the most common cause of maternal mortality? It is hemorrhage. So hemorrhage is the leading cause of maternal mortality. Tell me, will it be a direct maternal death or an indirect maternal death? It will be a direct maternal death. Can you tell me, to calculate maternal deaths, we include all deaths up to what time period? We will include up to 6 weeks. So this is a direct maternal death. So all maternal deaths up to 6 weeks. All right. As we have mentioned, whenever it is an atonic PPH, you will be asked the sequence. So sabse pehle you have to do a massage. At the same time, start uterotonics and Tranexa. If uterotonics fail, go to balloon tamponade, then go to B-Lynch or uterine artery ligation. How will you decide whether the answer will be B-Lynch or whether it will be uterine artery? Look at the vitals. B-Lynch we will do when vitals are stable. Then the next step will become B-Lynch. If the vitals are unstable, then the next step becomes uterine artery ligation. Please remember, in cesarean, we do not do balloon tamponade. We directly go to B-Lynch. Okay. Now, uterine inversion, remember, presents as immediate shock. This is not a hypovolemic shock. This is a neurogenic shock. And the first thing is manual repositioning, and it has to be done in the labor room. Okay. Remember some common timelines postpartum. 2 weeks is when uterus becomes a pelvic organ, but if we ask complete involution, it has to be answered as 6 weeks. We come to the final section of obstetrics. Teratogens is like super important for INICET. So lithium, everyone knows, will be associated with Epstein's anomaly. What will be the finding in chest X-ray? Yes, a box-shaped heart. Okay. Remember, phocomelia is thalidomide. It is a proximal limb defect. Gray baby is chloramphenicol. Which drugs will cause kernicterus if given in the 3rd trimester? It is sulfonamides. Drugs which will cause tooth discoloration is going to be tetracycline. Please remember rubella. The most common cardiovascular finding is PDA. But can you tell me the triad? The triad also includes SNHL and cataract. It is very, very important. Who is going to tell me important for INICET exam? Congenital rubella syndrome is seen up to what weeks? It is up to 16 weeks. What about congenital varicella? Who is going to tell me? Congenital varicella, the highest risk is between 13 to 20 weeks. What will be the keyword for CMV? For CMV, it has to be periventricular calcification and it has to be microcephaly. Who is going to tell me what is the leading cause of SNHL? Kaun batayega? Leading cause of congenital SNHL is actually CMV. Okay, coming to toxoplasmosis, the keyword will be hydrocephalus. Usually everything else causes microcephaly. Here you see hydrocephalus and generalized calcifications. Warfarin, we all know, is chondrodysplasia punctata, but the typical finding is nasal hypoplasia and stippled epiphysis. The most specific, listen to me carefully, the most specific anomaly, okay, is going to be caudal regression syndrome, also called as sacral agenesis. Who is going to tell me the most common anomaly? If we ask you most common, it is VSD. Which anti-epileptic classically causes neural tube defects or spina bifida? It is valproate. Carbamazepine can also cause, but the single best answer is valproate. Remember, it is contraindicated in pregnancy. Okay. Complete heart block by SLE. Alright, the general answer for MTP is up to 24 weeks. But what are the variations? For anomalies, we can do it beyond 24 weeks with approval from the medical board. What about contraceptive failure? So remember, for contraceptive failure, it is up to 20 weeks. Okay, consent. If she is a major beyond 18 years of age, we need her consent. But if she is a minor, we will take consent of legal guardian. There is no lower limit for consent. Up to 20 weeks, we need opinion of one registered medical practitioner, and between 20 to 24, 2 RMPs. Who is going to tell me what constitutes the medical board? So we say the CT family, right? So we need an obstetrician, a radiologist, and a pediatrician. Yes? The keywords for placenta previa will be warning hemorrhages. Remember, never do a PV exam, but when we ask you investigation of choice, it is ultrasound but transvaginal. And in placenta previa, it is always a cesarean. Do not answer vaginal delivery in any condition, and this will be a LSCS. Okay? Chalo. Non-immune eye drops ka leading cause is cardiovascular anomalies. Second leading cause is anemia, and then comes infections. Typically, remember, parvovirus and syphilis will cause eye drops, but HIV, hepatitis B typically do not cause eye drops. I want to know from you, does HIV cause gross congenital anomalies? The answer is no. It does not cause anomalies. Immune eye drops, INICET is fond of asking, will happen if the hemoglobin is less than 5. Okay. critical titer for ICT is more than or equal to 1:16. So once you reach critical titer, your answer is MCA, peak systolic velocity. I have two questions for you. Please tell me what is the cutoff we use in peak systolic velocity, the value. It is 1.5 MOM. Also tell me if the titer is less than 1:16, what do you do next? You simply repeat ICT after 4 weeks. Please remember, anti-D after delivery will only be given if the baby blood group is positive and direct Coombs test is negative. My question to you is, do we do DCT in all patients? No. In India, we are not doing DCT for everyone. In India, we only see the blood group. If the baby blood group is positive, we will give anti-D to all these women. So please remember, DCT is not mandatory as far as Indian guidelines are concerned. So these were my top 90 things, but discussed a lot more than that as well. So was obstetrics helpful? And I will switch to gynecology. Yes, is it good for everyone? Were you able to revise well? Okay, perfect. So now we will switch to gynecology and I will be putting it up there as well. So are we ready for gynecology, everyone? Yes? Okay, so we similarly have the high yield points for gynecology. Are we ready? Yes? Okay, but you have to promise me that you will keep doing the rapid fire that you are doing. You will be actively involved. Is that a promise? Yes? Okay. Yes, a lot of hard work has gone into compiling this for you. I was awake till 2 a.m. in the night as if it is my exam. And I hope it turns out to be good for all of you. Right? So let's start. So can you tell me which is the most common malignant ovarian tumor? So remember, the overall answer is serous cyst adenocarcinoma. Who is going to tell me what category tumor it is? So it is classified as a epithelial ovarian tumor. What will be the keywords for it? The keywords are raised CA125, papillary excrescences, and a post-menopausal women. Okay, those are going to be the keywords. On the contrary, when you say germ cell tumors, they are seen in young girls, 10 to 30 years of age. What are the keywords? They are unilateral and they are commonly responsible for precocious puberty. Can you tell me which 3 markers will you do if it is germ cell tumors? We have to do LDH, we have to do HCG, and we have to do alpha fetoprotein. Okay, can you tell me most common germ cell tumor? So now we are specifying germ cell tumor. The answer is a mature cystic teratoma, which is also called as a dermoid. Remember, it has all 3 germ layers. It is a benign tumor and it is usually unilateral. INICET may specially ask you in what percentage of cases it may be bilateral. So in up to 10% it may be bilateral. Okay. Which tumor will show you Schiller-Duval bodies? So yolk sac tumor, also called as endodermal sinus tumor. Karl-Exner bodies, granulosa cell tumors. My question to you is, what is the tumor marker? That will come later, but what does it produce? So remember, these are estrogen producing. So granulosa cell tumors are typically linked to what? They are linked to endometrial hyperplasia, endometrial cancer. They can even cause endometrial polyp. Okay, perfect. Meigs syndrome, you will mark with which tumor? The single best answer for Meigs has to be a fibroma. It is again a benign ovarian tumor. Remember, the other part of the triad is ascites and pleural effusion. Question for all of you. Can you tell me, when you say Meigs, which other tumors are included? What other tumors are included? So yes, you can include granulosa, thecoma and Brenner's. So granulosa, thecoma and Brenner's could also be a part, but single best answer is fibroma. Rinky's crystals. INICET is fond of asking. Single best answer is Leydig cell tumors. So now tell me, will it cause hirsutism or virilization? If it is a Leydig cell tumor, remember it will cause virilization. Who is going to tell me the older name of Leydig cell tumor? Batao. The older name is arrhenoblastoma. Now they are called as certainly Leydig tumors. Walnut cell nest is a classic finding of Brenner's. Can you tell me coffee bean nucleus is seen in which two tumors? Coffee bean. So coffee bean का एक आंसर होता है Brenner's और second आंसर होता है granulosa cell. What is the classic finding in a dysgerminoma? Yes, you will see lymphocytes in the septae. Okay, so it is a lobulated tumor. Typical color is red and tan, and you will see lymphocytes. Very simple. Most common strains causing cancer cervix is 16 and 18. Remember, they are together responsible for 70% of cervical cancers. But who is going to tell me if you have to mark one, what will you answer? The single best answer is 16. It causes 50% of cancers. If we ask you about warts, then it is 6 and 11. Now, who is going to tell me, when I say vaccine, it is made from what? The vaccine of HPV is made from L1 capsid protein. We also call them as VLPs, virus-like particles. Can you tell me which ones are responsible for malignancy? The proteins now are E6 and E7. So E6 and E7 are for malignancy. L1 is for the vaccine. Remember, the most common site of pre-invasive as well as invasive has to be answered as transformation zone. Remember, pap smear is also taken from the transformation zone. Remember the FIGO staging of only one cancer, and that is cervical, and it is a clinical staging. You are going to tell me what all do you include in stage 3. So remember, stage 3 has to be taken as hydroureter, hydronephrosis, or spread to lateral pelvic wall. What stage is this? Batao. To be very precise, this is 3B. What is 3A? Lower 1/3 of vagina. And what is 3C? It is lymph nodes. Parametrium कौन सा होता है? 2B. 2B is parametrium. And remember 1B3. Okay, 1B3 is tumor more than 4 centimeters. All stages beyond 1B3, what will be the treatment? Batao. Treatment will be chemoradiation. Yes? Okay, let's go forward now. Next. Screening as per the WHO recommendations and even as per the National Cancer Program. We have to begin screening at 30, not earlier than that. Even in our national screening program, it is 30. But WHO का recommendation है, the test should be HPV. The interval should be 5 yearly. But what is currently included in our national cancer program? Currently in the national cancer program, we are using VIA, and it is done every 3 yearly. Okay, we are not using pap smear. But yes, the recommendation is that we have to switch over to HPV. In fact, India has started the pilot projects for HPV testing as well. Remember, the interval for pap smear has to be 3 yearly. What is a co-test, bache? Co-test is a combination of HPV and PAPs. It is done every 5 yearly. Not in India, it is done in resource-rich countries. This is what resource-rich countries are doing beyond 30 years of age. If the report of pap smear is AGUS, atypical glandular cells, the most important next step has to be endocervical curettage and endometrial sampling, especially if your patient is beyond 35 years or she has risk factors for endometrial cancer, then yes, endometrial sampling has to be done. Colposcopy with biopsy is not mandatory but can be done. So if it is a multiple completion question, you include all three. But if you have to choose any two, can you tell me which one will you choose? So for any two, you will choose endocervical curettage plus endometrial sampling. If the report is ascus, atypical squamous cells, the single best answer of next step is HPV. But if the age is given as less than 25 years, then your answer will be repeat pap smear. Now, postmenopausal bleeding. Please remember, whenever we say PMB, it has to be taken as endometrial cancer unless proved otherwise. But if I ask you most common cause of postmenopausal bleeding, you will stick to atrophy. Remember, only 10% of patients with postmenopausal bleeding have endometrial cancer, but we have to rule it out for everyone. Coming to the latest guidelines. As of now, the American College guidelines say if a patient has come P with postmenopausal bleeding, now both investigations have to be done. Transvaginal ultrasound as well as endometrial sampling. Okay, so now we are saying both have to be done. Sampling should also be done for all patients. Okay, but yes, if I still ask you, on transvaginal ultrasound, what cutoff of thickness has low risk of cancer? So if it is less than or equal to 4 mm, there is low risk of cancer, but it can still happen. 12% of these patients can still have cancer, and that's why we are saying sampling is mandatory. So when we ask you investigation of choice for postmenopausal bleeding, don't answer it as ultrasound, okay? The ultrasound has to be not the IOC. The IOC has to be answered as sampling, okay? Yes, okay. Endometrial hyperplasia, the key word is without ATPR. If there is no ATPR, the treatment of choice is progestins. Can you tell me which one will we prefer? We will prefer Mirena over medroxyprogesterone acetate. If the keyword is with ATPR, the treatment of choice becomes hysterectomy. And in this hysterectomy, you will add BSO if she is a postmenopausal woman. If she is premenopausal, do not add BSO. Okay, now tell me, most common type of endometrial cancer, it is endometrioid adenocarcinoma, beta. That is the term. So endometrioid adenocarcinoma, which mutation will you see? So P10 mutations. Is it a type 1 cancer or a type 2 cancer? It has to be taken as a type 1 cancer. Remember, they generally have very good prognosis. Who is going to tell me what is type 2 cancers? So type 2 are non-endometrioid. Who is going to tell me the mutation? Yes, so in type 2, it is going to be P53. And please remember, they will have poor prognosis. Your INICET exams are very fond of asking about risk factors. So remember this. The nulliparity is a very important risk factor. Also include keywords like diabetes, like obesity. If we ask you about syndromes, can you tell me which syndrome will have highest risk? So highest risk is with Lynch syndrome, 80%. Also high risk with polycystic ovarian syndrome. Also high with, yes, which other syndrome? Can you tell me? Cowden syndrome. Then we have already talked about germ cell tumors causing endometrial cancer. Please remember, the staging for endometrial cancer is surgical. The treatment of his choice is hysterectomy with BSO. Okay. Now, some things that definitely you should know about contraceptives. So, please remember, copper T is effective for a span of 10 years. What about Mirena? Mirena is effective for a span of 8 years. Remember, IUD and mini pills, they are the only methods which do not act by inhibition of ovulation. Okay, so do not act by inhibition of ovulation. They act by inhibition of what? Kaun batayega? Inhibition of fertilization. Please remember, any undiagnosed bleeding is a absolute contraindication for copper T or for Mirena. What is the difference? When you talk about Mirena, it will reduce menstrual blood loss and it will reduce pain. What about copper T? Copper T increases blood loss and increases pain. So we will not put copper T in anyone who has more blood loss or heavy bleeding. Very, very important. What about postpartum IUD? So you call it as postpartum if it is within 48 hours. What is post-placental? Within 10 minutes of placental expulsion, which is preferred as per the Government of India guidelines. Post-placental is preferred with less expulsion rates and more desire for continuing with this method. If we talk about emergency contraceptives, overall most effective kaun sa hota hai? Overall most effective is copper T. Okay, second in the list is ulipristal. INICET is fond of asking the doses. So yes, the dose is 30 milligrams single dose, effective up to 5 days. Most commonly used, if we ask most commonly used emergency contraception, the answer is LNG tab. Okay, also called as what? Also called as Plan B, also called as morning after pill or I pill. But please see the difference. The preferred regime is 1.5 milligrams and single dose, but it is effective up to 72 hours. Who is going to tell me the multi or divided dose regime? What should be the time gap? So yes, 0.75 milligram taken twice, 12 hours apart. But what is preferred? Preferred is single dose. Can we use OCPs as emergency contraceptive? Yes, but they have to be high dose OCPs. Okay, most common bache ye OCP nahi hai. Most common is LNG tab. OCP is the least effective method. Who is going to tell me the name of this method where we use high dose OCPs? What is the answer? This is called as USP regime. So OCP wale ka naam hai USP regime. Very important for INICET exams. Please remember, OCPs will reduce the risk of endometrial, ovarian and colon cancer. Can you tell me which ones are increased? Increased hoga breast cancer, cervical cancer and hepatic adenoma. Okay, these are increased. Okay, mechanism of action. Remember, OCPs will inhibit LH and FSH. They also inhibit GnRH. Okay, so they also inhibit GnRH. But if you have to mark one, you will answer it as inhibition of FSH. Post-menopausal HRT, what are the problems? INICET is fond of asking. So post-menopausal HRT will increase the risk of breast cancer, venous thromboembolism and stroke. If you give only E, which other cancer will increase? Then it can increase even endometrial cancer. That is why if a woman has a uterus, we will not do what? We will not give only E. We have to give E plus P. Please remember, post-menopausal HRT is only given if a woman is less than 60 years of age. We do not give beyond 60 years. Tumor markers to bar paper mein aa rahe hain, so even path people will tell you. So with epithelial, the answer is CA125. With yolk sac tumor or endodermal sinus tumor, AFP. Choriocarcinoma is HCG. Who is going to tell me what will you find in the histopath of choriocarcinoma? Batao kya milega? So for choriocarcinoma, there will be dimorphic cells. There will be syncytiotrophoblasts, and there will be cytotrophoblast. The single best answer for dysgerminoma is LDH. Remember, it does not secrete alpha fetoprotein. For granulosa cell tumors, the answer is inhibin B. For mucinous, which are actually epithelial ovarian tumors, but still the tumor marker single best answer is CEA. Who is going to tell me the other tumor marker? The other one can be CA19-9, okay, but the single best is CEA, okay. Please remember, mucinous are also associated with something called as pseudomyxoma peritoniae, and they become like huge tumors. They can grow up to 20 centimeter in size. Can you tell me which ovarian tumor can also go up to 20 centimeters? Which is the other one? Yes, granulosa. They can also grow to huge size. Okay, some very basic questions NEET asks, like, most common site of endometriosis is ovary. Whenever you read the keyword as dysmenorrhea, think of endometriosis. Can you tell me which other condition will you think if it is dysmenorrhea? You will also think of adenomyosis. But how will you differentiate whether it is endometriosis or adenomyosis? So in endometriosis, uterus is normal in size, but in adenomyosis, uterus is enlarged. It grows only up to 10 to 12 week size, not bigger than that, okay. Overall leading cause of secondary dysmenorrhea is endometriosis, but it can also be pelvic inflammatory disease. It can also be adenomyosis. Remember, whenever we talk about primary amenorrhea, always focus on secondary sexual characters. And which secondary sexual character are we talking about? We are talking about breast development. So, if we are saying there is primary amenorrhea and secondary sexual characters are present, then the most common cause is MRKH, also called as which syndrome? Mullerian agenesis, right? So MRKH or Mullerian agenesis is the most common cause with normal secondary sexual characters. But if I say overall most common cause of primary amenorrhea, I am not talking about secondary sexual characters, then overall the answer is gonadal dysgenesis. And which one in gonadal dysgenesis? It has to be answered as Turner's. Can you tell me what is the age cutoff for primary amenorrhea? The general answer has to be answered as 15 years. But if secondary sexual characters are absent, you will begin evaluation at 13. So if secondary sexual characters or breast development is absent, then you begin evaluation at 13. Okay. Most common cause of secondary amenorrhea has to be pregnancy. Now you have to remember, any woman in reproductive age comes with abnormal bleeding, always rule out pregnancy. I have a question for you. Should we rule out pregnancy even in primary amenorrhea? Yes. Okay, rule out pregnancy, and the best test will be serum HCG, not a UPT. Very important for INICET exams. Most common cause of abnormal bleeding in an adolescent girl or a perimenopausal woman. What is the answer? It is anovulation. But if we ask you second most common cause in an adolescent girl, don't answer it as thyroid. The answer is coagulopathy. Okay. Now, precocious puberty. Who is going to tell me what is the cutoff? That is the question for you. The cutoff is 8 years in girls and 9 years in boys. The overall most common cause is idiopathic or central. But which means, is it GnRH dependent or independent? This is GnRH dependent. But please remember, 10% of these girls can have a brain tumor. Who is going to tell me which brain tumor? Important for any set. Yes, hamartoma. Okay. be very careful with INICET exams. If we ask you first sign, the overall answer is growth spurt. But if growth spurt is not in the options, then you go with thelarch. If I ask you the first visible sign, then the answer is automatically thelarch. And remember, thelarch corresponds to what Tanner stage? Tanner stage 2. Okay, drug of choice for precocious puberty. It has to be GnRH agonist and it has to be continuous. Can you tell me 2 cancers where we use GnRH agonists? So it is going to be breast and prostate cancer. And in these conditions, can we also use GnRH antags? Yes, we can also use GnRH antags. Now, if it is androgen insensitivity syndrome, please remember it is also called as testicular feminization syndrome. And therefore, can you tell me the gonad that they will have? Obviously, they will have a testes and they are 46XY. What are the keywords? The keywords have to be absent pubic and axillary hair, but breast development has to be present. Those are the combinations we are looking for. Yes, we will do a gonadectomy, but after puberty. How is Swires different? Kaun batayega? Swires are also XY, but do they have a testes? No, they have rather streak gonads. What is the second difference? In them, the breast development is absent, but uterus is present. In AIS, uterus is absent. The mutation is SRY gene. Can you tell me 2 MCQs? How many % of patients will have mutations and which mutation? So 20% of patients of Swires will have SRY mutation and it will be a point mutation. Yes? Okay. Coming to the next one. Turner's syndrome, R45XO. Remember, there are streak gonads. Remember, the breast is absent, the uterus is present. Okay, quickly tell me these keywords. What is the most characteristic finding? Do not answer it as shield chest. The most characteristic is short stature. Okay, yes, shield chest, low hairline, webbed neck. Yes, these are other keywords. What are the findings in the hands? Kaun batayega? Hands. Cubitus valgus. And what else? Short 4th metacarpal. Yes, so cubitus valgus and short 4th metacarpal. Okay, very good. Then Riefenstein syndrome is partial AIS. How will you differentiate it from complete AIS? These patients will also have clitoromegaly. Yes, okay. Exams are fond of asking the drugs of choice. So remember, for PCOS, it is letrozole, it is aromatase inhibitor. It increases FSH levels. Yes, that's the mechanism. Drug of choice for hirsutism is not spironolactone. The drug of choice is OCP. What is the second drug? It is spironolactone. What is the drug of choice for precocious puberty? GnRH agonists. Okay. Remember, now the overall most common cause of hirsutism is PCOS. Do not answer idiopathic. Idiopathic is an older answer. Named criteria I am saying are important. So Rotterdam is what we use for PCOS. We all know it has to be 2 out of 3. What is the most common finding? Is it hirsutism? Is it oligomenorrhea or ovarian enlargement? The order in which I have written is the order. The most common finding is hirsutism. Yes? Okay. Remember, if we are giving you a clinical question and the FSH is high, think of ovarian failure like primary ovarian insufficiency or premature ovarian failure in women less than 40 years. If we give you in the exam low FSH, think of functional hypothalamic amenorrhea. Think of Kalman's, think of Sheehan and pregnancy. I have a question for you. What is the normal value of FSH? Normal FSH is 4 to 10 international units done on day 3. Okay, and normal FSH is seen in Asherman's and in PCOS. Is that clear to everyone? How will you differentiate Asherman's and PCOS then? In PCOS, the LH levels are high, but in Asherman's, LH is not high. LH will also be high in ovarian failure or in menopause. Okay. Now, certain surgeries that your exams are fond of asking, especially vault prolapse and enterocele. The best surgery for vault prolapse is sacrocolpopexy. Then there is uterosacral suspension. Remember, this is a abdominal surgery. This is a vaginal surgery. In sacrocolpopexy, we will use a mesh. Okay. Enterocele, the treatment of choice is McCall's. But can you tell me the older surgeries? So Halbane's and Moshkowitz repair. You should know these names for INICET exams. SUI, stress urinary incompetence, loss of urine with raised abdominal pressure, right? The treatment of choice is TVT, single best answer. The other surgeries are TOT and colpo suspension. What is the full name? It is Birch colpo suspension. These are abdominal surgery, while TOT and TVT are vaginal surgeries. If there is a reproductive age prolapse, you will do a Shirodkar's sling. I have a question for you. Abdominal or vaginal? Shirodkar's is a abdominal surgery, not a vaginal surgery. Okay? Alright, we are coming towards the end now. Which surgery will you do if there is a cervical elongation? We will do a Manchester repair. What is the other name for Manchester? Fothergill's. Remember, for Manchester or Fothergill's, family should be complete. ठीक है? चलो, अगला सवाल करें. Okay, bacterial vaginosis. The key word has to be foul discharge and no pruritus. Please do not get confused with updates. It is not STD and routinely we are not treating partner. As per the update, we will treat partner only and only if there is recurrent bacterial vaginosis, not in everyone. Okay. pH has to be more than 4.5. You will see a clue cell, which is basically a epithelial cell studded with bacteria. The named criteria is AMSIL. I want to know from you, how many do we need in AMSIL? We need 3 out of 4 criteria in AMSIL. Okay, color of discharge is not a part of AMSIL criteria. Yes, what is the color of the discharge? Grey and off-white. On the gram stain, you will calculate the Nugent score. So this is the best test for bacterial vaginosis. Okay, trichomonas. How will you differentiate? Differentiate with keywords. Foul and frothy discharge with pruritus are the keywords. pH is more than 4.5 again. Strawberry cervix, everyone knows it is an STD, so you will routinely treat the partner. VVF, that brings us to the last. So there is continuous dribbling, there is no normal voiding. The IOC is 3 swab. The finding will be upper swab is wet and also stained blue. We are using methylene blue, so it will be stained blue as well. The surgery is Latsko. Okay, it is Latsko. Please remember the most common cause in developing countries. What is the answer? The most common cause in developing countries is obstructed labor. Okay, but in developed countries, it is a post-surgical complication, especially if you are doing surgery for malignancies. So these are the top questions or one-liners or topics that you must know for your exam. So with this, we come to the end. Yes, best is cystoscopy, but IOC is 3 swab. Okay, so with this, we come to an end with obs and gyne sessions. Yes, you will get the PDFs, but the PDF will only be available on the app. We have made the PDF free for everyone. So listen to me carefully. All you have to go is download the app, go to the home page of the app. On the upper right end, you will see a column called as revision. Okay, so on the home page, there is upper right column called as revision. Go to revision and there you will get INICET marathon PDFs. We have made them free for all, so everyone can access those PDFs on the app. Okay, it is not only for subscribers, so everyone can see the PDF on the app in the revision section. We have already uploaded all the PDFs of the sessions that have happened so far. So medicine, pediatrics, dermatology, radiology, all these are already uploaded. So just download the app, go to the home page, go on to top right corner, revision, and then go to INICET marathon PDF within revision. Everyone can access it. Okay, and we will keep it free till your exams so that you can revise it multiple times. Okay, so I hope the session was effective for everyone. Yes, and I hope it is a high yield revision and you are an amazing batch of students. You will all do exceedingly well. We promise you that today's day will be a super revision day for you. You can never do this kind of revision by yourself. So attend the session live. That makes it active recall. That makes it retention very easy. As Dr. Sumer said, we are waiting for you on the other side for an interview. And आप सब chat में लिखेंगे अपना time अपन खुद लाएगा, right? So write it, manifest it, make it happen. And here is your next session uploading in some time. Okay, take care everyone, all the best, and thank you so much for making me a part of your journey. I hope we will be remembered for the legacy that we are creating in the form of you students. Okay, so take care everyone and all the best.
Hello everyone, how are you guys? Hello everyone, how are you guys? Hello everyone, now dear students, we're going to start our session. I hope everything is fine over here. Can you please acknowledge, is everything fine? Audio video is fine? Okay, so we're going to start our session now. Okay, so this is slide number 1 where we have to revise the basically this foramen of skull, okay, in all the exams as you already know. So let's have a very quick revision over here. What is this? Is the cribriform plate, and the cribriform plate is where we have olfactory nerve. Olfactory nerve will be passing from here. This is the optic canal, right? Optic canal. And from the optic canal we have optic nerve passing through. Then we have the fissure. Here we can assume we have the fissure, and from the fissure we have 3, 4, 6 and first division of trigeminal will be passing through. Okay, and dear friends, basically we can say that after that we have 3 foramen in line, that is rotundum, ovale and spinosum. So very easy, like V1 is passing from here, so V2 will be passing from the rotundum, V3 will be passing from the ovale, and from the foramen spinosum we have nervus spinosum, correct? And of course what we can see that we have internal acoustic meatus which will lead to the petrous part of temporal bone. So from here we have the 7th nerve and the 8th nerve, and this jugular foramen which will allow 9th, 10th, 11th nerve. For the jugular foramen also, please keep in mind that 9th, 10th, 11th nerve is there, but 9th is separate. 9th will be separate and the 10th and 11th will be separate from the same jugular foramen. The foramen is divided into two parts by the dura mater, okay? Now, dear friends, after that we have the hypoglossal canal for the hypoglossal nerve to pass through. Then we have the big foramen, that is foramen magnum. Who will pass from the foramen magnum? From the foramen magnum, it's not the spinal cord but the lower end of the medulla which will pass through, right? Now, dear friends, one more thing, that we have the foramen which is contributed by the three bones. What is the name? The foramen which is contributed by the three bones is this one, which is called as foramen lacerum. If I ask you the foramen which is contributed by two bones, what's your name? What will be the name of that foramen? The name of that foramen will be, the jugular foramen, and rest all foramen will be, contributed by a single bone only. And jugular foramen, one more point, that when we discuss the 9th nerve, 10th nerve, 11th nerve, they all are passing from the jugular foramen. They are passing from the middle part. From anterior and posterior part, we have the sinuses. Let us have a very quick recall and tell me what sinus will pass from the anterior aspect of the jugular foramen. What will be your answer? Anterior part of jugular foramen, answer will be inferior petrosal sinus, and posterior part of jugular foramen, answer will be sigmoidal sinus. So far so good? So far so good, yes. Now, dear friends, let's move on and revise this particular picture. What is this? A favorite area of the INI peoples, and they keep on asking what is this nerve, what is we have to identify. This nerve is the cranial nerve 1, this is cranial nerve 2, this is cranial nerve 3, and this is cranial nerve 4 and 5. How we can identify? Let us look at the terminology over here, that we are looking at the thickest nerve. The thickest nerve is what is our fifth nerve, and the next to it is our thinnest nerve is the fourth nerve, okay? Then we have the sixth nerve over here, and now please visualize with me. We have, this is what, pituitary. By the side of pituitary, what you can assume that we have the cavernous sinus, right? So with respect to cavernous sinus, we can see the third nerve, the fourth nerve, the fifth nerve, they all will be related to the cavernous sinus, but on the lateral aspect. But the sixth nerve over here will be related to the cavernous sinus, but on the medial aspect. So only one nerve which is related to the cavernous sinus on the medial aspect is the sixth nerve, right? And we can see from the picture that this is how they are going. And the sixth nerve is piercing one, dura, that is called as duralos canal. That is also one question asked, that what is the structure passing through the duralos canal. Now we have the seventh nerve and we have the eighth nerve. These are the nerves which are passing through the internal acoustic meatus. And here we have the ninth nerve, right, and the 10th nerve and the 11th nerve. Okay, so if you see over here that we have 7th, 8th, this one is 9th nerve, 10th nerve and 11th nerve, and here we have the 12th nerve. Okay, if they ask you superior orbital fissure syndrome, what will be your answer? That will be 3rd, 4th, 6th and the V1 will be involved. But if they ask the orbital apex syndrome along with all these structures, what extra will be involved? What is the differentiator here? The extra will be cranial nerve 2. Okay, if the cranial nerve 2 is also involved, then we will say that yes, this is what, this is your orbital apex syndrome, correct? Now what is this pterion? Now deep to the pterion, they have been asking number of questions. Now if I have very quick revision with you guys, deep to the pterion, what structure will be present? We all know that anterior division of middle meningeal artery will be there, and they ask which, like this is a branch of which artery. Also if they ask which bony landmark, then answer will be lesser wing of sphenoid, lesser wing of sphenoid. But if they ask which part of the brain is there, then answer is what? Then answer will be, stem of lateral sulcus, stem of lateral sulcus. Now, apart from all these points, okay, I would like to add one more point over here. In the last exam, okay, there was some carotid angiogram was shown, okay. The term pterion was not mentioned, although, but this area was referred, almost roughly, it was mentioning near to the, you can say, pterion area. So if that approximate area is given, and artery is asked in the superficial aspect, answer will be superficial temporal artery. So please keep that also in your mind, okay? And now this is particular the area which is very, very, number of time repeatedly asked area. And let me tell what are the questions which can be asked here. So if they say what are the nerves at risk, I'll start with the most common injured nerve. Most common injured nerve will be marginal mandibular nerve. When you are operating in the submandibular gland region, marginal mandibular nerve will be the most common involved nerve. Otherwise, nerves at risk. So nerves at risk apart from marginal mandibular nerve is the lingual nerve, because that is looping around, along with that the hypoglossal nerve. But nerves not at risk are inferior alveolar nerve. Inferior alveolar nerve, why? Because that is present within the bone and supplying the teeth from below. And they, along with that, we have the ninth nerve also. Why? Because ninth nerve, let me show you in the diagram. Ninth nerve is there in the area, yes, but it is not related directly to the gland. It is separated, we can see it from by the muscle. The gland nerve is separated from the gland, right? So this is how we can say that it is not at risk. Now, with respect to the structures, if they ask who is at risk, who is not at risk, then we have to mark accordingly what I have already told you. But if by chance they change the question and they have give you identification, for the identification, please remember if the marked structure, because sometimes they give the cadaveric picture. So just look at the gland and look at the marked structure. If the marked structure is above the gland, if it is above the gland, then it can be either lingual nerve, or also it can be facial artery, because facial artery loops around it, right? And dear friends, we can also say if by chance structure is below, if it is below, then we can mark the hypoglossal nerve that goes below the gland, okay? So this is also important for us, right? Now, dear friends, what is this? Is the greater petrosal nerve, and we have the deep petrosal nerve. What is this, bony plate over here? We can see the bony plate is a pterygoid plate. If this is the pterygoid plate, what is this canal? This canal is pterygoid canal. This is pterygoid plate on one side and the palate on one side. So this is pterygopalatine ganglion within the pterygopalatine fossa. Okay, and if we have very quick revision now, let us start with the very quick revision. We have the lacrimal gland here, position is highest. Because of the highest position, something great is required. So greater petrosal nerve. We have the parotid gland, position wise little less. So less is okay, lesser petrosal nerve. And here we have the submandibular gland at the third number position, first, second, third, and third alphabet is C. So chorda tympani nerve. Okay. So we have the lacrimal gland with the greater petrosal nerve, parotid gland with the lesser petrosal nerve, submandibular gland with the chorda tympani nerve. But if they ask that these are the nerves, branches of which nerves, answer is 797. Okay, so gist of the parasympathetic is this. And what is this? This is some elevation, some dilatation at the junction of common and internal carotid artery, which is called as carotid body and sinus, Now, dear friends, what is body and what is sinus? Body is the chemoreceptor and sinus is the baroreceptor. Okay. Now, what is this over here? We can see the petrosal nerve. The yellow one is greater petrosal nerve. The blue one is deep petrosal nerve, and they are merging together to make the median nerve. But if you guys can help me with this nerve, which I am marking here with the red color, can you guess what's the name of this nerve? This is also petrosal. With respect to petrous one, has to be petrosal. But which petrosal? This is lesser petrosal. This is lesser petrosal nerve. And if you see, we have rows, rotundum, ovale, and spinosum. So ovale, male, L is the lesser petrosal nerve passing through the foramen ovale. I hope that makes sense now. Can you correlate? Yes. Now, dear friends, let's move on and see if by chance this type of picture is given. You need to remember one thing, that both of them are above the superficial to the petrous bone, but L for lateral, L for lesser. The lesser petrosal nerve will be laterally placed. Okay, so this is how we can identify. And if you see deep nuclei of the cerebellum, very, very, very important. And we have the mnemonic: doctors eat good food, And I hope you remember what is D is the dentate, what is E is the emboliform, okay, and what is G is globose, and what is F is fastigial. The names and arrangement both are important. This is the medial to lateral to medial arrangement. This is lateral to medial arrangement. So who is the most medial is the fastigial, who is the most lateral is the dentate. Okay, don't eat greasy food. Yeah, very good. Yeah. That is true, beta, है ना? But right now, so I don't think आप कोई भी food, you are in a sense of anxiety and nervousness. So because somehow you are managing, है ना? But if you can choose also the food, that means your preparation is very good, right? So जिनको डर लग रहा है तो which is normal बेटा. हमें डर उनके लिए लग रहा है जिनको डर नहीं लग रहा. Okay. So these are the layers of the cerebellum. We have the three layers: molecular layer, Purkinje layer, granular layer. Molecular layer cells are basket and stellate. Molecular layer. Purkinje cells will be in the Purkinje cell as well as layer. Granule cells and the Golgi cells, they are present in the granular layer. And the cells, the fibers which are coming from olivary nucleus, only olivary nucleus we have to remember. All the incoming fibers from the olivary nucleus, they climb up to the highest. Because they can climb up to the highest, that's why these are called as climbing fibers. But yes, rest all the fibers, they make the second set and they are called as mossy fiber. But mossy fibers will be held by the granule cells. The mossy fiber will be held by the granule cells and they will be helping it, carrying it forward. The message will be delivered forward, right? After this, we have this particular section, which I always say the section is very, very important for us. Let us identify what is this, beta. This is caudate, this is putamen, and this is globus pallidus. Check this. Putamen and globus pallidus, if you see them, the shape looks like lentiform, right? Shape looks like lens only. But we can also see caudate and putamen are connected to each other with the help of striations. So caudate and putamen, they are called as striatum, and the striatum is the afferent unit. The striatum is the afferent unit. Okay, and pallidum means globus pallidus, that is the efferent unit that will be sending the output from out of the basal nuclei. So far so good. Okay, now if you can identify what are these two, what are these two dots? These are thalamus. T for thalamus, T for third. Which ventricle between them? Third ventricle. If this is the third ventricle, can you tell me what are these two ventricles on both sides? These two are lateral ventricle. If these two are lateral ventricle, now dear friends, we have a septum between the two. What is this septum? Septum pellucidum. If this is septum pellucidum, what will be this structure higher up? This will be corpus callosum. Corpus callosum. If this is corpus above, septum below, further below we have what structure? This one, the round structure. Can you make a guess, beta? What is this round structure? This is nothing but fornix. Now the question is, fornix is the efferent from and the afferent to. Yes, quickly answer. Quickly recall. This is nothing but the fibers coming from the hippocampus going to mammillary body. These fibers are called as fornix. These fibers are called as fornix. And if you guys can help me with these, what are the name of these fibers? These are internal capsule. What is internal capsule? This is a combination of ascending and descending tracts. Combination of ascending and descending tracts, meaning if at all any injury in the internal capsule will take place, it will lead to spastic palsy. Okay. So please remember this. And lastly, if I ask you what is this structure, this is called as, yes dear friends, what is this? This is called as insula. Insula, very, very important areas. All right. Now the next part is the floor of fourth ventricle. There are certain areas which can be asked in the exam. What are these? Superior and inferior colliculus. Superior cerebellar peduncle, middle cerebellar peduncle, inferior cerebellar peduncle. And now what is this bluish green pigmented area in the higher aspect of pons? This is locus ceruleus concerned with the norepinephrine. And what is this part? That is facial colliculus. Which nerve? Seventh nerve. Around which nucleus? Around sixth nerve nucleus. This area is the vestibular area, eighth nerve nucleus. So we have sixth nerve nucleus, eighth nerve nucleus. After that, we have hypoglossal triangle, 12th nerve nucleus. Further below, we have vagal triangle, 10th nerve nucleus. And then area postrema, which is vomiting center, the area postrema. I hope that makes sense. Okay. These are the important areas which can be asked in the floor of the fourth ventricle. Okay. Now, next part, if you see over here, this is very, very important, beta. Why? Because posterior intercostal veins, they are 11 in number on both the sides, but the drainage is different. And I really hope that you must be remembering from the class. Can you quickly tell me, first vein on the both sides? Answer is fixed. What is our answer? Answer is first vein on both sides is brachiocephalic, because this is left subclavian and this is left internal jugular vein. Subclavian is the brachial component, jugular vein is cephalic component. So this becomes left brachiocephalic, this becomes right brachiocephalic. Now first vein into brachiocephalic itself. After that, whatever vein they ask on the right side, answer will be azygous vein only, either directly or indirectly. But when they talk about the left side, we have three areas of drainage. One will be left brachiocephalic, so 1 to 4. 5 to 8 will be accessory hemiazygous. And then 9 to 12 will be, hemiazygous. I really hope that you will remembering this. And if you guys can help me with the level of crossing beta. There are two levels of crossing, accessory hemiazygous and hemiazygous. The levels are T7 and T8. So we have T7 and we have T8. All right. So this is how we can remember zygous vein formation. Also, please follow this. Ascending lumbar vein is L1 and L2. Why this is important? Because abdominal aorta gives 4 lumbar arteries. With respect to 4 lumbar arteries, we have 4 lumbar veins. But out of 4 lumbar veins, L1 and L2, they are draining here in the azygous system. L3 and L4 will be draining into the inferior vena cava. So that is the difference. Again, the point of difference question can be asked. Okay. Now, dear friends, this is what we have the diaphragm. In the diaphragm, we have various, openings. What really happens to the IVC opening? Can you tell me? In the IVC opening, this is going to dilate. This is going to dilate during the inspiration, because the venous return is increasing. Okay. And what is happening to this? This esophagus, esophageal opening will constrict because it is present within the muscle part. But what about the aortic opening? Aortic opening, there will be no change because it is behind. The diaphragm. Now, if I ask you the levels, can you tell me IVC level? IVC will be present at the level of T8. Esophagus T10 and aorta T12. So far so good. Yes, these are important questions with respect to the diaphragm. Also the development of the diaphragm, and particularly Bosch-Dielich hernia. If they ask where is the lesion, if pleuroperitoneal membrane is having any defect, it will lead to Bosch-Dielich hernia, which is most common type of congenital diaphragmatic hernia. The other type of hernia is Morgagni. For that, we have remembered the mnemonic RAM like right anteromedial. Just opposite is the position of the Bosch-Dielich, left posterolateral. Okay, please remember these are very, very important areas. Now, root of lung, what is that? Extension of the pleura. And what is important here for us? For us, very important is anterior to posterior. This question has been asked 2-3 times already, and the relationship is VAB. What is VAB? Pulmonary vein above, pulmonary artery, and bronchus. Okay. pulmonary vein, pulmonary artery, and bronchus. And just behind bronchus, we have bronchial artery also. On this side, we have a single bronchus, but we have two bronchial artery. Again, a point of difference. On the right side, we have two bronchus, but only one bronchial artery. Okay. Now, dear friends, on this side, we are looking at the hilum part of the root of the lung. Whenever you see this section, you see the thickness. Okay, see the thickness here. This is vein, this is artery, this is bronchus. How can I say? One thing I can see from anterior to posterior. Second thing, I can see the highest is the artery. Why? Because I can very clearly see this arch of aorta. Do you appreciate the arch of aorta? Also, I can see this nerve, one nerve which I am highlighting. This is going this way, anterior, and the other nerve is going this way, behind. Which is the nerve anterior? Is the phrenic nerve. The nerve anterior will be phrenic. Okay, and the nerve behind will be the vagus nerve. The nerve behind will be the vagus nerve. So far, so good. Now, this is what is the methodology here? Just let me explain the methodology. Whenever you see the palm picture, it can be cadaveric or non-cadaveric. Always say this side pictures will be thinner, this side will be hypothinner. And outer muscle will be abductor. So start from there only. It is easy that way. So this muscle is outer muscle on the pollicis. So I will say abductor pollicis. This muscle is outer muscle on the digiti minimi. I will say abductor digiti minimi. Just inner is this muscle. So I will say flexor pollicis brevis. Just inner is this muscle. I will say flexor digiti minimi. And deep to that, we can, if at all possible, we can see the opponent's pollicis. But once we are done with that, you can see certain tendons have been reflected. When these tendons have been reflected, we are in position to see these tendons. So here we can say the one which has been reflected is FDS, so that we can see the deep tendon FDP. And from the FDP, we have first, second, third, and fourth lumbricals taking attachment. These are lumbricals. I hope that makes sense, beta. Could you appreciate everyone? Okay. Can you tell me the name of this muscle now, which is very, very deep and coming onto the thumb? This is very, very deep muscle and coming onto the thumb is adductor pollicis. Adductor pollicis, right? And this is what we have pad. Palmar does the adduction. We have dab. Dorsal does the abduction. We can see double pinna, D for dorsal, D for double pinna, bipinnate muscle. Palmar will be absent in the middle finger, whereas dorsal will be absent in the thumb and the little finger. And it will be 2 here because one on this side, one on this side. Okay. So middle finger will be having the 2 dorsal, so and 0 palmar. Okay, P0, D2 like that. Now, so far as rotator cuff is concerned, we have the rotator cuff subscapularis. In front of the scapula, we have subscapular, and behind we have suprascapular. And medial to the scapula, we have dorsal scapular. That was a quick recap, okay, of the different vessels and the nerves present with respect to the scapula. Scapula in front, subscapular, behind suprascapular, medial, dorsal scapular. So similarly, we have subscapularis muscle in the front of the scapula. That means when the subscapularis will pull, the pull will be from front. If the pull is from front, it can do the medial rotation. But where is the infraspinatus muscle? Infraspinatus is behind. It will be pulling from behind. Teres minor will be pulling from behind. So they can do lateral rotation. So medial rotation, they can do lateral rotation. But supraspinatus muscle is not doing any rotation. It is doing abduction from 0 to 15 degree. At this position, if you can help me, 15 to 90 degree is done by which muscle? It is done by deltoid muscle. And more than 90 degree will be done by which muscle? More than 90 degree will be done by serratus anterior plus trapezius working together. And how they will ask in the question? They will give certain, overhead abduction means patient have difficulty taking something from above, something like that. In the carpal tunnel, please remember palmar sensation intact. Palmar sensation intact. Okay. And if ulnar nerve is involved, we have gyne canal syndrome. Gyne canal syndrome. Okay. Fracture of hook of Hammett. Fracture of hook of Hammett. We are talking about ulnar nerve. Ulnar nerve. This is snuff box where radial artery is the content here, radial artery, and superficial branch of radial nerve is the nerve in the roof. If it is involved, it will lead to chiralgia. Wartenberg syndrome. But as you change the name Wartenberg sign, it becomes what? Wartenberg sign is because of ulnar nerve fifth finger abduction, like that. Understanding? Syndrome is the other name of chiralgia, but sign is because of ulnar nerve. So the altogether different entities. Okay. Now gluteus maximus supplied by inferior gluteal nerve. These medius and minimus supplied by superior gluteal nerve. What is the action? Chief extensor, but it can do abduction and lateral rotation as per the fiber. These two muscles are powerful abductor and powerful medial rotators. And upper and outer quadrant is the safer one. By mistake, if superomedial quadrant is used for the injection, the nerve will be injured and Trendelenburg sign will be positive. If the Trendelenburg sign is positive on the right side, means palsy is of the right side, drop will be left, because the sign will be positive on the paralyzed side and drop is opposite. This is epiploic foramen. What we can see over here, above we have liver. This is first part of duodenum. This is lesser omentum, which is attached everywhere, only this part. This is right free margin of lesser omentum. Right free margin of lesser omentum. But behind we can't see. For that we have to take the section. For section we can see behind we have IVC, and we have right suprarenal, and we have T12 vertebra. This becomes the posterior boundary for the epiploic foramen. And here you can see in the right free margin cut section, it shows portal triad. These are all important vital points, beta, based on which question have been asked. Okay. Now, beta, this is only for the quick revision. It's only for the quick revision, right? So those who want to quickly revise, those are doing like with, this is what ascending colon. If you move this direction, we have 5, 10, 15 and 20. What is the feature? Tinea coli, hostration, and appendices epiploicy. Appendices epiploicy will be absent in cecum, appendix and rectum. Appendices epiploicy will be absent. Appendices epiploicy will be absent. All right. If the stone ruptures from this side, it will enter transverse colon. But if it ruptures this side, it will enter duodenum. But even though it enters the duodenum, it will reaching the ileum part, leading to gallstone ileus, and regular stride will be positive. Regular stride. For the spleen, we need to remember phrenicocholic ligament. But a phrenicocholic ligament will be, sustentaculum, which will be, sustentaculum means it is going to support the spleen from below, and spleen cannot grow vertically downward. And we have gastrosplenic ligament and lienorenal ligament. First word is gastro, so gastric artery. Here we have splenic artery. Along with the splenic artery, tail of pancreas. Obviously, because splenic artery goes with the pancreas only, right? Are you able to follow, beta? Now the line is very, very important. This line, the dentate line, because above and below we have important features: endoderm, ectoderm. Okay, ANS. Please remember that part. Very, very important. And this is what you can see, that this is a thoracolumbar fascia, which is giving 3 layers on the medial aspect, anterior, middle and posterior. On this side it is attached to these two muscles, and you can see external oblique is not attached. Internal and transverse is attached. Okay. and this is the line of approaching the kidneys. Once you become urologist, you will be working on the kidneys in a legal manner, right? And you will be having these structures to be removed. What are the layers to be removed? First will be skin and superficial fascia. After that, posterior layer of thoracolumbar fascia. Then erector spinae muscle. This one is erector spinae. Then middle layer of thoracolumbar fascia. Then quadratus lumborum muscle. And then anterior layer of thoracolumbar fascia. Okay. And this muscle is the psoas major. This is thoracolumbar fascia. Now, dear friends, you know that vas deferens will be carrying the spermatozoa, seminal vesicle will be adding the secretion, semen will be put over here. But how it is made sure that it has to come downward only? By this arrangement that is called as internal urethral sphincter. This internal urethral sphincter, it prevents retrograde ejaculation in male. It is absent in female and it is injured in TURP. Now, dear friends, what will be the complication in case of TURP? What will be the complication in case of TURP? Yes, because the internal urethral sphincter is gone, the TURP will lead to retrograde ejaculation, right? This is the median lobe for the BPH, posterior lobe for the carcinoma. If BPH case comes, you are trying to cut it, so there will be injury, right? And here what you need to identify, this is very, very important, levator ani muscle, please remember that, obturator internus muscle and pudendal canal. This is ischium and this is rectum, so this is ischiorectal fossa. Okay, but what is usually asked, these are the markers, levator ani as a pelvic diaphragm, obturator internus and pudendal canal, right? Now what is this over here? We can see the mark, I can see the striations, I can see the branchings, a cardiac muscle. And also what is highlighted over here is the, uh, intercalated discs are there. So what are these? They are helping in fast movement. For the fast movement, of course, you will add the adherence molecule, you will add the gap junction, but you will never add the occludence molecule. So A will be our answer. A will be our answer. Now, what is this gland over here? This gland is, I can see the hair follicle and the sebaceous gland. That's why this is holocrine glands. What is this? Is the, these are the Kupffer cells. Kupffer cells are present in the sinusoids. This is the sinusoid. Okay. And this is the space of Disse. Who is present in the space of Disse? Hepatic stellate cell or the ito cells will be present in the space of Disse. Yes, which of the following is comprised of the dense irregular tissue? Dense irregular tissue means the cover. I hope you remember from the class cover. Okay, cover will be your dermis. B will be the answer. Okay, because this is what dense regular means, tal, tendon, aponeurosis and ligament. That's our mnemonic. Dense regular is the cover. Any cover, periosteum, perimysium, perineurium, etc. And loose irregular tissue, whatever you remember from the first year, that's more than sufficient, loose irregular tissues, lamina propria, those type of structures, okay? And dear friends, of course, you have sacrificed a lot, because if you don't sacrifice for what you want becomes a sacrifice. And I'm pretty sure and I have a firm belief in you guys, and I know that you guys are going to rock. So believe in yourself, believe in God, do the hard work. Okay, rest is Rab Rakha, and you guys are going to rock. I'm going to meet you on the other side. Once you have cracked the exam, we will celebrate your success. All the very best, Vita. All the very best. Thank you so much.
Hi, hello friends. How are you all doing? Such a wonderful session by Madan sir, right? So here we are for the marathon session, and good afternoon everyone. Such wonderful session by Madan sir. I was sitting here and listening to him. Such melodious voice and such a calm way of doing things. Yeah, is that okay? You will have to increase the voice because voice from my end is very good actually. All right. Uh, I'm not really sure about your lunch break, but just to make you guys feel relaxed. Even I haven't had lunch, and it's a marathon session, so we are going to push ourselves a little bit. What happened to the audio? Just a second. But audio is fine. I mean, I'm seeing it. Yeah, now is it better? Now is it better? Is the audio better now? Perfect. So these are the topics that I want to discuss just before your exam, which is the purpose of marathon session. So we are going to start, and you are going to talk more. I'm going to talk less. Malampatti classification, we all know, is a pre-operative airway assessment tool. And why do we need to assess the airway? So that we can anticipate a difficult airway and prevent the complication of hypoxia. Okay. Now we know in Malampatti we are supposed to visualize the four structures. What are the four structures? Pillar, uvula, soft palate, hard palate. Pillar, uvula, soft palate, hard palate. And based on their relative visualization, you have four classes, class 1, 2, 3, 4. In 1, you can see all the four structures clearly and completely. In 2, there is only tip of uvula missing, and that is what you need to remember a week before the exam. Only tip of uvula missing. Only base is visible in 3 and only hard palate in 4. And our obvious understanding is 1 and 2 are going to be easy and 3 and 4 are going to be difficult. Why? More space in 1 and 2 and less space in 3 and 4. But there is a rare entity, which is what is more important for INICET, that is called as Malampatti class 0, where epiglottis is visible, and it is just a rare finding. It has got no relation to difficulty. So you cannot comment about the difficulty of airway at Malampatti class 0. So one of the most important things to remember are the relative visualization of structures, that is push, most common airway assessment tool. 1 and 2 are easy, 3 and 4 are difficult, and epiglottis is visible in class 0, which has got no correlation to difficulty. Now supraglottic airway device is something which is one of the important topics all the time. And we have two generations of supraglottic airway device. The first generation have plain ventilating tubes, only ventilating tubes, which is an older type of device. And we have only one example here, classic. When I say only one example, because unique is just a single use version of classic, that is disposable. How would you identify a first generation supraglottic airway device? One tube. Now, if you look at second generation supraglottic airway device, we wanted to increase the margin of safety. Because with the use of supraglottic airway device, there is always an inherent risk of aspiration. So what we did was, we created a hole in the tip through which we can pass a tube, which is the gastric drain tube. So it is definitely a newer device with better protection against aspiration. But tell me, will a second generation supraglottic airway device prevent the risk of aspiration? No, remember this point. It is not secure. So Dharmesh, when you wrote that it prevents the risk of aspiration, you were little wrong there. Because only two devices are secure. That is cuffed endotracheal tube and cuffed tracheostomy tube. Alright. Now there are three examples of a second generation supraglottic airway device, and how will you identify them? You will identify them with two tubes. No shape is ProSeal. Two tubes. Anatomical shape is Supreme. And no two tubes and no cuff is iGel. Right? iGel. ठीक है. AMBU 40, AMBU Aura 40 is first generation supraglottic airway device. The sizes of LMA Classic are 1, 1.5, 2, 2.5, 3, 4, 5 and 6. Maximum intracuff pressure is 60 centimeters of water. Most common use size for male is 4, male is 5, female is 4, and a child weighing 30 to 50 kgs is 3. Now, apart from all of this, we have a special type of LMA, which is neither classified as first or second generation. Special type of LMA, where you can use it for intubation. You can use it for intubation. That is called as an intubating LMA or LMA fast track. Now, you might wonder, sir, in which condition would we want to use an intubating LMA? In any place where direct laryngoscopy is contraindicated. One of the commonest is unstable cervical spine injury. So what will you do? You will simply insert the LMA and through that you will pass a tube. All right. ASA physical status classification risk assessment tool. Why do we need to assess the risk? For written informed consent. Now we know the general understanding that there are 6 classes in ASA physical status classification from 1 to 6. 1 is a normal healthy adult and 6 is a brain dead patient. So all the living patients with any problem will be 2, 3, 4 and 5, out of which 2, 3 and 4 are increasing risk of medical problems with the patient. So 2 is a systemic disease which is well controlled. 3 is a severe systemic disease which is limiting but not incapacitating. And 4 is a severe systemic disease that is life threatening. But if you have a surgically emergent condition, then it is ASA 5. Any place where surgery is imminent to saving the life of the patient is ASA 5, and ASA 6 is a brain dead organ donor. The only thing that I want you to specifically remember, that despite of a pregnant woman not having a comorbidity, that is a normal pregnancy, you will still consider it as ASA 2. So normal pregnancy will still be considered as ASA 2. Capno. Now this is the clinical approach to capnography that will include the most common clinically asked 8 capnographs. So whenever you get a clinical question in the exam, always ask C whether it is hypo or hypercapnia. Hypo is less than 35 mmHg. Hyper is more than 45 mmHg. If it is hypo, see whether it is developing gradually or suddenly. If it is gradual and decreasing, it points towards simple hyperventilation, that is CO2 washout, or hypotension, that is decreased perfusion of blood to the lungs. But if it is gradually going to 0, that points towards an ill-sustained capnography, that is esophageal intubation. Similarly, if you have sudden hypocapnia, the position of the patient is sitting, and we know sitting position, sudden and abrupt drop of AtCO2 points towards venous air embolism. And when it is sudden to 0, it points towards all the causes of flat capnogram, that is cardiac arrest, disconnection, accidental extubation. If you look at hypercapnia, again ask gradual or sudden. Gradual hypercapnia, where graph is touching the baseline, points towards hypoventilation, CO2 retention. Graph not touching the baseline would be rebreathing of CO2. Sudden hypercapnia seen intraoperatively points towards venous malignant hyperthermia, and sudden hypercapnia while performing CPR points towards return of spontaneous circulation. Yes, rebreathing. One of the reasons for rebreathing is exhausted CO2 absorber, which could be any CO2 absorber, soda lime, bara lime, Amsorb. Any CO2 absorber, when gets exhausted, the patient will show rebreathing of CO2, and rebreathing of CO2 presents with graph not touching the baseline. Side effects of IV induction is very commonly asked. So can you tell me thiopentone, ketamine, propofol, etomidate? I'll wait for a minute for you to answer me. Dharmesh, is redistribution a side effect of a drug? Drug getting redistributed in the body, is that a side effect? Is that a side effect? Very good. Ketamine is dissociative anesthesia. Very good. But is it really a side effect or it is a unique effect of ketamine? Tell me. Is it a side effect or a unique effect of ketamine? Yes. And thiopentone diffusion hypoxia? Are you sure? I can accept ketamine, emergence, delirium. Very good. Etomidate, adrenocortical suppression. Very good. Very good. Propofol, propofol infusion syndrome. Thiopentone, accidental IV injection. Intra-arterial injection. Accidental intra-arterial injection. Yes. The first step in the management is keep the needle in situ. Keep the needle in situ. Dissociative anesthesia is unique effect, not a side effect. The side effect is emergence delirium, which is acute psychomimetic complication. Propofol infusion syndrome is excessive dose of propofol causing a fatal multi-system disorder. No treatment. And adrenocortical suppression is because of inhibition of 11 beta hydroxylase enzyme. 11 beta hydroxylase enzyme. Okay? Very good. I'm very happy. Sugamadex. Anything that you know unique about Sugamadex? Anything that you know unique about Sugamadex? Sugamadex. Anything unique about Sugamadex? Yes, it is a specific reversal agent for rock and wick. It is a specific reversal agent for rock and wick. Causes instant reversal. Very good. Very likely to be asked in your exam. Instant reversal. Instant reversal. Okay. Sugamadex. Inhaled anesthetic agents, the two pharmacokinetic properties that we really want to discuss. Blood gas partition coefficient, that tells us about the solubility in the blood. And solubility is inversely related to speed of onset and recovery. So more the soluble the agent in the blood, slower will be the speed of onset and recovery, and vice versa. Potency is defined by an entity called as minimum alveolar concentration. And a minimum alveolar concentration is the minimum concentration of an agent in atmosphere that prevents response in 50% of individuals. So it represents the ED50 of inhaled anesthetic agents. And we know ED50 or the MAC is inversely proportional to potency. But what is the real question is whether we remember the order, which is very, very important for INICET. Order based questions are very, very important for INICET. So if you arrange the inhaled anesthetic agents in the order of blood gas partition coefficient from less soluble to more, and speed from fast to slow, and if you arrange them in the MAC from high to low, that is potency from less to more, SIVO, ISO, HALO always follow the same order. SIVO, ISO, HALO always form the same order. That is, SIVO is faster than ISO, which is faster than halo, and SIVO is less potent than ISO, which is less potent than halo. Then if I ask you which is the fastest inhaled anesthetic agent, the answer would be xenon. Least potent would be nitrous oxide. Fastest and least potent volatile anesthetic agent. Fastest and least potent volatile anesthetic agent. When I say volatile anesthetic agents, which agents am I excluding? Nitrous oxide and xenon, pure gases. So answer would be desflurane. And overall, which is the slowest and most potent? Methoxyflurane. An overview of oxygen delivery devices. Oxygen delivery devices can be divided into conventional and advanced. Conventional oxygen delivery devices where flow rates of oxygen less than 15 liter per minute can be divided into variable and fixed O2 delivery. Variable would be where FiO2 keeps on changing, like nasal cannula, face mask or Hudson's mask, or non-rebreathing mask, or high concentration mask, or face mask with reservoir bag. Face mask with reservoir bag. While Venturi mask is the only fixed FiO2 delivery device, while maximum FiO2 is delivered using a non-rebreathing mask. Advanced oxygen delivery, where O2 flow rates are more than 15 liter per minute, which are again divided into invasive, non-invasive. Non-invasive are HFNC and non-invasive ventilation. A very important non-invasive ventilation technique that we get asked in the exam is BiPAP, which is your method of choice for acute hypercapnic exacerbation of COPD. And finally, you can put the patient on mechanical ventilatory support. How do you identify it on an image? Nasal cannula, pipe in the nose. Hudson's mask, a mask that you all have used so many times. Face mask with reservoir bag, NRBM, and face mask with a different color valve is Venturi mask. All right. Very, very important are lung protective ventilatory strategies, which are also taught to you in respiratory medicine by Bharat sir, where in an ARDS patient or a patient where you want lung protective ventilation, you decrease the tidal volume. You allow the permissive hypercapnia in respiratory rate. That means you cannot always keep on increasing the respiratory rate. Always start with control mode, then weaning. FiO2 minimum to maintain a saturation of more than 94%, and 5 to 15 centimeters of PEEP. That is because it recruits the alveoli and improves oxygenation. Recruits the alveoli and improve oxygenation. Very, very important. Lot of times you get questions on this lung protective ventilation. Favorite question of INICET. In the last 5-6 exams, every year we have got a question on CPR, and every CPR question has this question where they ask you 10 do's and don'ts of high quality CPR. Do's: compression rate 100 to 120 per minute. That means not less than 100, not more than 120. Depth at least 2 inches. That means not less than 2, not more than 2.4 inches. Allow full recoil. That means do not lean on the chest between compressions. Minimize pauses in the compression. That means do not interrupt compressions for more than 10 seconds, and ventilate adequately. That is, for every 30 compressions, give 2 breaths. Do not give excess ventilation. Do not give excess ventilation. All right. Now, this is a major update. This is a major update. Foreign body obstruction, major update. So first of all, which foreign body obstruction do you treat? Partial or complete? So partial foreign body obstruction, where patient can produce any sound, no active treatment is needed, just promote coughing the foreign body out. If the patient presents with no sound or universal choking sound, immediately start treatment, assess responsiveness. If the victim is responsive, less than 1 year. Less than 1 year. Less than 1 year. Now, less than 1 year, earlier we used to say 5 chest compression, 5 back blows. ठीक, अब हम क्या बोलेंगे? 5 chest thrust, 5 back blows. Only the terminology has changed. We are doing the same thing. Terminology has changed. Why? Because when they wrote chest compression, you thought it is compression of CPR, so you maintained that same quality. While here the idea is very simple. It is just pressing the chest to get a positive intrathoracic pressure more than 1 year. Earlier we used to do only Heimlich's maneuver. Now we will do 5 back blows and 5 Heimlich's maneuver. But at any point of time, if your victim becomes unresponsive, then just call for help and start CPR. All right. This is how you do it. 5 chest thrust, back blows, and in an adult, 5 back blows, 5 Heimlich's maneuver. Very, very important update to be asked in the exam. Few very important points about local anesthetic. They are sodium channel blockers, which act on the inside of the sodium channel. So inactivation gate. The order of susceptibility is A, B, C, irrespective of who tells you what. It was, is, and will remain A, B, C, A, gamma, delta, alpha, beta, B, and C. To increase the duration of action, you add adrenaline. To increase the speed of onset, you add soda bicarb. And the management of CVS last is 20% intralipid solution. Management of CVS last is 20% intralipid solution. All right. Last topic. Intravenous regional anesthesia, long forgotten technique from which we still get questions in the exam. So IVRA is a type of local anesthetic, regional anesthetic technique where you only anesthetize the upper or lower limb for distal surgeries less than 60 minutes in duration. So short duration surgeries of distal limb. Now the idea is to inject a local anesthetic intravenously. So what should be your biggest priority? Using a safe local anesthetic. So prelocaine is preferred. If at all prelocaine is not in the option, then you will give lignocaine. Because prelocaine is not available in India, there is a possibility you might not get that as an option. But which agent will be absolutely contraindicated? Bupivacaine. Why? Maximum cardiotoxicity. Maximum cardiotoxicity, right? So the 2 times that we have gotten this question, then they have only given this image where they have just put up a image of somebody getting a local anesthetic in a peripheral vein with a tourniquet. So it can also be asked as Bayer's block. Bayer's block. Mapleson circuit. Okay, Mapleson circuit, very easy. A, B, C, D and F, which are obsolete, B and C. So don't have to read it. A, B, C, D are adult circuits. E and F, pediatric circuit. Pediatric ka criteria, less than 20 kg. I hope you remember the other name. A, Megill's. D, Baines. E, Ayers, TPs. And F, Jackson and Rees modification of Ayers TPs. A is for spontaneous ventilation, D is for controlled ventilation, and E and F both spontaneous and controlled ventilation in a pediatric patient. Okay, in a pediatric patient. All right. Happy? Sarthak? So this is what I wanted to tell you. In INICET, anesthesia comes pretty, what you can say, predictable. You can get 3, 4, 5, 6. In one exam, we have even seen 7, 8 questions. You can also get 1. But whatever comes is the one question that you are 100% sure about. So that is why we do this. Despite of less number of questions, every question in INICET makes a huge difference. I wish you all very, very best. Keep working hard. Last week before your exam. Best wishes are with you, and I'll see you soon on the other.
Hi everyone. I hope I'm visible and audible. Let me see. All right, so let us see what we can do in half an hour session and quickly see what are the things which are important. Hi, everyone. Good afternoon, everyone. Pragya, Swati. Okay, so let us see in half an hour what I can give. So let us see some points regarding from DVD. I think the first thing you should know is this identification of the layers of the retina. In this animation, it has been asked quite a number of times. Like this is the outer word is towards the choroid and inner word is towards the vitreous. So actually there's four level of cells. If you remember the four level of cells, then you can tell uh, the level which is the cell which is closest to the vitreous is the ganglion cells. Then this is a bipolar that comes in inner nuclear cell. And from bipolar, the impulse goes to ganglion via plexiform. While the third category of cells is the outer nuclear layer, that's the rods and cones. And then the last is retinal pigment epithelium. Then we have choroid. So this is one important thing, that identification of the rods and cones. So if you see very carefully, this is a cone, this is a rod. The outer segment of the rod and cone determines the shape. And that has been asked, that contains membrane discs. Yeah, lunch break तो मुझे पता नहीं Rajni. Okay, so that's the rod, that's the cone. Outer segment contains the membrane disc. And the rods and cones, from rods and cones, the impulse goes to bipolar via this synapse, is known as plexiform. And generation of impulse, yeah, good, that is at rods and cones. So identification of layers is an important question. Then second thing is the vision senses. There are four vision senses: light, color, contrast, and form. And maximum questions are asked on this Snellen's chart. The Snellen's chart, you should know the top letter is 660. Patient stands at 6 meters. Normal person can see 6 meters. 60 from normal person can see this letter from 60 meters. The MER, it is based on minimal angle of resolution of only one letter is known as just reverse. 624 MER is 4. 660 MER is 10. But the total letter subtends 5 segments. So if total letter is asked, you have to multiply the MER by 10. In 612 MER is 2. Total letter subtend 10. And this was last year's November question. EDDRS and landlords cannot be used for vision testing in children because these are subjective tests. It is based on log MAR chart. EDDRS and landlords is for illiterates. EDDRS is for amblyopias. Now amblyopia has been asked multiple times, and one question I think amblyopia will be asked. So I'm going to take amblyopia next. So amblyopia is what? Amblyopia is that after best corrected visual acuity, that after giving the best correction, the vision is not improving in one eye. That is known as amblyopia. And see, there are three types of amblyopia. You should know that. One, because of difference in refractive error, that is known as anisometropic amblyopia. First thing, very, very important, best corrected visual acuity is less. And there should be two-line difference. Means one is 6.6, other is 6.12 or more. That is amblyopia. One can be because of difference of refractive error. One can be due to squint. And one, maybe the light is not reaching the retina, maybe due to congenital cataract, maybe due to ptosis. For this, the management is as soon as possible. Whatever is the underlying cause, as soon as possible treat. Like that's why the treatment of congenital cataract is as soon as possible cataract surgery. But for anisometropy and strabismic, the first thing is you give spectacle testing. And in children, you do under cycloplegia atropine. Then occlusion of the normal eye, or you put atropine drop in the normal eye so that you want the lazy eye to work more. And video games to stimulate the lazy eye. All this is done within 8 years of age. After that, there's no purpose of treating amblyopia. So amblyopia question is very important question. Refractive error. What is refractive error? Ametropium is refractive error. Difference is known as anisometropy. This was asked in FMGE 2026 January. So expect this question on amblyopia in May INICET. So what is refractive error? What question they can ask in refractive error is the next thing which I will take up. See, refractive error, they mostly ask this retinoscopy values and prescription of glasses. Like for example, they give an equation like this: +2 diopter spherical. Now spherical means it's this lens is working in all axes. So +2 and +2 work in both axes. And cylinder, what you people do mistake is cylinder at 90 means it is kept at 90, not working. Kept at 90 means it is working at 180. 90 means vertical axis and 180 means horizontal. So if it is kept at -1, cylinder at 90, it is working in 180. So vertical axis become +2, horizontal become +1. Both plus means that both the rays are focused behind the retina, because you have to converge them. So it is compound hypermetropic astigmatism. Now ये तो BTR करने रटना है कि against the rule horizontal axis steeper is against the rule, vertical steeper is with the rule. ये तो रटना है. But कैसे इसको याद करेंगे? How do you remember this? The one which is more in front as compared to other ray is more steeper axis. So here this y axis and for example this is A axis and this is B axis. A is more steeper because A is focused more in front, and A should be given value +1 because you have to converge it less. So +1 is more steeper axis, and that is horizontal steeper, that is against the rule astigmatism. Yes. So one more question I'll give you over here. For example, -2 diopter spherical is given to you. What is the refractive error? This is simple myopia, no astigmatism, because cylinder is not given. This is simple myopia of -2 diopter sphere. Means all the rays are focused in front at a single point. That is simple myopia. But if it is given -2 diopter cylinder, you can't solve the question unless and until I give you axis. For example, at 180 degree. Then answer is spherical is not there. Only cylinder is kept at 180. It is working over here vertical. So 0 and -2 means one on the retina, one before the retina. Simple myopic astigmatism. But minus is more in front because you have to diverge, and that is in vertical. So vertical steeper is known as with rule astigmatism. So one question amblyopia, one question of refractive error. Determination of retinal layers is an important question. Then cataract surgery and its complication is the next which I am taking up. Cataract surgery, phacoemulsification, each step of the cataract surgery is an important. Like the first step is you give incision into antechamber. Aqueous comes out. So this was asked November 2024. Viscoelastics are put to maintain the antechamber. Multiple times it is put. Then a circular opening is made, that is trypan blue dye, antercapsular excess. Then hydrodissection under the capsule, and it is contraindicated in what? Who can tell me it is contraindicated in which cataracts? Posterior polar cataracts. Because already the posterior pole is very thin, and posterior polar, like onion peel appearance, is very thin. It can rupture the posterior capsule. And to separate the nucleus from the cortex is hydrodelineation step. Why to separate? Because you have to emulsify the nucleus into small pieces. Alright, so that is phacoemulsification, that is emulsification by piezoelectric crystals. Everything is aspirated, cortex and nuclear material by lead zirconate piezoelectric, and everything is taken out. So lens capsule is left behind. You put an intraocular lens in the posterior chamber. Behind the iris is posterior chamber, and sutures are not required because it is very less incision. Viscose should be removed because it can cause high pressure after cataract surgery. It can cause high pressure after cataract surgery, and it can cause one more thing. It can cause inflammatory reaction in the anterior segment. What is that known as? What is that complication if visco is not taken out? What complication can have next post-op day? One, high pressures. Other, toxic anterior segment syndrome. And that toxic anterior segment syndrome has to be differentiated by endophthalmitis. Endophthalmitis means vitreous is involved, which I'll take up in last, acute red eye. So cataract surgery complication is very important. Most common is the posterior capsular opacification, Elschnig pearls, for which you do laser capsulotomy. The NEET exam 2025 question, endothelium is the most vital layer of the cornea. It has sodium pump. If that is not functioning, same in Fuchs dystrophy, which has Gateta, there can be edema in the cornea, epithelium edema lead to bullous keratopathy. That is Fuchs dystrophy and complication of cataract surgery also. Good answer, Taz. Then there is a Seidel test. Anywhere in the ophthalmology, Seidel test positive comes. Seidel test positive means that the wound is leaking. So aqueous comes out, the pressure is less, and IOP, shallow AC and low IOP. Sorry. And two examples of high IOP and shallow AC. One is pupil block glaucoma due to iris Bombay mechanism. Second is aqueous goes into vitreous and pushes the lens and iris forward. Which of these two will be A and B answer? Which of these two will be treated by laser iridotomy? Pupil block glaucoma is laser iridotomy, while aqueous misdirection, vitrectomy is done. It is very difficult to manage. Also inverse glaucoma, because psych projects are given here as a management. So inverse glaucoma is aqueous misdirection, not reverse. What is reverse glaucoma? November 2025 question. Reverse configuration of iris. In which glaucoma? Young myopic male after exercise, high pressures. Krukenberg spindles was the question. reverse iris configuration. Who can answer? Pigmentary glaucoma. So iridotomy is done for pupil block glaucoma. So cataract surgery and complication is one important question. Then you should know, see, eyelid I'm not taking, eyelid is a factual thing, but ptosis is important. Ptosis topic is important. See, absence of eyelid crease, congenital ptosis. But if absence of eyelid crease with worsening during the day, myasthenia, with jaw winking phenomena, lateral pterygoid is implied, that is Marcus-Gunn jaw winking phenomena. Absence of eyelid crease, yes, is congenital ptosis because of mild development of the muscle. Which nerve palsy? Next question I'm taking away is nerve palsy. Which nerve palsy can have ptosis? There are 3 nerve palsy, 3rd nerve, 4th nerve, 6th nerve. Only 1 nerve palsy can have ptosis, that is what? 3rd nerve palsy. Because 3rd nerve palsy supplies LPS. So 3rd nerve palsy is the only nerve palsy with ptosis. With down and out eye, why? Because only 2 muscles will work, SO and LR. And pupil is dilated, there is anisocoria. What is anisocoria? Difference of pupil size. So anisocoria can be seen only in efferent lesions of the pupil pathway. So efferent means either 3rd nerve palsy or AD's pupil. What is AD's pupil? Ciliary ganglion lesion. So in AD's there is no ptosis, no squint. So in AD's also there is dilated pupil, but no ptosis, no squint. And AD's can be constricted by what? AD's can be constricted by diluted pilocarpine test. So only in the entire world, diluted pilocarpine can constrict only one pupil, that is AD's pupil. So 3rd nerve palsy will have ptosis, down and out eye. Then 6th nerve palsy will have what? 6th nerve palsy will have esotropia. And to know the degree of squint, you have to know the Hirschberg reflex test. That if the pupil reflects at the limbus, it is 45 degree. At the pupil border, it is 15 degree. So here it is 45 degree equal to 90 prism. Why? Because it is ESO means convergent squint, right esotropia, maybe right 6th nerve palsy. And why 45? Because it is at the limbus. Now the 6th nerve palsy comes in incomitant squint. Means if you cover the eye will not move. That is either incomitant, either paralytic or restrictive. Comitant means eye is moving. So if you cover the eye, fixating eye, the other eye come to the center. So this cover test differentiate comitant from incomitant. Which test differentiate paralytic from restrictive? Force reduction test. Restriction is positive in restrictive squint. You can move the eyes, means negative test in paralytic squint. So if there is a paralytic squint having esotropia, has to be 6th nerve palsy. And paralytic squint with hypertropia is 4th nerve palsy. Why? 4th nerve supplies SO, and SO is a depressor. So SO will cause what? Hypertropia. That eye will go up. You can see here left eyes go up. That is 4th nerve palsy. So nerve palsy with hyper, 4th nerve palsy. Nerve palsy with ESO, 6th nerve palsy. Nerve palsy with ptosis and down and out eye, 3rd nerve palsy. And 3rd nerve palsy, there is anisocoria, means pupil. So one question on pupil is also important. Like if there is a dilated pupil in 3rd nerve palsy, that is Hutchinson's pupil. That word is given in 3rd nerve palsy due to aneurysm. So 3rd nerve palsy pupil is Hutchinson's pupil if the cause is due to aneurysm. Aneurysm of the posterior communicating artery. Anatomy question. Who can tell me what test is being done here? Right, left, right, left, right, left. Swinging flashlight examination. Here if you throw the light in right eye, both are constricting. Means right eye, 2nd nerve and 3rd nerve is working well. Because 2nd is afferent, 3rd is efferent. Even left 3rd nerve is working well because left 3rd is constricting. Left is constricting. But when you swing the light to left eye, it is dilating. It is paradoxical dilatation, means it is Marcus-Gunn pupil of the left partial lesion of the optic nerve. So Marcus-Gunn pupil is seen in partial lesion of the optic nerve. Maybe optic nerve compression, optic neuritis, first sign is RAPD. Complete lesion of the optic nerve will lead to amerotic pupil. So amerotic means complete lesion of the optic nerve, one pupil. Marcus-Gunn partial lesion, that is the first sign of optic compression. Optic tract has sluggish reactions known as Wernicke's pupil. Pretectal, argal reversal pupil, most common cause neurocephalus. That is accommodation reflex present, light reflex absent. Because pretectal involved only in light pathway, not in the near pathway. Neurocephalus is the most common cause. So all these are efferent, and efferent there is no anisocoria. Anisocoria is only seen in efferent lesion like 3rd nerve palsy with down and out eye. Without down and out eye, AD's pupil. And pilocarpine test, diluted pilocarpine is constricting AD's pupil. One more have anisocoria, that is Horner syndrome. Now, recent question, November 2025, Horner syndrome. Horner syndrome is a problem in sympathetic pathway. Pupil is smaller because sympathetic is not working. Sympathetic dilates pupil. So pupil is smaller. There is anisocoria. Small pupil is a problem here now. More in dark conditions. Ptosis because of Muller muscle. Heterochromia, difference in iris because of iris melanocytes are not developing. Mostly seen in congenital only, not acquired. Sweating is lost. But the question asked in November 2025, sweating is normal only in which lesions? Post-ganglionic. Here the ganglion is supracervical. So in post-ganglionic like IC aneurysm, cavernous sinus, sweating will be normal. And in Pancoast tumor, sweating will be lost because Pancoast comes in pre-ganglionic. Wallenberg syndrome, syringomyelia, central sympathetic chain, sweating will be lost. Sweating is normal only in post-ganglionic Horner syndrome. So pupil is one question, nerve palsy one question, refractive error one question, acute retine 2-3 questions, in which keratoconus can also come sometimes. Visual field one question. But always in visual field we have to know it is a patient's view. Like for example in visual pathway, if there is a right side optic nerve lesion. So right side optic nerve lesion means what? The lesion will be like this. Total loss of the visual field of the right eye. So this is right, this is left. This is right anopia. Optic chiasma will have both nasal fibers are not working. So it will be bitemporal hemianopia. Pituitary gland tumor, that is heteronymous. And when the lesion is behind the chiasma, retrochiasma, for example, on the left side, left optic tract. So left optic tract will have right homonymous hemianopia, means retrochiasma are always contralateral homonymous. So it is the left optic tract, it is right homonymous hemianopia. But if it is right homonymous hemianopia with macula sparing, that will be occipital lobe. Means 6th one is right occipital lobe, it will be left homonymous hemianopia with macula sparing. While temporal parietal have only one quadrant involvement, in temporal, see it is right homonymous, it is right, this is left. So left temporal lobe has inferior fibers involved. Superior defects are there, like pie in the sky. And this is what? This is left homonymous. So the lesion is behind the chiasma on the right side. Right parietal lobe will have superior fibers involved, so pie on the floor. So always visual field is opposite to retina fibers. But if I draw, let us see if you can answer this question. If I draw visual field of one eye, try to answer this question. This is visual field of which eye? Right or left? These all are taken by kinetic perimetry. Perimetry is for visual field examination. Kinetic perimetry gives gross disorders. This is taken by a static perimetry, like in glaucomas. So this is right visual field, this is blind spot. Blind spot is because of optic disc. So what is happening this? What is this? Enlargement of blind spot. So enlargement of blind spot is seen in 4 differentials. One, optic disc large in size in high myopias. Can be peripapilla myelination. Bilateral will be seen in papilledema. And optic neuritis. So papilledema, high myopia, optic neuritis and peripapillary myelination is bilateral, is enlargement of blind spot. While if the visual field effect is like this is blind spot, centrocecal scotoma. Central scotoma means papillomacular bundle 5, central fibers of the retina involved. That is the first sign of optic neuritis. And most common cause of optic neuritis is the radio question, multiple sclerosis. Investigation of choice, MRI. IV steroid is first given, then oral. And optic disc can be normal because it comes in retrobulbar category. All vision senses are decreased, color and contrast are more decreased. That was asked in May 2025 INICET question. And mostly seen in females with painful eye movements because of involvement of SR and MR, because they are anatomically associated with optic nerve. And in glaucoma visual field, last visual field question will be in glaucoma. The first visual field defect in glaucoma is paracentral scotoma because of involvement of which fibers in the retina? Arcuate fibers. So paracentral, when it joins blind spot cedral scotoma, then all the arcuate fibers are involved, that is arcuate scotoma. Then 2 arcs, like double arcuate, like a ring scotoma. And 1 step is left on the nasal side, that is ruinous step. Ultimately central, and last defect is temporal. Why? Because the nasal fibers of the retina are most resistant. So temporal defects are last. So what are the differentials? Double arcuate is what? Differential of what? Ring scotoma tunnel vision. So what are the differentials of ring scotoma tunnel vision? And how much tunnel will be there to call the patient blind? Less than 10 degrees. What are the other criteria of blindness? Visual acuity less than 3/60. So ring scotoma mostly occurs when peripheral part of the retina is not working. So let us see some retina questions which have ring scotoma. What is that? A young patient comes with peripheral vision loss, night blindness, maybe advanced stage ring scotoma, tunnel vision, delayed dark adaptation, that is retinitis pigmentosa. Investigation of choice, electroretrogram, first A wave decrease and then B wave. Electrooculogram is the investigation of choice for Best disease, because Best disease and Stargardt's involve what? RP layer of the retina. They are dystrophies of the RP layer, in which Arden's ratio is decreased. EUG is the investigation of choice, again a INICET question, in which autofluorescence has what? Lipofuscin deposit in the center, like an egg yolk. In Stargardt's, everywhere. But in Stargardt's, in angiography, what happens? Dark choroid is there, because lipofuscin is covering the entire RP layer. So choroidal fluorescence is not seen. So retinitis pigmentosa is differential of ring scotoma. Then advanced glaucoma. Two pharmac questions. Two drugs. One anti-epileptic, one anti-malarial can cause ring scotoma. One is vigabatrin and one quinine, not chloroquine. Vigabatrin and quinine can cause ring scotoma tunnel vision with retinitis pigmentosa, of course. Then retina vascular disorders like cherry red spot seen in CRO. That is a vascular disorder. What history will be there in CRO? Systemic history. That patient of rheumatic heart disease comes to you, maybe cardiac arrhythmia comes to you, sudden transient blindness. Sudden transient blindness. Transient because ambulance can go away, vision can come back. And there will be cherry red spot, where ganglionic layer is edema, red is normal. But history of blunt trauma with cherry spot will be Berlin's edema. And so many times this question is asked, pediatric question, if organomegaly is there with cherry red spot, it is Niemann Pick. No organomegaly, Tay-Sachs. But only one quadrant of the retina is having edema, that is branched retinal vein occlusion. So that will have visual field defects. That is branched retinal artery occlusion. What about CRVO? CRVO has splash tomato appearance, blood thunder appearance, 100-day glaucoma. So sudden vision loss can be seen in CRVO also. All the four quadrants will have hemorrhages, exudates. Which hemorrhages are these? Flame hemorrhages. Cotton wool spots. Tortuous dilated vein. The normal arteriovenous ratio in retina is what? 2:3. In hypertension becomes 1:3 because artery wall is thick and compress the vein. When venous occlusion can be 1:4. But again, in one quadrant involvement, it will be BRVO. That will be one quadrant involvement, so visual field defects. CRVO will have tomato splash appearance, 100-day glaucoma. Diabetic also, these hemorrhages can come. But hard exudates are more in diabetes. Total blot hemorrhages are more in diabetes. So identification of hard exudates and soft exudate. Soft is what? Cotton wool spot. Large fluffy, large fluffy border is soft. Small in clusters is hard. Flame is in nerve fiber layer like a flame. And outer plexiform has synapse, more space. So dot and blot hemorrhages. That is seen in NPDR stage of diabetes. Very mild NPDR will have microisms. INICET question, hyperfluorescent dots are seen on angiography because of microisms. Systemic management is done. Only two signs are hyper on angiography in diabetes. One is microisms and one leaky vessels, new vessels. So whenever new vessel word comes, whether anywhere in the eye, new vessel word come, it is a proliferative stage of diabetic retinopathy. And new vessels can pull the retina upwards, causing which detachment? Tractional detachment comes in PDR stage. New vessel word comes in PDR stage, which is hyperfluorescent branching, for which you have to do pan-retinal photocoagulation. That is also differential of ring scotoma tunnel vision, because you destroy the entire retina, sparing the macula. But who can tell me the only reason of sudden vision loss in diabetic patient? New vessels can leak the blood can go to vitreous cavity. So the only reason of sudden decreased vision in a diabetic patient with floaters, with dark glow, is vitreous hemorrhage. So floaters, anytime is floaters word come, floater means there is a vitreous involvement. Flashes word. flashes are three differential: migraine, rheumatogenic retinal detachment, and posterior vitreous detachment. So answer this question: a high myopia with floaters, flashes, field effect. Floaters, flashes, field effect means floaters cannot be seen in migraine. So answer can be PVD or retinal detachment. Curtain sign is visual field effect. That will be rheumatogenic retinal detachment. So floaters, flashes can be seen in posterior vitreous detachment also, but curtain sign means field effect can be seen only in rheumatogenic along with floaters and flashes. That is high myopia because they have holes in the retina. So retinal detachment is also next question. Tell me one last detachment. A pregnant lady comes with retinal detachment. What is the answer? Exudative. Malignant hypertension with retinal detachment. Exudative. So retinal vascular disorders, CRVO, CRAO or diabetic retinopathy, retinal detachment is also important question. What investigation will tell about the central retina? Central retina investigation is OCT. INICET question. Structure of the retina told by OCT. Function of the retina told by visual field, perimetry. So OCT, this is PVD showing macular hole. This OCT showing what? Thickness of the retina is increasing. That is cystoid macular edema, multiple causes. Multiple causes, drugs with flower petal appearance on angiography, with prostaglandin, pilocarpine, high dose of niacin. Even in diabetic any stage, anti-VEGF injection is given, and Irwin gas syndrome after cataract surgery complication. So you have to differentiate this cystoid macular edema from central serous retinopathy, which is an example of which detachment? Exudative. Why? Because more fluid is coming from choroid. So separation of neurosensitive from RP's retinal detachment, ink blot appearance, smokestack appearance in a young male, type of personality under stress, with metamorphosia, distorted vision, Amsler grid is asked there. That is outer barrier break, CSR. Type of exudative detachment. Because more fluid is coming from choroid, so the dye will rise like a smokestack appearance. So OCT tells about the structure, perimetry tells about the function of the retina. Angiography tells about the vessels of the retina. Now last 10 minutes I will take the acute red eye question. 2-3 question will ask an acute red eye. So let us see if you can answer acute red eye question like this. Starting with, who can answer this question? There is an acute red eye, but there is no pain. Answer in your mind. 10-15 questions we will discuss in last 10 minutes. Answer is no pain, blunt trauma, subconjunctival hemorrhage is the answer. No intervention, automatically resolves. But if the acute red eye will pain is there and anterior segment is not involved and itching is given, itching means there is an allergic conjunctivitis. And in allergic conjunctivitis there is this papilla in cobblestone appearance. But always the answer is not vernal keratosis. Why? Because if there is a history of contact lens history, then giant papillary conjunctivitis, more than 1 mm papilla. If the history of boy with ropey discharge in summers, then the answer is what? Horner trunta dots, vernal keratoconjunctivitis, for which topical antihistaminics and steroids are given. Topical, not oral. Well, discharge comes, follicles comes, discharge comes, then infection comes. Discharge can spread. So spread, who can spread more? Virus spread more. So serious discharge, epidemic spread more family members, more school going children, more offices going people at the same time, adenoviral. Well, mucopurulent discharge will be matting eyelashes will be bacterial. Most dangerous bacteria, gonococcus, in child as well as in adults. An INICET factual question, hemorrhagic conjunctivitis differentials. PACE. PACE was asked, picorna, not polio. Adeno, Coxsackie, A, B. Only A, not B. And most common cause is enterovirus 70. But if there is an acute red eye with rheumatoid arthritis, that can be either episcleritis or scleritis. Now, which drug can blanch episcleral vessels, which is only mydriatic, not cycloplegic? Phenylephrine. And scleritis, pain is more, and that's why in scleritis, keratitis, enterovitis, adjuvant treatment of choice is cycloplegics. And scleritis heals by what? Thinning. Underlying sclera is blue, that is can bulge also lead to staphyloma. And if limbus is not involved, it is ciliary staphyloma. If limbus is involved, it is intercalary staphyloma. Who can tell me posterior staphyloma seen in which conditions? Which refractive error is posterior staphyloma? High myopia. And corneal ulcer complication can be anterior staphyloma. But if this acute painful red eye come with hypopyon, what are the 3 conditions are ruled out? It cannot be episcleritis. It cannot be conjunctivitis. It cannot be, what should I write? Keratitis or scleritis? Scleritis. Keratitis can have. These three are outside eye problems, so hypopyon is not there. So acute red eye with hypopyon after cataract surgery with vitreous involvement, answer will be what? Cornea sclera not involved. Organism, staph epidermitis most common. After 1 month, bacterium acne, acute endophthalmitis. Maybe seen after trauma also, then answer will be a bacillus cereus. But cornea sclera involved, it will be acute panophthalmitis for which systemic antibiotic is given. And then any keratitis can be associated with contact lens, but most commonly pseudomonas. But history of trauma with mild symptom with satellite lesions, dry, rough texture ulcer, fungal. Scraping is done. Signs are more, symptoms are less. Well, acanthamoeba, last time question. Contact lens with dirty water, excruciating pain, symptom more, but ring infiltrate signs are less. Calcifer white stain, non-neutron E. coli culture. Well, very important question of PG exam. What is this blue color? Cobalt filter. Which dye is used? Fluorescein dye. Under filter, it's a clinical diagnosis, herpes simplex, dendritic ulcer. Sensation only decrease in viral keratitis. Herpes zoster will have Hutchinson sign, but tapering ends. Knobs are not there. This herpes simplex, acyclovir, adjuvant will be cycloplegics. Now, two very important differentials of acute red eye with high IOP corneal edema. Hypopyon can be there. One is what? With keratic precipitates, posterior seneca, small pupil. If small pupil, then anteruveitis, for which HLA testing is done because most common cause is idiopathic. Ankylosing spondylitis is important cause. Cyclogic is given as an adjuvant. Main answer is topical steroid. But if the pupil is dilated pupil, then it is acute angle closure. That is the iris Bombay mechanism for which iridotomy is done. And walk triad is there. Here pupil is dilated, anteruveitis pupil is small. And adjuvant, here cyclogic is contraindicated. In anteruveitis, cyclogic is given as a treatment. So this pupil can become what? This pupil can become, what is the name of this pupil? Irregular pupil, festoon pupil, seen after treatment of uveitis. So asked in two questions asked on festoon pupil in FMGE 2026 January. So festoon pupil is seen after treatment of uveitis. What treatment? Cycloplegic. And that glaucoma will be uveitic glaucoma. Investigation important is HLA-B27. HLA testing because most common cause is idiopathic. Bamboo spine appearance. Radio question. So 2-3 question on acute red eye can also come. And one last I will touch keratoconus. So keratoconus is the very important. So many questions have been asked in keratoconus nowadays. Young patient coming with rubbing eyes because of vernal keratoconjunctivitis, maybe frequent change of glasses because of astigmatism, but no pain. One reason can be pain, which was asked last time. Down gaze, Munson sign, curvatural myopic astigmatism, oil droplet reflex, cataract seen in galactosemia, V for vertical, V for walk stria, horizontal stria seen in HAB stria in congenital glaucoma, Seizuric reflex seen on retinoscopy because of astigmatism. Investigation of choice was asked January 2026 FMG question. Topography, surface of the cornea is changing. Pentacam, Obscan are topographers. Contact lens choice, rigid cast permeable, but who can tell me in early keratoconus, who can tell me? Early keratoconus, soft dash contact lens can be given. Toric, whenever toric word comes, astigmatism come. Because bulging has not started, so soft lens can be given and toric for astigmatism. But procedure of choice is C3R procedure to make the cornea strong by riboflavin under UV rays. And then intracorneal ring segments, that is PMMA, implanted in stroma of the cornea because that's the thickest layer, intracorneal ring segment to stabilize the cornea. Well, keratoplasty requires nylon sutures. Eyelid sutures are silk sutures in tarsorrhaphy. Vicral sutures for conjunctiva, pterygium surgery are absorbable ones. And this was asked last INICET. What happens? Descending membrane is the most elastic layer. It can rupture. It can lead to what is the only reason of acute red eye in keratoconus? That is known as acute eye drops. For which you put what? You put a gas, name the gas, which used in retina surgery also, which can expand and go up. That is SF6C3F8 can plug the descending membrane. That is known as pneumatic descemetopexy. Gas injection in anterochamber. C3F8 gas can be used. SF6 gas can be used. That was asked in last November INICET. Same can be used in pneumatic retinopexy. Pneumatic means gas, not air. 100% gas can expand. C3 if it SF6 in 100% concentration. And if it is used for retinal detachment, which type? Rhegmatogenous. For only superior rhegmatogenous. That is pneumatic retinopexy. Close the hole by laser cryo. Here you have to close Descemet membrane. That is pneumatic descemetopexy. So these are some questions or some quick revision of some important topics from my side from ophthalmology. Best of luck. Just do well. Just concentrate while giving the exam. Before one day, I did not study after 8 o'clock, attend in the class also before the exam, because after 8 o'clock, whatever you're studying is of no use. It's actually, you're just cramming. Just relax, because if you relax, 10 questions can get right from your relaxation mode only. All right. Thanks for a lot for listening, and best of luck from my side. Do well and come with good ranks. Best of luck.
Hello. Good afternoon. Can you confirm whether I'm audible, visible to all of you? Can somebody confirm whether I'm audible, visible to all of you? Hello, hello. Yes, I'm good. Dharmesh and Dr. Ankita Pandey, Pramod ji. Okay. So, welcome to the YouTube live session of Psychiatry Revision Marathon. We shall try to target 100 plus MCQ points on 20 plus important psychiatry topics for next 20 minutes. Is my voice clear, audible? Yes, no. If there's a problem in the voice, let me know. If my voice clear and audible. So the first thing to begin with, yes, I deserve to do post graduation in the central or the best institute. Yes, you do. You do deserve a decent chance. Give INICT exam with your 100% effort. Yes, you do deserve. Yes, you deserve. Those students who do post graduation and aims are like you only. They are not different. They also have two hands, 2 feet, and equal amount of brain as much as you have. And you can be there. You deserve a decent chance to do post graduation in center. My best wishes with you always. So the most favorite topics of psychiatry in INICT. Number one, psychopharmacology. Okay, the drugs used in psychiatry. Number two, de-addictions psychiatry. Psychiatric specialities are very commonly asked specialities. Okay, de-addiction, child psychiatry, dementia topic, because geriatric psychiatry is a super specialization. Then sleep and EEG, which we have very well covered in DVT, so I'm not covering it today. And basic phenomenology and clinical psychiatry. 20 slides, 1 minute each slide. It takes a lot of time to decide which 20 slides to give. Antipsychotic. It's their favorite topic. They have asked antipsychotic and its side effects many times. Typical and atypical. Are all of you well versed with this slide? Typical is D2 blocker, atypical is D2 plus 5ST2A plus 5ST2C blocker. Typical take care of positive symptom, atypical take care of positive and negative symptom. Are all of us well aware about this slide? Have you seen this slide in main class, DVT, T&D, every class? Slide number one. Only 20 slides, 20 minutes, each slide 1 minute. Not reading, memorizing. Are you trying to memorize right now? So if I am at your place, I will memorize like this. Typical D2, atypical D2 and serotonin. Okay, typical positive symptom, atypical positive and negative symptom. Typical EPS and prolactin elevation more common. Atypical, metabolic more common. Have you revised these 4 points? We don't have to rush. One slide, 1 minute. In next 20 minutes, if you revise these 20 slides, I ensure 100 MCQs in psychiatry. Each page, I can make 5 MCQs. Each page, each slide, I can make 5 MCQs. I have designed these 100. Imagine I am teaching you psychiatry for 20 minutes and two questions out of these come on next Saturday. Two questions out of these come on next Saturday. Isn't it useful? I feel it is. Extrapyramidal side effect. Last INICET, they asked neuroleptic malignant syndrome. A patient on antipsychotic presents to you with fever, rigidity, raised CPK, altered sensorium. What will you do? Stop antipsychotic and give dantrolene and bromocriptine. That was the question. That was the question. Last to last, in FMG, they ask a patient on antipsychotic presents to you hypokinesia, rigidity, tremors. It is the triad of Parkinsonism. Centrally acting anticholinergics are used. Patient on antipsychotic presents to you with bending of neck to one side, up rolling of eyeball, acute muscular dystonia. Treatment is injection promethazine. Injection promethazine. Finargan. You have to remember each and every term written in this table. Will you remember? You have to remember each and every term. Patient on antipsychotic presents to you with subjective restlessness, urge to move, can't sit at one place, akathisia. Treatment propranolol. Treatment propranolol. Patient on antipsychotic presents to you with orofacial trunk movement, tardive dyskinesia. Treatment valbenazine. Will you remember each and every line written in this table? Slide number 1, antipsychotic. Slide number 2, EPS. Do you want me to share these slides with you? Do you want these slides? I will be sharing them in my WhatsApp channel. I will be sharing them in my Telegram group today itself. Lithium blood level has been asked in INICET 2 times, 0.5 to 0.8 maintenance, zero point 0.8 to 1.2 acute mania. Acute mania require higher blood level and maintenance require lower blood level. Toxicity more than 1.5 and hemodialysis more than 4. Lithium causes nephrotoxicity. So we need to do hemodialysis. Hemodialysis. Most common side effect of lithium is fine tremor, but lithium toxicity causes coarse tremors. Lithium causes hypothyroidism, and in lithium-induced hypothyroidism, we first give thyroxine, then stop lithium. Lithium causes T wave changes, so we need to get a pre-lithium ECG done. Pre-lithium, we require ECG, serum creatinine, pregnancy test, TSH level. ECG, serum creatinine, pregnancy test for women of childbearing age, and TSH level. Lithium causes diabetes insipidus. Are we aware? Lithium induced diabetes insipidus, the drug of choice is anybody knows it? Amiloride. Lithium causes Epstein anomaly. This was the fourth slide. Fifth slide, lithium side effects. Lithium can cause hypothyroidism. Lithium can cause hyperthyroidism also. In INICET, multiple options correct. Multiple. Suppose they ask which of the following is caused by lithium? Hypothyroid, hyperthyroid, hypoparathyroid, hyperparathyroid. hypothyroid, hyperthyroid, hypoparathyroid, hyperparathyroid. So please remember, lithium causes hypothyroid, hyperthyroid, and hyperparathyroid. Lithium causes acne, hair loss, psoriasis. Lithium can cause goiter. Lithium can cause weight gain, just like valproate. And for lithium toxicity, the first sign is always GI toxicity. Lithium toxicity starts at 1.5. First sign is GI, but the cause of death is nephrotoxicity. Lithium is GI toxic, CNS toxic, nephrotoxic. Imagine I get 20 minutes to teach about INICT important topic and I teach lithium for 5 minutes. That means it is really important. Lithium is their favorite topic. Second favorite topic is valproate. How many times INICT have asked question on valproate? 6 times. Weight gain, hair loss, PCOD, old age question, thrombocytopenia, agranulocytosis, hyperammonemia. Which of the following drug used in mood disorder causes hyperammonemia? It is more common in patients who have G6PD deficiency. Pancreatitis. Lithium causes valproate causes hepatotoxicity. Valproate is the most teratogenic of all drugs. Valproate causes neural tube defect in 1 to 4%. Valproate causes thrombocytopenia. Is the voice clear? Other students, is the voice clear? Thrombocytopenia. Do I need to make some changes? Or is the voice clear? My 7 minutes are done, 13 minutes are remaining. Carbamazepine, dose dependent side effect, dose independent side effect. Please remember, agranulocytosis is dose independent. Agranulocytosis, carbamazepine, clozapine. Carbamazepine causes rash, Steven-Johnson syndrome. Its newer congener Oxcarb causes less rash but more hyponatremia. This was asked in INICT 2 times. Less rash and more hyponatremia. In antidepressant, the famous question is TCA. You need to know imipramine, clomipramine, desipramine, amitriptyline, doxepin. Doxepin has antihistaminic action. Amitriptyline used in migraine. Clomipramine approved in OCD. TCA overdose causes ECG changes that respond to sodium bicarbonate. Tricyclic antidepressant is the most important for exam. Then comes SSRI, the drug of choice for depression. Fluoxetine is the longest acting. Escitalopram is the highly selective SSRI. Most common side effect of SSRI, upper GI dysfunction. Most common long-term side effect of SSRI, sexual dysfunction. Anorgasmia. Anorgasmia. SNRI, venlafaxine causes hypertension. I am expecting this question. Venlafaxine causing hypertension. I am expecting this question. The newer congener desvenlafaxine does not cause hypertension. Duloxetine is used in stress incontinence. Bupropion, very very famous drug, used in smoking control, used in ADHD, used in depression. Its important side effect is seizure. It also increases libido. Can be used in hypoactive sexual desire disorder. Mirtazapine. They have asked for nicotine addiction. Varenicline. Varenicline has been asked 3 times. Alpha 4 beta 2 nicotine partial agonist, which is better than bupropion. Are we aware about nicotine and tobacco de-addiction? Enough about the drugs. Let's talk about clinical psychiatry. I know drugs is boring. So whenever a question on clinical psychiatry comes, the first thing to identify is whether it is psychosis or neurosis. Come on, people who have attended my AIMS capsule class, tell me, how will you identify psychosis versus neurosis? It is not insight, it is not reality contact. In a clinical question, it is always delusion and hallucination. If delusion and hallucination are present, it is psychosis. Psychosis include acute psychosis, brief psychosis, delusional disorder, schizophrenia, schizoaffective disorder, schizophreniform disorder. All this comes under psychosis. Psychosis. So first thing to identify is psychosis. Psychosis means dopamine, dopamine means antipsychotic. So antipsychotic is a drug of choice for schizophrenia, schizophreniform, acute psychosis, brief psychosis, all the disease that have psychosis. What we need? Antipsychotics. Antipsychotic. Neurosis. What is the neurotransmitter of neurosis? GAD, panic, phobia, OCD. So can you at least compartmentalize psychiatry into two part? Psychosis and come on, psychosis and neurosis. If any clinical question comes in psychiatry, the first thing that should come in your mind is whether the question is psychosis or neurosis. Are all of us clear with this? Any clinical question comes in psychiatry, first psychosis, neurosis. First psychosis, neurosis. Will you do it? Because psychosis means dopamine, antipsychotic, neurosis means serotonin, SSRI. Can you do it? In organic mental disorder, we have delirium versus dementia. Delirium is acute, dementia is chronic. Delirium is fluctuating, dementia is progressive. Delirium is altered sensorium, dementia is clear sensorium. And delirium remote memory is normal, dementia remote memory is lost. The key identifying feature gradually progressive more in females. Alzheimer. This slide is from DVT. Step ladder progression more in males. Emotional lability. Vascular. Vascular is post stroke dementia. Personality and behavioral changes predominant. Memory affected late. Frontotemporal, also known as Pick's disease. Visual hallucination, Capgras syndrome, REM sleep behavioral disorder, fluctuating cognitive impairment, Lewy body dementia. Dementia, urinary incontinence, ataxia, normal pressure hydrocephalus, rapidly progressive dementia plus myoclonus, CJD. Can you identify all these six? Can you identify all these six? Substance use, the most famous question. Alcohol withdrawal. Tremors is the first sign, key symptom, most common symptom. Autonomic hyperactivity. Delirium tremens has been asked in INICET 4 times. A patient on not taking alcohol, having visual hallucination, disorientation, altered sensorium. Delirium tremens. IV lorazepam plus thiamine. In Caesar, IV diazepam plus thiamine. Why do we give thiamine? To prevent. Why do we give thiamine? To prevent Wernicke's encephalopathy. Are we clear with this table? Opium. Opium withdrawal is not fatal. Opium intox is fatal. Last to last INICET question. In morphine, codeine, smack, you give naltrexone, but in heroin, we do OST, buprenorphine and methadone. Nicotine, decrease attention and concentration. Are we knowing this slide? I have selected 20 best slides for today. 20 best slides. And we are at last 3 slides. Last 5 minutes. Just hang on for 5 more minutes in psychiatry. After this, 3 more slides. After this, 3 more slides. Imagine something comes from these 20 slides. It will be useful for you. Opium causes cold turkey. See, I have envisioned these slides based on that if the examiner makes paper, he will make something from these 20. Your time at this moment is very precious. I don't want to waste it. So let's focus on high yield. OST means opium substitution therapy. Buprenorphine, methadone. It is to be used in heroin users only. Heroin users only. Are you getting anxious for the exam? It's normal. Don't think it is a disorder. Getting anxious for the exam. There's something called as eustress. Some degree of stress is good for your performance. If it is distress, then there's a performance problem. Are you feeling like not able to study yourself? Yes, that's also normal. Before exam, there is something called as burnout, something called as mental fatigue. I don't feel like studying. Somebody teaches me, that's good, but I can't study myself. It's normal phenomenon before exam. Don't label it as a disorder. I have forgotten everything. Yes, you feel so, but you haven't forgotten everything. It's just a thought. You remember many things. ADHD, HIA, hyperactivity, impulsivity, attention deficit. Hyperactivity means motor restlessness. Impulsivity means can't wait for their turn. Attention deficit means low attention, low focus, low concentration, low memory. For ADHD, onset must be before 12 years and symptom must be present in two situations. Does ADHD sound familiar to you? Can't focus, can't memorize, can't concentrate. If I sit in front of the book, mind goes somewhere else. I am thinking about random things. I am procrastinating. I am having emotional dysregulation. I can't control my emotion these days. I am getting overwhelmed. Does these things seem familiar? Give a thumbs up, give a like, give a heart. For those who understand हिंदी ऐसा कुछ लग रहा है दिमाग में नहीं घुस रहा याद नहीं हो रहा रेस्टलेस फील हो रहा है onset before 12 years symptom must be present in two situation drug of choice methylphenidate it increases tics autism spectrum disorder impairment in social communication and interaction these children do not communicate socially properly verbal and non-verbal ret is a favorite topic of INICET examiners restrictive repetitive stereotype behavior, normal language, Asperger syndrome, normal IQ, delayed language, autism, Reds, and Hellers, autism, mental retardation in two-third cases, Rett, X-linked dominant only affect female, normal development till 5 months to 1 year, followed by loss of milestone. Heller, normal development till 2 to 3 years, followed by loss of milestone. In INICET, they asked Rett 3 times. In the same INICET 2022, they asked which of the following is seen only in females, Rett syndrome. Which of the following is X-linked dominant, Rett syndrome. In the next INI, they asked new drug for Rett, profinetide. Profinetide. So this is perhaps the last academic slide for INICET revision in psychiatry. My 20 minutes are over. And here I am with the final best of luck. Please take care of your mental health in last 6 days. Only the mentally fit, healthy, and calm person is going to perform nicely. You know a lot. Just relax, revise. I am always there with you. May my luck also goes with you. Thank you. Bye bye. All the best.
Very good evening, all my students. Is audio video fine? Can we start with the session? Very good evening, everyone. Can you update in the chat box? Is audio video fine? Can we start with the session? Anji, everyone. So how is the Josh? I hope everybody is loving all these sessions, and take my words, beta, these sessions will give you the momentum which is required in the last spell. So can we continue? Can we start with ENT now? Yes, crystal clear? Is audio video fine, beta? Is audio video fine? Can you update in the chat box? Is audio video fine? Can we start with the session? Beta, is audio fine now? Is fine? Can you update in the chat box? Is audio video fine? All good. Let's start, beta. Now every student, now what is my motive of next 30 minutes? I'll be giving you all the must read topic for your Central Institute, and I'm confident, beta, next week you will be coming with flying colors. Before starting this session, which are the 5 topics? If I'm your examiner, I'll be giving you these 5 important topics. One is block, all the important blocks. What is anterior ethmoidal block? Is it clear? Now, is audio video fine? Now concentrate on the board. One student is asking me for the last 5 days ka plan kar do. Last 5 days, beta, just follow this success mantra. Revise your DVT with PYQ multiple times. At this, in the last spell, make a promise to me, we will not touch any new topic, beta. If you waste your time on any new topic, it will not help you in the examination hall. In the examination hall, Dr. Anmol, it is for you only. I am giving you the next 5 days plan. Just focus on DVT and PYQ. Everyone make a promise to me. In the chat box, we will focus on DVT with PYQ. Nasal block, very important. Carcinoma larynx expected. 1 MCQ from CA larynx expected. Functional endoscopic sinus surgery. They will ask you something either on the diagnostic endoscopy or on the treatment part. Last session, they have asked you on the endoscopic surgery. This time I am expecting they will ask you something on diagnostic endoscopy. 1 MCQ on audiometry expected, beta. And your the favorite choice of your Central Institute, autocaustic emission, outer hair cell, BARA is for high risk baby, or they will ask you some graph, that is pure tone audiogram. Is it clear? And one important topic, benign paroxysmal positional vertigo. So in my ENT, I am expecting around 5 to 6 MCQs, and these are the high yielding topic. These are the topics which they ask every year. Is it clear? Crystal clear? Let's start. So in the very fast mode, I am giving you all the important topics so that you can manage to revise this in a fast mode. This is sphenoid sinus, very posterior superior. Always remember this sphenoid sinus. Everyone should write in the chat box. It opening. I'm just making the list of all the topic which should be on your tips, beta. So it is your sphenoid sinus. Where it open in suprameatus. You should be confident. Suprameatus. Where is your posterior ethmoid open? It is superior meatus. In the middle meatus, I am having 4 important sinus, and these 4 important sinus are on anterior part or posterior part. They are on the posterior part. In front of these sinus, there is uncinate bone. So they will ask you something on the uncinate bone. In the inferior, lowermost is your nasolacrimal duct. Everyone revise with me. Where is your supreme sinus open? Sphenoid open. Supreme hiatus. Other name of supreme hiatus, sphenoethmoidal recess. Where is posterior ethmoid open? Superior meatus and fourth sinus. Something opening of all these sinus in the meatus should be on your tips. Is it clear? Next favorite segment, I'm showing you some images on which they make the MCQ. One is here. Can you make a diagnosis by seeing these two images, beta? Double density, multiple double density with peanut butter. That is your allergic fungal rhinosinusitis. They will ask you to make a diagnosis of allergic fungal rhinosinusitis. Everyone actively participate. Let's make the session interactive, beta. Write all the important points. Very good, great. Yes, beta, Dr. Swati, it is your allergic fungal rhinosinusitis, peanut double density. What is my expectation at this point? You should be confident. Double density. Let's see you reply. Double density on HRCT. Paranasal sinus, allergic fungal, double density on HRCT of double ring on HRCT of inner ear, cochlear otosclerosis. Expected MCQ for your upcoming examination. Clear? So allergic fungal rhinosinusitis, your AIMS people fond of asking BENT Bent's criteria. Which are major component, which are minor component. Fungal culture is a minor. This topic, this point should be on your tips. Now coming on the block segment. These are the visuals I am showing you. This is which block? I am giving a block on the dorsal block. Revise करेंगे मेरे साथ बेटा. मैं आपको 5 इमेज दिखा रहा हूँ. I am showing you 5 images from where they will pick one. This is your dorsal block, also known as anterior ethmoidal block. This year they have asked you greater palatine. Everyone, if I keep my finger in the middle segment of my palate, that is greater palatine block. One is anterior ethmoidal block. This is anterior ethmoidal. I just want these images should be printed. These images will help you in the examination hall. Now concentrate. Let's take this slide now. If I am giving block at this point, it is supraorbital block. Revise करेंगे बेटा. Supraorbital, supratrochlear, supratrochlear. If I give a block at this point, it is infratrochlear block. If I give a block in upper part of medial canthus, this is your infratrochlear, and this segment is your infraorbital block. Supraorbital, focus your eyes on the board, beta. This area, examiner favorite, supraorbital, supratrochlear. This is infraorbital block. Infraorbital. And if examiner give you at this point, that is your infratrochlear. I hope you will never forget. Just focus your eyes on this one. Infraorbital. Compare supraorbital block with infratrochlear block. So out of these images, they will pick any one for your upcoming examination, and higher probability greater palatine. Where is the greater palatine block? On the middle part of your palatine bone. Again, ENT with ophthal, they can give you this slide and they can ask you what is going on. It is nasolacrimal duct patency test. Nasolacrimal duct patency. Is it clear? Next, I am showing you few air cell. Everyone should reply. Most anterior. Everyone should reply is agar nasal. So most posterior is your anode cell. सबसे आगे अगर पूछेंगे बेटा, it is agar nasal. And if they ask you something on the most posterior, it is anode cell. These are normal air cell. Any student can help me in making a diagnosis. Can you tell me what I am showing you? Yes, beta, focus your eyes on this area, what I am showing you. Can you make a diagnosis of this slide? Very favorite, yes, is a most common variant pathology in the nasal cavity, paranasal sinus. What I am showing you, middle turbinate, increase in size. Why? Black. There is some air in the middle turbinate. What we call it as concabillosa. We use a word concabillosa. Always remember this point. Is it clear? If examiner asks you concabillosa, it is most common. Second most common is DNS. And this year, I am expecting they will ask you something on SMR, submucous resection against septoplasty. Very important, favorite of your central institutes. SMR, we give incision on both sides. Septoplasty, we give incision on one side. SMR, high risk of perforation. Septoplasty, no risk of perforation. Is it clear? Inferior turbinate hypertrophy, always remember, inferior turbinate is the most common site for hypertrophic rhinitis, and what they ask you, they show you a palate endoscopic view, and just remember, anything close to the palate, which turbinate is very close to the palate, it is your inferior turbinate is close to the palate. Is clear? 2026 one MCQ expected from this slide. They will be either asking you rhinophyma, potato nose. Revise karo mere saath beta. It is potato nose. It is your hypertrophy of sebaceous gland. This is your rhinoscleroma, which is the keyword in the MCQ. They will mention woody nose. They will mention Mikulicel. They will mention Russell bodies. Woody nose, Mikulicel, Russell bodies, all these going in the favor of rhinoscleroma. Anyone, if they show you a mulberry-like polyp, it is rhinosporiosis. So your examiner will be giving you a typical history of patient taking bath in ponds, and they will ask you treatment of choice. Treatment of choice is surgery, or your AIMS people, JIPMER people can give you the choice. Dapsone is the treatment of choice. Not at all. Is a false statement. Better choose the false statement regarding this slide. Dapsone is a treatment of choice. No, Dapsone is the drug of choice, not treatment of choice. What is the treatment? Treatment is surgical excision with cautery at the base. Very good. Everyone is responding. That's the best part. Clear? Rhinoscleroma. Have this image print on your brain. If they show you this image, it is rhinoscleroma. If they show you big spores, that is your rhinosporiosis. Never confuse. ENT with microbiology, integrated MCQ. Done. Any student who can make a diagnosis from this slide. Let's see. A tumor coming from lateral wall of the nose. A tumor coming from the lateral wall, going into the maxillary sinus, damaging the maxillary sinus. Anyone who can make a diagnosis? Tumor coming from lateral wall of the nose. I will look for maxillary sinus. It is not damaged or it is damaged. If it is not damaged, तो बेटा टिक कर देना inverted papilloma. And if it is damaged, in this slide, can you appreciate all the walls of maxillary sinus damage? It will be squamous cell carcinoma. Is it clear? Inverted papilloma against squamous cell carcinoma. How we differentiate? We differentiate on one is histopath. Second is your radiology finding. Done. So this slide is very important. Can you make a spot diagnosis of this one? देखो बेटा, your central institute, they are fond of asking either basal cell carcinoma. They will show you multiple ulcer, a tumor invading the skin. You will attempt basal cell carcinoma, or they will show you a tumor in the upper part, upper 1/3, which is known as olfactory area. There is a tumor in the olfactory area. Revise करेंगे बेटा everyone. इस slide को देख के very favorite slide. For your AIMS people, last 10 years, they have asked you this slide 2 times. This is ethinoneuroblastomas. Is it clear? What is this one? This is ethinoneuroblastoma. For very important slide for Central Institute. If there is a tumor in the upper part, olfactory area, we call it as ethinoneuroblastomas. Done. Very good. Excellent, beta. Clear? Coming on to important classification for maxillary sinus carcinoma. Maxillary sinus carcinoma बेटा 2 classification याद होनी चाहिए. One is Ogren's, one is Ledman. What is Ogren's? From medial canthus to angle of mandible. If the tumor is below the line, is good prognosis. Tumor above the line, poor prognosis. याद रहेगा बेटा, इस concept को नहीं भूलना आपने. और they will ask you something on Ledman classification. What is Ledman classification? Horizontal line. With the help of 2 horizontal line, we divide the face into 3 parts: supra, meso, infra segment. Done. Crystal clear? That's great. Everyone clear? After learning this trauma part, in the last exam, they have asked you horizontal fracture trauma coming from front. Jarjave fracture. This year, I am expecting they will ask you something on Chevrolet fracture. Chevrolet fracture, that is vertical fracture. That, or the next topic I am expecting is your leaf foot fractures. Beta, they can ask you leaf foot fractures, leaf foot 1, leaf foot 2, leaf foot 3. इस स्लाइड को ध्यान से देखेंगे बेटा. leaf foot 1, leaf foot 2, leaf foot 3. No need of mugging up anything. Leaf foot 1. If examiner asks you low maxillary sinus, low maxillary fracture, examiner asks you pyramidal fracture, that is leaf foot 2. Low maxillary, leaf foot 1. Craniofacial, cranium separated from the face, craniofacial disjunction is your leaf foot 3. Is it clear? Very good. Great, Dr. Dharmesh. Excellent. CSF rhinorrhea will be seen in leaf foot 2 and leaf foot 3. Done. They will either show you bleeding on the palate, it is Gurin sign, and if they show you bleeding on the mastoid, that is Battle sign. These two signs are signs of trauma, not infection. Is it clear? Now, all my students, better concentrate on the board and learn this concept. Abscess on lateral wall, it is parapharyngeal abscess. Abscess on posterior pharyngeal wall, it is retropharyngeal abscess. Revise with me. If the abscess is on posterior pharyngeal wall, it is retropharyngeal. If abscess is in the lateral wall, it is parapharyngeal abscess. In parapharyngeal abscess, we give incision along anterior surface of sternocleidomastoid. In retro, we give along posterior surface of sternocleidomastoid. Is it clear? Important concept. How you differentiate parapharyngeal abscess from peritonsillar abscess? Neck swelling. External neck swelling will be visible. How you differentiate retropharyngeal abscess from prevertebral abscess? This abscess is localized abscess. This is localized abscess. Best part, beta, the speed at which the chat box is moving, you people are responding. I am confident you will be cracking this exam, and have this confidence that yes, we can crack this Central Institute, and take my word, beta. Honestly, as a faculty, I am telling you, it is easy to crack this exam. Why? Paper will be very conceptual paper. Just apply the common sense, just be aggressive in the game and crack this exam. Clear? So how you differentiate retro from prevertebral or para from peritonsillar? This is the concept. Now, for the last 2 years, your examiner is asking you orange colored tonsil, and I am confident you will reply, what is orange colored tonsil? Tanger's disease. It is Tanger's disease. But just speed pay, I am teaching you. Take my words, better. Next 5 days, 6 days, just flip up the notes, just revise, scan your notes, because at this point, it is your revision which will matter. Don't touch any new point. PYQ, last 3 years PYQ should be on my tips, बेटा. अगर मैं रात को 2 बजे भी आपको उठा के पूछता हूँ कि बेटा इस क्वेश्चन का आंसर क्या है, you should reply, सर ये क्वेश्चन है, ये 4 choices हैं, this is the right answer. I hope you are getting my point. So just be confident. Revise your PYQs again and again. Coming on, keratosis obtrans, very favorite choice for Central Institute. There is a squamous cell, squamous debris in the external auditory canal. Bilateral condition, young patient, 5 to 20 years, and there is no necrosis. 5 to 20 years, bilateral squamous cell in the external auditory canal with no necrosis. Keratosis obtrans, very favorite point of your Central Institute. Malignant otitis externa. One day before your I ask you malignant otitis externa, you should reply, sir, 5 point. Diabetic patient, granulation with facial nerve palsy. Technetium 99 for diagnosis, gallium and ESR for prognosis. It is pseudomonas, therefore I will be going for anti-pseudomonas 3rd generation cephalosporin. Again, diabetic patient, most common now facial nerve with granulation. Technetium 99 for diagnosis, gallium ESR for prognosis, treatment of choice, anti-pseudomonas. Is it clear? Crystal clear? Coming on, serous otitis media. Very important point, serous otitis media, anterior inferior. We put the grommet We do maryngotomy, we give a small incision, that is your anterior inferior. If they show you a red inflamed tympanic membrane, that is your cartwheel appearance, stage of pre-suppuration, lighthouse sign, stage of suppuration. We are talking about ASOM, and I will be giving a circumferential incision in posterior inferior part. Circumferential incision in posterior inferior segment. Is it clear? Crystal clear? After learning all these basic points, clear beta? Just give me a minute. Yes. After learning this slide, treatment part. Treatment of CSOM. Management, safe CSM, unsafe CSM. Safe CSM. If the examiner asks you safe, it is tubotympanic. And what is the treatment? Tympanoplasty. Tympanoplasty. Just remember this point. Safe ear, tubotympanic ear, tympanoplasty with OCR. Ossicular chain reconstruction. And if the examiner asks you unsafe ear, that is atticoantral, treatment is MRM. Modified radical mastectomy. Modified radical mastectomy. Is it clear? Crystal clear? Type of mastectomy: canal wall up, canal wall down, should be on your tips beta. Most common surgery done in unsafe ear is your MRM. In malignancy part, we do radical. Every student beta, now just close your eyes and learn one golden rule of management part. We never do tympanoplasty if ear discharge, active discharge is there. Just remember, very favorite concept of Central Institute. In active ear discharge, I will prefer to do mastoid search. I will prefer to do mastoid search. Is it clear? Done beta? Any? Yes beta, any query on the management part? Feel free to ask any point you want to discuss on the management part. Just remember this important point: active ear discharge is a indication for mastoid search. Done. Now one more point: tympanoplasty. All the classification, they will give you match the following MCQ on tympanoplasty. Type 1 maryngoplasty, type 2 maryngoinkidopexy, type 3 maryngostapedopexy, type 4 minor K-worm. All these points should be on your tips. Clear? So this is something on mastoid search. Coming on, this is your reddish mass behind tympanic membrane, expecting one MCQ this year on glomus tumor. Glomus tumor, just remember they will be using the word pulsatile. Pulsatile mass. Flap sign, very favorite. What is flap sign? The bony partition between carotid and jugular damage. When there is a bony partition between carotid and jugular is damaged, we call it as flap sign. Done. Clear? That is your glomus tumor. Trauma, very Central Institute fond of asking this. Perforation with blood clot, and just remember the golden rule: blood clot with perforation, we will keep the ear dry. It will heal of its own. Just remember, treatment of traumatic perforation is heal of its own. Done. Just keep the ear dry. Coming on the audiometry, the nutshell I taught you: in all newborns we do autoacoustic emission. In high-risk baby, we do BARA. Now, few audiograms. Airborne gap seen. Can you make a diagnosis? If airborne gap, we are talking about conductive deafness. One graph within 25, one graph beyond 25, that is conductive deafness. Both the graph beyond 25, it is sensory neural. But if the examiner show you both the graph beyond 25 and there is a big airborne gap, I will be going for mixed deafness. We'll be going for mixed deafness. Is it clear? Crystal clear? Notch at 2000 Hz, Carhart notch, autosclerosis. It is in bone conduction. Stapedotomy is the treatment. But if Schwartz sign, I will give sodium fluoride. Can you appreciate this way of learning, beta? 1 week before your Central Institute, autosclerosis, Carhart notch, 2000, bone conduction. Stapedotomy. If Schwartz sign positive, I'll be giving sodium fluoride. That's it. Is it clear? Loss at 4000 is your Boiler's notch. That is your noise induced hearing loss if it become 4000. Is it clear? If the examiner give you rising curve, can you play with audiometry now? On the same audiogram, I am drawing all the possible MCQs. Rising curve. What is this rising curve? Meniere's disease. A low frequency hearing loss. And if the graph is coming down, down sloping graph, that is your high frequency hearing loss. That is your high H presbycusis. Is it clear? This PDF file will be with you only, beta, and I will advise to revise this PDF file again and again. 2 years back, they have asked you some concepts of how to diagnose the loss depending on the presentation of the patient. Like, patient is having difficulty with faint speech. It is 26 to 40. Guesswork, mild deafness. We use pure tone audiometry to quantify the loss. But how to quantify depending on the symptom? Like, patient can understand only shouted. This was the MCQ. Patient can only understand shouted or amplified voice. It is severe loss. It is severe loss, beta. So please, I'm making just 2 stars on this table. It should be on your tips. That tympanogram is a investigation of choice for conductive. This is normal tympanogram. This is my flat tympanogram, which is fluid in the middle ear. This is ET tube dysfunction, C tympanogram. If this type of graph is AS, this type of graph is AD graph. Is it clear? This is something to do with conductive deafness. That one is stapedial reflux. Beta, stapedial reflux, the highest center is superior olivary complex. Superior olivary complex, and 7th nerve is 8th nerve responsible for this protective reflux. Superior olivary complex, favorite MCQ for Central Institute. This is, can you read the graph? Yes, sir. Loss is at 4000. So this must be noise induced trauma. Noise induced trauma. They can show you Antony A, Antony B cells, or they can show you one ice cone appearance. So I will be going for vestibular schwannomas, Antony classification or ice cone appearance. Clear? Treatment of choice will be here surgery. It is neural deafness. Keyword ice cone appearance, or they can give rollover phenomena. That is a phenomena of fatigability. Clear? So these are the points related with your vestibular schwannomas. What is the investigation? It is neural deafness. Because neural deafness, it is better. And what is the favorite question of your Central Institute? They ask you auditory pathway again and again. 8th nerve, cochlear nucleus, olivary nucleus, lateral lemniscus, medial geniculate body, auditory cortex. This auditory pathway should be on your tips. Is it clear? Done. BPPV, benign paroxysmal positional vertigo, calcium carbonate body. In the MCQ, the word position, investigation of choice, Hall-Pick maneuver, treatment of choice, Apples maneuver. ये सारी बातें याद होनी चाहिए आपको related with BPV. Question repeat होगा. 50-year-old female, wake up in the morning, she is having vestibular symptoms. Done. On rehabilitation, they will be asking you more of cochlear implant, brainstem implant. But if they ask you something on hearing aid, they will be asking you BAHA. This is BTE, behind the ear. But if I keep this hearing aid on mastoid, we call it as BAHA, bone anchored hearing aid. Why you keep hearing aid on mastoid? Why? Because there is canal atresia, canal stenosis. That's why we prefer to keep on the mastoid. If they show you this slide, this is your cochlear or brainstem implant, depending on where I am keeping the electrode. Everyone should reply in the chat box where we keep electrode of cochlear implant electrode against brainstem implant electrode. Cochlear implant electrode is kept in scala tympana A. Brainstem implant is kept in lateral recess of fourth ventricle. Lateral recess of fourth ventricle. Whatever is the contraindication of cochlear implant will be indication of brainstem implant. Like Michel aplasia. In aplasia, I cannot use cochlear implant. So in Michel aplasia, we prefer brainstem implant. Just remember this point. Clear? The next important topic for your Central Institute, they will ask you something on superior semicircular canal dehiscence syndrome. And everyone should tell me which type of deafness. They always ask you which deafness. We expect it should be sensory neural deafness. No, it is conductive deafness. Conductive deafness with CNS symptom. I will be going for an investigation. VEMP, vestibular evoke myogenic potential. Is it clear? So it is conductive deafness with CNS finding. Clear? Investigation of choice, vestibular evoke myogenic potential. Done. Coming on the larynx part, very simple, straightforward. I am showing you few images. Thumb sign, आप अटेंड करेंगे epiglottitis. ICU mandatory. Admit the patient. You should treat the patient with anesthesia backup. Why? Patient can collapse at any point of time. Stipple sign will be going for croup, that is laryngotracheobronchitis. Done. If they show you progressive hoarseness, the key word, 5-year-old child with progressive hoarseness, that is your papillomatosis. And I am confident every student attending this session, watching this video, you must have read all these things, but आपने सब कुछ पढ़ा हुआ है. So what is the motive behind this session? To give you the final momentum. इस point पे बेटा इस speed पे पढ़ना है आपने, so that we should brush up, we should revise each and every point which we have done efforts in the last 6 months, 1 year. Is it clear? So just try your best to read. Make a promise to me. Thumbs up in the chat box. We'll follow the same speed, because this is a need of hour. Is it clear, beta? We have to crack this exam, and we'll be aggressive in this examination. Multiple resolve spontaneously, reoccur spontaneously. It is papillomatosis. If it is single, it is here juvenile papillomatosis. Which virus? Human papillomavirus. They can ask you HPV, very strongly associated with oropharynx, very strongly associated with oropharynx larynx. Is it clear? Done. CA larynx, very important point, beta. I'm showing you this slide. Listen carefully. No controversy. You should not be trapped in this controversy. If the tumor have invaded the thyroid cartilage, examiner is showing you T4. If the tumor reaches the neck muscles involved. Thyroid rupture, neck muscle involved, T4. 2024, they have given you T4. But in last INI, they have mentioned inner perichondrium is involved. Neck muscle not involved. If neck muscle not involved, it is T3. If neck muscle involved, I'll be going for T4. याद रखेंगे, repeat कर रहा हूँ. If a tumor is confined within thyroid, it is T3. Perichondritis, your paralysis, fixed vocal cord, paraglottic space, T3. Neck muscle involved, carotid artery involved, it will be T4. Neck muscle is your T4A, and your carotid artery chest involvement will be T4B. गलती मत करना बेटा, CA larynx पे आना ही आना है क्वेश्चन. Management should be on your tips. Early stage of T3, 2 साल से पूछ रहे हैं. Early stage of T3, I'll be going for organ saving, that is your concurrent chemo radiation. Concurrent chemo radiation. What is this one? What she is doing is polite yawning? No, sir. What is polite yawning? Polite yawning is yawning with closed mouth. Why? So that air should go in the nose. Olfactory refunctioning. Olfactory refunctioning. This is olfactory refunctioning. After surgery, we keep a prosthesis, that is your tracheoesophageal prosthesis. I am drawing one line diagram for you. After total laryngectomy, on the anterior wall, we keep tracheostomy tube. On the posterior wall, we keep a prosthesis that is known as tracheoesophageal prosthesis. Revise with me. On the anterior wall, tracheostomy. On the posterior wall, tracheoesophageal prosthesis. Done. MCQ on vocal cord paralysis. Unilateral vocal cord paralysis, we always prefer to wait and watch. Head and neck surgery, I am giving you one flow chart. They will be asking you this MCQ. Bilateral recurrent nerve palsy, patient will have severe dyspnea. After head and neck surgery, patient have severe dyspnea. Which nerve is involved? Bilateral recurrent nerve palsy. If it is bilateral superior laryngeal nerve palsy, patient will be having severe aspiration. Always remember, bilateral superior laryngeal nerve palsy, aspiration. I will be going for type 1 thyroplasty. Here I will be going for type 2 thyroplasty. Is it clear? Match the following MCQ on thyroplasty: type 1 midligation, type 2 lateralization, type 3 shortening, type 4 lengthening. अगर एग्जामिनर ने इफ ही वांट टू आस्क यू MCQ on superior laryngeal nerve, he have two options. Either he will ask you MCQ on external branch or internal branch. If he want to ask you external branch, he will say patient not able to raise the pitch. Which muscle is involved? Cricothyroid. Which nerve is involved? External branch. Patient loss of sensation in the upper part. Which nerve is damaged? Internal. Which area it is damaged? That is piriform fossa. So they will be asking you something on piriform fossa or cricothyroid muscle. Is it clear? So beta, best of luck, best wishes. I am confident you all will be coming with flying colors beta. और याद रखो, whatever effort we are taking, जो मेहनत कर रहे हैं कभी waste नहीं होगी. And take my word, in the rest part of your life, each and every day, hard effort will pay you back. Best wishes. Good luck.
Hello students, let us begin respiratory medicine INICET Marathon 2026. Myself, I am Dr. Bharat Katti, consultant pulmonologist and DAMS medicine faculty. Starting with very important topic, arterial blood gas. This is the range of normal values: pH 7.35 to 7.45, PaCO2 35 to 40, bicarb 22 to 26, and oxygen 80 to 100. In INICET, they might ask you direct interpretation. For that, there is a golden rule. Whenever they give you any parameters, even if you don't know any basics about ABG, draw arrow marks. When compared to normal values, what is the trend? What is happening to pH when compared to normal? Reduced. CO2 normal is 40. What has happened to CO2? Increased. Bicarb normal is 26. What has happened to bicarb? Increased. There is a simple mnemonic to solve any ABG in seconds called as ROM. If it is a primary respiratory disorder, change in pH with respect to CO2 and bicarbonate will be in opposite direction. If it is a primary metabolic disorder, change in pH with respect to parameters will be in same direction. You need not do anything, just draw arrow marks. See the pH. Is it acidosis or alkalosis? pH is reduced, acidosis. What is primary? Change is in opposite direction. So it is respiratory. In the same way, try to solve next question. What has happened to pH? Reduced. CO2 when compared to normal, reduced. Bicarbonate when compared to normal, reduced. Anywhere decrease in pH is acidosis. What is primary? The change is in same direction. So what should be the name? Metabolic acidosis. Very simple concept. Next important topic in ABG is anion gap. Anion gap is calculated as the difference between sodium minus chloride plus bicarbonate. Normal value is usually in the range of 8 to 12 milliequivalents. For your exam, they will ask you metabolic acidosis. What are the causes of high anion gap, normal anion gap? For anion gap to increase, most important aspect is addition of strong acid to your body. It can be either keto acids, diabetic or alcoholic ketoacidosis, lactic acid, renal failure. When will all these acids aggregating in your body not go out? That is renal failure. Any toxins. You must be knowing any alcohol can get converted into aldehyde, later to acid. If somebody takes methanol, it will get converted into formic acid. Ethylene glycol, oxalic acid, aldehyde is also getting converted into some acid. And drug, which is an acid, salicylic acid, nothing but aspirin. On the other hand, normal anion gap metabolic acidosis, it is not due to addition of strong acid, direct loss of bicarbonate. Pancreatic fistula, ureterosigmoidostomy, diarrhea, carbonic anhydrase inhibitor use, aldosterone deficiency, renal tubular acidosis. The mechanisms have been extensively discussed in regular classes. Because this is a rapid revision session, you should know what causes high anion gap, what causes normal anion gap. Direct question you can expect from this slide. Then metabolic alkalosis is divided into saline responsive, saline unresponsive. That means if the metabolic alkalosis is corrected by saline, it is saline responsive. Whereas saline unresponsive means saline is not effective in correcting the metabolic alkalosis. Saline responsive generally associated with volume loss, vomiting, Rayleigh tube aspiration, chronic diuretic use. Saline unresponsive is very similar to primary aldosterone excess, that is primary aldosteronism, Cushing syndrome, renin secreting tumor, and all these genetic defects of renal tubules, Bartter-Gitelman-Liddle syndrome, are also responsible for saline unresponsive metabolic alkalosis. Then, in INICET, usually they focus on clinical scenario. You might think, sir, this is a very short clinical scenario, but around this keywords, they are going to stitch a big question. It will be given. There was a patient to age 35-year-old male patient. He was alcoholic. He was having abdominal pain. Later, it was found to be pancreatitis. In hospital, he was there for 4 days. On the 5th day, he started developing shortness of breath. Later, a chest X-ray was taken. It showed bilateral diffuse pulmonary infiltrates. What can be the diagnosis at this point of time? But in that big clinical scenario, the keywords are pancreatitis, shortness of breath, and bilateral diffuse pulmonary infiltrates. If you see this combination, what is your diagnosis? Come on, write down. It is ARDS. How will pancreatitis be responsible for ARDS? Damaged pancreas will release enzymes into circulation. This blood can reach the lung. And these enzymes now can damage the lung, resulting in ARDS. Next patient, non-HIV patient. He had IV drug abuse. Now high PaCO2. What is the type of respiratory failure? High PaCO2 is type 2 respiratory failure. This is the expected answer. Next patient is a young female, raised pulmonary artery pressures, and there is dyspnea. So when there is isolated rise in pulmonary artery pressures, you should think possibility of pulmonary hypertension. Another patient with pneumonia, diarrhea. Usually they will mention this is an atypical pneumonia. Now tell me the answer. Atypical pneumonia with diarrhea. Who is the organism? It is Legionella. On the other hand, a patient with atypical pneumonia. Typical means fever, productive cough. Atypical generally means there will be fever but dry cough. With hemolytic anemia. Who is the organism? Very, very important. Mycoplasma. What I want you to know is, if you notice these keywords, you should be able to identify these conditions without any confusion. Atypical pneumonia with diarrhea, Legionella. Atypical pneumonia with hemolytic anemia, think of mycoplasma. Let us see few revision pearls. Whenever there is respiratory failure, you have to divide it into type 1 and type 2. Type 1 is a hypoxemic respiratory failure. This is generally due to decrease of transfer of oxygen. It is seen with severe pneumonia, ARDS, fibrosis ILD, pulmonary embolism. Type 2 respiratory failure is due to hypoventilation or decreased respiratory effort. And what was the mnemonic that I told you to remember in the class? For type 2 respiratory failure, it is COPD. C stands for central cause, which is happening at the level of brainstem injury. O stands for obstruction, severe COPD. And P stands for peripheral causes, neuromuscular disorders, where there is respiratory muscle weakness. And who is the strongest respiratory muscle? Diaphragm, diaphragmatic injury. And type 2 respiratory failure is characterized by increased PaCO2. Coming to ARDS diagnostic criteria. Important features are there will be acute shortness of breath within 1 week. This was also called as Berlin 2012 criteria. And if you take a chest X-ray, there will be bilateral diffuse pulmonary infiltrates. What is the type of edema? It is non-cardiogenic pulmonary edema. And the number to call it as ARDS, PaO2 by FiO2 ratio should be less than 300 mmHg. When you see this combination in a clinical scenario, first you should think possibility of ARDS. Coming to next set of clinical scenarios. Now there is a patient with cirrhosis and right-sided pleural effusion. And if they have mentioned that this pleural effusion was a transudate in nature, think in terms of liver disease responsible for transudative pleural effusion. This combination is called as hepatic hydrothorax. Next patient is having a massive left-sided pleural effusion. Pleural fluid analysis is showing high amylase. So whenever there is very high amylase, two situations will come into your mind. One is a pancreatitis related pleural effusion and also esophageal rupture. Now how to differentiate? If it is esophageal rupture, generally it happens due to very severe vomiting. The esophagus is rupturing and beside the esophagus there is thin mediastinal pleura. So the contents of esophagus will go into the pleural space. What does esophagus contain? Gastric contents and saliva. Saliva contributes to high amylase. Gastric contents contributes to low pH. So if it is very high amylase, normal pH, you should think of pancreatitis. Because pancreas is an infradiaphragmatic structure. When it is damaged, it irritates the diaphragm. Through the diaphragmatic pores, pancreatic inflammatory fluid will gain access into left pleural space. Another cause for very high amylase is malignancy. But in malignant pleural effusion, they'll also give you, there was also atypical cells. When atypical cells are there, then you can think of underlying malignancy. But in a clinical scenario, standard left-sided pleural effusion side is given with high amylase normal pH. You should think of pancreatitis because pancreas is a left-sided organ. Then the next patient is having a pleural fluid which is milky white. Whenever there is white pleural fluid, there are only two situations. One is chylothorax and other is pseudochylothorax. To call it as chylothorax, triglycerides will be elevated. Milky white pleural effusion, high triglycerides. You think in terms of chylothorax happening due to damage to thoracic duct and accumulation of chyle. What does chyle contain? Triglycerides. Whereas if that milky white pleural effusion is rich in cholesterol crystals, it is a long-standing pleural effusion where cholesterol crystals accumulate. And this situation was called as pseudokylothorax. Coming to examiner's favorite, there is acute shortness of breath, absent breath sounds, hypotension, and you're also seeing a hypertranslucent area with compressed lung margin, tympanic node, air in the pleural space. It is pneumothorax. Is it simple pneumothorax? Patient is in hypotension. So this is a tension pneumothorax. The next step should be wide bore needle insertion. Coming to revision pearls, whenever they give you any pleural effusion, by Light's criteria, you have to see whether it is transudate or exudate. If it is transudate, life is very easy because majority will be systemic causes. What are the three systems? Heart, kidney, liver. This is cardiac failure, kidney disease, nephrotic syndrome. If a liver disease is responsible for transudative pleural effusion, it is called as hepatic hydrothorax. Whenever it is exudate, life becomes very difficult as if you are dealing with your ex. Very difficult. You have to explain so many things. You have to send the fluid for cytology to look for any malignancy. Gram stain to look for any infection. TB markers. Lymphocyte-rich pleural effusion. ADA will be elevated. Interferon gamma will be more than 140 picograms per ml. And you have to check, are you dealing with low glucose pleural effusion? It is seen in empyema, malignancy, rheumatoid arthritis. High amylase pleural effusion. Just now we have discussed. Pancreatitis, esophageal rupture, malignancy. White colored pleural effusion. High lipid pleural effusion. Seen in chylothorax. Here the disease defining feature. Pleural effusion triglycerides more than 110 mg. Damage to thoracic duct due to surgical trauma. Pseudokylothorax, accumulation of cholesterol crystals in long-standing effusions such as TB, rheumatoid arthritis. Then the next set of questions. There is a patient with cough, wheezing, looking like an obstructive airway disease, but you have done a spirometry. They have given it has, FEV1 has increased after bronchodilator. SABA is bronchodilator. By how much? 12%. This is called as bronchodilator reversibility. If there is bronchodilator reversibility, what is this phenomena called as? Asthma. So bronchodilator reversibility, if it is present in an obstructive lung disease, think of asthma. If there is persistent airflow limitation, think of COPD. Next patient is a smoker. He is having chronic cough. And in the last 2 years, he is having sputum production for more than 3 months. This is the technical definition of COPD subtype called as chronic bronchitis. Now the next patient is already having COPD. Now you are having features of right heart failure, peripheral edema, raised JVP, but normal left heart function. What is this called as? RV dysfunction due to primary respiratory cause. Primary respiratory cause. Excluding diseases of left heart. This is called as a cor pulmonale. This is called as cor pulmonale. The next patient had chronic productive cough. In the fingers, there was clubbing. And if you put your set, there is coarse crepitations. If you see this combination, what is the name of the disorder? Chronic productive cough, clubbing, and coarse crepitations. This is seen with bronchiectasis. Then, next patient is a known asthmatic. Within the blood, there is very high IgE, but the CT scan is showing bronchiectasis very nearer to the trachea. What is this type of bronchiectasis called as? Central bronchiectasis. When you see asthma, high IgE, and central bronchiectasis, What is the condition that should come into your mind? A very important clinical scenario in your exam. ABPA. What is meant by ABPA? It is allergic bronchopulmonary aspergillosis. So think of allergic bronchopulmonary aspergillosis. Let us see few revision pearls. Aspergillus related lung disease is a favorite topic in INICET. Starting with allergic bronchopulmonary aspergillosis, which is usually a hypersensitive reaction. Whereas invasive pulmonary aspergillosis is a pneumonia. Aspergilloma, it is not a hypersensitivity or pneumonia. It is just colonization. Let us see in detail. ABPA, it is a complex hypersensitivity to the fungal spores, combination of type 1, type 3 and type 4 hypersensitivity. Frequently seen with bronchial asthma, recent evidence has shown cystic fibrosis can also be responsible. Because it is an hyperimmune response, skin test can be positive to a fungus called as Aspergillus fumigatus. Within the blood, there will be elevated IgE levels. New criteria is 500 international units, old criteria is 1000. And within the blood, there will be antibodies, IgE and IgG against Aspergillus fumigatus. On the CT scan, come on, now answer. What is the pathognomic radiological finding? It is central or proximal bronchiectasis. Then, because this is a type 1 hypersensitivity response present, eosinophils will be elevated. Ultimately, this is a hypersensitivity reaction. Single drug of choice. Your answer should be steroid. Along with that, optionally itraconazole can be added to reduce the antigenic load. But single drug of choice for ABPA is steroid. Whenever your body's immunity is bad, this fungus will grow aggressively and cause a pneumonia. This pneumonia in immunocompromised, especially in neutropenia, because neutrophils are responsible for clearance of fungal hyphae from your body. When neutrophils are less, fungal hyphae cannot be cleared and they invade your lung. The type of invasion, it involves bronchus. Patient will have shortness of breath. Angio blood vessels also involved, hemoptysis. On the CT scan during active phase of the disease, you see something called as, what is the name of the sign during active phase? Come on, answer. Type in the chat box. It is CT halo sign. Whereas in the recovery phase, it is air crescent sign. Coming to the treatment, this is an aggressive pneumonia. Who is the drug of choice? Who is the drug of choice? It starts with the letter V. So now V has become very famous. TVK. Vijay Dalapati. So that Dalapati against invasive pulmonary aspergillosis is oricanazole. Coming to aspergilloma or fungal ball. Here there is a pre-existing lung cavity. In this, the fungus will go and colonize. On the X-ray, you see a monad sign. This is just a colonization, not invasion. The fungus can be freely mobile within the cavity. If you take chest X-ray in different positions of the patient, you can see that ball moving with patient's decubitus. Treatment. Already cavity is destroyed lung, in that a fungus has aggregated. So here, what will be the treatment? Removal or resection. Next set of one-liners. There was a patient with rheumatoid arthritis. There is dry cough, fine crepitations, and you can see subpleural honeycombing. So whenever there is dry cough, fine crepitations, think of ILD. There is a connective tissue disorder, and in which type of ILD you could see honeycombing. Your answer should be UIP. Usual interstitial pneumonia. Usual interstitial pneumonia. It is the most common pathological pattern of ILD. Then another connective tissue disorder, there is dry cough, fine crepitations, but more of ground glass opacities, GGOs, with subpleural sparing. So instead of abnormal rounded areas of air, you see more of haziness, ground glass opacities. This is NSIP, non-specific interstitial pneumonia. Next patient, upon bird exposure, every time they are developing dyspnea and fine crepitations. This allergy-like presentation with bird exposure. It was called historically as bird fancier's lung. What is this phenomena? Technically called as hypersensitivity pneumonitis. All these are nothing but various forms of hypersensitivity pneumonitis. Next patient is a smoker, and radiologically there are so many cysts, and it breaks and results in a pneumothorax. Cystic lung disease in smoker is LCH, Langerhans histiocytosis. This is what you have to identify. Then a patient with bilateral hilar lymphadenopathy, eye involvement. There is also joint involvement, multi-system disorder with bilateral hilar lymphadenopathy. Think in terms of sarcoidosis. Is there any Lofgren syndrome? These are very important questions that they can ask in ILD as clinical scenarios. For your exam, you should know the differentiating features of UIP and SIP. With help of a table, UIP, elderly, males frequently involved than females, chronic symptoms, smokers are involved, fine crepitations and clubbing. Biopsy, you see areas of fibrosis, fibroblastic foci. Radiology, it is a bilateral lower zone disease. Good findings called as ground glass opacities will be less. All bad findings will be more, that is honeycombing. Because bad findings are more, prognosis is poor. And what are all drugs that you have? Antifibrotics, pirfenidone, nintedanib. But these drugs cannot reverse the disease. They only stop further progression. Ultimately, bad disease, drugs not effective, there will be mortality. And if you are being asked what is the best treatment, old lungs are gone, get new ones, lung transplant. Whereas NSIP, middle age, females more involved than males, subacute symptoms, there are fine crepitations. Here bad areas called as fibroblastic foci are rare. Lot of good findings, ground glass opacities. Because fibroblastic foci are rare. What will be rare? Honeycombing will be rare. Because bad findings are rare, you'll have good prognosis. When you don't know what to give, what will you give in respiratory medicine? The drug of God called as steroid. Now, how to remember? See how God is clear towards men. Whatever bad happens, happen in them only. Being elderly is bad. Being male in society these days is very bad. Having chronic symptoms is bad. Smoker is bad. Fibroblastic foci is bad. Honeycombing is bad. Already bad prognosis. Whereas whatever good happens in NSIP. Middle age is good. Being female is very good. Having rare fibroblastic foci is good. Having ground glass opacity is good. Good prognosis. Remember, for NSIP, 3 Gs. Female predominant. Girls, ground glass, ultimately good prognosis. Whereas opposite to UIP, men, honeycombing, bad prognosis. Next set of clinical scenarios. This patient is exposed to asbestosis and there is diffuse pleural thickening, asbestos exposure and pleural involvement. Think possibility of mesothelioma. Then next patient is having rheumatoid arthritis, silica exposure and lung nodules. This is rheumatoid arthritis with pneumoconiosis due to silica exposure. What is this combination? Silica exposure is pneumoconiosis with lung involvement. Along with that, there is rheumatoid arthritis. This classical combination is Kaplan's syndrome. The next patient is having obesity. There is daytime hypercapnia. And there is no other cause responsible for hypercapnia. It means his obesity is not allowing his respiration to happen. Hypoventilation syndrome. The patient is so much obese, lot of fat in his chest and his abdomen. Fat is not allowing him to breathe properly because the respiratory effort is not proper. Who is not coming inside oxygen? Who is not going out carbon dioxide? So CO2 significantly increase. What is this historically called as? It is also called as Pickwickian syndrome. It is also called as Pickwickian syndrome. Then next patient is a smoker. There is a hilar mass. Hilar mass generally indicates the mass is central. And there is syndrome of inappropriate ADH as a paraneoplastic syndrome. So what is the lung cancer causing SADH? Hyponatremia. I told you mnemonic, all hypos. Hypo means small. It happens in small cell carcinoma. Another long-term smoker, central mass, hilar mass. But now there is hypercalcemia. What is the lung cancer responsible for hypercalcemia? It is squamous cell carcinoma. Very important for your exam. The differentiating features of adeno, squamous and small, occupational lung diseases. What happens in asbestosis, silicosis, coal workers pneumoconiosis? Silicosis is most common overall. Asbestosis, you could see pleural plaques, pleural effusion. Predominantly there is lower zone fibrosis. And asbestos has maximum malignant potential. Most common is lung adenocarcinoma, most specific, especially happening in asbestos. What is the name of this cancer? It is pleural cancer, mesothelioma. Another radiological finding you come across is round atelectasis. Silicosis, more of initially individual upper zone involvement. Later, those nodules will merge into large areas of fibrosis called as progressive massive fibrosis. Silica exposure can also cause lung cancer. Whenever people are exposed to silica, they develop a disease called as tuberculosis. How? Silica particles can directly damage alveolar macrophage. And macrophages are first line of defense against TB bacilli. And on the chest X-ray, you notice bilateral hilar lymphadenopathy with classical eggshell calcification. Then exposure to coal workers pneumoconiosis. Initially, the features of silica exposure and coal exposure are similar. Only difference is the occupational history. Just like silicosis, here also initially individual upper zone lesions, stage called as simple coal workers pneumoconiosis. Later they merge. This is complicated coal workers pneumoconiosis. Smoke inhaled from burning of coal can also result in COPD. Then you have Kaplan syndrome. It is combination of rheumatoid arthritis with pneumoconiosis. It was first identified with coal. Recently, silica is also causing it. Many studies have shown that these particles, after inhaling, not only cause lung disease, but they can also trigger few autoimmune phenomena. One such autoimmune phenomena is rheumatoid arthritis. Then the differentiating features of adeno, squamous and small. Most common overall is adeno. Adeno is peripherally located. It is the most common type of lung cancer in young male, female, non-smoker, asbestos exposure. Adenocarcinoma is highest associated with clumping. And these tumor cells produce few substances and cause various manifestations called as paraneoplastic syndromes. Adeno is famous for hematological paraneoplastic syndromes, worth mentioning migratory venous thrombophlebitis or Troche syndrome. Squamous cell lung cancer. Whenever I say squamous, what is the mnemonic I told you to remember in the class? 4 C's. Centrally located, associated with cigarette smoking. It causes cavity formation and a paraneoplastic syndrome with calcium, that is hypercalcemia. Why? Because the tumor cells can produce parathermone related peptide, and this hypercalcemia is very severe. It can also cause death. That's why it was called as life-threatening metabolic abnormality. The name is small, but it causes all manifestations. What all they? This is also centrally located, strongest association with smoking. This is causing metastasis and it rapidly recurs. So even if you give treatment, it will recur very quickly. And due to metastasis, this is the lung cancer with worst prognosis. It can cause superior vena cava obstruction, very important, or these paraneoplastic syndromes. Tumor cells produce excess ADH, resulting in hyponatremia, excess ACTH, resulting in hypokalemia, excess calcitonin, resulting in hypocalcemia. How to remember? If you see here, hyponatremia, hypokalemia, hypocalcemia. Hypo means less. Small means also less. Majority of hypos are caused by small cell lung cancer, whereas hypercalcemia is a life-threatening complication of squamous. Very important exam question. Then, let us see next set of clinical scenarios. This is favorite for INICET. Anything in emergency room is a potential question in any subject. Surgery emergency room setting, medicine emergency room setting. Let it be gynops emergency room setting. In emergency room, you have seen a patient with pleuritic chest pain, hemoptysis, unilateral swollen leg. There is DVT. What you should immediately suspect? Is there any possibility of pulmonary embolism? Next patient, pleuritic chest pain with shortness of breath, presenting suddenly to the emergency room, and unilateral absent breaths. Think first in terms of pneumothorax. Then, pleuritic chest pain, fever, cough. There is infective signs. You should think of pneumonia. Now, there is a patient with shortness of breath and associated features. Chest tightness, cough, wheeze. This can be asthma exacerbation if the patient is young and there is allergy history. Elderly smoker, you should also think of COPD exacerbation. So it all depends upon further history. Young, allergy history points towards asthma exacerbation. Elderly smoker presenting with shortness of breath in emergency room, along with that cough wheeze. It is COPD exacerbation. Before we conclude, INI is also famous for asking newer drugs. In asthma, the new biologic is anti-TSLP. Come on, guess the name. It is tezepelumab. COPD, we have a new bronchodilator, which is a dual PDE3 PDE4 inhibitor. Guess the name. It is none other than ensifentrine. Bronchiectasis, there is a new drug known to decrease neutrophilic enzyme activity and reduce worsening. It is B for bronchiectasis, B for brensocatib. ILD, there is a new drug, antifibrotic, which is PDE4B inhibitor. This is called as nerandomilast. Pulmonary hypertension, there is a new drug, which is an activin signaling inhibitor, which reduces proliferation of excess smooth muscle in the pulmonary artery. The name is sotatercept. Lung cancer, we have the magical immunotherapy, anti-PD-1 antibodies, that is nivolumab, pembrolizumab. With this, I would like to conclude our rapid revision session in respiratory medicine as a part of INICET marathon. So trust your hard work, students. Don't panic. We are with you. Stay.
Hi friends, this is Dr. Kashish Grover, your PSM faculty, and today I'm here with you for the INICET marathon. Are you ready? Yes, are you ready? Can we start? Are you ready? Yes, can we start? Can we start? All right, so first point I want to talk about is all right, so can we start? Is it audible? Yes, everyone, is it audible? Is it audible? Is it? All right, so hi friends, now we are starting. Okay, now, like, so friends, I will be talking about the chapters related to our DBT topic. First thing which I want to talk about is HDI. Yes friends, HDI. I will be discussing the topic, and you have to write quickly. So we are here to revise these topics within next 30 minutes. HDI. Yes. Now audio, visual, everything fine. Let's get settled now. HDI, what is the mnemonic? Yes, everyone. HDI, what is the mnemonic? The mnemonic is knowledge, income, life expectancy at birth. Life expectancy at birth. Now, PQLI stands for ill at the age of 1 year. So, life expectancy at 1 year, infant mortality rate, literacy. Infant mortality rate and literacy. These two are very important topic for your INICET. Now coming to the next part. If I talk about the level of prevention, primordial, primary, secondary, and tertiary. Now primordial prevention, it is that prevention where risk factor is absent. Primary, where the risk factor is present, but here disease is absent. Here also disease is absent. If I talk about secondary, then in secondary the disease is present. But the disease is in early stage. And in tertiary, the disease is present, but it is in late stage. Now, yes, quickly, what is the example for the primary prevention? The example for primary prevention, the example is like vaccines. Vaccine is example of primary prevention. Post exposure prophylaxis, environmental change, everything is primary. If I talk about secondary, then early diagnosis and treatment, or you can say screening. Early diagnosis and treatment, or you can say screening. Now, coming to the next part. Now, what is case fatality rate? What is proportional mortality rate? The formula for case fatality rate is number of death due to a disease divided by total cases into 100. If I talk about proportional mortality rate, the number of deaths divided by total deaths into 100. This case fatality rate tells us about killing power. Right? Now, the most important point for INICET is Kaplan-Meier curve. This Kaplan-Meier curve is for survival analysis. Kaplan-Meier curve is for survival analysis. What do we find in Kaplan-Meier curve? It is median survival. What is median survival? It is the time when 50% people are alive. So, suppose this is your Kaplan-Meier curve. The time where 50% people are alive, this is known as median survival. Right? This is known as median survival. Now, do not enter in your exam without reading incidence and prevalence. What is incidence? Number of new cases divided by population at risk into 1000. Number of new cases divided by population at risk into 1000. What is prevalence? Number of new plus old cases divided by total population into 100. What is the relationship between two? Prevalence is equal to incidence into duration. Now, next thing is, if there is a highly virulent disease means more mortality, then what will happen to incidence and prevalence? If disease is highly virulent, then the prevalence will decrease. If there is good cure, then what will happen? Then prevalence will. If there is a good vaccination coverage, then what will happen? Then the prevalence will, then the incidence will decrease, and after some time the prevalence will also decrease, but the immediate effect will be on incidence. Now, this has been asked previously many times in your INICET exam. If there is a drug, they give this question like this: there is a new drug in the market which increase the survival, but it does not cure properly. For example, diabetes. Oral hypoglycemic drugs, they prolong the life, but they does not make a person diabetic free, but they never make a person diabetes free. Now, coming to the next one, who is a primary case, who is a secondary case, and who is a index case? Primary case is the one which is the first case in the community. Who is the secondary case? The case which developed after exposure to primary case. And who is the index case? Index case is the case which comes to notice of investigator for the first time. Now, previously they have asked a similar question. There are two brothers, Ram and Sham. Ram develops fever and rash. Mother ignores. Ram is 5-year-old. Sham develops fever and mother takes him to the hospital and he is diagnosed with measles. Right? He is a 3-year-old boy. Who is the index case? Yes, Sham is the index case. Who is the primary case? Ram is the primary case. So this is a very, very, very important topic for your INICET exam. Next, coming to secondary attack rate. Next, coming to secondary attack rate. If I talk about secondary attack rate, next is secondary attack rate. What is secondary attack rate? Secondary attack rate means number of secondary cases divided by number of secondary cases divided by susceptible population into 100. Number of secondary cases divided by susceptible population into 100. This is also very important for your exam. Very, very, very important. Now coming to study designs, which is the best study design for exposure and outcome? It is cohort. Which is the best study design for rare disease? It is case control. Which is the best study design for rare exposure? It is cohort. Study which gives us prevalence, cross-sectional. Study which gives us odds ratio, case control. Study which gives us relative risk incidence, cohort. Right? Study which gives us incidence, it is cohort. Study which gives us correlation, ecological. It is ecological. Now, quickly coming to all the formulas. Odds ratio, AD by BC. Relative risk, incidence among exposed divided by incidence among non-exposed. Right? So, if relative risk is more than 1, then it is causative. If it is equal to 1, then there is no association. If it is less than 1, then it is protective. Now, coming to what is cluster RCT? Cluster RCT is that design where individuals are not randomized. Instead, groups are randomized. Now, next revision point here is, what are the drawbacks of meta-analysis? Meta-analysis drawbacks are, the drawback of meta-analysis drawbacks are GIGO, garbage in, garbage out. Publication bias. Right? Publication bias. Now, next point is confounding and effect modifier. Now, please understand, confounding is, suppose A is related to B. Here, what is the difference? The difference is, for example, alcohol causes lung cancer. It is not the alcohol which causes lung cancer, it is the smoking. Those who take alcohol, they also smoke. Then, what is the effect modifier? The effect modifier is air pollution is causing lung cancer and Smoking is also causing lung cancer. They both together. Now, what is the difference between these two? If I remove this factor, then alcohol is not able to cause lung cancer individually. But if I remove this factor, air pollution can cause lung cancer individually. This is known as effect modifier. If in absence of this third factor, the disease can happen, it is effect modifier. Right? Okay, I will ask you one question and you will tell me what is the correct answer. Those who have lighter in their pocket, they are tend to get lung cancer. What is this? They are tend to get lung cancer. Dr. Paras, by the arrow, I do not mean it is bidirectional. It is just a symbol that they are interlinked. Those who smoke, they sometimes take alcohol. Those who take heavy alcohol, they smoke. Right? These are just to show that they are interlinked. Now, what is this? Confounding, because it is not the lighter which is causing the lung cancer. The person who takes lighter is usually a smoker. Now, next question is exercise causing weight reduction and diet control also causes weight reduction. Now, what is this? Guys, quickly. Now, what is this? Effect modifier, because if you remove the diet part, exercise alone is capable of causing weight reduction. Now, next is coming to the next part. Right? So, we have just revised the epidemiology quickly. Now, one topic which I am predicting that this is going to be in your exam, right? Can you guess the topic? Yes, I was revising it again today. It is census 2027. I don't know, but I have a strong gut feeling. Yesterday, I was also talking to Dr. Siddharth. He was also predicting this point that this will be there in the exam. Right? So it is census 2027. Right? Okay. So this census 2027 is also the first digital census. This will be the first digital census. It has two mascots, one male and one female. The name of male is Vikas. The name of female is Pragati. Right? It has two mascots. They two are enumerators. Now, this is going to be a census. This is going to be the first census where self-enumeration is going to happen. See, this is an ultra important topic. If it is not coming in your INICET, then it is definitely coming in your NEET, because this is the major update in your exam. Right? This is the major update. First census, this is going to be a self-enumeration. Self-enumeration means we will be given a link and we will be uploading how many family members are there in our family. And when these two enumerators, one male and one female, Vikas and Pragati, they will be coming to our home, rather than they will asking me how many members you have, we can give them the link where we have entered our family details. They are just going to add the reference number of self-enumeration / blah 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 blah. This number they are going to add, and automatically the details which we have filled, it will be there in their system. So this is a major update, guys, right? So do not enter in your exam either INICET or NEET PG or FMGE without census 2027. This is the major update right now. quickly, what is the nodal ministry? Nodal ministry, quickly. Nodal ministry is home ministry. Nodal ministry is home ministry. It is going to happen in two phases, phase 1 and phase 2. Phase 1 is going to happen April 1st, 2026 to September 30, 2026. Phase 2 will happen 1st October 2026 to Feb 2027. And in this area, we will be starting enumeration, and here we will be doing house listing. And here we will be doing house listing, right? Here we will be doing house listing. Now, in snowbound areas, in snowbound difficult areas, during winters like JNK, Ladakh, Himachal, September 30, 2026. So this phase 2 will go in rest country up to Feb 2027, but because the difficult areas, it should finish, phase 2 also finish in the difficult areas up to September 30, right? Up to September 30. So this is the major update. This is the major update right now, right? This is the major update right now. Now, how, if I talk about conducting immunization session, conducting immunization session, whenever we are conducting immunization session, especially the outreach session, we have two ANMs, or you can say two vaccinators. The job of one is to give the vaccine, and the job of another one is to maintain the record. The job of another one is to maintain the record. Now, the job of another one is to maintain the record. There are certain updates in tuberculosis as well that was beautifully covered by Dr. Bharat and Dr. Siddharth in their TB session. So, right, I will not be again overdoing it, right? So, now, other than that, so this is a major update. Please do not enter your exam hall without reading census 2027, without reading census 2027. There is another update where actually it is not an update, not a recent update, but yes, many students, they ask it. Zuvin. So like even, like Covin, like Uvin, Zuvin is a portal where Zuvin is an online portal where you can get the information about, your, anti-rabies vaccine. So you enter in the Zuvin, you get the anti-rabies vaccine availability around you, and anti-snake venom. So even is an electronic portal for the vaccine and cold chain. This is for the vaccine stock and the cold chain management. Covin, we already know. Uvin is UIP. We have to enter Uvin. Uvin is for entering all the vaccines under National Immunization Schedule. See guys, UIP is the program. Under this program, there is a schedule of the vaccine. The name of that schedule is NIS. The name of that schedule is NIS. Right? Name of that vaccine. Name of that is NIS. Now, quickly, there was earlier a portal which was known as RCH portal. Now, the name of this RCH portal is Janani 2.0. So, we have now Janani 2.0, right? So, this portal, Janani portal, this is a portal where we are not going to have one thing, but this is for the continuum of care. Right? So what is the full form of the portal? Journey of antenatal, natal and neonatal integrated care. Integrated care. So this is Janani. So this is also an update, Janani, right? This is also an update, Janani, right? Now, last topic which I want to discuss before I sign off, and that topic is lead time bias. That topic is lead time bias. What is lead time bias? Lead time bias is screening is confused with prolonged survival. Screening is confused with prolonged survival. This is known as lead time bias. This is known as lead time bias, right? This is known as lead time bias, right? This is known as lead time bias. I will give you the exact line how the question they will frame. They say that we are doing screening and we are catching the disease early, but there is no effect on survival. There is no effect on survival. There is no effect on survival, right? There is one more point which I feel that might be important for your exam, that is Prospero. That is Prospero. INICET, since day one, INICET is very much passionate about meta-analysis. Whenever we have to do meta-analysis, we have to register. So this is basically for registering meta-analysis protocol. Dr. Payal, COVID is for COVID vaccines. You must be remembering, if you got the COVID vaccine, we have to go to the portal of COVID. We have to register ourselves for the vaccination, COVID vaccination, right? COVID vaccination portal. With this, I thank you so much and I wish a very good luck for your INICET exam. May you guys shine, right? May you guys shine in the exam. From whole DAMS family, I wish you a very, 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 very good luck. I wish you a very, very, very good luck, right? All right. Thank you so much. If any doubt, you may ask. Thank you. Thank you. Yes, Dr. Abhinav, registering meta-analysis. Prospero. Very good. Yes. Thank you, everyone. Thank you, everyone. God bless you.
Yeah, hello guys, good evening, namaskar. I'm Dr. Dinesh, your pharmac educator, and I'm going to take your pharmacology, right? Okay, so we will discuss some important topics in pharmacology. Quickly, we will discuss some important topic, and these topics are very important for your NICT, very important. Okay, so let's start. The first is some basic question. The basic question is the drug following the redistribution from the brain to fat. The drug following the redistribution from the brain to fat, and that's why it is very short acting drug, that is thiopentone sodium. It is used for induction of anesthesia. The second important frequently asked drug in general pharmacology, the important concept, and that is about the Hoffmann's elimination. Through the lungs it occurs, and in Hoffmann's elimination it is safe in the liver as well as the kidney disease patient. The name of the drug is etracurium. The benefit of this etracurium is no histamine. If no histamine release, then definitely there is benefit and there will be less risk of histamine related reactions. Okay, yes. Next, again, the very frequently asked topic is inducers and inhibitors, or you can say the PGP inducers or PGP inhibitors as well. So in this, the frequently asked question, anti-epileptics are mostly inducers, rifampicin mostly inducer. These two very important topic. Antibiotics and valproate, these are mostly inhibitor. In the PGP inhibitor, you can also remember, in the PGP inhibitor you can also remember the quinidine and verapamil, or you can say the calcium channel blockers. So quinidine or calcium channel blockers, these are the PGP inhibitors also. right? So these are the important. Yes, griseofulvin is also there in this, but rifampicin is more important. Okay, chaliye. Now next, these drug interactions, frequently asked topic. Out of the drug interaction, contraception failure, hormone estrogen failure by the rifampicin. Cat group of drug toxicity due to CYP inhibitor, frequently asked topic. Clopidogrel is a prodrug. Omeprazole decrease the activation of clopidogrel, and tamoxifen is a prodrug, and SSRIs can decrease the activation. So these are frequently asked drug interaction, but definitely they can ask you many other drug interaction related to CYP. So don't forget the CYP inducers, CYP inhibitors, drug interactions. Some active forms are also important. In some of the active drugs, we need to know the active form. These are definitely not the prodrug. So we should know these are not prodrug, but still they are having some active form. So out of these, one frequently asked is this canrenone. Spironolactone changed to canrenone. Diazepam to oxazepam, allopurinol to oxypurinol, but spironolactone converts to canrenone. Very important. Very important. Fluoxetine is long acting because of this norfluoxetine. Diazepam is long acting because of the oxazepam. In general pharmac, these formulas very important, frequently asked. Loading dose depends on VD and target plasma concentration. Definitely, bioavailability is always important. Whether you check loading dose, whether you check maintenance dose, bioavailability is always important. You can see F is fraction, bioavailability. So whenever you take the fraction, definitely you multiply it by the 100. And target concentration, if you ask, then you can see the target concentration steady state that can be achieved after 4 to 5. Okay. Now half-life formula is very important. 0.693 multiplied by VD divided by the clearance rate. So these formulas, they are frequently asking in the general pharmacology. In general pharmacology, also the important topic is types of antagonism. So we have the competitive, non-competitive, uncompetitive type of antagonism. If the graph shifting to right side, this is competitive type of antagonist. Remember the mnemonic HELP, height for efficacy, left side for potency. And they are also asking about the antagonist, full agonist, partial agonist. So this is full agonist, +1 intrinsic activity, partial agonist, less than +1, antagonist or inverse agonist. In inverse agonist, there will be opposite action and there will be negative intrinsic activity. So by this graph, you can easily understand. Okay. Some frequently asked topic, I would say frequently asked topic is antidote. Definitely they will ask the antidote. So amphetamine, ammonium chloride and digoxin is diazepiant. In benzodiazepine, flumazenil, that is a competitive antagonist, flumazenil. In opioid, we have the naloxone. Naloxone is the antagonist. Naltrexone is also there, but in acute condition, we use the naloxone. And in alcohol poisoning, this is very important, fomepizole, that is alcohol dehydrogenase enzyme inhibitor. In atropine, you will see it is the physostigmine, datura poisoning, physostigmine. In amitriptyline, soda bicarb, and cranberry juice is important nowadays. Cranberry juice used for amphetamine. So cranberry juice is the acidic juice. It can be used for amphetamine overdose. It can be used for the urine stones as well, to change the urine pH. And because some drugs are having narrow therapeutic index drug, and because of narrow therapeutic index drug, because the ratio of LD50 divided by ED50, this ratio is basically called as therapeutic index. And if the ratio is less than 2, then it is called as narrow therapeutic index. And you can see the drugs narrow therapeutic index, we need to check the plasma level. Out of digoxin, plasma level is very important. It is 0.5 to 1.2 milliequivalent per liter. If the level goes more than 1.5, it is toxic. If the level goes more than 4, it is need of dialysis. And dialysis need to be continued till the level comes below 1. So these are the important points. And the last in the general pharmacology will be the definitions. Essential drugs are satisfying the priority healthcare need. Drugs used for rare disease are called as orphan. The drugs which are available against prescription are the Schedule H and H1. And in narcotics and psychotropics, we have the Schedule X drug like ketamine, like morphine. Sham drugs are basically placebo dummy medicines, and spurious are basically counterfeit medicines. Very hit topic. Direct question from these. So these schedules they are frequently asking. So in the schedule, remember the C is biological products. In F, we have the blood and blood products. The G is giving a label of caution regarding dangerous to use except under medical supervision. P for shelf life, expiry. P for shelf life, expiry. In W you will see only marketed under generic names. And X are highly abused substance dependence. Y has been replaced. Now in Y we have the on lithium therapy. To measure the blood level of lithium, when we take on the 4th day or 5th day, either 4th or 5th day. First sample should be taken on the 4th day or 5th day. The sample should be taken in the morning after 12 hours of night dose. That is the best sample, 12 hours of night dose. So this schedule Y has been replaced by the new drugs clinical trial rules. New drugs clinical trial rules 2019. So that has been replaced. Now in the migraine we have the important drug 5-HT1F without vasoconstriction. It is a wonderful drug, lasmiditan. And in the scalp we can directly give the injection onabotulinum. Out of the Gpent, it is approved new drug which is approved for prophylaxis only. Atogepant is not approved for acute condition. The drugs which are already available in Gpents, they are used for acute purpose as well. So that is important. Which is the longest acting NSAID, that is piroxicam. And nimesulide is not used because of hepatotoxicity. But don't forget the paracetamol antidote, that is N-acetylcysteine, which will replenish the glutathione peroxidation. And the new painkiller in the market is suzetrigine, which target the NaV 1.8 sodium channel. A new targeting the peripheral nervous system. Out of the gout drug, the important is which gout drug having the risk of this xanthine oxidase inhibitor, but safe in the CKD patient, but risk of MI. So that is the febuxostat. Antihypertensives which are having uricosuric property, that is losartan mainly, but it could be amlodipine as well. And anti-dyslipidemic is basically fenofibrate. Even statins are also having some property. But this is very favorite question, the drugs causing hyperuricemia. So these are the drugs causing hyperuricemia: pyrazinamide, aspirin, immunosuppressants, niacin, ethambutol, and diuretics. Pained drugs, pained. So don't forget the pained drugs. A very frequently asked topic about the most common side effect of salbutamol. Remember the T. T for tremors, T for tachycardia, T for tolerance. So tremors, tachycardia, tolerance, these are the common side effect. And one important is hypokalemia. Always check the potassium. Arrhythmia risk is there because hyperglycemia will be there. So that causes the insulin release and potassium shift. In Montelukast, there is risk of psychiatric problem, depression, suicide. So that is the new thing about the Montelukast. One very important topic for INICET is pulmonary hypertension. In the pulmonary hypertension, guanyl cyclase activator approved is sinesiguat, vericiguat approved for heart failure. Rho kinase inhibitor approved is fasudil. Ripasudil, netarsudil approved for glaucoma. In inhalational route, we use the treprostinil for adult and nitric oxide for the newborn. But nowadays, one more important group is basically these prostacyclins. In the prostacyclin, the analog is iloprost. Embrisentan, if you see the entans are the drugs which are endothelin antagonist. And selexipag is a drug which is agonist for this receptor, prostacyclin receptor agonist, selexipag. Epoprostinol itself prostacyclin. So these drugs are also important. Then comes to out of the antibiotic with cephalosporin having this ring, NMTT ring, and causing the bleeding time prolongation. So that is basically cefoperazone. Remember perazone, razo. So this drug. The drug effective against MRSA every bacha knows, and that is very frequently asked topic as well. Vancomycin, linezolid, daptomycin, these are the drugs. And out of the topical drugs, we have these mupirocin and fusidic acid. Daptomycin is basically having risk of pneumonia, and it is not effective in the pneumonia patients as well because it is inactivated by the surfactant. This slide is very, very, very important. It is for the resistant bacteria CREs. It is for the resistant bacteria CRE. The antibiotic having the Trojan horse mechanism, cefiderocol. The antibiotic which is best for KPC, Klebsiella pneumoniae carbapenemase, ceftazidime avibactam. And the antibiotic for New Delhi metallo-beta-lactamase, we need to add the aztreonam as well. Aztreonam. And the most nephrotoxic but last option, that is colistin. That is the last option. And we have one oral option as well, and that is fosfomycin. That's why it is used for complicated UTI patients. So this is the important slide. Pseudomembranous enterocolitis, you know the drugs causing pseudomembranous enterocolitis is cephalosporin, clindamycin, but the drugs used for the treatment are the like fidaxomicin, vancomycin. The most effective drug out of this is fidaxomicin. Nowadays, you also replace the, this microbiota, the flora, the microbiota, right? That is also important. Which antibiotics can cause the disulfiram-like reaction? So these are almost the same antibiotic which are having the NMTT ring. Out of these, metronidazole is basically different. Rest of them are cephalosporin. So these cephalosporins like cefoperazone, cefotetan, cefamendol, they have the same risk, just like bleeding risk as well as the disulfiram reaction. But metrozil is different. Okay. Now comes to the next. Trojan horse mechanism is basically the mechanism by which they enter and the exit is inhibited because they have the siderophore chain. So basically they binds to the iron inside the bacteria and not able to not going in the efflux mechanism. So that is called as Trojan horse mechanism. Vancomycin unique adverse effect is Redman syndrome. Linezolid is serotonin syndrome or cheese reactions because of the MAO enzyme inhibition. Daptomycin can cause the muscular, and cefepime is causing seizures. Cefepime is the fourth generation. Even imipenem can cause seizures. In the TB, one of the favorite question is TB. MDR TB is H plus R. Pre-XDR is H plus R plus fluoroquinolone, and XDR is 1 bedaquiline linezolid also. BPALM regimen approved by National Tuberculosis Elimination Program, and BPAL regimen is also approved by the this FDA. So these BPAL regimen, all oral 6, very effective, but there is risk of QT prolongation. There are some drugs which are effective for hepatitis B as well as HIV both. So remember the tail drugs, TEL, tenofovir, lamivudine, and emtricitabine. And the CYP inhibitor approved is cobicistat, and the one monoclonal antibody approved is ivalizumab. So what are the drugs for post-exposure prophylaxis? We have the TLD regimen. We use for 4 weeks, start within 72 hours. As early as possible you can start, but at least within 72 hours. For pre-exposure prophylaxis, the preferred regimen for pre-exposure prophylaxis is this one. So we use the tenofovir, TDF plus emtricitabine. So this is the preferred regimen, but you can use the tenofovir alafenamide as well. That is the alternate. That is for pre-exposure prophylaxis. That is WHO recommended. Again, very important slide. STIs. In the STIs, what is the drug of choice? Very frequently asked question is neurosyphilis, where aqueous penicillin. In gonorrhea, it is the ceftriaxone, diplococci. In the chlamydia, it is doxy. In the lymphogranuloma venereum, it is doxy. So that is one of the frequently asked. Gonorrhea, syphilis, frequently asked. Herpes, everybody knows herpes acyclovir, and in the trichomonas we use the metrozil, as well as in the B vaginosis we use the same, that is the metronidazole in the B vaginosis. Okay. In antifungal they are asking mainly the mechanism of action. Remember, mechanism or drug of choice. Azoles are inhibiting the ergosterol synthesis by inhibiting the 14-alpha demethylase. Terbinafine inhibit the squalene epoxidase. Both are inhibiting the ergosterol synthesis. But this is the cell wall inhibitor caspofungin. Griseofulvin inhibit the microtubules. The rest of the two drug, amphotericin B, that is basically bind to cell membrane and causing the pores formation. And the flucytosine is S-phase antimetabolite. And these two drugs, LAMP, liposomal amphotericin B, and this, LAMP plus flucytosine, that is basically used for the cryptococcal meningitis in the acute phase, intensive phase, induction phase, in the cryptococcal meningitis. And then after this we give the fluconazole for the maintenance therapy. Fluconazole. Out of the malaria, the favorite question is primaquine. Primaquine target the exerocytic in the vivax. So that is basically killing the hypnozoites. It kills the hypnozoites. But if you ask about the primaquine in the falciparum, In falciparum, it kill the gametocytes. So in falciparum for gametocyte, but for vivax kill the hypnozoites, preventing the risk of relapse of malaria. In gametocyte, preventing the transmission of malaria. Out of the chloroquine resistant falciparum malaria, ACT is best, but in vivax still we use the chloroquine because chloroquine is not resistant for vivax. So artesunate plus sulfadoxime pyrimethamine for all except northeast, but artemether plus lumefantrine for the northeast. That is for uncomplicated malaria. That is for uncomplicated. But if you ask me for complicated malaria, it is the artesunate. Alternate is quinine in the dextrose drip. For prophylaxis in chloroquine resistant, we use the mefloquine or doxycycline. Fast is doxy, but longer is mefloquine. In long journey, we prefer the mefloquine. Out of the anti-helminthic, sure short question anti-helminthic. So in the anti-helminthic, remember the 3 important point. In the anti-helminthic, remember the 3 important point. For most of the nematodes, we use the albendazole. For most of the nematodes, we use the albendazole. But for most of the trematodes and cestodes, we use the praziquantel. So whether they ask you lung fluke, they ask you blood fluke, they ask you bilharziasis, so that is the praziquantel. But for liver fluke, there is exception, and that is triclavendazole. But in nematodes, mostly albendazole, and the alternate is ivermectin. Like for river blindness, strongyloidosis, we use the ivermectin. Ivermectin can also be used for, in northeast state, ACT is, yes, artemether plus lumefantrine, we discussed. Yes, primaquine is basically for gametocidal purpose. In the scabies, we use the ivermectin orally, but topical drug is permethrin. Permethrin should not be given for less than 1 year child. Out of the anti-cancer, very hit topic, anti-cancer. Some anti-cancer inhibit this enzyme, DHFRase, that is methotrexate, and the drug inhibit the 5-fluorouracil is thymidylate synthase. Both these drugs need the leucovorin. Or folinic acid. Both these drugs need the leucovorin or folinic acid, or you can say the tetrahydrofolate, to decrease the risk of toxicity. One of the common toxicity of anti-cancer is vomiting, and we use the drugs like cetron for early onset, pitant for late onset, cannabinoids, antiemetic plus increase the appetite also some control of pain. Steroids are dexamethasone and olanzapine for the resistant cases. So we use these drugs for chemotherapy, vomiting, very important topic as well. If chemotherapy causing diarrhea, then we use the anti-motility, anti-secretory. Anti-motility is loperamide, anti-secretory is octreotide. Cardiotoxicity is commonly caused by anthracyclines because they contain iron. Iron overloading leads to dilated cardiomyopathy. And the antidote for this purpose is dexrazoxone, that is the iron chelator. Hemorrhagic cystitis is commonly caused by cyclophosphamide, and the antidote for this is mesna, mercaptoethane sulfonic acid. Hand and foot syndrome commonly caused by the 5-fluorouracil. Bleomycin can cause the pulmonary fibrosis. It is the most toxic for lungs, and bleomycin is also causing the cutaneous flagellate dermatitis rash. The skin reactions, lungs reactions. It can damage the type 1 pneumocyte cells. The drug which damages the type 2 pneumocyte cells is amiodarone. So type 1 pneumocytes by the bleomycin. You can see early onset nausea, vomiting, then I told you ondansetron. 5-fluorouracil and capecitabine, they are commonly causing hand and foot syndrome. 5-fluorouracil is a prodrug, capecitabine is the active form. Cytarabine causing cerebellar toxicity. And the drug which is having highest risk of vomiting, the drug which is having high risk of ototoxicity, the drug which is having high risk of nephrotoxicity, all these 3 toxicities are common. That is the drug cisplatin. But if they ask you which platinum compound having more risk of neurotoxicity, So that is basically oxaliplatin. Out of the platinum compound is the oxaliplatin. So neuro is mainly with the oxaliplatin. In the tyrosine kinase inhibitor, targeted therapy, EGFR inhibitor, osimertinib, that is the third generation, used for non-small cell lung cancer, T790M mutation. The TKI for HER-positive breast cancer is lapatinib and neratinib. So lap and nera for breast. And VEGFR inhibitor for colorectal or head and neck cancer. So that is basically this bevacizumab or ramucirumab, to CC, circulatory system, vascular endodermal, to circulatory, to ramu ki beva, colorectal cancer, as well as they decrease the neovascularization in the diabetic retinopathy. Diabetic retinopathy risk, because these are targeting the blood vessels. In the small molecule inhibitor, one important is BRAF. So RAF inhibitor like rafinib, and MEK inhibitor is matinib. So we use the dabrafenib plus trametinib combination. So we have these drugs, dabrafenib, trametinib, vemurafenib. These are targeting these small molecule. Also, we have one more important small molecule inhibitor, that is the proteasomes inhibitor, and that is the bortezomib. So these are zomib, multiple myeloma, wonderful drug, bortezomib, carfilzomib. One more important drug is histone deacetylase inhibitor, penabinostat, also important for multiple myeloma, penabinostat. They can be used for pancreatic cancer also. And JAK inhibitors are very important. JAK inhibitors, tofacitinib, baricitinib, upadacitinib, ruxolitinib. Ruxolitinib used for myelofibrosis. But rest of the drugs are mainly important for rheumatoid arthritis, or they are mainly important for inflammatory bowel disease. Out of these, upadacitinib is only JAK1. Only JAK1 inhibition is upadacitinib. Tofa is 1 and 3, baricitinib is 1 and 2. So T for 3, B for 2. But upada is only 1. These drugs are important for breast cancer, in the breast carcinoma, as well as ovarian cancer, ovarian carcinoma, as well as prostate cancer. The PARP is PARIP, and cyclin dependent kinase is ciclib. So PARIP and ciclib. So this PARP inhibitor for BRCA gene. This PARP for BRCA. This cyclin dependent kinase inhibitor, that is ciclibs. These are for HR positive but ER negative breast cancer, palbociclib. If triple negative breast cancer, then we use the immune checkpoint inhibitors. In the monoclonal antibodies, the drug for breast cancer, trastuzumab, pertuzumab, and the drug for colorectal cancer is panitumumab. In diabetes, Tapley. In Alzheimer's nervous system, lecanemab, that is for beta amyloid. HIV, that is the ibalizumab, post-attachment inhibitor. Ibalizumab. For inflammatory bowel disease, we use the vedolizumab, that is alpha 4 beta 7 inhibitor, and for plaque psoriasis we use the ustekinumab, that is 1, 2 and 2, 3. Ustad 1, 2 and 2, 3. I always say ustad se yaad rakho. ये ustad hai. In multiple sclerosis, you can use the natalizumab, that is alpha 4 beta 1 as well as alpha 4 beta 7. It is acting on both. But for multiple sclerosis, it is the one. But there is a risk of PML. And that's why it is a risky drug. So in IBD, we don't use it. We use only vedolizumab. We have one more drug for this purpose, that is ozanimod. That is the S1P receptor inhibitor. Right? Yes. Ustad, we told you. Eculizumab, ravulizumab, so EC, complement 5 inhibitor. Eculizumab, ravulizumab, zilucoplan, and rezonolixizumab is FC neonatal receptor. but these drugs are same. Eculizumab, ravulizumab, zilucoplan, complement 5 inhibitor used for paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, myasthenia gravis. Wonderful. Eculizumab. Out of the anti-inflammatory, we have the TNF alpha. In TNF alpha, remember the A, C, E, G, I. One alphabet is there, one is not there. A, then C, then E, then G, then I. One is not there. Out of these, infliximab is IV infusion. They have the risk of TB flare-up, and that's why we need to screen the TB. For interleukin 6, C46, tocilizumab, sarilumab, C46, 6 sari. So 6 tocilizumab, sexy sari. So 6 sari. 20 Ritu, Fattu, Bintu. Ritu, Fattu, Bintu. These are CD20. And in CD38 we have the Daratu. And that is an important drug for multiple myeloma. Daratumumab. Alemtuzumab for multiple sclerosis. So important. And then immune checkpoint inhibitor. Immune checkpoint inhibitor, PD1, Neve, Pembro, Semi, Dost. So Nevo, Pembro, Semi, Dost. Naye Purane Sabhi Dost. PDL1. What is PDL1? Aate Ave Dur. So Nave Purane Sabhi Dost, Aate Ave Dur. In CTLA, Pili Meli, and in the leg 3 inhibitor, relatively. So yaad rakhna, relative for leg pulling. So relative leg pulling, Pili Meli CTLA, Aate Ave Dur is PDL1, and Nevo, Pembro, Semi, Dost is PD1. Out of this pembrolizumab, I told you, triple negative breast cancer. Very good drug. Triple negative breast cancer. Pembrolizumab. There is risk of immune related adverse reactions, and that's why skin reactions, GIT, endocrine, so many reactions are there. The most dangerous is neurological. Most dangerous is neurological, but common is thyroid. Most common is definitely skin. So these are the problems whenever we use the immune checkpoint inhibitors. And the last is immunosuppressant. This is the last slide. In calcineurin, we have the cyclophilin binding is cyclosporin, and mTOR binding is this tacrolimus. Sorry, this cyclosporin and tacrolimus. mTOR inhibitor is sirolimus and everolimus. And that is for cardiac stent. IMP dehydrogenase is mycophenolate, that is not nephrotoxic, safer. Thalidomide used for immunomodulator. It was very toxic drug, teratogenic drug, but in aphthous in HIV for lepra reactions, immunomodulator use, it can be used. So these topics we have revised. These topics are very important. In general, chemo means anti-cancer, antibiotics, and autocoids. These topics are frequently asked, and respiratory system. The rest of the topic Dr. Thiru sir will complete. So that's all. So I hope we have justified these 30 minutes. So please, these 25 to 30 minutes, these topics very important. Whatever the points we have covered, these are very important. So please revise these. Thank you. Best of luck to all of you for this INICET exam, and I wish you good luck. Thank you guys.
Chale, very good evening, everyone, and we are here to discuss the important topics of the physiology. Yes, very good evening, very good evening. Yes. So energy levels are high. Chale, yes. First of all, I'll share with you one doubt which crept in yesterday, and that was that you were telling me that biochemistry madam has told the answer for IGF-1 and IGF-2 as insulin. So actually, in the biochemistry books, it is written that IGF-1 and IGF-2 is structurally related to insulin. That is why she told you the answer. But the better answer is pro-insulin, because the pro-insulin IGF-1 and 2, all the three are having three structural parts, which is A chain, B chain, and C peptide. And she has also told me to tell you all on her behalf as well that pro insulin is the better choice, right? But as she was also saying in one of the question, there was no option of pro and pre-insulin given, pre-pro insulin given, only insulin was given. Then maybe I can go with the biochemistry person. But if the pro insulin is given, it is the best answer because pre-pro insulin has four parts: A chain, B chain, C peptide, and N-terminal signal peptide. The proinsulin has the N-terminal signal peptide, which is removed, only A chain, B chain, and C peptide, and that is why it is the better answer, right? Chaliye, let's start with the session for today. So first is the body fluid measurements. So as you know, I'll quickly brush up the things here. So as we can recall, easy mnemonic, we have the girl who is Manasi, and I am going to secure her data, right? Or Manasine data, right? Which is mannitol, sodium thiosulfate, thiocyanate. Yes, very good evening. Sucrose, inulin, and data is deuterium oxide, aminopyrine, tritium oxide, and antipyrine. Intercellular fluid and interstitial fluid are all measured, both of them are measured indirectly. Indirectly, we all understand this will be total body water minus ECF. This would be ECF minus plasma volume, right? That's it. And for plasma volume, remember we have the radioiodine labeled albumin. Albumin is a plasma protein. You should not be making any mistake here, right? And finally, for the RBC, we have the tagging technique. The tagging means RBCs are tagged with some elements such as 51 chromium, 32 phosphorus, and 59 iron. Moving on to this interesting picture given in some of the PG books and the research articles, it's a wonderful picture trying to show me that in simple diffusion, we have the best examples, which is my gases and the channels. So kindly remember, channels are also an example of simple diffusion. The carrier protein is involved in both facilitated diffusion and active transport. But what is the difference in facilitated diffusion versus active? Energy. Facilitated, I am not using energy. In active, I am using energy, whether it is primary or secondary active. Naturally, in primary, there is a direct breakdown of ATP, such as we have discussed yesterday. Apart from the sodium potassium ATPase, hydrogen potassium ATPase, hydrogen ATPase, there is a ABC cascade of proteins, which is ATP binding cascade proteins, P0 glycoprotein. Secondary active, you remember so many examples, indirectly dependent on the sodium potassium pump, co-transporters, SGLT1, SGLT2 to name a few, and antiporters such as NCX, sodium calcium exchanger, and sodium hydrogen exchanger, right? Moving on to a comparison between ECF and ICF. So very quickly, just glance through it once more. I'm sure everybody of you know this, that the osmolarity is the only thing, or osmolality, which is same in both the compartments, right? Then remember, the most osmotically active ion in the ECF is sodium, in the ICF is potassium. And remember, the major buffer, that means most abundant and most important, same answer, bicarbonate for the ECF. But for ICF, proteins are much more important buffer because their dissociation constant, which is pKa, is closer to the intracellular pH. Moving to the feedback systems, is very important topic for INI. Keep in mind the mnemonic of positive feedback, but the much more commoner are the negative, which always try to maintain homeostasis. And which ones are going to destabilize it? That is positive feedbacks, right? Amplification, vicious cycle. The few examples, if before I take you to positive feedbacks, remember the interesting question, one of the favorites. They can ask you to calculate the gain. Gain is nothing but correction upon error. And kindly remember, yesterday also we had discussed a PYQ. Infinite gain is of zero error, which is control of extracellular fluid volume by the kidneys, renal body fluid mechanisms, right? Moving on to examples of positive feedback, quickly glance through it. Everyone seems to be knowing this already. CLAPS, so clotting cascade, calcium induced calcium release, LH surge, action potential, where I'm talking about opening of voltage gated sodium channels, activation of pancreatic proenzymes to their main form, trypsinogen to trypsin, yes, via enterokinase. Then we have the trypsin, which converts procarboxypeptidases into carboxypeptidases, chymotrypsinogen into chymotrypsin, proelastase to elastase. Then we have parturition, oxytocin, suckling again oxytocin, and decompensated or uncompensated shock. Feed forward control, normally we say, is an anticipatory control. That means the disturbance has not happened as of now, but the body anticipates that something can happen, makes the corrective response much before the actual disturbance. Common examples which can be asked in exam: anticipatory tachycardia, increase in heart rate much before the start of exercise, role of cerebellum in movements, cephalic phase of salivary secretion, and receptive relaxation of the food, of the stomach, where the fundus and the upper part of the body, the uh, Dr. Varun 7042, that is more of dealing with pharmacology, right? That is the pharma topic, that is not physiology topic. They are dealing in the T-half calculation, right? We are not teaching it. So receptive relaxation, fundus and the upper part of the body of the stomach relax to accommodate the food without much increase in pressure. And kindly remember, thermoregulation is an example of both feed forward control and negative feedback. This is due to the presence of the peripheral thermoreceptors in the skin and central thermoreceptors which are in hypothalamus. Then Nernst equation is a must know. It's a very important topic. Remember, Nernst equation is used to calculate the Nernst potential or the equilibrium potential, right? And please remember, this Z is the valency. You just have to do in the exam, just first calculate the magnitude, and then for finding out the sign, just figure out whether the ion is moving from the ICF to ECF or ECF to ICF, whether it is a cation or an anion. Goldman-Hodgkin-Katz equation is actually used to calculate the resting membrane potential. This is very important. Please do not mark the answer as Nernst equation to calculate the RMP, right? Resting membrane potential is calculated using GHK, or famously known as Goldman-Hodgkin-Katz equation, right? Goldman-Hodgkin-Katz. Membrane conductance for sodium and potassium is a very important figure. This has been asked twice now. As we can understand, this is the time scale given in millisecond. This is the membrane potential shown over here. So what we are saying is that if I plot the conductances of two ions, then we can understand the first ion is extremely fast to open and fast to close, but the other one is slow to open and much slower to close. So which one remains open for a very short time? That is none other than this one. If this is X, then I can say this is sodium. If this is Y, then I can say this is potassium, right? Fast to open, fast to close, slow to open, slower to close. This has been asked twice in the INI only. Factors affecting nerve impulse conduction velocity. So they haven't asked it in last 2 to 3 exams, but it might be on the cards. So you have to know that a large diameter myelinated nerve fiber, right? This is extreme just now, has low exoplasmic resistance because exoplasmic resistance is inverse to the radius. In a large diameter fiber, radius will be high, so exoplasmic resistance will be low. Then if I do myelination, then what is going to happen? When I am doing myelination, then remember, when we do myelination, myelin is a sphingomyelin. These are dendrites. So sphingomyelin. So when I'm wrapping this with the myelin sheath like this, this is all, let's say, myelin. So wherever we wrap, it's a sphingomyelin lipid rich complex. It will act like an insulator. It acts like an insulator. So in these areas, the membrane resistance will increase and capacitance will decrease, right? So what will happen in the nodes of Ranvier? If these are nodes of Ranvier, the action potential will jump from one node to another. Why? Because nodes of Ranvier are places where myelin sheath is absent. That means resistance will be less. You very well know that the current always takes the path of least resistance. That means the current will start jumping from one node to another. So action potential is jumping from one node to another. So it starts jumping like this. If you are jumping, naturally you are going to travel the same distance in a shorter time, velocity increases. So please remember, if I have a patient of multiple sclerosis where there is autoimmune destruction of myelin sheath, what is going to happen? The resistance will be less and capacitance will be high, right? Reverse will happen in multiple sclerosis. Then arrangement of sarcomeres, yes, saltatory conduction, absolutely correct. Arrangement of sarcomeres in a myofibril, two questions have come from here. One, most of you would be knowing, an important one. If I just see over here, this is Z band is written, but they actually is it's Z line. So anything they can write in the exam. If I am going lateral to medial, arrange the Z, M, H and A in the right order. So first you will have the Z line, then you have the A band. This entire is the A band. Then you have the H, and finally you have the M line, right? So Z, A, H, M as we say. And the second thing is node of Ranvier pe Dr. Bishnoi, the capacitance, you tell me normally what is happening. Node of Ranvier pe capacitance will be high. That is why the current is jumping, right? So this is Z, A, H and M. And the second one is during the muscle contraction, which is the band which remains same or unchanged. Again, most of you will be able to immediately point it out. The A band remains the same. The A band remains the same, right? The A band remains the same. Then moving on to the same EM picture, this is one of their favorites. So very easy to identify. Kindly see the way out. Whatever is lighter in color has to be my I band, right? The lighter in color. In the middle of the I band, we will have the Z line. In between two successive Z lines, I will have my sarcomere. So you will be easily able to identify the I band, Z line, and then the adjacent areas will be naturally A band. In the middle of A, we have a lighter area. This is all H. And in the middle of the H, we are having a line which is M line, right? So this way you can easily identify any band or line which they are asking in the exams. Always start from the lighter area, right? Moving on to excitation, contraction, coupling. So very quickly, I will brief you regarding all the three muscles one by one. This is the first one, which is skeletal muscle. How can I make out this? Only by reading or looking at one thing, that there is a mechanical coupling between the dihydropyridine and rhinodine receptors. So basically, this is the one which is famously known as electromechanical coupling. Electromechanical coupling, where as soon as please look at the flowchart once, as soon as the sarcolemmal depolarization occur, the T tubule will depolarize, and please remember the DHPR here is behaving like a voltage sensor. So it will undergo a conformational change and the calcium will come out into the, from the terminal cisterns into sarcoplasm. So this calcium is going to come out eventually. This one. This is coming out. So please recall, do I have calcium induced calcium release here? No, no. No calcium induced calcium release. Which is the only calcium which is important here? ICF calcium, right? Now let's go for in the cardiac muscle, as one or two of you have already started writing. Please see this one. So in cardiac muscle, first of all, the coupling which is happening is known as electrochemical coupling. Electrochemical. Why are we calling it as electrochemical? Because the ECF calcium here will cause the release of ICF. That means calcium induced calcium release also occurs. Please remember this. Very, very important point, right? Which calcium is more important? ICF calcium, 80% role, right? And relaxation is also via dual mechanism. One is circa, like in all the muscles, but additional mechanism is sodium calcium exchanger. On the right side, I have tried to show you the same thing. Action potential reaches, sarcolemma depolarizes, T-tubule depolarizes, main point. Dihydropyridine receptor opens, the voltage gated calcium channel, small calcium influx occurs, 20% around. Even if you don't want to remember the percentage, please remember ICF is the main one. Then what happens? As we have understood, this is the main one. The rhinodine receptor will open, which will cause CICR, calcium induced calcium release, sarcoplasmic calcium, higher concentration, eventually binds to troponin, shifts the tropomyosin away, actin myosin interaction can start, right? Moving on to excitation, contraction, coupling in the smooth muscle. So let me zoom this figure a little one for you and just have a glance here. So first thing, which is the main calcium, ECF calcium is the main one. Why is the ICF not main? Because please remember, sarcoendoplasmic reticulum is rudimentary, poorly developed. That is why this is not the main source, although it has a contribution, right? This is the reason. As soon as the ECF calcium comes in, again it will cause calcium induced calcium release. Please remember the important points. Here you do not have troponin. Here you have calmodulin. Calmodulin will bind to the calcium and will activate a very important enzyme, myosin light chain kinase. It causes phosphorylation of the regulatory chain, actin myosin interaction starts. Which is the enzyme which is going to oppose this? Myosin light chain phosphatase. So when I want to do relaxation, circa will decrease the sarcoplasmic calcium, which will activate myosin light chain phosphatase, and eventually the regulatory chain returns to original conformation. So key points, CICR occurs, yes, which is the main calcium here, ECF, right? And remember MLCK, MLCP, please, no confusions here, right? Moving on to the tetanizing frequency, this also now quickly solve this for me. What is the tetanizing frequency in the given figure? Yes, please try to give the correct answer. Yes, quickly. This is, let's say, 5. This is the highest point of contraction. I will simply draw a straight line like this, right? And this is 30. Now you all can give me the answer quickly. What is the tetanizing frequency in this case? Tell me quickly, quick. Tetanizing frequency is, yes, absolutely correct, SK, that's right, yes. Tetanizing frequency is 1 upon, what is the contraction period? देखिए फटाफट, 30 minus 5 millisecond, कितना हुआ? 25 millisecond, but I always have to take in seconds. सेकंड में लेंगे तो ये हो जाएगा 1000 अपॉन 25. आंसर हो गया यहाँ पे 40 हर्ट्ज. वेरी गुड, एब्सोल्युटली करेक्ट. नहीं 1/30 नहीं लेना है, दोबारा से देखिए, बिकॉज यू हैव टू remove the latent period. ठीक है, that is the concept. So I've changed the picture slightly. Instead of showing you the picture of yesterday, I've changed the picture, right? I'm not giving you the identical picture which they asked. I've just changed the picture so that you are clear. ठीक, नहीं स्वाति रॉय, आई थिंक आपने गलत करा है, दोबारा से देखिए. ये जो 0 to 5 है, दिस इज, प्लीज फोकस, दिस इज द लेटेंट पीरियड. ठीक है, यहाँ पे देखिए ये लेटेंट पीरियड है. लेटेंट पीरियड इज द टाइम ऑफ एप्लीकेशन ऑफ स्टिमुलस एंड प्रोडक्शन ऑफ रिस्पॉन्स. तो 30 में से 5 माइनस करना है. ठीक है, यू हैव टू सब्ट्रैक्ट 5. Then moving on to some important receptors in central nervous system. Very quickly, we'll just figure out the most important points. Pycnion is located deep inside the skin, fascia and joint capsules. It is responsible for fast vibrations, deep pressure. It is the most sensitive receptor. Meissner's corpuscle, remember, is responsible for texture. They can ask you topognosis, study of surfaces. Please remember, best stimulus is moving touch. And it is the most numerous receptor, but it is mainly present in non-hairy skin or dermal pegs of glabrous skin. Non-hairy. Dermal pegs means depressions in the dermis. Finger lips, nipples, palms and soles, fingertips, best sites. Hair and organs, light movement over my hairy skin, right? So if insect is crawling over my hairy skin, that is hair and organ. If the insect is crawling on my fingertips or my palms, that is basically Meissner's corpuscle, right? slowly adapting or tonic. One important question from here, please, no confusions. Merkel is the best answer for 2-point discrimination. The reason is Merkel has the smallest receptive field. Merkel has the smallest receptive field, right? Please remember, even for Braille, the Merkel is the best answer, which has been shown by research experiments of the neurophysiology textbook. And normally we say even for Braille, the Merkel is the better answer. Ruffini's nerve ending, remember, for prolonged pressure, best stimulus, stretch on skin. Sometimes we say it is the best answer for stereognosis. Kindly remember this. For stereognosis, Ruffini's ending is the best one, right? Then apart from this, muscle spindle, Golgi tendon, I will discuss in the reflexes, which after this slide. Joint capsule, please remember, whenever we are doing joint capsule sensations, right? These are all superficial receptors. That is why the key word is superficially, right? So joint proprioception, always by joint capsule, do not say pexinium. They are deep inside, right? Nociceptors, we all know, for pain. Stretch reflex, another favorite topic, stretch and inverse stretch. Almost every alternate year they ask in some exam or the other, especially in INI, either in May or November. So please remember passive stretch. Passive stretch means a light stretch, change in muscle length as we say. Then which is the receptor? We all know receptor is the muscle spindle. This is the spindle, which is the afferent fibers 1A and 2. Where do they come? Center ventral horn, which is the efferent A alpha, also known as lower motor neuron. What will it do to the muscle? Contraction. So kindly remember, any reflex I ask you in exam, ankle jerk, triceps jerk, biceps jerk, anything, always the efferent answer is A alpha or the lower motor neuron, which directly supplies the large muscle fiber. Inverse stretch reflex is the one which is stimulated due to powerful stretch or increase in muscle tension. Remember, the stimulus here is powerful stretch, but the receptor organ is Golgi tendon organs, which are located like this. These are the main receptors. We say 80 to 85% are in tendon muscle junction, musculo-tendino junctions. Please remember this. Only the remaining 15% or 15 to 20 are actually inside the tendons. Afferent, they have asked many times. 1B, it's a multiple times asked PYQ, 3 or 4 times. And please remember this one, that it does not directly land up on the A alpha, but rather there is another intervening neuron known as inhibitory interneuron, which releases glycine. So it's a bisynaptic reflex which is going to inhibit this. Eventually, the A alpha was supposed to contract the muscle, but here the muscle will relax. What is the advantage? It prevents the rupture or the avulsion of the tendon. So they can give you a question that a weightlifter is trying to lift a very heavy load, right? And suddenly his muscle relax. Cerebellum, the division is very important. Functions are extremely important. As I am going from lateral to medial, doctors eat good food. But in humans, E plus G have been combined to give me the nucleus interpositus. That means I will write like this: DIF, FID. So basically the spine vestibulocerebellum is the flocculonodular lobe, whose main role is postural balance through the visually guided movements. Spinocerebellum, medial part vermis, adjacent part paravermis. This is paravermis. Absolutely true. Remember, if I ask you, the vermal efferents will exit out. Very easy question. The vermal efferents will exit out via this nucleus, which is in the vermal part, which is this nucleus fastigial. The paravermis efferents will exit out via interpositus, and the neocerebellum will exit out via dentate. Neocerebellum role is planning and programming, spinocerebellum motor coordination. Hypothalamus, the only one or two changes being done to the table according to the latest literature. Just keep an eye on these two. One I had told you yesterday as well. Hunger, thirst, no issues, lateral or ventrolateral hypothalamus. For rage, remember the best answer now considered is periaqueductal gray, PAG. And if this is not given, then they might give you sometime periventricular areas. For satiety, the answer is same, ventromedial. But for reward, now they say medial forebrain bundle and nucleus accumbens. This is considered as the best answer. If this is not given, then I can go with ventromedial, right? But in today's scenario, they will definitely give you forebrain bundle, medial, or the nucleus accumbens. Heat gain, heat loss, we already know. Anterior hypothalamus, preoptic, we had done yesterday as well. Circadian rhythm, suprachiasmatic nucleus. Sexual activity, anterior and posterior most portions. But please remember, in sexual activity, in the males, we have additional area which is pyriform cortex, right? Pyriform cortex. And for neurosecretions, we say SAD, POX. Supraoptic is ADH, paraventricular is oxytocin, right? Or as I say, Om Prakash, right? Oxytocin and paraventricular. Moving on to CVS physiology, let's quickly recap the plateau potential. The plateau potential, if you can figure out two or three questions here are must know. Phase 0, one of their favorites, and phase 2. These are asked maximally. So phase 0 is due to voltage gated sodium channels, not calcium. And phase 1, transient rectifier outward potassium channels. But plateau is the most commonly asked slow calcium channel, calcium influx. Then phase 3, delayed repolarization or delayed rectifier outward potassium channels. Mostly they are asking 0 and 2. So please remember that 0 and 2, right? Moving on to pacemaker potential. If I look at the pacemaker potential, then remember this is famously known as pre-potential or the slope of the pacemaker potential because it makes an angle with the horizontal. That is why we call it slope. For phase 0, which is again asked many times, the answer is not sodium now. The answer is long lasting calcium channels. Calcium L, long lasting, right? Phase 3, potassium efflux. Phase 4, we have three reasons. Decline in efflux of potassium. Remember sodium HCN, hyperpolarization, cyclic nucleotide gated channel, older name funny channels. Calcium influx through transient calcium channels. Kindly remember maximum role is of calcium and not funny sodium. Right? Please remember this. Maximum role transient calcium. Right? Transient calcium. Also, you can easily give me the answer. Just follow here. If this is a stimulation given in the exam, and this is another stimulation given in the exam. ठीक? This is the X, this is the Y, which is parasympathetic and which is the sympathetic one. X is sympathetic nervous stimulation, Y is vagal, parasympathetic. Why do I say so? Please look at the slope in comparison to the normal. In this slope has increased. I am reaching the firing level in a shorter time, increase in heart rate. In the this one, the slope is less. I'm taking a long time to reach the firing level. So here I'm taking long time, here I'm reaching quickly, right? Sympathetic versus vagal. Absolutely true. Good. Most of you are correct here. This is an additional thing which can be asked. Moving on to hemodynamics, please keep an eye on only the third and fourth one, which is important for us. Ohm's law, I think we all can recap. Q is equal to delta P upon R, right? Or R is equal to delta P upon Q, right? Velocity is inverse to total cross-sectional area. That means, yes, It can be, but generally they will always ask you the sympathetic and parasympathetic here, right? So I will not say per se digoxin, because digoxin, why is not digoxin as per se, because it will also increase the contractility as well. Poiseuille-Hagen law, please remember this relationship, delta P into pi by 8 into 1 by eta, but most important for me is this one. The blood flow is directly proportional to fourth power of radius and inverse to length. Please remember this. And from here only we can understand that the R is 8 eta L upon pi R4, right? Please remember, they can ask you any one. Laplace law, no, it is not stuck. It is not stuck. It is working fine. SK, just refresh. T is equal to P into R, or T is equal to P into R upon W. This is, we say, for a cylindrical structure, which can be your capillary or any other blood vessel. For a spherical structure, W is wall thickness. The relationship is P into R upon 2, or P into R upon 2W, right? P into R upon 2W. Remember, we will be looking at this in the cystometrogram relationship just in a while. Cardiac cycle. So I hope by now we are all clear with the basic concept. Electrical events are followed by mechanical events. So no need to write today. P is atrial depolarization. Atrial depolarization will be followed by, yes, please look over here. Which mechanical event? Atrial systole. QR, ventricular depolarization, electrical event, will be followed by, yes, will be followed by onset of ventricular systole. Onset of ventricular systole, S1. Then I will have IVC, isovolumetric contraction, then ejection, rapid and slow. Finally, T is ventricular repolarization. Then we have onset of ventricular diastole, S2. As soon as we have onset of ventricular diastole, we will have now IVR, venous filling of the atria. As soon as the valve opens, we will have S3, rapid, filling, and then the same will lead to Y, descent. And as the Hindi mnemonic goes, PA is पान की दुकान पे, QR is QR code scan किया, 1C is एक सिगरेट जलाई, X is X-ray में T2 की finding आई, V3Y, right? This is the mnemonic for the cardiac cycle. Moving on to left ventricular pressure volume loop. This is another important one. So when we talk about left ventricular pressure volume loop, now everyone can agree here and immediately tell me the MAM COCO. This is the arrangement of the valvular opening and closure. So remember, one, this is the mitral closes, aortic opens, aortic closes, mitral opens. They can ask you from where is the diastole starting and where is the systole starting. Nothing to worry. Systole is starting from point 1 and systole will finish at point 3. So 1, 2, 3, please see, 1, 2, 3 is the extent of systole, but 3 to 1 is the extent of diastole, right? So this is how some new questions can be given, right? My MAM COCO is mitral closes, aortic opens, aortic closes, mitral opens, right? Then variations of the loop are again important. We can quickly see this again. Just see this. There can be a loop like this, where there is a very high left ventricular pressure, but the stroke volume is still less. This is an increase in afterload, or increase in TPR, total peripheral resistance. Why? Because left ventricular pressure is very high, but still the stroke volume is less. Another one could be something like this. Here now what happens in this one, there is increase in contractility. Why do I say so? The key point, naturally left ventricular pressure is slightly increased, but not like the other one. But here the main thing which you have to figure out is that although LVP is increased, but the stroke volume will always be increased, right? That is the key point. Stroke volume will always be more because of maybe digoxin or increase in contractility. And the last one is when I'm giving you IV fluids. IV fluids means increase in preload. So I will shift it like this slightly. EDV is increasing, which is giving me this kind of loop. This will be increase in end diastolic volume or resulting in increase in stroke volume. This is increase in preload, right? IV fluids. So please keep an eye on this. They are actually asking it quite frequently, right? Because this is basic physiology as we go about. Moving on to cardiovascular reflexes, the first one is the baroreceptor. So this again is well versed. All of you are very well versed. Person is in standing posture. He lies down. Immediately the effect of gravity is nullified. More blood pressure, which is the main baroreceptor, carotid sinus. What will happen? More stretching. Where are the baroreceptors present? Tunica adventitia. Which blood pressure they are most sensitive to? Pulse pressure. More firing rate, more afferent fiber discharge, ninth nerve and 10th nerve goes to NTS. CVLM is stimulated, caudal ventrolateral medulla, RVLM is inhibited, sympathetic outflow will reduce. So basically what will happen? Heart rate decreases, stroke volume decreases, and total peripheral resistance decreases. But vagal stimulation will only decrease the heart rate because vagal fibers sparsely innervate the ventricles. And because of the product of heart rate and stroke volume being cardiac output and TPR reduces, so eventually the blood pressure will decrease, right? The blood pressure will decrease. Moving on to other cardiovascular reflexes, Cushing, yes, Paras Cushing was that basically in intracranial tension when it is increased due to tumor, trauma or abscess, then this is a pathological condition. There will be decreased blood flow resulting in ischemia, starts happening after less than 50 mean arterial pressure, right? And what happens now? There is excessive stimulation of the baroreceptors, increase in blood pressure. But baroreceptors will try to reduce your blood pressure. But please remember the vagal tone is dominant. That is why there is reflex bradycardia, right? Bainbridge reflex, again, very commonly asked. In IV fluids, if I give or increase in fluid transfusion causes increase in heart rate, mainly due to atrial stretch receptors. Basal-Jarisch, double repeat, injection of viratridine, serotonin, capsaicin, phenylbigonides directly into coronary arteries causes both hypotension and bradycardia, right? Both hypotension and bradycardia. Moving on to GFR, this figure is very important. Either they will give you the calculation of the pressure out of any 5, they will give you 1. Suppose this is NFP, net filtration pressure. So you can be asked 1, 2, 3, 4, 5. Out of 5, I will give you any 4 in the exam. I will ask you the missing one. Second is directions of the pressures. Please keep in track. Hydrostatic in glomerular, pushing. Oncotic in glomerular, pulling back. Oncotic in Bowman's, again pulling out. Hydrostatic in Bowman's, pushing back, right? So please keep the idea of the directions. Tubuloglomerular feedback, the important concept, which is the substrate released, who senses. So this is sensed by macula densa, right? Macula densa at the junction of TAL and DCT. What is released? Adenosine, which is the receptor A1. What is eventually going to happen? Calcium will cause constriction of afferent arteriole, right? So please keep a track of this. Then clearance curves. So clearance curves, and I have added one more picture today, but first let me only show you the one which you are very well versed with, clearance curves. This I don't think we need to even discuss. Yes, what is this? Para amino hippuric acid. What is this? Inulin. Inulin. This is inulin, neither reabsorbed nor secreted. Anything which is having clearance of less than inulin, over here this is glucose, reabsorbed. This is creatinine. This is creatinine, partly secreted. But I would like you to tell me and just give me 1 second here, because I would like you to figure out this for me. So now the question is, please look at this picture, very interesting figure. This is shown as pAH titration curve. I will give all of you 30 seconds to think about the answer, right? This is a pAH titration curve. You have to tell me, just listen to the question first. This is X, this is Y, this is Z, right? Which one out of X, Y, and Z is filtration, which is excretion, and which is secretion? Think about it. This is a figure which I wanted to show you today. This can come in exam. This is not given in all the books, but it's an important picture. Very basic concept. This is on the y-axis we have pH, which is either filtered, secreted, or excreted, right? Three curves. And on the x-axis, unbound plasma ka matlab hai the pH which is not bound to plasma protein, because the one which is not bound to plasma protein will naturally get filtered, right? The one which is bound to plasma protein will not. बताइए फटाफट बोलिए आंसर. X is what, Y is what, Z is what? Okay, good. What is X? You can see TM. You should have been able to tell me. That is the easiest thing here. TM, pH is secreted. It has a T max 80. Yes, milligram 80. Remember T max 80. Yes, X is secretion, Y is filtration. So what is Z? Excretion. Very good. Now I can probably erase this for you and let me show you the exact picture. Very good. Just see this. X is secretion. How do I get this? There is the T max. This was the hint. What is the concept? Please see. Very interesting figure. pH is getting excreted. Excretion is filtration plus secretion. So this much amount is filtered, this much amount is secreted. Excretion is sum of both the two, so it will always be the higher than filtration and secretion. But please see, once there is a T max, then what happens? The filtration curve has become parallel to excretion curve. Why? Because all the carriers have saturated. So please keep an eye on this. Very interesting picture, can come in exam, right? So moving on to the next one, this is also a many times repeat, percentage of filtered load remaining in the tubular fluid. So when I talk about percentage of the tubular load, that means I look at A, which has become nearly zero in PCT, proximal tubule. What is A? This could be glucose, this could be amino acids, but please do not say bicarbonate, because bicarbonate are 85% reabsorbed in the proximal tubule. B could be my bicarbonates or the other electrolytes, because they are still there in the proximal tubule. And then we have the C, which is again fixed. It is inulin, and the DA is increasing, which is none other than para-aminohippuric acid. Yes, very good. Absolutely correct. All of you have seen this picture. And then the cystometrogram. Remember, 1A is the initial part of the picture. Up to 50 ml, there is only rise in pressure to 10 centimeter water. But from 1A to 1B, we say flat part of the curve where the what happens? Yes, 1B, remember 1B, Laplace law. What is Laplace law? Laplace law states that P is 2T upon R. So what is happening here? Tension is increasing along with filling, but bladder is a smooth muscle. It stretches to accommodate due to the property of plasticity. Pressure remains same, right? Pressure remains same. This is a multiple times repeat. And finally, beyond 400 ml, you cannot hold the urine. So you will have sudden urge to micturate, right? Sudden urge for micturation. So the other part will be taken by the other faculty. Before that, kindly remember that these are some other important topics which lot of people had asked me. This is the spirometry, flow volume loops, oxygen hemoglobin dissociation curve. Kindly go through chemical and neural regulation, basal electrical rhythm, GI motility, GI hormones, MMCs and peristalsis. In the hormones, remember MOA, mechanism of action, and second messengers. Thank you so much for patient listening. Your preparation is on track, very sound. So nothing to worry, just give exam confidently और maximum question attempt करना है. ठीक है, please maximum attempt करना है. without any tension, without any stress. Leave rest to Almighty, but give your best, right? Finally, thank you so much. Thank you so much once again. God bless you all. Thank you. बोमराज उसके लिए प्लीज मुझे डीएम डायरेक्ट मैसेज करिए, ठीक है? आई हैव अदर फैकल्टी लाइंड अप, ऑल्दो अगेन आई हैव टेकन 10-15 minutes extra, right? So sorry for not answering the other queries because we have the paucity of time, right? Thank you so much. Well, thank you. बोमराज उसके लिए प्लीज मुझे डीएम डायरेक्ट मैसेज करिए, ठीक है? आई हैव अदर फैकल्टी लाइंड अप, ऑल्दो अगेन आई हैव टेकन 10-15 minutes extra, right? So sorry for not answering the other queries because we have the paucity of time, right? Thank you so much.
Yeah. Good evening, doctors.
Sorry for not answering the other queries because we have the paucity of time, right? Thank you so much.
Good evening, doctors. Could you able to hear me? Guys, if I'm audible and if you could able to screen the screen and the scribblings as well, please do give me a thumbs up. Good evening, doctors. Yeah, that's good. That's good. Just give a second. 1 minute, doctors. Good evening, doctors. Just a second. Guys, if I'm audible and if you could able to screen the screen and the scribblings as well, please do give me a thumbs up. Yeah, that's good. That's good. Just give a second. 1 minute, doctors. Just a second. Yeah. Good evening, doctors. Just give me a second. We'll be beginning. Yeah, all good now? हाँ बस जी just a minute. Yeah. Yeah, it's there, sir. Just a minute. No, you, sir, you're connected, sir. Actually, you can move. Yes, yes. Sir. Which side, sir? Okay. One minute, sir. You are still clicking. Okay. Okay. Okay, sir. Again, display capture. Okay. Right. Where, sir? Where double click? Sir, you are moving, sir. You're moving the screen. Just a minute. All right. Fine, guys. I hope the screen is clear and you could able to see the writing as well. All right, guys. I think we can start with the session. Right, people. So we have 4 topics left in physio. One is respiration and the other one is endocrine. Third JAT and fourth one is reproduction, guys. So let's start with the first topic, respiration. So here the predictors are the topics we got to be clear about is V/Q mismatch and ratios, oxygen hemoglobin dissociation curve, obstructive versus restrictive lung disease, hypoxia types, control of ventilation. These are the topics we got to be clear about. Now let us start with V/Q mismatch. People, to begin with, normal V/Q ratio is going to be 0.8. The very normal V/Q ratio is going to be 0.8, guys. Yeah, normal V/Q ratio is going to be 0.8 here. And the way we get this ratio to 0.8 is we have ventilation of alveolar ventilation of somewhat about 4 liters, and normal cardiac output is going to be on an average of 5 liters. So alveolar ventilation of 4 liters and cardiac output of 5 liters together, the ratio is going to be 0.8. Then let's take up pulmonary embolism. Pulmonary embolism is a situation where there is going to be a development of alveolar dead space and V/Q ratio is going to become infinity. So it's going to be infinity, and this condition is going to be alveolar dead space, guys. The third condition is atelectasis. Atelectasis is a scenario where lung units are getting closed, and this is going to turn into pulmonary shunt. This is going to turn into pulmonary shunt, and you guys know the V/Q ratio in pulmonary shunt is going to be 0. Asthma as well as COPD, these two conditions, asthma as well as COPD, these two conditions are going to be having a V/Q ratio of somewhat about 0.5. So these two conditions are considered as low V/Q ratio conditions, asthma as well as COPD. Now the reason is it's going to be a partial airway closure. Number one, it is going to be partial airway closure. If it happens to be a complete closure, we will be calling this as shunt. Since it's going to be a simple partial closure, it's going to be low V/Q ratio, number one. The most important point here, don't just think that this is a simple partial airway closure alone. There is also going to be a compromised gas exchange. There is also going to be a compromised gas exchange, guys. So that's V/Q ratio with a lesser value. Now conditions with low V/Q ratio, conditions like this, regions of low V/Q ratio will be manifested with decreased partial pressure of oxygen. It's going to be manifested with decreased partial pressure of oxygen. So hypoxemia is practically the norm, guys. So here we have decreased PaO2, number one. If it is going to be early pathophysiology, the carbon dioxide value will be very much normal. If it is going to be a late pathophysiology, or if it is going to be a chronic one, late, or is it going to be a chronic one, this is going to be manifested with a reduction in, there is going to be manifested with increase in carbon dioxide with reduction in oxygen. So if the question is about regions of low V/Q ratio, and that's going to be a very important point, regions of low ventilation perfusion ratio, be it early pathophysiology or be it late pathophysiology, one thing is going to be definite, that there is going to be decrease in oxygen, there is going to be hypoxemia. The carbon dioxide level differs based on situation. If it is going to be early problem, carbon dioxide level will be normal. If it is a late problem or if it is a chronic disorder, carbon dioxide level will be elevated, hypercapnia. And the third point you got to be clear when it comes to V/Q mismatch is this. Situations like right to left shunt, example pulmonary shunt, will have no improvement or very little improvement with 100% oxygenation. You see a question, the question says there is a compromised oxygen tension in the blood, the patient is supplemented with oxygen. In spite of oxygen therapy, there is not much rise in oxygen tension. Clearly, it's a case of right to left shunt, and for us, it is going to be pulmonary shunt, doctors. These are the points you got to be clear when it comes to the first topic, V by Q mismatch. Good. Moving on to the second condition. It's examples of low V by Q ratio. People, this is something I need you to be very clear about. The questions are not only going to limit with this word low V by Q ratio alone. These days the questions are coming up with a diagnosis, and you got to be very clear about the conditions which is going to manifest as a low V by Q ratio situations. Alright. Number one, it is going to be atelectasis. It's easy to recognize. Atelectasis is nothing but closure of airways. You can very easily understand why this is a condition of low V by Q ratio. Alright, number one. Number two, pneumonia, a word that has been so many times asked, and that takes so much of importance both in physio as well as in medicine. Pneumonia is a condition which is associated and which is going to be recognized as a low V by Q ratio condition. Why? Because of this inflammation, alveoli are going to be filled with pus and fluid. There is going to be no gas exchange, doctors, and still blood is going to go through the pulmonary capillaries. So just because there is going to be no gas exchange, there is no oxygen transferred to pulmonary capillaries, and hence we call this situation as a low V by Q ratio condition. Pulmonary edema, where the alveolar spaces are going to be filled with fluid. Acute respiratory distress syndrome, again there is going to be alveolar flooding and collapse. Pneumothorax as well as hemothorax, where the pleural space is going to be accumulated with lot of fluid, and that is going to squeeze the alveolar segments. Then pleural effusions, same way. Asthma, airway closure because of spasm as well as mucus. COPD exacerbation, again mucus hypersecretion and bronchospasm. Aspiration, foreign body obstruction, mechanical blockade of airways, and mucus plugging. Every one of these conditions will be connected with this ratio called low V by Q ratio, and V by Q ratio will be on an average of 0.5. Complete zero is going to be shunt. Infinity is going to be alveolar dead space, pulmonary thromboembolism. These are all situations where V by Q ratio is going to be decreased, doctors. Alright, just be clear in this one point. Waterfall effect. Waterfall effect is nothing but zone 2, doctor. Alright, waterfall effect is nothing but zone 2, and that will be studied in different lung zones, zone 1, zone 2, like this. So zone 2 is going to be considered as waterfall effect, and here the blood flow to alveoli will happen in phases. During RV systole, there will be good blood flow to alveoli. During RV diastole, there won't be any blood flow. Since the blood flow to lungs is intermittent, we call zone 2 as waterfall effect. That is all, doctor. Alright. So I hope you are clear with that zone 2. Fine. Moving on to the graph on V by Q ratio. Doctors, let me mark these picture with alphabet. So let me start with point A here. It's going to be point B. It's going to be point C, point D, as well as point E. Now here point A is going to be considered as pulmonary shunt. Point A will be considered as pulmonary shunt. Point B is going to be considered as a situation where there is going to be low V by Q ratio. Point C is going to be absolutely normal. Point D is considered as a region with high V by Q ratio, and point E is going to be considered as perfect alveolar dead space. It's going to be alveolar dead space, guys. So this is one set of questions you got to be clear with, and from the same picture we'll be having other set of questions as well, and that's going to be the alveolar gas tensions. If it is going to be normal V by Q ratio, we have partial pressure of oxygen at a value of somewhat about 104 millimeters of mercury. Partial pressure of carbon dioxide will be somewhat about 40 millimeters of mercury. If it is a pulmonary shunt, partial pressure of oxygen will be equal to venous blood, that's going to be only 40. Partial pressure of carbon dioxide will be 46 millimeters of mercury. If it is alveolar dead space, partial pressure of oxygen will be 149 millimeters of mercury. Partial pressure of carbon dioxide will be 0 millimeters of mercury. This resembles atmosphere. So in this graph, you have to be clear about two sets of questions. Number one, all these points. What is point A, B, C, D, and E? That's one set of question. And the other one is going to be gas tensions at different regions. What is the gas tension at point A, point C, as well as point E, doctor? So these two are the two sets of questions when it comes to V by Q ratio graph. And that takes us to the second topic. It is going to be oxygen hemoglobin dissociation curve. People, in RS, this is one of a very important topic, and it's pretty simple and plain as well, right shift as well as left shift. If it is a right shift of curve, point number 1, we will be seeing right shift where the P50 value, guys, could you able to answer the P50 value? P50 value will be, it's going to be more than 27 millimeters of mercury. That will be indicating right shift. Whereas if it is a left shift, the P50 value will be dropping less than 26 millimeters of mercury. That's first set of question you got to be remembering when it comes to oxygen hemoglobin dissociation curve, right? And the second set of questions, the conditions. If it is right shift, you can see increased temperature will be shifting the curve to the right. That will be seen associated with fever as well as exercise. Then acidosis, Bohr's effect will shift the curve to the right. Hypercapnia, too much of carbon dioxide. Increased to 2,3 bisphosphoglycerate seen in anemia, chronic hypoxia as well as high altitude. And finally HBS, sickle cell anemia, will be having the curve getting shifted to right, doctors. Moving on to left shift. Left shift is seen with conditions exactly opposite. Of course, you know this, right? Hypothermia, and this is going to be, it's reverse Bohr effect, guys. You cannot be calling this as Bohr's effect. So let me cut this point here. Alkalosis will shift the curve to the left. Then we have hypocapnia, decreased carbon dioxide, and there is also going to be presence of increased oxygen that shift the curve to the left. You know this condition. It's going to be called as Haldane's effect. This is going to be called as Haldane's effect, and obviously decreased to 2,3 bisphosphoglycerate will shift the curve to the left. And people, this is a point you got to be a bit clear about. See, when it comes to the left shift, you will be having questions related to blood transfusion. Blood transfusion will shift the curve to the left at only one point and one condition. It must be a very, very, very massive transfusion, and these much of blood products has to be transfused in a very short duration of time. And the RBC, packed RBC, should be a long stored blood, close to 38 days. It is that kind of blood that is going to be transfused in a huge quantity, and that is going to shift the curve to the left. Be clear. So you will not expect a left shift of curve with 1 or 2 bags of transfusion. It will be absolutely normal. So if you are looking at a left shift of curve with blood transfusion, it must be a massive transfusion within short duration of time. And then two other conditions, one is septic shock and the second one is going to be hypophosphatemia. These are other two conditions that will be shifting the curve to the left, doctors. Coming to hemoglobin, fetal hemoglobin HbF will be shifting the curve to the left. So that's going to be left shift, doctors, right? Okay, so I'll be moving the graph, doctor. Sorry for the bad template. Yeah, I think you can see the picture now. Yes, good. So these are the right shift as well as left shift of condition, doctors. And moving on to the third condition, obstructive as well as restrictive lung disease. Pretty simple, plain topic. You can able to pick up which is going to be the curve for obstructive lung disease as well as restrictive lung disease. Pretty plain and simple, doctors. So let me display the curve here for your reference. It's obvious if you happen to see this concavity at the expiratory part, clearly it's going to be an obstructive pattern. If the whole curve looks normal but only small in size, it's going to be considered as a restrictive pattern. Now every other condition associated with obstructive lung disease as well as restrictive lung disease, what happens to FEV1, what happens to FVC, what happens to ratio, this is again a point. I'm sure you will be aware of this. So anytime when the point is going less than 0.7, it's going to be considered as obstructive, and 0.8 or more than 0.8 is going to be considered as restrictive, doctors. It's pretty plain and simple. So let's not spend more time on this one graph here. Let's keep moving on, doctors. Now moving on to hypoxia, the penultimate topic in RS. Guys, you got to be familiar about certain conditions, in which conditions you'll be getting different kinds of hypoxias, right? So let me start with the first condition here. It's going to be high altitude, chronic obstructive pulmonary disease, pneumonia, pulmonary edema, asthma, pulmonary embolism, atelectasis, respiratory arrest, all these conditions, guys. You can clearly see one parameter which is going to be common for every condition in the first case. Here, there is going to be decreased transfer of oxygen from alveoli to pulmonary capillaries. If there is a compromised oxygen transfer from alveoli to pulmonary capillary, what are you going to name this one condition as? From alveoli to pulmonary capillary, this condition is going to be named as hypoxia. The another name for this condition is going to be called as hypoxemia. People, it's either hypoxia or hypoxemia, guys. So just be clear on that one part. So whatever the situation it is, if you happen to find this one point, there is a decreased oxygen transfer from alveoli into pulmonary capillary, the name is going to be hypoxia, plain and simple. Good. Then we move on to the next one condition. Here it is going to be iron deficiency anemia, megaloblastic anemia, hemorrhagic anemia, hemolytic anemia, bone marrow failure, whatever the problem here. If the problem is limited either to RBC or if the problem is limited to hemoglobin, this kind of condition is going to be called as anemic hypoxia. It's going to be the second pathophysiology, anemic hypoxia, guys. That's number 2. Good. And number 3. People, the third condition, if you watch close, it's going to be associated with cardiogenic shock, hypovolemic shock, Raynaud's phenomena, peripheral vascular disease, local ischemia, which means that tissue is not getting enough blood supply, right? The heart is neither pumping well or the blood vessels are not taking the blood to the tissues. Now, this is going to be stagnant hypoxia, guys. The third pathophysiology, it's going to be stagnant hypoxia. And the fourth pathophysiology is this. It's going to be cyanide poisoning, carbon monoxide poisoning. Clearly, there is going to be a problem with the mitochondria. Mitochondria are unable to utilize the oxygen well, and this is going to be histotoxic or cytotoxic hypoxia. Histotoxic or cytotoxic hypoxia. These are different types of hypoxia, and each and every condition associated with this one, type of hypoxia, doctors. And that completes hypoxia. And we are moving on to the last topic in RS. It's going to be control of ventilation. People, pretty plain and simple. The first condition is the central chemoreceptors. What are all the triggers for central chemoreceptors? Central chemoreceptors respond primarily to change in hydrogen levels in cerebrospinal fluid, number 1, as well as in brain's interstitial fluid. Doctors. So point number 1, central chemoreceptors are going to be activated by, it's going to be hydrogen in cerebrospinal fluid, number 2, brain's interstitial fluid. And peripheral chemoreceptors respond to decrease in oxygen provided the oxygen tension goes less than 60 millimeters of mercury. Good. And increase in carbon dioxide, even a slightest increase in carbon dioxide will be triggering peripheral chemoreceptors. And acidosis, even a slightest fall in pH is going to trigger peripheral chemoreceptors, doctors. And when it comes to acute response, and another important point, if it is going to be an acute response, doctors, for these kinds of acute responses, carotid bodies are going to be even more sensitive rather than aortic arch or central chemoreceptor. So if it is an acute hypoxic response, it is going to be primarily carried out by carotid bodies. Good. And third one, hypoxia depresses central respiratory centers, but please be clear, it is going to stimulate peripheral chemoreceptors. While hypoxia do have a dual action, hypoxia depresses central respiratory centers, but just because it could able to stimulate the peripheral chemoreceptors, the net effect of hypoxemia or hypoxia is going to be excitation. So the net effect is going to be increased ventilation. Just be clear, hypoxia will be actually decreasing central respiratory centers, doctors. And finally, Herring-Brewer reflex. Herring-Brewer reflex limits excessive lung inflation. It limits the excessive lung inflation, and the stretch receptors are going to be innervated by vagus nerve. The stretch receptors are going to be innervated by vagus nerve, doctors, and they will be making sure the inspiration doesn't happen beyond a point. So Herring-Brewer reflex, the afferent is transmitted by vagus nerve, the receptors are going to be stretch receptors, and the efferent is going to be inhibition of inspiration. The efferent is going to be inhibition of inspiration, guys. That's going to be Herring-Brewer reflex. And finally, central chemoreceptor sensitivity. Just be clear, if a patient is suffering from chronic hypercapnia for any reason, if there is going to be carbon dioxide accumulation, and the best case study is going to be severe chronic obstructive pulmonary disease. If a subject experiences chronic hypercapnia, in this subject there is going to be a significant alteration in the respiratory sensitivity for carbon dioxide. So what happens, the drive and the sensitivity for carbon dioxide is practically lost. Just because the sensitivity of carbon dioxide is lost, a patient who remains in a chronic hypercapnic state, they will have the primary respiratory stimulus transferred from carbon dioxide to oxygen. In these patients, the primary respiratory stimulus is going to be just oxygen, doctors. Please remember. So these patients will be, sensitive only for oxygen, right? It is going to be pakka hypoxic drive alone. That is exactly the reason. If a patient is having long-standing COPD, and if you hyperventilate the patient with too much of oxygen, that itself will decrease the ventilatory drive, and the patient will go for hyperventilation. So patients who are experiencing long-standing hypercapnia will show paradoxical hyperventilation with oxygen therapy, because the trigger itself is going to be hypoxia, doctors. So the questions are, hypoxia decreases central. Neurons are very sensitive to hypoxia, doctors, whatever the neuron it is, be it a frontal neuron or a parietal neuron or respiratory center neuron, whatever neuron it is. If there is a drop in oxygen tension, neuronal activity goes down. That is the reason why hypoxia decreases neuronal activity. It is not due to J receptors. Low tidal volume 6 ml. Yeah, fine guys. So that's going to be the questions and points you got to be clear with RS. Then moving on to endocrine doctors. We have just two most important conditions to be clear when it comes to endocrine. The one is thyroid and the second one is adrenal. Let's start with thyroid first. Let's just cover up the primary points around doctors. When it comes to thyroid gland, the most produced hormone is going to be T4. T4 is the most produced hormone, but the most acting hormone is going to be T3, because the T3 gets converted to, the T3 gets converted from T4. This is done by an enzyme called 5'-deiodinase, and the prime site of conversion is going to be liver as well as kidney. So T3 is the secretory product, T4 is the secretory product, whereas T3 is the active form, doctors. Number one. Number two, Wolff-Chaikoff effect. You know this. There is going to be inhibition of thyroid hormone synthesis. There is an inhibition of thyroid hormone synthesis if we inject too much of iodine load. Exactly opposite is going to be Jod-Basedow phenomena, but Jod-Basedow phenomena is not seen in every thyroid gland. It is seen only in autonomously functioning nodules. Only in autonomously functioning nodules, injection of too much of iodine is going to trigger thyroid production. That's going to be called a Jod-Basedow phenomena, doctors. And actions of T3 and T4. T3 and T4 increases the activity of sodium potassium ATPase. They develop more heat. They increases basal metabolic rate. Not only that, they increases the expression of beta adrenergic receptor. Thereby, the sympathomimetic actions are going to be manifested even if there is a hyperthyroid patients. And finally, thyroid binding globulin. TBG is going to be increased in pregnancy. The levels of thyroid binding globulin is going to be increased in pregnancy as well as in OCP use guys. So this is going to be increasing total T4, but the levels of free T4 is going to be normal. Patient will be clinically absolutely euthyroid. So we cannot able to use total T4, total T3 as a marker of hyperthyroidism. It is going to be free T3 and free T4, because even if there is an excessive thyroid binding globulin, the levels of total T3, T4 is going to be elevated, doctors, right? Good. And the same points, doctors. Conditions that elevates thyroid binding globulin. One is pregnancy. Number two, estrogen rich oral contraceptive pills, and number four, hepatitis. Inflammatory conditions of liver is going to elevate the thyroid binding globulin level. So there will be, yes, increased total T3 T4, but free T4 will be normal. Patient will be clinically euthyroid. Situations where the thyroid binding globulin is going to be very low, decreased T4 T3 total, but free T4 will be normal. The conditions are going to be presence of androgens, nephrotic syndrome as well as severe illness, doctors. And of course, we just understood that giving iodine is going to manifest two types of effects. One, it is going to be Wolff-Chaikoff, seen with the administration of imidazole, contrast dye as well as Lugol solution. And the second condition is going to be Jod-Basedow phenomena, seen in autonomous nodules where there is going to be hyperthyroidism. It is Jod-Basedow phenomena, same condition once again, doctors. Then moving on to insulin and glucose. Typical. The trigger for insulin release is going to be increased ATP for ADP ratio. If inside the beta cells of pancreas there is going to be more adenosine triphosphate than adenosine diphosphate, that is going to be considered as the trigger, and that closes potassium channels, and that leads to depolarization, calcium entry, leading to release of insulin. People, there is one question you got to be very, very sharp and sure about. It's going to be, release of insulin with oral sugars. So if the question goes like this, there is going to be, oral sugars are going to produce more insulin rather than IV, intravenous, glucose. This is pakka incretin effect, because there is going to be two types of cells in duodenum and ileum. One is K cells and the other one is L cells. They produce incretins, glucagon like peptide 1, glucose dependent insulinotropic polypeptide. They trigger beta cells of pancreas to release more insulin, doctors. Good. And moving on to counter-regulatory hormones, glucagon is going to be the primary counter-regulatory hormone, followed by cortisol and growth hormone, 3 Gs. Glucagon, 3 Gs guys, glucagon, growth hormone as well as glucocorticoid, that is cortisol. And of course, insulin dependent glucose transport is going to be GLUT4, that will be present inside the vesicle. In the presence of insulin, they will be taken to the cell membrane. And finally, hypothalamus pituitary axis. People, every hormone in anterior pituitary will be triggered by hypothalamus. The one hormone which is getting significantly suppressed is going to be prolactin. Alright, prolactin is going to be only anterior pituitary hormone which has got a predominant inhibitory control, and that is coming from dopamine, guys. When it comes to growth hormone is pulsatile in release, and the highest secretion is seen in slow wave sleep, especially during NREM stage 3. right? Growth hormone, releasing hormone stimulates growth hormone production, somatostatin inhibits it, and the effect of growth hormone is mediated by insulin-like growth factor type 1, and that's going to be mediating all the growth effects, guys. Coming to vasopressin, coming from posterior pituitary, the primary stimulus for vasopressin is going to be increased plasma osmolality, acts via V2 receptor, and increasing aquaporin 2 levels, increasing water reabsorption. People, this is very important. Pulsatile gonadotrophin releasing hormone. If gonadotrophin releasing hormones are released in a pulsatile manner, it will be increasing. So pulsatile release of GnRH will be increasing production of FSH as well as LH. Increases FSH as well as increases LH. If it is a steady state release, if it is a continuous increase, if the increase is not steady state, if it is a pulsatile release, it's going to be increasing FSH and LH. If it is a continuous increase, it is going to be down regulate the receptors. As a consequence, there is going to be drop in FSH as well as drop in LH, guys. Just be clear in this one point. There is a drop in FSH as well as a drop in LH, guys. And coming to adrenal cortex, so we have zona glomerulosa that will be producing aldosterone mineralocorticoid, fasciculata glucocorticoid, and the reticularis will be producing adrenal androgen. Aldosterone is going to be regulated by angiotensin 2 and hyperkalemia. Please be clear. The release of aldosterone. Very good, doctors. Very good. Leuprolide is a very important drug, GnRH agonist in treating testicular cancers as well as endometriosis. Good. Very good. So aldosterone is going to be released by angiotensin 2 and potassium. And finally, coming to cortisol, it is anti-insulin, anti-inflammatory effect. So increases blood glucose level, guys. And moving on to GAT. So just two conditions, doctors. One, it is going to be hormones, and second one is going to be GI secretions. First one is GI hormone, second one is GI secretions. Every single hormone is listed here, and the point is more important when it comes to secretin and cholecystokinin. Secretin is going to be increasing bicarbonate secretion, whereas cholecystokinin is going to be involved in increasing pancreatic enzymes, guys. Motilin is the hormone associated with migratory motor complex, and GIP is going to be incretins. GIP is going to be the incretin, doctors. That's few points you got to be very clear when it comes to GI hormones. And coming to GI secretions, we have parietal cells that secretes hydrochloric acid, and this is going to be primary active transport. H plus K plus ATPs belong to primary active transport, and destruction of parietal cells leads to A-chlorhydria as well as B12 deficiency. Chief cells are the one that produces pepsinogen. It is a zymogen. It gets produced in inactive form that gets activated to form pepsin, doctors. And we have three phases of acid production: cephalic, gastric, as well as intestinal phase of acid production, and that's going to be gastric secretion, doctors. And that's going to leave us to last three topics. One is menstrual cycle, male reproductive physiology, and pregnancy and lactation, doctors. Of course, it's been covered well in advance, so let's have a quick look the essential points alone. Coming to follicular phase, FH is going to be the primary hormone dominant in the follicular phase, and that leads to increased production of estradiol as well. LH surge, it's going to be positive feedback. Please remember, when it comes to LH surge, it's mediated by estrogen. It has got a positive feedback effect on GnRH as well as LH. It's going to be positive feedback. That's the reason behind LH surge, doctors. Coming to luteal phase, the dominant hormone is going to be progesterone, and to very little extent there is also going to be estrogen. There is a rise in basal body temperature to 0.5 degrees Celsius post ovulation. Progesterone is a thermogenic hormone. If no fertilization takes place, corpus luteum gets disintegrated and there is a drop in progesterone, and that leads to menstruation. If fertilization takes place, human chorionic gonadotrophin is going to maintain corpus luteum till 10 weeks. When it comes to negative feedback, every single hormone that involves a negative feedback on FSH is going to be pakka inhibin B. FSH is not inhibited by estrogen or anything. It is going to be purely inhibin B, doctors. Right? Good. And in follicular phase, it is going to be inhibin B, and in luteal phase, it is going to be inhibin A, doctors. That's going to be the hormone that will be inhibiting FSH levels. Coming to male reproductive physiology, number one, blood testis barrier is maintained by Sertoli cells. In males, it is the Sertoli cells that produce inhibin B, which is going to be inhibiting follicular cell stimulating hormone. The first hormone coming out of Sertoli cells is inhibin B, and the second one, androgen binding protein. Third one, Mullerian inhibitory factor. Leydig cells releases testosterone, and Leydig cells have got receptors for luteinizing hormone, and Leydig cells are under the command of LH to release testosterone that gets converted to dihydrotestosterone by the enzyme 5-alpha reductase. The function of dihydrotestosterones are development of external genitalia, prostate, and male pattern baldness. whereas testosterone as such will be involving in promoting muscle growth, spermatogenesis, libido, as well as voice deepening. The enzyme that converts testosterone to dihydrotestosterone is going to be 5-alpha reductase. In the deficiency of 5-alpha reductase, the consequence is going to be female external genitalia at birth. There is going to be virilization at puberty, and even though testis is present, testosterone is going to be normal. But there is a significant decrease or absent dihydrotestosterone. That's the characteristic finding in 5-alpha reductase deficiency, guys. It takes 74 days for spermatogenesis to take place. It takes a lesser temperature than core body temperature, 2 to 3 degrees Celsius less. Cryptorchidism leads to infertility, and even though testosterone is necessary for spermatogenesis, FSH initiates spermatogenesis, whereas testosterone continues and promotes sustained spermatogenesis, doctors. Before I move on, let me just finish this one out. Inhibin A and B role. Simple, doctor. Inhibin A will be causing negative feedback effect over gonadotrophins, decreases FSH release. And this happens during luteal phase. Whereas inhibin B, the same job, inhibits FSH release, but this happens during follicular phase coming from granulosa cell. So from the follicular cell, we get inhibin B. From the luteal cell, we get inhibin A, but they have same action. They try to inhibit follicular cell stimulating hormone. That is all. Right, doctor? Good. And finally, pregnancy and lactation. People, human chorionic gonadotrophin level peaks at 10 weeks and then falls. So till 10 weeks, there is going to be a rise in HCG levels. It will be detected in urine from 8 to 10 days post fertilization. Their prime job is to maintain corpus luteum. The levels will be increased in trophoblastic diseases, used in Down syndrome screening as well. Human placental lactogen, it's an insulin antagonist, HPL. Human placental lactogen is going to be an insulin antagonist, and that's why there is going to be increased blood sugar level in pregnancy. It promotes lipolysis. It makes sure fats are getting broken down so that glucoses are preserved and transferred to the fetus for fetal utilization. So HPL ensures mother breaks her lipids so that her metabolism is taken care of by lipid breakdown and the glucose is taken to the fetus. The clotting factors increased and decreased in pregnancy, right? Clotting factor levels of 2, 7, 8, 10 and 12 are increased during pregnancy, and the clotting factors that gets decreased in pregnancy is this. There will be a drop. There will be a drop in clotting factor levels of 11 as well as 13. The factor 11 as well as factor 13 is going to get decreased. Other factors are showing rise, doctors. And coming to lactation. Prolactin drives milk synthesis and oxytocin drives milk ejection. Two hormones, one promotes milk production, one releases milk, guys. Finally, lactational amenorrhea, it happens till 6 months. So increase to prolactin. Prolactin is going to suppress gonadotrophin releasing hormone, and that leads to suppression of ovulation. It may happen for 6 months, but after 6 months, the effect of lactational amenorrhea on contraception is going to be undeniable, and that completes the discussion, doctors. Fine, good. People, if there are any doubts, please do text me personally. I'll clarify your doubts. If not, I'll finish the session. Doctors, heartiest wishes. May God bless you all with clarity, calmness, and sharp mind. You make sure that your preparation goes well, and my heartiest wishes and greetings for your examination, doctors. God bless you all. Thank you very much, ma'am.
Hi guys, good evening all of you. Welcome to this INICET marathon. I hope you guys are enjoying the session for today. So I could see that we were actually having a cute session with physiology till now, and now I would like to take ahead where P for physiology ends with P for PSM. Okay, so let us now look into the discussion of PSM. So I would be taking 50% of your discussion for PSM, yes, and then we would be looking into the other 50% with Kashish sir, yes. Now, so highs and hellos in the group, done, shuru ho jaye, theek hai? Okay. So INICET Marathon May 2026, let us look into the health system, okay. Now, when you talk about the health system, you would see that basically, yes, I hope you can hear me. Yes, guys, I hope you can hear me. Is the audio there? Yes. Is the audio there? Audio is great. No problem. Yes, the volume is full, guys. The volume is full from my end. Yes, the volume is full. Okay, great. Yes, so let us have a quick look into this. Okay, chalo. Sabse pehla, you need to understand few things that now we are having the Health and Wellness Center, which is a upgraded sub-center. So a sub-center has become a Health and Wellness Center whose current name is Ayushman Arogya Mandir. So you guys very well know that now India is branding everything as Ayushman Bharat. So one of the 4 components is basically the Health and Wellness Center. So if you understand, when I talk about Ayushman Bharat, the Ayushman Bharat has 4 components. The first component is the Ayushman Arogya Mandir, that is AAM. Yes. Second is my PMJ, Pradhan Mantri Jan Arogya Yojana, under which we are providing health insurance. Next we have PM Abhim. So in this, we are improving the health infrastructure of our country. And that is the reason that district hospitals are being upgraded into medical colleges. Okay? And the last, if you see, is basically the Ayushman Bharat Digital Health Mission. So 4 components. Now, in the Ayushman Bharat Digital Health Mission, basically what we are trying to do is, we are trying to create Aadhaar cards. So AAM is one of the components of Ayushman Bharat. INICET important question. At this AAM center, we have a CHO, a community health officer. Rest, you know this particular table, the health system, where we start from a village, next we have a sub-center, next we have a PHC, next we have a CHC. After a CHC, we have a sub-district hospital, then a district hospital, then a medical college. You know, village is no level of health system. Your PHC and sub-center are primary levels of health system, whereas CHC is a secondary level of health system. At a village, we have an ASHA. She is just a bridge, and ASHA does not do any active form of intervention. At a sub-center, we have a health worker female, also called as a multi-purpose worker female, also called as ANM, auxiliary nurse, midwife. Now, this sub-center have been upgraded into a Ayushman Arogya Mandir, AAM. At AAM, you have an additional person called as CHO, Community Health Officer. Now, what is the main function of this CHO? The main function of this CHO is non-communicable disease and also doing your Sanjeevni, the teleconsultation platform. Yes, I hope everyone knows the health system. Generally, INICET loves to put up a question from this particular topic. Second topic, hospital waste management. Let me make you a very simple rule. All empty infectious plastic is in red. Please remember, no plastic can be burnt. So imagine this is a vacuum container. Now this has got blood. I have to empty this blood. Yes, and then this empty plastic would be thrown into red. So no plastic can be burned, even if there is a gloves, yes, which is totally stained with blood. We do not burn it. Okay? The only plastic which can be burnt is a blood bag, which is thrown in yellow. Full stop. All glassware in blue. Full stop. Exception, cytotoxic, expired or discarded medicine, culture plates, live attenuated vaccine. This is put up in yellow because we cannot take a chance with this to put it in blue because there can be a contamination. Baat khata. So general rule, general waste, black. RE for recycle, RE for red. If you want to burn, yellow. If it is a sharp, it is white box. If it is a glassware or metal, it is a blue bag. I hope I'm clear with it. No doubt, guys. Hospital waste management, again one question in the INICET exam. Triaging. Generally, INICET loves to put up a question over here. Red color is highest treatment in 4 hours. Yellow is treatment in 24 hours. Green is an ambulatory patient. Black is lowest, that is dead. Just a small clarification over here. The guideline which we teach you in community medicine and the guideline which is taught in surgery are slightly different because community medicine is in the community, whereas the surgery one is in an emergency room. If nothing is given, please answer as per community medicine. I hope I am clear with it. Done. Over. Sir, in some question, answer is doctor for health. No. प्लास्टिक सिर्फ और सिर्फ रेड में, बात खत्म. Most common vaccine given post disaster to victims is measles plus vitamin A. That's all. Yes, guys? Now, measure of central tendency. 3 measures: mean, median, mode. Please remember, this itself is a question that what are the measures of central tendency? It is mean, median, and mode. How do you calculate the mean? Add all, divide by sample size. How do you calculate the median? Arrange in ascending or descending order, and mid value is the median. How do you calculate the mode? The most frequently occurring is the mode. Preferred measure of central tendency. If it's a normal distribution, what is a normal distribution? When mean, median, and mode, all 3 are same. That is what is a normal distribution. In a normal distribution, the preferred measure is a mean. Non-normal distribution, mean not equal to median, not equal to mode, we prefer a median. Now, general question students ask, so kaise pata kare whether it is normal or non-normal? Very simple, calculate the mean, median, mode, that's all. Outlier, any extreme value. The most affected in this case is a mean, least affected is a mode, most preferred is a median. Please remember guys, at the end of the day, outlier is a type of a non-normal distribution. Bimodal, there are 2 modes, and if it's a uniform bimodal, it typically looks like a bathtub because both the peaks are of same height. Non-uniform, they are not of the same height. Arithmetic mean, you add all, divide by the sample size. Geometric mean, the way bacilli multiply. Harmonic mean is 1 upon arithmetic mean. Weighted mean, when each component is given a different weightage. The best example to this is MDPI, where all the 3 components are given different weightage or importance. Next, measure of dispersion or deviation of data. The most important is standard deviation, root mean square deviation. Twice in INICET 2022-2023, they have asked standard deviation ka formula x minus x bar whole square divided by n. If the sample size is less than 30, it is n minus 1. Sabko pata hai. Range minimum to maximum value. Z score, bone mineral densities, and the growth charts we use a Z score. So it is x minus x bar by standard deviation. Yes, COV. It is a unitary measure to compare 2 dissimilar variables. So it is SD by mean into 100. Standard error of proportion for quali, it is root over PQ by N, where P over here is prevalence. What is Q? It is 1 minus P or 100 minus P. Yes, guys? Now, standard error of mean is SD by root over N. Now, when we talk about distribution of data, we have a standard normal curve, a bell-shaped curve, which is bilaterally symmetrical. Area under the curve is 1 or 100%. The tails touch the baseline from minus infinity to plus infinity. The mean is equals to median equal to mode equal to 0. The standard deviation is 1. Variance is whole square of SD, so it is 1 square is 1. We know the theorems: mean is equal to median equal to mode, plus minus 1 standard deviation, 2 standard deviation, 3 standard deviation. 1 standard deviation 68, 2 standard deviation 95, 3 standard deviation 99. When we talk about the non-normal distribution of data, this is a normal distribution where all 3 are same. You can see there is a tail over here. So this is a right skewed. We have a tail on the left side. So this is a left skewed. Very simple. Jidhar ka skewness. If it is right skewed, mean will be maximum. If it is left skewed, mean will be minimum. For a uniform bimodal, the mean is equal to median, not equal to mode. Going ahead. Variable, the most important classification, quali versus quanti. If I say hypertension, yes or no, quali. If I say blood pressure is 146 mm of mercury, quanti. If I say hemoglobin is 20, 15, 10 grams per deciliter, quanti. If I say polycythemic, normochromic, anemic, then it is quali. So beta, ratta nahi hai. You have to see how they have asked the question and accordingly you make the answer. Binary or dichotomous, only 2 answer, girl or boy. Polytomous, more than 2 answer, tall, intermediate, short. Continuous and discrete, continuous which can take decimals, like my temperature 37.6. Discrete cannot take decimals, like number of girlfriends and boyfriends someone has, it is 1 or 2. You cannot have a half girlfriend, which is a Bollywood movie. Scales of measurement, we measure the quantitative scale on a metric or dimensional scale. The qualitative data is measured on a nominal and ordinal. Ordinal, there is a order. Yes, so basically in this we can see a TNM staging. Nominal, we can see only names, the race, religion and gender. Likert scale, all of you know, we see such kinds of smileys and emojis. It is a type of ordinal scale. The median and mode can be calculated. It summarizes the human behavior. Pain scale or the visual analog scale is a very good example of Likert scale. Now, when you look into graphical representation of data, quali, there are only two diagrams, bar and pi. Quanti, it can be a histogram, a frequency polygon, a frequency curve, a line diagram, a cumulative frequency polygon, and a scatter diagram. So a bar diagram is basically showing quali data which is discrete, and that's the reason, guys, if you typically see a bar, it is something like this. There is a gap in the middle because the type of data is discrete. Histogram, it is quantitative data which is continuous, and that's the reason if I have to depict a histogram, my histogram typically looks like this, where there is no gap in between. Yes, GCS scoring is ordinal, exactly right. Line diagrams is talking about trends. Now, spot map, geographical distribution of data. If I want to show the distribution of diabetes in a city, Venn diagram talks about overlap, tree diagram talks about spread of disease, scatter diagram talks about relationship, keyword. So the concept of regression and correlation is very simple. It is nothing more than the equation of straight line. This is y, this is x, this is m the slope, this is c the constant. The r ranges from -1 to +1. Minus means inverse relationship, plus means direct or forward relationship. Please remember, r gives you only relationship. It does not talk about association, causation or absolute magnitude of variable. Now, if you look over here, we have dots going up in both the cases. But in the first, the scattering is less, and that's the reason it is strong. Here, scattering is more. That's the reason it is moderate. Okay. Someone is writing that GCS is ordinal. हाँ सही है. I thought someone wrote and then deleted. Please understand, guys, a score which is calculated, whether it be on GCS, APGAR, it is not quantitative variable. To make a quantitative variable, you need two things, a number and a metric scale. हम बोलते हैं ना 72 per minute heart rate. 72 is the number, per minute is the scale. Without that, you cannot say it to be a quantitative variable. So any score, it gives you a number, then we classify it as a quality. So whether it be your GCS, TNM, कुपुस्वामी स्केल, APGAR, EDSS scale for depression, सब कुछ आपका ordinal में आ जाएगा. ठीक है? Done? Now, this is no relationship because you can see that over here at the end of the day, we are not seeing any pattern. Over here, there is no relationship because there is no pattern. But here, we do have a pattern. Here, we do have a pattern. Yes, guys? Done? Now, someone was asking me about box and whisker. Now, please see, this is a normal box and whisker where 1, 2, 3, 4. We have 4 parts. Q2 over here, this is also called as median. The Q1 to Q3 is an interquartile range. Now this is normal, so 4 parts are equal. Now someone was asking skewed box whisker. Now look over here, the tail is elongated on the right side. Here also the tail is elongated on the right side. Similarly here, tail elongated on the left side. Here, tail is elongated on the left side. I hope I'm clear with it. Now probability, if it is dependent, this is also called as mutually exclusive. In such a case, we add it here. So PA plus PB is that. Independent is multiply, that is PA into PB into PC. Now, sample size, how do we calculate? Z square PQ by D square is the sample size formula. The most common one which we will use is 4 PQ by D square. Quantitative data, same. It will be 4 SD square by D square. Yes, guys? Done. Over. In some questions, vertical, then we rotate clockwise. Yes. Now see beta, over here, imagine my box whisker is given something like this. Okay? So the top end, please remember, you need to rotate the top end. Now when you rotate the top end 90 degree clockwise. Yes. Now I do not know how your screen orientation looks. Basically, you have to turn it to the right side. Okay, so this image will become exactly like this. So you can see basically it becomes a right skewed. Okay, so turning of quartiles is done in this way. Okay, done over. Yes, CBT वाला क्वेश्चन वीडियो देखो तभी समझेगा. ठीक है, तभी समझेगा. ठीक है सर, जो बॉक्स विस्कर को 4 पार्ट में डिवाइड किया, इंडिविजुअल बॉक्स को क्या बोलते हैं? नहीं, इंडिविजुअल बॉक्स नहीं बेटा. प्लीज अंडरस्टैंड, व्हेन यू लुक इनटू this Q1, Q2, Q3, this mathematically is called as a intercept. This is the technical word, intercept. Okay. Now, sampling convenient as per my choice. Simple random is a lottery method. Quota meaningful non-random, whereas stratified is meaningful random. Please remember one thing very clearly, guys. The only difference between a quota and stratified is how you select. One is non-random, one is random. Now, what do I mean by meaningful? Suppose I am looking into prevalence of anemia. Boys and girls, meaningful hai. But imagine I say those who are wearing t-shirt versus those who are wearing formal shirt. That is non-meaningful. Similarly, severity of disease, mild, moderate, severe, meaningful hai. Cluster is non-meaningful but random. So if I take those who are wearing in a class A and class B, that will be a cluster because that is a non-meaningful division. Systematic is orderly. Multi-stage or multi-phase is more than 2 stages. Please remember, convenient and simple are 1-stage sampling. The rest all are 2-stage of sampling. Now, very common query I get, sir, where to use standard deviation and standard error? Please remember this golden word. Wherever the word confidence or population, we calculate standard error. How do we calculate standard error? SD by root over n and root over PQ by n. We have already seen this formula and we use this theorem. Mean is equals to median equal to mode plus minus 1, 2, 3. Standard error is 68, 95, 99. Now let us look into this interpretation. 3 rules. Rule A, if the CI touches null value. Now what is null value in PSM? 1. So when odds ratio and relative risk is 1, it is null value. So if the CI touches null value, this is insignificant. The rest all are significant. So first rule, if the CI touches null value, it is statistically insignificant. What is the null value? RR or OR equal to 1. Second, this is my point estimate. So more the distance of point estimate from null value, more is the significance. So the dot jitna dur hoga, utna zyada significance. Rule C, CI is inversely proportional to sample size. Now, if you look into BNE, the point estimate is same, but he has smaller CI. And that's the reason, if you look into this image and I talk about significance, E is most significant, followed by B, followed by A, followed by C. D though is insignificant. Now, CI is inversely proportional to sample size. Chota CI, more is the sample size. So N max will be A. Now there are many students who make this basic mistake. They will forget that these 3 rules A, B and C, they have to be applied in a sequence. And ultimately whoever is the winner in C will be considered to be best. Students क्या करते हैं? They will directly use this rule. जिसका N maximum वो significant. So they will mark in this question A as most significant. This is a very big mistake which a student can do. So just be careful not to make this basic mistake. Statistical tests. We have 2 types of statistical tests. One is a parametric, one is a non-parametric. They are just names, but you should be knowing it. Yes. So at the end of the day, a parametric test is basically one where the sample size is more than 30. A non-parametric is one where the sample size is less than 30. Okay. So please remember, for your level, chi-square and Fisher-Exact are the 2 non-parametric tests which you know. Chi-square, Fisher-Exact. 99% times the answer is chi-square. When do we do a Fisher-Exact? When in the 2x2 table, any value is less than 5, we will do a Fisher-Exact. Okay? So If the sample size is more than 30 with a normal distribution of data, quantitative output, we calculate or we compare the mean. We generally have the t-test and the ANOVA. If it is less than 30 with a non-normal distribution of data with a quali output and we compare the median and proportion, then my answer is a chi-square. Please understand, guys, there are 100 people. Anemic, you give IFA before, after. Paired data. Paired data. Yes. Yes, any box with less than 5 is Fisher. Less than 5 is Fisher. Okay. Now, this is one table which you have to mug up. INICET loves to ask this miscellaneous one. The Q-test, Pierce, Grubb, Shavant is outlier. Internal consistency is seen by Cronbach alpha. Kappa is used to see agreement. Bland Altman is used to compare a gold standard with a new test. Cox proportional hazard risk function is basically survival curve. Z-test is the universal test. You can use it everywhere. Kolmogorov-Smirnov test is basically the test of normality. If you want to see whether the data is normal or not, we basically draw this, yes, or the Shapiro-Wilk and the Anderson-Darling QQ plots. These are all tests which tells you about normality of a data. Now, hypothesis testing, you know what is a null hypothesis when drug 1 is equal to drug 2. What is alternative hypothesis? Drug 1 not equal to drug 2, and suppose drug 2 is better. What is cell number 1? In both, drug 1 is equal to drug 2. This is called as confidence. What is cell number 4? In both, drug 1 not equal to drug 2. This is called as power, because I have the power to claim that someone is better than the other. What is cell number 2? The error. In reality, the two drugs are not same. You made a mistake and you proved both are same. The cell number 3, in reality, both are same. You made a mistake and you proved both are not same. Guys, by this time I expect you know how to read this table, because if you do not, a question AIMS mein khatam ho jayega on spot. Okay. Now, type 1 error is also called as alpha, also called as p-value, also called as false positive. Okay. Now, alpha is 1 laddu, p-value is 1 laddu, false positive is 1 laddu. They are all called as type 1. Beta is also called as type 2, or also called as false negative. Now, this question, how do we practically use it? So, you have to read the question carefully. In reality, null is true. In RCT, HA is true. So, if I draw this 2 by 2 table, H0, HA, H0, HA. So, in reality, my null is true. In RCT, HA is true. This will be a type 1 error or alpha. This, my dear students, is all about the discussion of stats. Boss, please remember, you're surely going to get at least around 6 questions from stats and EP together. Because if you look into the trend of questions, if you see 2, 3, 4, 5 papers, 34 questions have come from EP and stats. Yes, 24 plus 10 from vaccine and health programs. That means majority chunk comes from these 4. ठीक है, जिसमें stats and EP are the game changer. These are generally factuals, and that is where you should be careful with it. I hope all of you are following the updated quizzes. Today only on my YouTube channel, I have dropped a very good question of INICET where I have drawn a standard normal curve and all the possible questions with it. Okay? This was just a mental break. Yes, let us look over here now. Surveillance. What is passive surveillance? Basically, patient visits the hospital. Minimum resources are needed. Majority of health programs run a passive surveillance. Active surveillance, the health worker visits the home of the people. Maximum resources, most accurate. This is mainly done in case of your TB, polio, and leprosy. Sentinel surveillance, this varies from disease to disease, which is used to find missing cases and the total disease burden. This is mainly done in HIV. Inventory, again important. What is inventory? Making a list. Mummy bhi banati hai. 5 kg atta is needed, 2 liters oil is needed, 1 kg sugar is needed. Ye sara is making a list. One way of making a list is VED, vital, essential, desirable. In this VED, the most important is the V, that is the vital one. So in VED, for me, most important will be V. Whereas other is ABC, where I talk about money. Again, A is most important because what is category A? 10% drugs cost 70% of money. What is B? 20% of drugs cost 20% of money. What is C? 70% of drugs cost 10% money. So basically, if you see, it is A, it is B, it is C. So मेरे लिए most important will be the category A, because 10% of drugs is costing 70% of money, which is a very, very important one. So basically it is like a dry fruit from the home. Itna sa dry fruit, but itna costly. Next, the reorder factor. The government of India sets that the reorder factor for all the emergency medicine list is 2 per month. Matlab, if you are ordering 1000 paracetamol, so into 2, if it comes once a month, the answer will be 2000. If it is coming once in 3 months, the answer will be 6000. If it comes once in 1 year, then it will be 24,000 tablet. ठीक है? SDR formula पता है, less than 15 plus more than 65 by 15 by 65. Just remember एक चीज, in India ये 65 नहीं है, in India this is 60. ठीक है? So INICET people love to make these small questions. Delphi's method, experts are there, all the AIMS HODs, medicine ka, of PGI, of JIPMA, NIMATs, they are independent, they are geographically dispersed, and they are brought to a consensus, same views. A question had come on ICER, incremental cost effectiveness ratio. This is basically calculated in a cost effective analysis, and my prediction, if you see, probably ICER will be asked in slight detail this time in the exam. So basically you should know ICER is nothing more than the cost of whatever new thing you have done divided by cost of the standard thing divided by the effectiveness of the new thing minus the effectiveness of the standard thing. So that is what you can get a question on. Plus, please remember, a lower ICER means a higher cost effectiveness. You can get this image. Now, if you look into this, this is 4 quadrants. Kya 4 quadrant hai? In this quadrant, cost is more, effectiveness is more. In this quadrant, cost is less, effectiveness is more. So you can see this is probably the best one, क्योंकि कम पैसा में ज्यादा फायदा, तो इसमें तो कोई डाउट नहीं है. यहाँ पे कॉस्ट भी मोर है, effectiveness is कम है. This is the most pathetic one. This cost is also less, effectiveness is also less. So we always try to rotate my line in this manner. Why? Because you can see I am going towards the best case scenario, which is this. Okay, that is the reason we do this. So ICER, incremental cost effectiveness ratio. So नाम से ही पता चल रहा है. What is the additional cost you pay to get a better effectiveness? ठीक है? This is all probably from my side. Still, if you guys have any doubt in PSM, please do not hesitate to reach out to me. Yes, I hope all of you are also part of the Telegram channel. So feel free to drop a message. Golden rule of INICET, you need to be aggressive. More than 195 questions is what you have to attempt in the exam. Otherwise, exam शुरू होने के पहले ही खत्म हो जाता है. So do not do this mistake. Please understand that at the end of the day, keep a calm head. You know, anxiety will be there. Your heartbeat will be racing. But the more calmer you are, the better result you have. And trust me, if I could crack INICET, being a fresher with a rank of 204 AIMS May 2012, anyone who is hearing this can definitely crack. Okay? So all the best, guys. Love you all. And I will always pray for the success and affection of all of you. Chalo, bye bye. See you. Love you all.
Hello friends, hello, good evening, good evening, good evening everyone, hello. Okay, just to cross check, am I audible? Are you able to see me? Are you able to hear me? Just a thumbs up would help us to confirm that you are able to receive the audio and video feeds, and we can immediately start. All right, so what I'll do is I'll quickly just take a look at few of the images. See, biochemistry has some important images which you should be knowing, and once you've looked at the images, then I'll look at some of the very important points which I expect are likely to land up in your exam. Okay, so I'll go from there, and I think one of the most likely and hottest questions in image-based questions is the Lesch-Nyhan syndrome. I assume all of you will agree with this, the Lesch-Nyhan syndrome. So you have to make note of the self-mutilation tendency in children. The only differential diagnosis for self-mutilation tendency will be the Lesch-Nyhan syndrome, where you can see the bite marks or the nibbling of the fingers or the lips, the bite marks on the hands. These are some of the characteristic features for the Lesch-Nyhan syndrome. Very good. And as most of you have already guessed, the absence, there is absence of the enzyme HGPRTase. Please make very special note of this term which I have said. There is absence, not decrease. When there is decrease, that is a Lesch-Nyhan variant. So the Lesch-Nyhan syndrome is the absence of the enzyme HGPRTase, and the self-mutilation tendency is a part of the psychiatric component of the presentation. In addition to psychiatric component, you also have the neurological component and the biochemical component. One of the most important features here will be the hyperuricemia. So please don't forget the hyperuricemia presentation. And the neurological feature will be mental retardation, so poor performance in the school. And along with that, they can give the description of aggressive behavior, frequent quarreling and frequent fighting with the siblings. So aggressive behavior can be one important feature. Okay, so if the decrease is there, okay, so if you're asking if the decrease is there, we call it the Lesch-Nyhan variant, and sometimes it is also known as the Kelly-Siegmiller syndrome. It is known as the Lesch-Nyhan variant or the Kelly-Siegmiller syndrome, and in this case the psychiatric and the neurological features will not be there. These will not be there. So what you get is only hyperuricemia. In Kelly-Siegmiller syndrome, the only thing you get is hyperuricemia. Neurological and psychiatric features are not there. So please remember, Lesch-Nyhan syndrome, one of the most likely a question to land up in your exam, either in the form of MBBS question or in the form of a proper clinical case. Okay. Then another important image which has been landing up frequently for the last 2 years, we have had this image or description multiple times, and that will be the phrinoderma. See, previously we've been having the white rod spot for the vitamin A deficiency. Please remember that, very good, that when there is keratinization of cornea, along with that there is keratinization of the skin also. So what you can see here, what you are seeing here, these are described as the keratotic changes. These are described as keratotic changes. So you are likely to get the phrinoderma. You're likely to get the phrinoderma. Typically, along with vitamin A deficiency, there will be other deficiencies. In addition, in the question itself, they can mention that the white rod spot is present. So it will indicate, further confirm that this is a vitamin A deficiency. So please look at this image. You should be able to identify this when we are talking about the keratotic changes in the phrinoderma. Okay. The associated white rod spot is here. You can see the white rod spot where you are likely to get this elevated shaggy patch. This elevated shaggy patch on the sclera is there. The elevated shaggy patch on the sclera is there. So this is the characteristic white rod spot. So you are likely to get the white rod spot. Very good, very good. All right. So that's one, phrinoderma and the keratotic changes in vitamin A deficiency, and this very characteristic Casal collar, or sometimes described as the Casal necklace, characteristic of the pellagra. All of you know pellagra. Okay, so in pellagra, what you have to remember, the vitamin B3 or the niacin is deficient. The B3 or the niacin is deficient. And when we talk about pellagra, we mention the 3Ds. So here you have diarrhea. Along with that, you have the dementia. And about the dermatitis, you have to remember two things. About dermatitis, please remember two things. Number one, this dermatitis is photosensitive. And second, along with the photosensitive nature, you also get stomatitis. The stomatitis resembles what you see in the B2 deficiency in A. rhaboflavinosis. So, Casal collar or necklace, the diarrhea, dementia, and dermatitis. Dermatitis is photosensitive in nature, and along with that, you're going to get stomatitis. When we say that the dermatitis is photosensitive, what it exactly means is only in the sun exposed areas, you will see the pigmentation. So it will be in the face, on the hands, and the part of the neck which is above the collar, so that is why collar shaped pigmentation is seen. Sometimes the pigmentation may not be as harsh as this. You can get the lightly pigmented image of the neck as well. So please be careful, don't always look for the highly pigmented lesions. You can also get the lightly pigmented lesions. Okay, so very careful about the Casal collar or Casal necklace. Has to be in the sun exposed areas. Okay, so we have these three important images which will be related to the urine. First one, as you can very well tell, this is the Benedict's test. The first one is the Benedict's test. Very important. Benedict's test is for reducing substances. Benedict test is for reducing substances. One of the very commonly presenting image in your exam. You should remember, you're performing this test in the urine. You also get the positive Benedict test with vitamin C, with uric acid, with amino acids. So these will act as false positive for the Benedict test, because normally we are performing the Benedict test for reducing sugar. Okay, so you can label the presence of these substances as causing the false positive result. Second is the heat coagulation test. Which is for the proteins. What you're doing here, you heat the upper half of the solution. If the protein is there, then the cloudy presentation will be there. More is the protein content, more is going to be the frothiness or the opacity. All right, and the third one that you are likely to get is the Rothera's test. The Rothera's test, as a lot of you have already written, the Rothera's test is the test for the ketone bodies. The first two tests that we have shown, the Benedict test and the heat coagulation test, both of them are giving you an idea of concentration. See, traces, moderate, large amount. Similarly, here when the frothiness is there, the opacity is there, we give the rating of +1, +2, +3, +4. So, like some of you already written, these are examples of semi-quantitative tests. Both of them are example of semi-quantitative tests, both heat coagulation and the Rothera's test. Talking about the ketone bodies, you have to remember the important ketone bodies and the points about ketone bodies. The first one to be produced is acetoacetate. Acetoacetate converted non-enzymatically into the acetone. The acetone is the one which is responsible for the fruity odor of urine and breath. It is responsible for fruity odor of urine and breath. The acetoacetate also gets converted enzymatically, and that too reversibly, in the beta hydroxybutyrate. About beta hydroxybutyrate, what you have to remember, that the beta hydroxybutyrate is a pseudo ketone, means it doesn't have the keto group, and therefore when you test it via the Rothera's test, the result will be negative. So please remember, among the three ketone bodies, the beta-hydroxybutyrate doesn't give the positive Rothras test. It is called as the pseudoketone. It is called as the pseudoketone. So this is about the Rothras test. The Rothras test is also known as the modified nitroprusside test. It is also known as the modified nitroprusside test. So if you see the term modified nitroprusside test or the nitroprusside test, you should remember that it is the alternate name for the Rothras test for ketone bodies. Okay. So we talked about these, and the last one among the important standalone images, this is the oil drop cataract. As you can see very clearly, cataract, oil drop cataract. Okay, so you can see here presence of drop like appearance in the eye. You can, when you're looking at the eye in the lens, it is showing the drop like appearance. Wonderful. As all of you know, this is the presentation of the classical galactosemia. So the enzyme which is deficient here, is the galactose 1-phosphate uridyl transferase. So sometimes you can see the name as gal1 put. It can look like Galliput. When they write it, it can look like Galliput. So that is one way in which they can write the name, or they can write it as GALT, galactose transferase, or they can write it as uridyl transferase. So please be very careful about these names. Galactose 1-phosphate uridyl transferase, the galactose transferase, or the uridyl transferase. Okay, so please remember about these points. And about the classical galactosemia, the second very important thing you have to remember is the age of presentation is first week of life with neurological signs and symptoms. Sometimes in the question they might not mention the oil drop cataract, and in this case you will have to distinguish this similar clinical presentation which occurs at more than 6 months of life in case of what is known as the hereditary fructose intolerance. Similar clinical presentation, and only the age of presentation will be different. In fact, they even have the similar urinary findings. And what is that similarity in urinary finding? You will find that they have the positive Benedict's test and the negative glucose oxidase test. Okay, all right. So please remember that in classic galactosemia you cannot give milk, and you have to give them the galactose free diet or the lactose free diet, because lactose is also going to get metabolized into the galactose and cause the problem. So this at 6 months, what is happening in HFI when you're doing the weaning, the fructose is coming to that through the fruits. So till the breastfeeding is there, you will have the glucose and galactose coming from lactose but no fructose. When you do the weaning, that is when the fructose will come into the picture. So this first week of life for galactosemia and more than 6 months of life for HFI, for hereditary fructose intolerance, it has to be more than the 6 months of life. All right. So at this point, okay, one more. Different ways in which the image for the crumpled or wrinkled tissue paper appearance. Almost every year we have this paper. Different images will be there. So crumpled or wrinkled tissue paper appearance. Wonderful. All right. So I'm so happy to see that you're confident about what you're looking at. So this is the Gaucher cell. The only important thing you have to remember, besides the description that you just mentioned, that there is crumpled or wrinkled tissue paper appearance, that we also have something known as the pseudo Gaucher cell, and this pseudo-Gaucher cell is seen in the chronic myelogenous leukemia. Therefore, Gaucher cell is not diagnostic. It is not diagnostic for the Gaucher disease. So please remember that Gaucher cell is characteristic. It is seen very frequently in the Gaucher disease, but we can't call it diagnostic because we have a similarly presenting cell called the pseudo-Gaucher cell, which is seen in chronic myelogenous leukemia. About the Gaucher disease, as you rightly said, the deficient enzyme is the beta glucocerebrosidase, and the Gaucher disease is the most common. This is the most common lysosomal storage disorder, and it is also the first condition for which enzyme replacement therapy was made available. The first condition for which enzyme replacement therapy was made available. So remember these points about the Gaucher's. Typical presentation is with the hepatosplenomegaly. Sometimes there can be the bone pain, or also known as the bone crisis. So these 2 points to remember about clinical presentation. Either it can present with abdominal pain, which will be due to hepatosplenomegaly, or there can be bone pain described as the bone crisis. Okay, enzyme replacement therapy is available for treatment of the Gaucher disease. I'll start from the beginning now. Okay. One other very important question which I think is likely to land up in your exam, and it has been coming frequently, is the treatment of renal cycle disorder based on the biochemical molecules. Now here we have 2 molecules. I'm sure all of you know. Okay, great. So someone has written the name of the enzyme, aldurozyme. The first one to be launched for Gaucher's was the cerezyme, but now we have multiple other variants which are available. That is correct. Okay, so treatment of renal cycle disorder, there are 2 important biochemical molecules which can be given in all types of urea cycle disorders. You know there are 8 types of urea cycle disorders. So the 2 biochemical molecules which can be given in all the condition. The first one being the phenylbutyrate, and the second one being the sodium benzoate. Okay, for phenylbutyrate you have to remember that phenylbutyrate is actually a prodrug. It is not the active molecule. It first gets converted into the phenyl acetate, which then combines with glutamine. The end result is the phenyl acetyl glutamine, which is readily water soluble and therefore excreted in the urine. Water soluble, and therefore it is excreted in the urine. Okay, first is phenylbutyrate, which is prodrug, gets converted to phenyl acetate and then combines with glutamine and gets excreted in the urine. The second one is sodium benzoate, which combines with glycine to form the hippuric acid, and again the hippuric acid is also water soluble and therefore it is lost in the urine. Wonderful. So in this case what happens, body has to compensate for the loss of these amino acids. It has to synthesize these amino acids. To synthesize these amino acids, it will use up the ammonia. And therefore ammonia levels in the body will decrease. The 2 drugs are non-specific. They can be used in any type of urea cycle disorders. All the 8 subtypes of urea cycle disorders, in each of them this can be used because it is targeting the ammonia level. It is directly targeting the ammonia level, and therefore it is useful in all the different types of urea cycle disorder. Second is the Menkes disease, which I think is likely to land up. A lot of students will commonly confuse it when we talk about the genes in terms of the Wilsons. So remember ATP7A in Menkes, ATP7B will be for Wilson's. Now, in addition to knowing the gene defect, what you have to know, due to the deficiency of ATP7A, there is decreased copper in extracellular matrix. And this copper is actually required by the enzyme lysyl oxidase. This copper is required by the enzyme lysyl oxidase. So there are 3 questions here. Number 1, when you're talking about Menkes disease, which gene is defective? That's question number 1. Number 2, what is the effect of gene defect? There is decreased copper in the extracellular matrix. And number 3, which enzyme is getting affected? So when I ask you which enzyme is getting affected, there the answer is the lysyl oxidase. All of them are involved in the cross-linking in collagen synthesis. Please remember, cross-linking in collagen synthesis. For Menkes, the 2 important features to keep in mind is poor growth, that is growth retardation will be there, and along with that there is what is known as kinky hair. Kinky hair is the important thing. Okay, so no, please not. It is not prolyl oxidase. It is the lysyl oxidase. Lysine is getting oxidized. Asthasen. It is the lysyl oxidase and not the prolyl oxidase. Okay, please remember enzyme is lysyl oxidase. Okay. Wonderful, wonderful, great. Now I've just given for the Wilson's disease, as all of you are able to identify, this is the Kaiser Fleischer ring. You are likely to get this image also when we are talking about the Wilson's. In Wilson's, you have to remember the diagnostic test is liver biopsy, where you have to show accumulation of copper in the hepatocyte matrix. Okay, so please make sure that you're able to identify this image, link it with Wilson's, where defective gene is ATP7B, and confirmatory test is the liver biopsy. Confirmatory test is the liver biopsy. Wonderful. Now, very frequently we are getting this question that what happens in a patient of diabetes mellitus, and typically they are asking about the effect on lipoprotein lipase and the hormone sensitive lipase. LPL stands for lipoprotein lipase and hormone sensitive lipase. The first thing what we have to understand is, as soon as you mention diabetes mellitus, whether it is type 1 or it is type 2, there is a functional deficiency of insulin. In type 1, what is happening? Insulin is not being produced. In type 2, what is happening? No, prolyl hydroxylase is not the correct answer. It will be the lysyl oxidase. Dr. Diwali, it will be lysyl oxidase. Please don't worry. The answer will be lysyl oxidase. Lysine gets oxidized and combines with other lysine residues. Okay. Okay, so please keep in mind, when we talk about diabetes mellitus, first thing you have to understand whether it is type 1 or type 2, there will be functional insulin deficiency. In type 1, production is not there. In type 2, all the production is more, but insulin resistance is there. So functionally, insulin is not available. So that is point 1 you have to keep in mind for the diabetes mellitus. Now, about insulin, what you have to remember, insulin normally activates the lipoprotein lipase and it inhibits the hormone sensitive lipase. The lipoprotein lipase is acting on the triacylglycerol of lipoproteins. So in this way, the tissues are getting the triacylglycerol. The hormone sensitive lipase is acting on triacylglycerol of the tissues. So what is happening here? This free fatty acid is going in the blood, whereas in this case the free fatty acid is going in the tissues. Okay, so please remember very carefully, when insulin is present, it is going to activate lipoprotein lipase, and when insulin is present, it is going to inhibit the hormone sensitive lipase. When lipoprotein lipase is active, it will break the triacylglycerol of lipoprotein and provide free fatty acid to the tissues. When hormone sensitive lipase is active, it will break the triacylglycerol in the tissues and provide free fatty acid in the blood. So they are having opposite action. They are having just the opposite action. Now, when I say that we are talking about diabetes mellitus, in this scenario, insulin level will fall and everything will become opposite. What was getting activated will become inactivated. What was getting inhibited will become active. Okay, so please remember, when we say diabetes mellitus, there will be decreased action of lipoprotein lipase and there will be increased action of HSL. Okay, please remember this point. When there is decreased action of lipoprotein lipase, there will be decreased stores of PAG. There will be decreased stores of PAG. When there is increased action of HSL, there will be increased free fatty acid in blood. There will be increased free fatty acid in blood. All right, that's perfectly fine. Great. Thank you. No, cave ring is not seen in monkeys. I showed that for Wilson's. When we wrote ATP7B, below that I had given that image. Cave ring is not for monkeys. Cave ring is for Wilson's disease. All right, coming to the very important electron transport chain.
coming to the electron transport chain. Now, most commonly the question which is asked is for inhibition of the cytochrome C oxidase, also known as complex 4. Please note, nowadays in the question they are not writing the number of the complex, rather they are writing the name of the complex. So you have to remember that complex 4 is also known as cytochrome C oxidase, right? Now, for the complex 4, the 4 names which you have to remember: carbon monoxide, cyanide, azide, hydrogen sulfide. These 4 names should be on the tip of your tongue. These 4 names you cannot afford to forget. For carbon monoxide, you have to remember, whenever you are burning fuel in closed space, for example in a very small room or in a vehicle, you have all the windows up and you're burning an angiety or something like that, that is where the carbon monoxide will build up. Hydrogen sulfide will build up in sewer lines. So history can indicate workers going to clear the blockage in the sewer lines and they become unconscious or they die. So that will be the buildup of hydrogen sulfide. Hydrogen sulfide will build up in the sewer lines. Please remember that. In addition to that, for the last 2 years, we have been seeing the question focusing on rotenone. This question is becoming important. First time when this question was asked, they talked about the use as pesticide. But more importantly, why we are asking this question is because nowadays in the shampoos of the pets, we are using the rotenone. Rotenone is present in the pet shampoo, from where it can cause poisoning in the children. So it is clinically very, very relevant. If the children ingest the pet shampoo while bathing the pets, they are likely to get poisoned. So this is very, very important. Rotenone you must know about rotenone. It is inhibitor of complex 1, and the name of complex 1 is NADH-Q oxidoreductase. Please remember the name, because in the question they might not give the number, they can give the name. This is NADH-Q oxidoreductase. The other name for Q is ubiquinone. So we have seen the question where in the option they have written NADH ubiquinone oxidoreductase, and a lot of students got confused. So please remember, Q alternate name is ubiquinone. So the question can mention NADH ubiquinone oxidoreductase, indicating complex 1. The other important inhibitor of complex 1, the amobarbital, secobarbital, or most relevant for you is the phenobarbital. These are additional inhibitors of complex 1. These are additional inhibitors of complex 1. Okay. Now, with the term of pesticide, you have to remember there is another pesticide, that is antimycin A. So don't confuse the rotenone with the antimycin A, which is inhibitor of the complex 3. Okay, so please remember, rotenone, when it is there in the question, sometimes they can provide the details that it is a tasteless, odorless substance. Tasteless, odorless substance becomes important, because when you are using it for bathing the pets, if it is having some odor or some taste, then the pets will not allow you to use it. They will become very, very restless. Okay, so that's about the cytochrome C oxidase, most important question. One last part here which I would want to mention is the F0 F1 particle is also known as ATP synthase, and sometimes this is also known as complex 5 of electron transport chain. And in this context, please remember, inhibitor of F0 is oligomycin. This question has been asked previously, and when it comes again, you should be able to answer. All right. Okay, so somebody is mentioning atractyloside. Anyone knows atractyloside? Have you heard about atractyloside? Anyone? Atractyloside? Very good. Who's written? SK9OM. This is acting on ATP ADP translocase. Acting on ATP ADP translocase. Please note, atractyloside will act on the ATP ADP translocase. This enzyme brings out the ATP from matrix. It will pull out the ATP from matrix and replace it with another ADP, which can be converted to ATP. So ATP ADP translocase is bringing out the ATP from the matrix after the synthesis, which is inhibited by atractyloside. Yeah, antimycin, please remember antimycin is not tasteless, not odorless, and it is acting on complex 3. Okay, the Q cytochrome C oxidoreductase, it is acting on complex 3. Right. So that was 4. We move on. One of the very common question talking about mutation in the sickle cell anemia. Why sickle cell anemia? This is the most common abnormal variant of hemoglobin. Most common abnormal variant, and that is why frequently you'll get the question on the mutation in sickle cell anemia. What you have to remember, in sickle cell anemia, the change is happening in beta chain. In each of the chains we have 8 helices, so the change is limited to A helix at position 6. And what is the change? Glutamic acid is converted to valine. Glutamic acid is converted to valine. This is a point mutation. This is a point mutation. This is a type of missense mutation. This is a type of missense mutation which is partially acceptable. Partially acceptable missense mutation. Okay, so please remember it is a partially acceptable missense mutation in the exam, so that you don't confuse what came, what went away. Please remember this. The G is gone, glutamate or glutamic acid is gone when we're talking about the HBS. Okay. Another very commonly repeated question that we're getting is how the vitamin B12 deficiency is going to happen. So sometimes they can give the clinical case like this. Patient had gastrectomy and now presents with loss of proprioception and tingling sensation with numbness. Which deficiency? So remember, the vitamin B12 deficiency can occur due to problem in 3 areas. Number 1, if there is any problem in the oral mucosa. Oral mucosa, you can have dry mouth syndrome, keratoconjunctivitis sicca. In the mouth, there is production of the cobalamin, which is responsible for protecting the B12 from the gastric acid. Similarly, when there is atrophic gastritis or you have done gastrectomy due to gastric cancer, what is happening here? The intrinsic factor is being produced from the stomach. This intrinsic factor is required for absorption of the vitamin B12 at ileum. And last, if there is ileal resection, then absorption cannot take place. So remember, any problem at any of these 3 places, then B12 absorption will not take place. In the mouth, you are getting the cobalamin. In the stomach, you are getting the intrinsic factor, and in the ileum, which is responsible for absorption. All 3 sides must be intact and working normally so that the B12 absorption can take place. Very good hyperpigmentation, pigmented knuckles can be there. And the main feature of B12 deficiency is what you describe as the pernicious anemia. When we say pernicious anemia, we have 2 components in picture. First component is the megaloblastic anemia. Megaloblastic anemia is due to the folate trap. And second is the SCD or SACD, subacute combined degeneration of the cord. This is the damage, neurological damage of the vertebral of the spinal cord, vertebral spinal cord. So subacute combined degeneration of the cord. This is the irreversible neurological damage which is happening in the B12 deficiency. In fact, if you have B12 deficiency and you supplement with the B9, the neurological defects can get aggravated. So please remember, when B12 deficiency is there, you cannot give the B9 alone. You have to give B9 plus B12. Okay. You also get asked about the distinction between B9 and B12 deficiency. This is very common. So what you have to remember, that we have megaloblastic anemia. I just mentioned megaloblastic anemia. Megaloblastic anemia will be seen in B9 and B12 deficiency both. In addition to that, what you will get is homocystinuria. Homocystinuria will be seen in both B9 and B12 deficiency. In addition to this, you are likely to get methylmalonic aciduria. Methylmalonic aciduria is not seen in B9 deficiency, but it is seen in B12 deficiency. And last, what you're going to get is the subacute combined degeneration of the cord, which will not be seen in B9 deficiency, but it will be seen in B12 deficiency. So with the help of these 4 features, you are readily able to distinguish between the B9 and the B12 deficiency. 2 important common features and 2 important differences. So methylmalonic aciduria only in B12 deficiency, and the neurological deficit only in the B12 deficiency. Then we are also getting the questions on the vacutainers. Very commonly you're getting the questions on vacutainers. 2-3 out of the way questions on vacutainers which are there. One is for HbA1c. Okay, so as of now we are using EDTA. However, if in the question they are mentioning black vial used for, so black vial was previously used for the estimation of HbA1c. So you have to watch out for the presence of black vial in the option. Previously the black vial was used for HbA1c, which was specific for HbA1c, but now there has been upgradation of the equipment, and with the new equipment we are using the lavender top vial having the EDTA. So most of the laboratories have now shifted to newer equipment where you're using the lavender top vial for the estimation of HbA1c. Please also note that this lavender top vial is also used for the estimation of ESR. Oh, I'm so sorry. Black vial was for ESR. I'm so sorry. Black vial for ESR, HbA1c for lavender top, and now we are not using the black vial for ESR. Now we have shifted from black vial to the lavender top vial. No. Only for HbA1c, lavender top vial, ESR, lavender top vial. These you have to remember, which are extra. Otherwise, the routine vials that you remember, that is more than enough. One extra test you have to remember is for the ethanol in blood. How do you estimate ethanol in blood? Which vial you are going to collect the sample in? For this, you have to remember the gray vial. These are the only 3 extra you have to remember. Okay, what is to be done for HbA1c, what is to be done for ESR, and what is to be done for ethanol estimation. These are the 3 extra tests you have to remember. For ethanol you use the gray vial. For the ESR, previously we had black vial, but now we are doing the ESR also in EDTA vial, and HbA1c we are using the EDTA vial. So these are the 3 extra tests you have to remember. And for electrolytes you have to remember, it is done in serum. Serum will be obtained in the golden or the red top vial. Golden or the red top vial. Ethanol in gray. Ethanol in gray vial. Ethanol in gray vial. I am sure all of you know about the sequence of these vials. The first is for the blood culture, second is for the coagulation profile, the third and fourth, the red top and the gold top will give you the serum. We can do the biochemistry and the immunological parameters. The green top vials will give you the plasma. So some biochemical parameters need to be done in plasma, which you can collect in the green top vial. The lavender top vial and pink top vial are the same. They are having the EDTA for complete blood count or hematology, or for the you can say blood grouping. For blood grouping also you can use in the lavender top or in the pink top vial. They are exactly the same. The pink top vial only has a difference in the labeling. And the gray top vial for plasma glucose, it has sodium fluoride plus potassium oxalate or the EDTA. Please note, sodium fluoride plus strong anticoagulant is required. Very good, Saurav Nagar. Please remember, yes, you're right. When we are taking the sample for ABG analysis, classically, all of you remember that we take it in heparinized syringe, but now it is not required to take it in heparinized syringe because you already have the vacutainer, which is vacuum sealed, having the heparin. So this green vial is having the heparin inside. Heparin is already there. Okay, so you can take the sample in the green top vial for the ABG analysis. You can take it in ABG analysis. Till now they've not asked, but okay, you raised it, so I'm telling that you can take it in the green top vial. You don't need to use the heparinized syringe any longer. This is having a better vacuum seal than you can create by bending the needle. Okay, so please note, this is a better place where you can collect the sample for ABG analysis. Okay, again we are getting the question on the high anion gap metabolic acidosis very repeatedly. So I would expect you to remember this mud piles. Please remember this mud piles as the mnemonic for the high anion gap metabolic acidosis. Okay, electrolytes in serum. Serum is in red top or the gold top vial. RBS is in gray vial. RBS, I told you, in gray vial. Sodium fluoride inhibits glycolysis. Enzyme number 9, that is enolase. Okay, culture is always first. Culture is always first. We saw this. The first vial is always for culture. The first vial always for culture. If you require culture, it must be done right in the beginning. If you require culture, it must always be the first vial. Okay, what is the question at the end? Green was given, sir, so it's not at all green. No, see, the when you're looking ethylene glycol, we have not had question on ethylene glycol. For electrolytes we had the question on HbA1c, we had the question on ESR. We not yet had the question on ethylene glycol. We have had the question on ethanol. For ethanol, I told you it is going to be the gray vial. Black vial was used previously for ESR, no longer used. Now we are using the lavender top vial for ESR as well. Previously we are using the black top vial for ESR. So if in the question they ask black top vial is used for, then you can mark ESR. But as of now we are using the lavender top vial. We are not using the black vial. Electrolytes is in serum. You get the serum in the red top or the gold top vial. Okay, electrolytes you measure in the serum. Serum is obtained from the red top or the gold top vial. Please forget black. We don't use black now. Black is outdated. We are not using for more than 5 years now in the country. Black is outdated. Please forget the black. Black vial, please forget. We don't use it now. Only thing you have to remember that if they ask black, you say that yes, sir. That's all. But now we are not using the black vial. So I'll leave it that we are not using black vial any longer in the country. So I'll not go there. Okay. Okay, so about ABG and lights, what you have to remember, the ABG analyzer will give you the electrolytes as well. Okay, so if you're sending the electrolytes separately, then it is preferably done in the serum. But if you're sending for ABG analysis, for arterial blood gas analysis, that equipment does the electrolytes as well from the plasma. That is doing the electrolytes from the plasma. But however, for the routine electrolytes, we are using the serum. Okay. All right. The ratio will be 1:9. See what happens is in the vial it is already marked till what mark you have to take the blood sample. You don't have to decide what is the ratio. It is already marked till where you have to collect the blood. So ratio is 1:9, but you don't have to do that calculation. You are using the Vacutainer. Vacutainer is already having the label. Okay, let's come back to this high non-gap metabolic acidosis. Commonly in the question it may be written as HAGMA, high non-gap metabolic acidosis. And remember the mud piles: M for methanol, U for uremia, D for diabetic ketoacidosis, P for paracetamol. And here you also have the paraldehyde, fenformin, polyethylene glycol. I for inborn error of metabolism. Please note, very important, inborn error of metabolism. And L for lactic acidosis, E for ethanol, again ethylene glycol, S for salicylates and aspartate. For D, remember any type of ketoacidosis. We write it for diabetic ketoacidosis, but any type of ketoacidosis which is there, for that you will have the diabetic ketoacidosis. Last point, in diabetic ketoacidosis questions you will not get the value of PCO2 and bicarbonate. You will only get clinical scenario. You will get the pH value. You have to identify that we are dealing with the high non-gap metabolic acidosis. In these questions they will give the clinical scenario, they'll give the pH, and that's it. So you have to identify that it is a type of metabolic acidosis. Okay, moving on to the very important question, and that is the B1 deficiency. B1 deficiency causes two things: beriberi and the Wernicke's encephalopathy. Wernicke's encephalopathy is very commonly asked, so you should remember this. Wernicke's encephalopathy presents with what is known as GOA. Global confusion, ophthalmoplegia and ataxia. All of you know that. Global confusion, ophthalmoplegia and ataxia. Now when there is Korsakoff psychosis, these two, amnesia and confabulation, will be feature of the Korsakoff psychosis in addition to the features of encephalopathy. Okay, in addition to features of encephalopathy, when you have the amnesia and confabulation, and that is the Korsakoff psychosis. So please remember that point. Korsakoff psychosis will have features of Wernicke's plus amnesia and confabulation. For Wernicke's and Korsakoff, the treatment is IV thiamine, and if they have the hypoglycemia, then you give the 25% dextrose infusion as well. Okay, so global confusion, ophthalmoplegia and ataxia. Along with that you can have amnesia and the confabulation. Okay, moving on, we have the congenital lactic acidosis, very common question. Lactose can happen due to a lot of causes, but congenital lactic acidosis is commonly associated with pyruvate dehydrogenase deficiency, genetic deficiency of the pyruvate dehydrogenase. Thymine has to be given first. Yes, thymine has to be given first. Thymine has to be given first, and then you have to give 25% dextrose only when the hypoglycemia is there. Otherwise, you don't need to give it. Okay. So talking about lactic acidosis. Talking about lactic acidosis, it can be due to problem in the PDH complex. It is due to problem in the PDH complex, and it can be due to the B1 deficiency in chronic alcoholics. It can be due to inhibition of lipoic acid. Inhibition of lipoic acid due to mercuric and arsenite ions, due to mercuric and arsenite ions. Okay, but lastly, it can also be due to the deficiency of pyruvate dehydrogenase. It can be due to deficiency of pyruvate dehydrogenase. Moving on, very common question about the inhibition of enzymes. About inhibition of enzymes, where we talk about the Lineweaver Burke plot. So you should be able to identify the competitive inhibition common point on the y-axis and non-competitive inhibition where the common point is on the x-axis. If you remember these 2 points, in competitive inhibition common point on y-axis, in non-competitive inhibition common point on the x-axis. If you remember these two, then your work is done. Okay, yes, that also works. Competitive is a cross, non-competitive is an angle, so that equally works. Now we are repeatedly getting question on the familial hypercholesterolemia and the familial hyperchylomicronemia. Okay, so type 1, where lipoprotein lipase deficiency is there, you get elevated chylomicron, triglycerol levels are elevated. Common presentation can be pancreatitis, and in these patients what you can see is the cutaneous or the subcutaneous xanthomas. Whereas in case of the type 2A, the familial hypercholesterolemia, where LDL is elevated and cholesterol is elevated, there will be history of coronary artery disease, and you will get the tendinous xanthomas, So please remember tendinous xanthomas. No give synergy, no graph, no. Okay, so tendinous xanthoma in cholesterol elevation and coronary artery disease, whereas the subcutaneous xanthoma and pancreatitis when the triglycerol level is elevated. The other types are generally not asked, so will not go over there. The additional point only you can remember is type 3, where remnants are elevated. Just remember this point: in type 3, chylomicron remnant and VLDL remnant are elevated. Question on amino acid derivatives. 3-4 names I want to highlight. Number 1, that glucose from amino acids. Number 2, creatine requires 3 amino acid: arginine, glycine, and methionine. Arginine, glycine, and methionine required for synthesis of creatine, not creatinine. For creatine synthesis, you require arginine, glycine, and methionine. Third, for synthesis of nitric oxide, you require arginine. Very frequently repeated question for nitric oxide. Arginine is required. Enzyme is nitric oxide synthase. Then how do you get histamine? Histamine is produced by decarboxylation of histidine. And the GABA is produced from glutamate again by decarboxylation. 3 more names. Tyrosine is giving you the catecholamines, thyroxine hormone, and melanin. Tryptophan is giving you the serotonin, melatonin, and niacin. And methionine is required for production of SAM. Please remember these: the production of SAM from methionine, the serotonin, melatonin, and niacin from tryptophan, catecholamine, thyroxine hormones, and melanin from tyrosine. Decarboxylation requires vitamin B6. Vitamin B6 is required for transamination, deamination, decarboxylation. All these three processes require the vitamin B6 in the form of pyridoxal phosphate. Okay. All right, so that was about the special products, and also make note of the catecholamine synthesis. Lots of coenzymes are required in catecholamine synthesis. Conversion of tyrosine to dopa requires tetrahydrobiopterin. Conversion of dopa to dopamine requires pyridoxal phosphate because it is again a decarboxylation. From dopamine to norepinephrine, we require the copper and vitamin C, and conversion of norepinephrine to epinephrine requires SAM. It requires SAM. Okay, creatinine is a waste product. Creatinine is a waste product. Production of creatine requires the arginine, glycine, and the methionine. All right. Okay. One important concept: post-transcriptional modification of hnRNA into the messenger RNA, hnRNA to messenger RNA. It requires the 7-methylguanosine at 5' end. It requires the poly A at the 3' end, and splicing. These are the three changes which are included in the post-transcriptional modification. Okay, post-transcriptional modification require the addition of 7-methylguanosine at 5' end, poly A at 3' end, and splicing. Okay. Diagnostic tool for the neonatal screening program. Nowadays, a lot of states are rolling out the neonatal screening program. It has been working for a long time in the Western world, but now in our country also some states are rolling out the neonatal screening program. So there, the preferred test will be the tandem mass spectrometry. In the question, it will be written as tandem MS. Tandem MS is tandem mass spectrometry, and here what you have to remember, we are using two mass spectrometer linked in series. That's it. Two mass spectrometer linked in series. First one will carry out separation. Second one will identify each of the separated molecules. Separated molecules. Okay. Now, heme catabolism, repeatedly the question is coming. You have to remember three products coming out from the heme catalysm. First is ferric iron. When you synthesize, you use ferrous iron, but when there is breakdown, at that time you are getting the ferric iron. We'll come to epigenetics. Don't worry, we'll come to epigenetics. Don't worry. TMS, tandem mass spectrometry, is correct. Second, biliverdin. One heme will give you one biliverdin, and most importantly, carbon monoxide. Only reaction where physiologically carbon monoxide is produced. So you remember these three things on the breakdown of heme. We get biliverdin, we get the ferric iron, and we get the carbon monoxide. Okay, COF3 and biliverdin. These are the three things you get. Not ferrous iron, not carbon dioxide. Okay, please don't make that mistake. These three are very, very important. Again, we are getting question about the insulin dependent and insulin independent uptake. What you have to remember, that GLUT4 is the one which will be affected by the insulin. GLUT4 is present in the muscles, whether it is cardiac muscle or skeletal muscle, and the adipose tissue. Second point, you also have to remember, when there is fasting, overnight fasting, these receptors will go inside. So what will happen? There will be decreased concentration on surface. So this is second type of question which is asked. You have to remember, after overnight fasting, decreased concentration of the receptors occurs on these three tissues: cardiac muscle, skeletal muscle, and adipocyte. So number one, these receptors are affected by insulin, and number two, after overnight fasting, these receptors will go inside. These receptors will go inside, and therefore the concentration will be decreased after overnight fasting. Second, the RBC contains only GLUT1. All tissues will have GLUT1 plus something else. All tissues will have GLUT1 plus something else. RBC has only GLUT1. This is second important question that you have to keep in mind. Others, I'll not go there. No point in going to the others. Now, coming to the Chargaff rule. Chargaff rule is for double stranded DNA. That means adenine will be equal to thymine, guanine is equal to cytosine, and purine is equal to pyrimidine. If your genetic material is RNA in nature, then the Chargaff rule does not apply. Please remember, Chargaff rule will apply for double-stranded molecule. If your genetic material is single-stranded RNA, then the Chargaff rule does not apply. According to Chargaff rule, in double-stranded DNA, adenine will be equal to thymine, guanine will be equal to the cytosine. Okay. Then glycogen phosphorylase is another very important repeated question. So here you have to remember two things. It is activated by calcium and AMP. It is inhibited by free glucose in liver, and it is inhibited by ATP and glucose 6-phosphate in both liver and muscle. Okay, in both liver and muscle, ATP and glucose 6-phosphate. Only in liver, free glucose. Free glucose will not act in the muscle. Activation by calcium and AMP. About calcium, you have to remember it activates directly, and it also activates via cal moduline, means it is acting indirectly as well. It is acting indirectly as well. Moving on to RBC. RBC uses only glucose. Only glucose. RBC uses only glucose. It cannot use the ketone bodies. It cannot use the fatty acid. So fed state, fasting state, starvation state, early starvation, post starvation, whatever is there, only RBC. Only RBC. ठीक है, चलिए RNA-I and microRNA, same question. Okay, RNA-I stands for RNA interference. It acts through knockdown. Knockdown will have three mechanisms: mRNA degradation, mRNA destabilization, and prevention of translation of messenger RNA. These are the three methods by which RNA interference, that is knockdown phenomena, will work. And this microRNA acts by interacting with messenger RNA at the 3' untranslated region. Okay, microRNA will act on messenger RNA by interacting with the 3' untranslated. It matches the sequence. If the match is there, then RNA interference will happen. If there is no match, both of them will go their own way. Okay, and the role of microRNA is for regulation of the gene expression. Knockdown, knockup is happening at the level of DNA, not at the RNA. Knockup. There is no knockup. There is knock-in and knockout. I'm so sorry. There is knockdown, which is mRNA. There is knock-in and knockout. Knock-in and knockout will happen at the level of DNA. Knock-in means you add something. Knockout means you take out something. Knock-in, there will be gain of function. Knockout, there will be loss of function. Knock-in is generally frowned upon. Knockout is the one which we are doing routinely for the research purpose. Knockout means you take out a gene and there is loss of gene function. Okay. Okay, I'll just write quickly. Knock in means you add gene. Knock out means you delete the gene. When you do knock in, there is gain of function. When you do knockout, there is loss of function. Alright. So that's it. Don't have to remember anything beyond this. Both of them, knock-in and knockout, are happening at the level of DNA. Both of them happening at the level of DNA. Little bit about nutrition. Which of the following consumes highest energy during assimilation? What they are basically asking is the thermic effect of food, also known as the specific dynamic action of the food. How much energy we spend for metabolism? How much energy we spend for metabolism? Another 5 minutes. That's all. Just another 5 minutes. Okay. So the carbohydrate thermic effect of food is 5%. Very easy to digest. Lipids, slightly more energy is required, 10 to 15%. And most difficult to digest are the amino acids and proteins. Up to 30% of the energy content is utilized for metabolism itself. Okay, no, we are not going to CRISPR-Cas. That is old story. Don't go there. We'll focus somewhere else. Don't worry. Okay, then which of the following is amphipathic triacylglycerol and cholesterol ester? Okay, and very commonly asked question, wobble hypothesis. Wobble hypothesis is explaining the degeneracy, and both of them together are responsible for silent mutation. Both of them are responsible for silent mutation. Last part which you are asking about the epigenetics, the effect of DNA methylation. In DNA, we have only one change, that is methylation. It is going to cause the decrease in gene expression. It is going to cause decrease in gene expression. And effect of histone acetylation. In histones, we have a lot of changes, but most important is the acetylation, which is going to cause increase in gene expression. Two more points about DNA methylation. DNA methylation commonly occurs in the CPG islands. It will commonly occur in the CPG islands. CPG islands are part of the enhancer element. CPG island are part of enhancer element. CPG island are part of enhancer element. Okay. Before I close, just 2 points about PCR. PCR is used for identification and where you need the 6 important substrates. First, template DNA. What you have to remember, this is the only variable element. This is what comes from the patient. The template DNA is what comes from the patient. The rest of it we give in the lab. What do we give in the lab? We give the tag polymerase. Along with this, we give the building blocks, that is DNTP. We give the primers. We give the activator for polymerase, that is magnesium, and we give the buffer to maintain the pH. All this we give from the lab. The variable component is the DNA which is coming from the patient. Second, we have something called multiplex PCR. See, this is again going to land up in the exam. 2 years back it was there. It is for syndromic diagnosis of meningitis. We had used this during the pandemic. We have used this during the pandemic, but now we are using it for the syndromic diagnosis of meningitis. In the same tube, you can identify 3-4 infections for meningitis. You can test for each of them. Whichever is positive, you will know your diagnosis at one shot. And one shot, you can identify the cause for meningitis. Okay, DNTP means deoxyribonucleotide triphosphate. There will be building block for the DNA. In PCR, you are amplifying the DNA, right? So you need the building block for the DNA. You need the building block for the DNA. When you're doing the histone acetylation, that is activation. When you do the histone deacetylation, that is inactivation. Okay, when you give the histone deacetylation, that is inactivation. You don't give anything to stop the PCR. You just stop the machine. Okay, you just stop the machine. You just need to stop the reaction when you're doing the RNA amplification. For DNA amplification, we don't need to give anything to stop the reaction because it happens at a specific temperature which is optimum for the enzyme. You remove the temperature, optimum temperature, the reaction will stop. You don't need to give anything to stop the PCR. You just decrease the temperature, you bring the temperature back to normal. Okay, I think these are some of the most important topics which I wanted to discuss. One, odors is there. Please take a look at odors. Mousy or musty odor for PKU, burnt sugar odor for maple syrup urine disease, fruity odor for ketoacidosis, I told you, boiled cabbage odor for tyrosinemia, swimming pool odor for Hawkinsinuria, also known as chlorine-like odor. Summation is a type. Summation is a type of the histone modification, but you can ignore that. You can ignore that. It is a type of the histone modification. Okay. Just one more minute. I'm so sorry. Zellweger syndrome. Peroxisome is absent or defective. Okay, absent or defective. Liver cannot use ketone bodies because enzyme thiophorase is absent. Thiophorase is also known as succinyl coenzyme acetoacetate coenzyme A transferase. And in Zellweger, okay, what you have written is correct. In Zellweger's, VLCFA will accumulate in CNS, liver, kidney. And last, that lipid up to 30% in diet is normal. Last point. That is the last point. That is the last point for my side. The 30% of lipid in the diet is normal. So until you have 35% or more, we'll not call it the fatty meal. I have taken a lot more time than I was allotted. I'm very, very sorry, but I could not stop in highlighting the very, very important topics for you. I hope you are able to score well with this quick revision of biochemistry, and I've tried to cover what I felt was must-know topics for you. And I'm very, very hopeful that all the questions, the 14-15 questions that we are getting from biochemistry will be from what we have done today. In RefSums, you will only have peripheral neuropathy. Only one enzyme is defective, which is causing the breakdown of the branched fatty acid, the phytanic acid accumulation. So in RefSums, the question will mention phytanic acid. When you see phytanic acid, then we are dealing with refsums. There is deficiency of one enzyme, the phytanyl dioxygenase, phytanyl coenzyme dioxygenase. That is the only thing which is deficient. So there is peripheral neuropathy, the deposition of the phytanic acid. Okay, so that is all from my side. Thank you very much, and take care, and best of luck for your exam. I'll be signing out here, and take care, and bye bye. Hello. Hi, good evening. Audio, video, everything is okay? Good evening. Great, great, great. So live from Chennai after the class. Today is the second day of Chennai class. I'm live from Chennai classroom. Happy to see you. I thought I don't want to discuss MCQs because half an hour I can discuss maximum 15 MCQs. I can give 15 to 20 points. I want to give you 150 points matter of 30 minutes. One liner just to shoot. What is the temperature for autoclave? What is the temperature for autoclave? 121 degree, 15 minutes, 15 pounds per inch square pressure. Negative staining. Example, India ink for capsule. Visualizing capsule is negative stain. Okay. Next is flash pasteurization. It is 72 degree for 20 seconds followed by rapid cooling into 13. What is the culture medium for anaerobes? Many are there. Very famous RCM, Robertson's cooked meat medium. Selective medium for Brio cholera. TCBS agar, thiosulfate, citrate, bile salt, sucrose agar. Learn. No need to take down, just to answer this available video. After that, I will send the PDF also, not an issue in my group. McIntosh field jar, anaerobic culture, used for creating anaerobic conditions. Cold enrichment, growth at 4 degree by Listeria monocytogenes. Listeria monocytogenes. What is protoplast? Gram positive without cell wall, protoplast, lost the cell wall. Gram negative, lost the cell wall, is spiroplast. And staph aureus, we don't know the question. Question may be it is gram positive cocci cluster, I don't know what it is. Most common cause of osteomyelitis, surgical site infection, toxic shock syndrome is the most common. Most common is surgical site infection, osteomyelitis, infective endocarditis. Most common is staph aureus. What is the function of protein A? Binds with the Fc portion of immunoglobulin, escape from immunity. And toxic shock syndrome is a super antigen caused by Staphylococcus aureus. It produces typical sunburn rash, massive cytokine release. ASO titer more than 200 indicates recent exposure to streptococcal pyogenes infection. It is significant in post-streptococcal glomerulonephritis and rheumatic fever more than 200 units. Waterhouse-Fridgen syndrome is a complication of Neisseria meningitidis. Adrenal hemorrhage, fulminant meningococcemia, many things it causes. Good. Thiamartin medium, selective medium for Neisseria, both gonococci and meningococci. Anthrax bacillus is bioterrorism, category A agent, as well as it produces medusa head, agar bamboo stick in microscopy. Bamboo stick in microscopy, medusa head in agar. And frosted glass in naked eye. If you see like this, frosted glass. McFadden reaction, demonstration of amorphous material, diagnosis of anthrax, not a confirmatory, presumptive diagnosis of anthrax. Necklace reaction, demonstration of lecithinase,
Clostridium perfringens. Diphtheria. Albert stain shows metachromatic granules. It's otherwise called volutin granule, Babes Ernst granule, polar bodies. Other stain, Albert stain, Ponder stain, Neisser stain. That's all. LX gel precipitation test, demonstration of toxin of Corynebacterium diphtheriae. Satellitism exhibited by Haemophilus influenzae, factor 5, factor V, in the presence of Staphylococcus aureus, colonies around Staphylococcus aureus. Whooping cough caused by Bordetella pertussis, it's otherwise called 100-day cough. Growth in Regan-Lowy medium or Bordet-Jungu medium. Leprosy cannot be grown in artificial culture medium. It is cultivated on 9-banded armadillo. Footpad of mice, 9-banded armadillo. Stormy fermentation of litmus milk, Clostridium perfringens. Negri bodies, intracytoplasmic inclusion bodies of rabies. You practice like this. Before exam, you need to do like this. Hepatitis B. It's a blood-borne pathogen, DNA virus, anything. First marker appears hepatitis B surface antigen. First antibody is core antibody. Hepatitis E, fecal-oral route. It causes fulminant hepatitis in women. High mortality. Window period for hepatitis B virus. Disappearance of surface antigen. Surface antibody yet to appear. Only core antibody present. Period between disappearance of surface antigen and appearance of surface antibody. Dengue is called breakbone fever. Vector is Aedes mosquito. Zank smear, demonstration of multinucleated giant cells. Herpes. Koplik spot, oral cavity, white lesions in oral cavity by measles virus. Buccal mucosa. Reverse transcriptase enzyme present in HIV and hepatitis B virus. P24 antigen is nucleocapsid antigen of HIV. First detectable protein in HIV. Rotavirus is the common cause of diarrhea in children, infants globally. Kala azar, black disease caused by Leishmania donovani. Vector is sandfly, phlebotomus. LD bodies, we otherwise call A mastigotes, gold standard diagnostic for Leishmania in bone marrow or splenic aspiration, Leishmaniasis. Stepladder fever, people hit 6. What is it? It is typhoid, classic presentation of typhoid. NIH swab, rectal swab, National Institute of Health for Enterobius vermicularis. Cysticercosis, ingestion of Taenia solium egg leads to cysticercosis. Germ tube test, Candida albicans and Candida dublinensis also. Asteroid bodies, Sporothrix. Spaghetti meatball, where you can get, or banana grapes appearance. Malassezia furfur, Taenia versicolor, Malassezia furfur. Cryptococcus, most common fungal meningitis in HIV positive. We can use latex agglutination test to diagnose cryptococcal antigen. Type 2 hypersensitivity, cytolytic, lot of examples are there. Erythroblastosis fetalis, hemolytic disease of newborn, myasthenia gravis, many things. Type 4, all kind of skin tests, graft versus host disease, Mantoux test, contact dermatitis, granulomas, many things. H. pylori, it won't take Gram stain. It take Warthin-Starry silver stain or Sterner silver stain. Capsulated bacteria, NHS, Neisseria meningitis, Haemophilus influenzae, Streptococcus pneumoniae, Klebsiella pneumonia, many things are there. Bacillus anthracis polypeptide capsule. Swarming, Proteus, Vibrio parahemolyticus, Burkholderia pseudomallei, many things. Clostridium tetani, many people swarming growth. Chinese letter pattern. Corynebacterium diphtheriae. And due to incomplete separation, Chinese letter pattern. Fish in stream is Vibrio cholera. School of fish is Haemophilus ducreyi. Yes, school of fish, Haemophilus ducreyi. Fontana stain for flagella and spirochetes. Trichoderma pallidum, spirochetes and flagella. Aramin rhodamin for tuberculosis, Mycobacterium tuberculosis, more sensitive than Zil-Nielsen. Thier-Martin medium for mainly for cultivation of Neisseria. It contains chocolate, vancomycin, colistin. Thier-Martin medium is chocolate agar contains vancomycin, colistin and nystatin. More sensitive, more selective. LJ medium for tuberculosis. Skirro medium, Campylobacter and Helicobacter. And eosin methylene blue agar. For E. coli, diarrhegenic E. coli, it produces metallic sheen colony, green metallic sheen colony. Catalase test differentiates Staphylococcus and Streptococcus. Staphylococcus positive for catalase test. Coagulase test, Staphylococcus aureus positive, epidermidis other people negative. Oxidase test, cytochrome oxidase positive for Pseudomonas, Neisseria, Vibrio, many people. CAMP test positive for GBS, group B Streptococcus, Streptococcus agalactiae. Councilman bodies where you can get yellow fever, midzonal necrosis, liver during yellow fever. Cowdy type A, varicella zoster, herpes and yellow fever. Cowdy type A, herpes simplex, varicella zoster and yellow fever. I'm not giving time for you to breathe. Don't worry. You take breathtaking performance. Aula inclusion, cytomegalovirus. Antigenic drift, mild form of influenza. Point mutation, antigenic shift, pandemics. Genetic reassortment, pandemics of influenza A. Pulmonal test, Epstein-Barr virus. Heterophile antigen antibody test, Epstein-Barr virus. Infectious mononucleosis. Den particle, 42 nanometer, complete virome of hepatitis B. Mayurer dot, seen in Plasmodium falciparum. Schnaffner's dot, seen in Plasmodium vivax and Plasmodium ovale. Some books are mentioning, but James dot is ovale. Crescent-shaped gametocyte, Plasmodium falciparum. Toxoplasma, what is the triad? Hydrocephalus, chorioretinitis. Hydrocephalus, chorioretinitis, intracranial calcification. Steatoria, foul-smelling, floating, fatty stool, steatoria. Giardia lamblia, falling leaf motility. Flask-shaped ulcer, submucosal spread, Entamoeba histolytica, amoebic ulcer. Amoebic ulcer. Onchobius pus, where you can get amoebic liver abscess, chocolate color pus. Free living amoeba, acanthamoeba, Naegleria, they causes keratitis. And Naegleria causes primary amoebic meningoencephalitis. Acanthamoeba causes granulomatous amoebic meningoencephalitis. Germ tube positive, Candida albicans and Candida dublinensis. Cigar shape appearance, you can get which yeast, cigar shape, Sporothrix key. Darling's disease caused by is otherwise called Histoplasma capsulatum. Intracellular yeast in macrophages. South American blastomycosis, Paracoccylides brasilensis. Pilot wheel appearance or Mickey Mouse appearance. Rat bite fever, Spirilla minus, Streptobacillus moniliformis. Rose Bengal cot test, Rose Bengal plate test, pasteurization, Brucella. Rapid screening test for Brucella to check the pasteurization is perfect or not. Wheels disease, Leptospira, Leptospira interrogans, jaundice, renal failure, meningitis, many things. Leptospirosis diagnosis, gold standard is MAT test and you have culture also. Microscopic agglutination test, MAT test, gold standard. Q fever caused by Coxella burnetii. No rash and no vector. Negative for Wilflix. No rash, no vector. Scrub typhus caused by Orientia sushugamushi. Mite is the vector. Vector is the trombiculate mite. Yet sure, you can see in Bacillus anthracis as well as scrub typhus. Scrub typhus as well as Bacillus anthracis. Both you can get yet sure. Cat scratch disease. Bottonella Hensley. Cat bite abscess. Pasteurella multocida. Cat scratch disease, Bottonella Hensley. Cat bite abscess is Pasteurella multocida. Plague caused by Yersinia pestis is a pandemic. It is safety pin appearance in Weissenstein. Weissenstein, it is safety pin appearance. Neonatal meningitis caused by Bell, Group B streptococcus, E. coli, Listeria, Klebsiella pneumoniae. Very important, Group B streptococcus, E. coli and Listeria. Klebsiella also you can add. Naegleria fowleri, brain-eating amoeba, primary amoebic meningoencephalitis, brain-eating amoeba. Inhaled, when swimming, it directly invade, trophozoite invade. It causes primary amoebic meningoencephalitis. Subacute sclerosing panencephalitis is late, rare, fatal complication of measles. Late, rare and fatal complication. PML, progressive multifocal leukoencephalopathy, ring enhancing lesion in brain caused by JC virus, John Cunningham virus, DNA virus, immunocompromised patients. Japanese encephalitis virus, Culex is the vector, pig is the amplifier host, birds are the reservoir host, dead end host, human, transmitted by Culex, pigs are the amplifier host. Syphilis screening, VDRL and RPR test, non-prepenomal test. Syphilis confirmatory, specific test, TPPA, TPHA, FTA-ABS, all people. FTA-ABS, fluorescent triphenomal antibody absorption test. And soft chancre caused by Haemophilus ducrei, painful. Chancroid, Haemophilus ducrei, painful. Hard chancre by syphilis, Trypanosoma pallidum, painless. Soft is painful, hard is painless. Donovan bodies seen in granuloma inguinale, Klebsiella granulomatis. Klebsiella granulomatis, Donovan bodies. Clue cells, epithelial cell embedded with bacteria. It's a clue for bacterial vaginosis. Vaginal cell coated with bacteria, diagnostic for bacterial vaginosis. Strawberry cervix, strawberry tongue, scarlet fever. Strawberry cervix, Trichomonas vaginalis. Hand, foot, mouth disease, Coxsackie A virus, vesicular rash, herp angina. A16. Slapped cheek rash, you can get it in parvovirus B19 in children, erythema infectiosum, parvovirus B19. And other appearance is called blueberry muffin rash. So I bat up, century, 100 over. 50 more points, and every day my group I am going to release 50 points till the exam, or 2 days before exam, because 2 days before I don't want to trouble you. Got it? Every day you may get 50 points like this. Please spend 5 to 10 minutes, read. Definitely it will be useful to you. Okay, instead of reading now, it's not the time to work out MCQs and all confusion. Only few days are pending. So now we need to go change our app mode. Now it's not the time to aim and shoot. AK-47 shoot. Orchitis is the common complication of mumps. Oophoritis in women, postpubertal males. Hydrated sand in Echinococcus granulosus. It contains brood, capsule, scoliosis, everything. Brood, capsule, everything. Scoliosis hook. Scotch tape technique, otherwise called NaH swab or cellophane tape technique. Entropis vermicularis. Loeffler's pneumonia, Loeffler's syndrome, Ascaris lumbricoides. transient pulmonary eosinophilia due to larval migration of Ascaris lumbricoids. Most common cause of UTI, no other go, E. coli, uropathogenic E. coli. Honeymoon cystitis, Staphylococcus saprophyticus. Staghorn stone, Sturoid stone, Proteus vulgar, Proteus. Gas gangrene, gas cryptus bubbles in muscles, plus Clostridium perfringens, alpha toxin, lecithinase, pseudomembranous colitis, Clostriditis difficile, antibiotic associated pseudomembranous caused by, due to clindamycin-like drugs, clindamycin and aminopenicillins, cephalosporins. Rice water stool, no second thought, cholera. Peptic ulcer disease, gastric ulcer, duodenal ulcer. Helicobacter pylori diagnosed by urea breath test. Fry's test, skin test for LGV, lymphogranuloma venerum. Long back people used historically. Wheel-Flix reaction, ricket cell diagnosis, heterophil antigen antibody test using protease antigen. KFD, Kaizenous forest disease, monkey fever. Vector is tick, monkey fever transmitted by hot tick. Black water fever, Plasmodium falciparum. Massive hemolysis, urine become black. Blue-green pigment, always remember, Pseudomonas aeruginosa, produces pyocyanin. Ventilator-associated pneumonia caused by many people, Enterococci, Pseudomonas, Acinetobacter, many things. Pseudomonas and Acinetobacter are very common. Catheter-associated UT is the common hospital-acquired or healthcare-associated nosocomial infection. Healthcare-associated infection globally. Biological indicator for autoclave, all the 360 directions. But what is the biological indicator? Geobacillus stereothermophilus. Plasma sterilization using hydrogen peroxide nanoparticle. Heat sensitive equipments. HEPA filter 0.3 micrometer. We want to get a pure air. Operation theatre, isolation ward, many places. Remove 99.9% particles of more than 0.3 micrometer in diameter. Spill management, hypochlorite. It's from 1%, even 0.5% to 10% depending upon the big spill. 10% for large spill. Pneumocystis jirovecii, most common cause of fungal pneumonia, HIV positive patients. Pneumonia and AIDS diagnosed by GMS stain, broken pink ball cyst, crushed pink ball cyst. Cottage cheese discharge, where you can get in vulvovaginal candidiasis. Rhizopus in mucor. These people causes rhinocerebral mucormycosis, aseptate hyphae, 90-degree branching with uncontrolled diabetes, ketoacidosis. Aspergillus, septate hyphae, 45-degree acute angle branching, allergic pneumonia it causes, bronchopulmonary aspergillosis. Majura food, Majorella mycetomatis. You can get granules, swelling, characterized by triangle of tumefaction, tumor, sinus and granules. Chromoblastomycosis. So sclerotic body, medullary body, copper penny body or muriform bodies. Medullary, copper penny, muriform body, sclerotic bodies. Bubo, where you can get bubo? You can get plague, bubo, and lymphogranuloma venerum, you can get bubo. Painful lymphadenopathy, plague or lymphogranuloma venerum. Wool sorter's disease. It is pulmonary anthrax, widening of mediastinum, mediastinal widening, hemorrhagic mediastinitis. Inhalational anthrax, pulmonary anthrax. Gas gangrene, Clostridium perfringens, boxcar shaped gram-positive bacteria you can see on smear. Tetanus, drumstick appearance, deep injury, drumstick appearance of terminal spore. Botulism, infant botulism, we have what's called botulism we have different types of botulism. Botulinum toxin, which inhibit the release of acetylcholine. I don't know what is the question. Floppy baby syndrome, honey containing spores. Infant botulism, yes, that is floppy baby syndrome. We can consume honey. It's the reason for floppy baby syndrome is consumption of spores containing honey. Preformed toxin, descending paralysis. Actually, infant botulism is mainly due to spores. Okay, I can rectify this. Sorry, spores. Spores injection, descending paralysis. Listeriosis. What does it causes? Listeriosis causes meningitis, tumbling motility, unpasteurized cheese, tumbling motility. Bruley ulcer caused by atypical mycobacterium. What is the name of the bacteria? Mycobacterium marinum. I started at 8:45, 30 minutes time. I need to finish by 9:15. Okay. Swimming pool granuloma, Mycobacterium marinum. Bruley ulcer, Mycobacterium ulcerans. Antibody dependent enhancement. Pre-existing antibody enhance the infection. Seen in dengue. Secondary infection is very dangerous. NS1 antigen. We can diagnose early, within 1 to 5 days. Early diagnosis, NS1 antigen. SARS-CoV-2 receptor is ACE2 receptor. Binds to ACE receptor, angiotensin converting enzyme. Respiratory syncytial virus is the most common cause of bronchiolitis in children. Rhinovirus is common cold. Common cold, best at 33 degree nasal temperature. Salmonella typhi, rose spots in the abdomen, rose spots and coated tongue, pea soup diarrhea. These are all features of this one. Blood culture is the best first week of Salmonella typhi diagnosis. Blood culture, first week. Shigella dysentery produces a toxin called Shiga toxin, leading to hemolytic uremic syndrome. Campylobacter jejuni causes Guillain-Barré syndrome, O19. It is seagull wing, grows at 42 morphology. Seagull wing morphology, 42 degree, Campylobacter. H. pylori, urease production, allows it to survive acidic pH because it neutralizes the gastric juice. And also the urease break the urea into ammonia and carbon dioxide. Ammonia neutralizes the acid. And also the same ammonia damage the gastric mucosa. Yersinia enterocolitica causes pseudoappendicitis due to mesenteric lymphadenitis. Pseudoappendicitis. Rat flea is the vector for plague and endemic typhus. Bottonella bacilliformis. It causes cat scratch disease. It causes cat scratch disease and also bacillary angiomatosis. Sorry, slip of the tongue, I mistake. Bottonella Hensley only. I'm sorry. Bottonella bacilliformis causes Oroya fever, Verruca peruana, Carrion's disease. Carrion's disease. Vector is sandfly. Bottonella Hensley causes cat scratch disease and also bacillary angiomatosis. This is Bottonella bacilliformis. It causes Oroyo fever, Verruca peruana, as well as Carrion's disease. Vector is sandfly. One more fellow, Bottonella quintana. It causes trench fever or 5-day fever. Vector is louse. So bacilliformis vector is sandfly and quintana vector is louse, where Bottonella Hensley, sometimes the vector may be tick. Okay, now the time is 9:12. 3 minutes before of my time. I am finishing the show. 150 points you fired. Matter of 30 minutes. Like that, every day I'll give 50 points per day. So no need to spend 30 minutes. Even spend 15 minutes your day. Even you sit in your toilet, you can read 50 points. It will be useful to you. Okay, I request you. You please read all the 50 points per day. Definitely helpful to you. After the exam, you give the feedback whether it's worked out or not. You give the feedback after the exam. Till the time you would sincerely try.